Are you also there, Archana, in Pune?
Yes, ma'am. We are sitting next to each other. The entire team is here.
Nice.
So we have met after 2 years. The last Idec was totally virtual. So this time, at least the organizing team, we decided to meet.
Dr. Sunil Gupta has joined.
I can see him getting
Yes,
connected.
he is joining. Sarita ma'am is also there.
Yeah, he's there. Good.
Okay. Come, you want to say hello from here? Everyone is logged in.
Everyone's here.
Nita is here. Blur कर रहे हैं.
Hi, Neeta.
Hi everyone.
Hi, Nita.
Good to see you.
Good to see you.
Virtually, yes.
I'll join in from the other laptop.
थांबलेला ऐकू. हां.
I feel weird with like makeup at 11:30 at night.
We don't know. It's 11:30 there.
Oh,
But I'm
you're in US now.
Yeah,
Oh, I didn't know. I thought you're here.
that is what I'm trying to tell you, Mala. I said we came here and sold our house, Channai. So we came here 2 months ago.
Okay.
Then got the house because we haven't been here in like months and months and months, 8-9 months. So came here and got the house ready, put it up on the market. But our luck, it sold in 4 hours.
Okay.
The first couple who came and saw, they went home, made an offer, and it was a good offer. So we accepted it, except they wanted the whole proceedings to be completed in 4 weeks. Which is a lot of like legalities and inspections and this and that to be organized and completed. So it's been pretty hectic, but it got finished on August 31st. And that's why I'm leaving in about 2 weeks. I have to take another booster shot and then also get my COVID test, lots of procedures.
So end of the month, you're back in India.
Long before that, like 3rd week. If the next meeting was in another 2 or 3 hours, right, I would have somehow just stayed up and finished that, except that's at 6 in the morning.
We'll have the recording, ma'am, if you want.
Sure. Okay. Recording of?
I thought you're talking about the meeting.
No, I have another one in the morning. And I was saying it would have been nice if that was just in another 2 hours. Then I could have finished everything and once for all gone to bed. But now I can't. I have to.
Good morning. Good morning, Anjali. Good morning, Archana.
Good morning, sir.
Good morning.
Good morning, sir.
Good morning. Good morning, Usha.
Hi, is it Sanjay?
No, it's Vijay.
Vijay.
Hello, Vijay. I can't see you. Then.
Oh, I'm invisible. Okay.
That's a new virtue we have got now.
I know. Invisibility. Where is Nita? Nita, I can't see.
Yes, I'm right here.
Yeah, Nita. Looking fresh and nice.
Thank you.
Good morning, everyone. Usha ma'am.
Good morning, Sunil.
Anjali.
Good morning.
Sunil.
Good morning,
sir.
Welcome, sir.
Sunil,
Welcome,
Sunil.
sir.
Very unique idea, Nita. Fantastic
Right.
concept, and I
Right.
think it should really click well. It is a attraction to all my students,
Oh,
postgraduate students. They're going to log in a big way.
okay, thank you so much.
Yeah, so I think it's really unique. Both of you, Anjali and Nita, and of
Thank
course Sanjay.
Thank you, sir. Thank you so much.
Yes, yes.
Hi, Sharita.
Hi. Morning, everyone. Sunil.
Ah, yes.
Dr. Vijay.
Hi, madam. How are you?
Madam,
Good,
good
how are
morning
you?
to you.
Fine.
Sunil is here.
Good morning.
Yeah, good
Ah.
morning, ma'am.
Dr. Mala is also there. Dr. Mala.
Hi, Dr. Vijay.
Mala, how are you?
I'm good.
Long time we not met.
Nita. Since
Mala,
Nita,
madam, good morning.
I've told
Yes.
you.
Hi.
Good morning.
The virtual platform has taken us to, the individual homes. Everybody has come to my home, and I've seen Nita's house, everybody's house. So the advantage of the virtual platform.
How do I get it on the side?
This countdown is for what? Starting? Okay. Okay.
Yes, sir. The countdown is to start.
How do I get this on the side? The video panel.
Sarita, you're right in the middle. You're looking good.
No, that's not the point. But I want it on the right-hand side. So I can,
Ma'am, on the top right, there is a view, the kind of view you want. So the gallery view, and then
Gallery
you
view.
can choose which kind of view do you want.
You want gallery or speaker?
Right. So,
Yeah, but
there are
it
different
usually comes on
views.
the right-hand side.
So the speaker will, the right top would give you the choice of view.
Yeah, now it's good. Yeah.
Right.
Nita,
Yes.
I'm sorry, because the principal has called me. I don't know how come. So I've already informed Usha, Mala, and of course Sunil. Now,
Okay. So
if you
somebody
permit
will be
me to
taking your
leave after
slides?
my talk.
After your talk.
Yeah. Thank you. Thanks.
Usha, just to reiterate, you will be introduced by us, and then if you could just please quickly introduce your other three expert speakers, the slides will come up.
Awesome.
Nita, but we have not received any slides, or means you have shared the slides or no? It's an introduction slide, you mean to say?
Yeah.
Hello?
Yeah,
the introduction slide, she said.
Introduction. Okay. And the concept what Usha ma'am has written on the mail, I feel that's the way we will be going ahead.
Yeah. That I think
It's a discussion. There is no lecture of ours. No, it will be shown by, all the slides will be shown by Usha ma'am.
that is as per how you would have decided.
I'm going to
By
show
the time I realized too late in the evening. And
No. You can do it actually casually. You can just, give the points. Absolutely no need for slides. If you want to show slides, it's good. If you
I don't have any slides. I have not prepared. I thought it's more of a discussion. It's an interactive session.
You are more than welcome to just speak extempore.
Yes.
We're going to start.
Yeah, you can start.
So good morning, everyone, to the second exciting day of International Diabetes Expert Conclave. From today, we have our signature EBM masterclass, which we thought was the time demanding thing of experts in the field from all over the country coming up and having the discussion on important topics, which can at the end take a very important message, which can be directly translated into clinical practice. And for the very first session, we have none other than the stalwart Dr. Usha Sriram ma'am, who is an endocrinologist and general physician in ADIA, Chennai. I am sure the audience is very well versed with who and what Dr. Usha ma'am is doing for last 38 years. So she'll be leading this first session, which is a very important session and practically very difficult and a lot of question raising topic, that is diabetes and obesity, the care during the preconception time. So I request Dr. Usha ma'am to briefly introduce her experts and take over to the session. Over to
Thank
you,
you.
Usha ma'am.
Thank you so much. Okay, one second. Thank you so much, Anjali. And I must thank Neeta and the entire organizing team, Sanjay and you and everyone for putting this topic as an important part of the EBM masterclass because it's so vital. I'm so honored to have Professor Sarita Bajaj, Professor Mala Dharmalingam, and Professor Sunil Gupta as my co-panelists. And Sarita is consultant endocrinologist, former director and head of medicine, MLN Medical College, president of the RSSDI, and she has held many important posts. And the RSSDI established a Professor Sarita Bajaj oration in RSSDI UP in 2018. Gotten many awards, an amazing speaker and teacher. So I'm thrilled to have Sarita on board. The next person will be Dr. Professor Mala Dharmalingam. Mala is a dear friend for many years, director and the Bangalore Endocrinology and Diabetes Research Center, senior professor and HOD of the MS Ramaya Medical College. And again, Mala has great interest in many areas in endocrinology, particularly in thyroid and PCOS and many women's health areas. So welcome, Mala. And Dr. Sunil Gupta, freshly minted president of DIPSI, is a diabetologist, CEO and MD of Sunil's Diabetes Care and Research Center from Nagpur. Again, very well published, has many honors and awards through the years, and has been a national treasurer for the RSSDI in 2019 to is the national treasurer for RSSDI from 2019 till 2022, and is the DIPSI president. So really honored to have all three of you as the panelists. So today's session is on preconception care of diabetes and obesity. And what I thought was just set the stage because each of the speakers will be addressing different areas. Like, for example, Dr. Sarita will be talking about diabetes and pre-diabetes. Mala will be talking about obesity, and Sunil will be talking about prevention of GDM. Can you enable screen sharing, please? Because it says the host has disabled it. I can do it now. Yes. One second. Okay, I may have to. Just 1 second, it's not coming through. One second, let me see. Just give me a second, guys. I see the slides, but it's not coming up.
The share screen option is not coming, ma'am.
No, it's coming. Just 1 second. It'll come in. I can.
Yeah, sometimes it may take a minute or so. It's okay.
It takes a minute.
Yeah.
1 second. Got it. I think now it might work. It may not working now also. Okay,
Can you
so
tell us what is the message that it is showing, ma'am?
it's not, it's not showing any message. I'm just saying that it's not showing my slide, which I can see on the, okay, one second, let me try one last time. If not, I can just, like Sunil said, okay, got it.
Or you can email us.
Finally
Yeah,
got it.
It's happening. Yeah, great.
Yes. Okay.
Okay. So, because sometimes the picture is worth, as they say, 1,000 words. So nothing like it. So I really wanted to just very quickly set the stage that particularly in this post-COVID era, talking about women's reproduction and women's health is very, very vital because all these things, non-communicable diseases, maternal, child health, everything has taken a backseat and has been deprioritized thanks to COVID. And all the human resources and other resources have all been channeled towards that. So I'm very glad that we are addressing this. Traditionally, we have been very myopic when it comes to maternal health because we only have been looking at it as healthy mother goes on to have a healthy baby. But we know that you suddenly overnight cannot become a healthy mother. It has to be a paradigm shift where it has to be healthy girls have to become healthy women who then become healthy moms who can have healthy babies. So we need to go back and start making sure that preconception care really happens from the time of childhood and adolescence as well. And why is it important for preconception care? First, more than 50% of pregnancies are unplanned. And when we say planned, we really are not talking about any preconception care, but really make that the woman is expecting to get pregnant. That's all. That's all is the planning. So even in that 50% are unplanned. Health of the women currently of reproductive age, 15 to 49. And by the way, just to tell you, in India alone, there are more than 300 million women in the reproductive age group. So their health is not good like before. And with good preconception care, birth defects can be minimized, and I'll show you. And maternal health influences fetal health and growth. Baby weight can be optimized with preconception care. And now we also know that pregnancy is a window to future chronic disease. So if a woman has an uncomplicated pregnancy, chances of her developing chronic disease in the future goes down. So the first 8 weeks are so critical that if preconception care is not there and she walks into the pregnancy, the window is already closed. You can get all kinds of birth defects and complications simply because of lack of preconception care. And women think they are too young for diabetes or pre-diabetes. The CAR study has clearly shown the interrupted blue lines are young women, as you can see. Young women are having so much pre-diabetes in Chennai, in Karachi, in Delhi, everywhere, that these are all the people who are walking into their pregnancy. And does preconception matter in diabetes? Clearly, it has been shown preconception care, so many preterm births avoided, 3,000 birth defects prevented, perinatal death. So we know it works and it should be done. But to me, really what is very important is if you take good care of the mother, the baby will not develop diabetes. If the mother doesn't get GDM, baby does not get GDM. So both a multi-generational and transgenerational impact will not be there. And in a snapshot, I just want to say maternal diabetes means offspring diabetes early on, recurrent GDM, future cardiovascular disease, offspring obesity, visceral adiposity. All these challenges we knew. I just want to add one more, which is now they are linking diabetes in pregnancy to lung health of the offspring. And COPD, we know, is also an NCD, which is why next week, and Sunil is part of that, we are doing a program on gestational diabetes as the mother of all NCDs, because it's leading to all these problems. What about obesity? You can see in most of the states, the women are more obese. And maternal obesity can lead to increased placental growth and big babies, or it can cause maternal hypertension, gestational hypertension, and problems with the placenta, vasculopathy, and actually have SGA babies. And this big study that is going on called, Top Moms, and this the top stands for towards prepared moms. That's what it stands for. The Top Moms program, they are looking at women and studying, because you can see uh, uh, obesity in the mother can lead to so many problems across the life course, and the woman herself in future developing many complications. So obesity in the mother leads to multiple complications. And so what solutions can we offer? And I think that is what Sarita and Mala and Sunil are going to talk, mention to us about what we are seeing in the ground level and what solutions. But I just want to say that the 4 simple steps to preconception care that we should be following is a dialogue regarding the patient's readiness for pregnancy with all women who are just married, planning to get married, in the process of getting married, or planning a pregnancy in the next 1 year. And a big low hanging fruit, which we forget, is between pregnancies. So postpartum care of the woman is actually preconception care for the next pregnancy. It's really important to not miss these women and not think only of preconception care as first babies. An evaluation of her overall health and opportunities for improving her health, and education about the other things, social, environmental, occupational, behavioral, all that should be discussed. And very, very importantly, which is what we'll be discussing, is identification of women at high risk for adverse pregnancy outcomes, and address all of these things. So on that note, I will stop and invite Sarita to talk about diabetes and pre-diabetes.
Thank you, Usha.
Yeah.
That is, I think you've set the stage very, very nicely. And my role is set already. Again, I would like to thank Neeta, Sanjay, and Anjali for organizing this wonderful meeting. And like Vijay said right in the very beginning, I think the idea here is brilliant. Okay? Visible? Audible?
Audible, yes. Visible also. Yes.
Right. So what I thought is that I would just focus on diabetes and pre-diabetes, like it says, in young women and women of reproductive age. What is the relevance? And of course, a lot of prevalence data will be there, ending up with what you just gave, those 4 salient points. I will focus on what a little bit, because I think that's more of Sunil's task to go into the details of prevention of gestational diabetes. So I'll be focusing a little on the guideline aspect as well, what we should be doing. So this is the roadmap that I will be taking. Undoubtedly, amongst the top non-communicable diseases in women, both you can see diabetes and cardiovascular disease are right on top. And we know that women with diabetes have so much more to manage. I'll be discussing a little bit about the morbidity, the mortality. You can see the percentage of diabetic deaths, 9th leading cause of death in women globally. And we are all aware of the fact there's so much more of heart disease, as well as the microvascular complications. In the South Asian women, in Indian women, I'll be talking about the neglected aspect of diabetes as well. So we have the global prevalence data.
I think there's some connectivity issue. Sarita's.
Yeah.
Neeta, shall we jump to Mala and then come back to Sarita?
Yeah, we can do that. But I think Sarita was in a rush or something to go to college.
Correct,
But yes, so
correct.
as you said, let's move on.
Or
Yeah,
shall we,
yeah.
you want to give her a call or?
We'll give her a call in the meantime. And I think Mala can start her presentation. Yeah.
So I'll just share my screen.
Yeah, except Sarita may have to unshare her screen.
That will happen automatically.
Okay, sure.
So my screen is visible.
Yeah.
So thank you very much. Thank you, Usha, for the introduction. And thank you, Neeta, Anjali, and the whole team of Idec for having invited me. So today I'm going to talk for the next 7 minutes. That's what Dr. Usha has given us to talk about reproductive age group. Hopefully 7 minutes. Please pardon me if it becomes a little more. So basically, this was a study which was published in the lower socioeconomic countries and developing countries, just to show between 2002 to 2012 how the mean BMI has gradually increased in women of the reproductive age group. You can see it is almost going up vertically, almost to reach roughly around 60% in 45 to 49 years, and also in the age where they become pregnant between 25 to 35 also, the prevalence is almost up to 40%. Now, if you look at different BMIs, at whichever age group you take, the BMI which is more than 30, they are the largest among all the population of women, whether they are normal weight or BMI of 25 to 30 or more than 30, we find that it is quite a significant increase, almost about 16 to 20% of people are more than 30. Again, this is the global data. Now coming closer to India, this was another very elegant study which was published only in 2020, looking at low and middle income countries. So it's like a twin of underweight as well as overweight. Here you can see India in the underweight, and we are quite high in prevalence of underweight. This is also very important. It's not just obesity, but even if you see underweight, we are almost right at the bottom, which means that 40% of our population is underweight in women. And if you look at obesity in women also, we are quite close at about 20 to 25% of overweight and obese. So it's something that India has to tackle, that we are also looking at underweight women who are also going to go into pregnancy and overweight women who are becoming pregnant and causing problems. Today, let's talk just about the obesity part. Again, this is forecasting what will happen in 2040. If you look at all the BMI ages of 20 to 34 or 35 to 54 or 55 to 69, let's look at 20 to 34 alone, because that is the age they become pregnant. If you look at 2010, the point estimate was 8%, and at 2040, the point estimate will be 15.6. This is for overweight rural, obese 1.7 and 5. So it is all increasing, whether we are looking at overweight or obesity, or whether we are looking at rural or urban. Closer home, urban, you have 2010, overweight is 17.4% is the point estimate, and it will become 25.1% by 2040. And in obese is 5.4 to 9.9. This is something which we cannot afford to increase, and we need to look at it. Now, this is again, same forecasting, overweight, rural, urban, put in a nutshell. You can see that in all, whether it's rural or urban or the national, we have a increasing trend, and it is estimated that overweight will from 14.7 will increase to 27.4%, and obesity, which is at 4.4%, will increase to 14%. And closer home, I have Karnataka data, which shows that normal weight is about 63%, overweight is 23.8%, and obesity is about 12.7% of women in the reproductive age group in Karnataka. So now the problem is just not obesity. It's called osteosarcopenic obesity. What happens here? There's osteoporosis, like how Dr. Usha and Sarita were saying. There is bone loss and there is muscle loss, but there is increased adiposity general as well as abdominal adiposity, which causes fat infiltration and fat redistribution, which is called osteosarcopenic obesity, which is very increasing concern in India because India as such has very poor muscle mass. Now, the risk of it, apart from the general risk, the risk of women, why do they suffer? Social environmental pressures, pressures to be thin, teasing history, discrimination, reaction to their weight by family. And this is called weight cycling. If you see here, they go on one diet, they lose weight, then they put on weight, then they go on the second diet. This is called cycling. They go up and down. And this itself has been found not only to affect them mentally, but also cause an independent risk. So they go into binge eating and hunger, cognitive factors. These are something which is very important because this is the age group that they have image satisfaction and they have hugely body image dissatisfaction. So it has also been seen, the less educated, the more obesity. Here you can see no education or primary education, the obesity is maximum compared to the higher. And this is again a data for showing the in Indian women frequency of TV watching. If you see here, I've just taken this part out, where it says if you see almost every day, it is about 13.9 relative risk more, and if it's you don't see, the risk is about, or percentage is about 4.6%. So almost 4 times the risk if you see TV every day for obesity. This is the body image. This is a standard Stunkard scale where the person, how they feel about themselves when they put on weight, and this is how it is, they are graded from 1 to 9. And if they put on weight, their self-image becomes less and less. And anxiety, depression, whether you're looking at anxiety scores or depression scores, it is quite high. So these are all some problems. Long-term arterial hypertension, diabetes, anemia, depression. This is 30 people who had a bariatric surgery who were morbidly obese and 30 people who did not have. And you can see that once they lost weight after bariatric surgery, all of their parameters came down quite significantly. And this is just to say that obesity can cause, the traditional risk factors are hypertension, dyslipidemia, diabetes, and gestational diabetes, preeclampsia, premature delivery, and endothelial dysfunction are some of the problems. But apart from that, long-term ischemic heart disease, heart failure with preserved ejection fraction, peripheral artery disease, obstructive sleep apnea, all are problems of obesity. So something we need to deal with. And this is again data to show CV mortality. As the BMI increases, the CVD mortality increases, and so does any death, cause of death of any cause, that is also increasing with increasing BMI. This was another Europe data which came out in women, the hazards ratio by BMI, and as your BMI increased, whether it's MI, ischemic stroke, CVD death, or death from any cause, kept increasing. This was a very interesting article from European Journal of Preventive Cardiology in 2020. So how to deal with it? Very difficult question, and it's a very interesting topic. I'm sure we can debate on it. Of course, we need to do exercise training, hypocaloric diet, and in that period of time, whether they need hormone replacement or vitamin D. These are some of the speculations, but I'm sure we could discuss when we have the question answers. But yes, and of course, a lot of counseling, I feel that is very, very important when we are talking about obesity, especially in the reproductive age group, and of course, a lot of support. I'll end here and over to Usha once again.
Thank you. Thank you, Mala. So I have a couple of questions, and the questions were for Sarita and for Sunil, but we are all welcome to jump in. And so Sunil, if you want to take, I had 2 questions. One was, one was to Sarita, which was, should schools and colleges and workplaces, incentivize healthy living or a healthy lifestyle? Otherwise, how are we going to motivate young people to get healthy? So that's, Sunil, you want to take that question or yeah.
Yes, thank you very much. And again, congratulations to the whole team of Idec and Dr. Neeta and Sanjay and Anjali. Thank you. And thank you, Usha madam, for introducing so nicely to me. Now, the question is intentionally we have not prepared any slide, but maybe it is, I thought should be more of a discussion. I'll put more into the practical aspect of prevention, and then we'll put myself into how does the education can help. I feel all three speakers have wonderfully kept the platform ready for discussion. Importantly, we know the prevalence, we know the outcomes, we know that obesity is bad, we know everything. Now our focus today is on preconception care. So one thing is very important, our delegates should know. That's unfortunately it is the mismatch. We have three important issues. One, that we have a transition in the culture. Earlier, when I was born, my mother was possibly got married at the age of 16, and possibly when I was born, it was around 17 or 18, something on those lines. Many of us who were born, our mothers were of the age below 25, and most of the childbearing issue used to be over in our Indian culture, or most of the culture across the globe, before 25. But because of the career issue, we have our own data of GDM around 900 pregnancies. I just want to share it's unpublished data. We say that the average age of GDM in this part of the country is 29.5 years. So average age of marriage has gone up, average age of conception has gone up, and unfortunately, the age of diabetes is coming down. Earlier, we used to see patients with diabetes that after 50s and near 60s. But now we are all getting a few data coming from AIMS with Nikhil Tandon group. It says, I feel 30% of the patients are being diagnosed at a very tender age of less than 30 years of age. So we now have young diabetics being detected. Reason we know all about the overweight, obesity, dietary habits, physical inactivity. I feel everyone has said this. So we have a mismatch of young people coming to you, young women coming to you with either pre-diabetes or diabetes or polycystic ovarian syndrome. And then they are also getting conceived at a later age. And this again becomes an additional risk factors. If they want to plan their pregnancy, they should try to finish up by before 25. But unfortunately, that is a cultural change which we have to accept it. So what is important is that how should we address this issue and how should we go ahead? The thing is that education becomes a pioneer here. Education, and education. That's the main part of it. And every speaker has said this, that more and more you counsel, you have to possibly first is detect them early, maybe in a pre-diabetic stage, maybe in the hyperinsulinemic stage, maybe polycystic ovarian disease. So you have to first detect them early, catch them young. Now, madam has just spoken about the colleges. I'll say in the schools, let us focus on the middle and the high school children and adolescent education. I feel that again is an important challenge, that they should be preventing their obesity from the early stage, because we know almost 70 to 80% of the children who are obese in the childhood, they ultimately remain obese adult. And the prevention of obesity in the childhood should not be only, there is no data available from the pharmacotherapy point of view, there is no recommendation. So we have only one thing, and that is lifestyle modification, dietary interventions, and physical activity, which need to be improved and in the society. So diet plays a major role. We are not going into detail of it, but we have a data coming out from the DPP trial, Diabetes Prevention Program trial. Of course, that was a program amongst those women. There's a subset of women who had past history of GDM and then becoming diabetic in the later part of life. And we have found that almost 57% of the women could prevent the development of diabetes with those who had past history of GDM, and they could be preventing the development of diabetes after GDM if they are on lifestyle modification, and also if they're on metformin therapy, and they responded well to metformin. But here our data, our discussion is the conceptually that can be picked up, that we lifestyle modification does prevent, and more you people, you make the society aware of it. Possibly, Usha madam, will be able to will be able to target this. We have seen the risk factors. I was just listening to Mala madam. We have seen the risk factor. We know TV watching is bad. We know physical inactivity. Children don't have a place for the outdoor games. So we need to encourage and see to it how best we can counsel them and pick them young. If you pick them young, if you pick them early, I feel the compliance is going to be more. And of course, someone coming to you with a very, very early, and when it comes to preconception, then I feel in the preconception phase, we know that the data says 90% of the women, they have an accidental pregnancy. And this is what is even say true for women with pre-diabetes as well as diabetes. And this accidental pregnancy may create a problem too when women comes to you with maybe 10 weeks or 12 weeks of pregnancy, when the organogenesis is already over. They're already on the drugs which are contraindicated for during pregnancy, and then we are in trouble, and then we have to all have so such situation, if we don't want to see your face, I feel we'll have to have more and more education and awareness in the society. Every woman coming to you with childbearing age, even at the age of 40, should be given a counseling, that's preconception counseling. Every doctor, every clinician should tell them that you can become conceived. You should take conception issue only after the counseling or permission. So unless and until Dr. Usha Sriram or Mala madam or Sarita madam or Niglur sir tells you that you are fit for pregnancy, you should not be planning your pregnancy. Every childbearing, and we have seen people coming at the age of 43 and 44 also with second or third child. Similarly, those who had past history of GDM, when they plan for second pregnancy, even they have to be warned for it. They should be screened for it. Annual screening, I feel we know the rule of 6. After delivery, they are supposed to screen themselves at 6 days, 6 weeks, 6 months, and then once in a year for diabetes, and then they should be counseled. But unfortunate part is the postnatal care in our country is very, very poor. Patient goes away from us as well as possibly from the gynecologist, and they'll end up with pediatrician. So I feel now some action. I feel Usha madam will have to focus the pediatrician also. There should have been someone in the pediatrician group coming in as a panelist here, should be discussing with us that how can, because every woman will land with the child for the vaccination to a pediatrician. And that in that phase, I feel we should be focusing on screening and education of these women when they land up with the pediatrician. So something on these lines may be there. Of course, the weight reduction, other things will further be discussed. I feel I have done little, taken more than 7 minutes, if I'm not wrong. Usha madam, over to you.
No problem. Thank you, Sunil. Sarita is back. So Sarita, can you jump in and wrap up your part of it, and then we can have a quick discussion on the various aspects.
Yeah, so I think, can you tell me till where I was?
You were on this one.
This one?
Yeah.
Right. So this growing problem is going to be the highest in India. And there's data from the ICMR INDIAB group, and that is for young women with diabetes and pre-diabetes. As you can see, the graph is going up. Of course, is again data from India, metabolic syndrome, all across north, south, east, and west, from 10.7 to a whopping almost 46%. The risk factors which are relevant, women-centric. Number 1, PCOS, a history of gestational diabetes and parental history of gestational diabetes as well. Then, of course, this is from our neighboring countries, type 2 diabetes in women from about 7.4 to 8.9%. This is our own data. This is about almost 40,000 school children whom we studied, looking at obesity as well as abdominal obesity. It was more in women, especially the prevalence of abdominal obesity. It was significantly higher in girls, in metros, in private schools. So this is the shape of India today. From what was being done earlier, this was the best gym once upon a time. And I think Mala, I'm sure, has already elaborated on this from what I heard from Sunil's discussion. And this is the current scenario. As far as I said, I'll be focusing on South Asia as well as India, the problems that are unique to us. The risk for diabetes is many-fold higher. The diabetes-related mortality is higher. I'm talking of an age range from 20 plus. And this is all across. This is all across the globe. The mortality is higher for women as compared to men. There is definitely anxiety which is associated with type 2 diabetes. We have data from Delhi that mental health among diabetic women living in New Delhi was much higher. Sexual health concerns are never discussed. Malignancy, again, there is a very, very strong association with colorectal cancer as well as sex-specific malignancies of the ovary and endometrium. Now, the malnourished mother. So this is, see, what we are walking here is a very tight rope. We're talking of obesity, but what about malnourished? So malnourished, poorly cared for girls will, when they become mothers, they'll have small footed babies, more of metabolic syndrome, obesity, type 2 diabetes, a poorer brain development, poorer decision making, and more of complications. And women constitute more than half of the South Asian adult illiterates. We have scant economic resources, delay in seeking care, gender discrimination, social taboo. So, and definitely males have better access. Look at this. When we talk of availability of insulin, again, girls do not get a preference. These are the challenges which Sunil has highlighted. Lack of preconception care. Usha has referred to that. Again, child marriage, yes, it's still existing. The medical complications, problems from the society and family, all these need to be addressed. And of course, the crowding, the lack of privacy in overcrowded healthcare facilities. What are the fears of young girls? If they have diabetes, they'll not be accepted. How will they bear the cost of the treatment? Fear of being rejected by the husband and in-laws. And then the worry of not being able to have a healthy pregnancy and a healthy baby. Again, I've already addressed PCOS, the stigma, the body issues, the anger and the self-pity about not being normal like other girls. In this context, from RSST, I was very happy to have this publication. Thank you. Thank you to RSSTI for that. And the solution, we are obviously wanting some solution. Usha also referred to this, but it starts with healthy babies, healthy girls, healthy women who will become healthy mothers in turn. And good health begins with good preconception care. Sunil just said that 99% of pregnancies are unplanned. It should not be that way. A little bit about preconception care. It's a crucial and sensitive time described as a continuum of care designed to meet the needs of women throughout their reproductive life. So it should be comprehensive. There is evidence-based practice, and it is associated with major reductions in adverse pregnancy outcomes. So this is reproductive life plan, from counseling to risk assessment before pregnancy occurs, medical decision making, and a collaborative approach. You need a lot of team members to collaborate with, and all have a very important role to play. The whole aim is to reduce the number of unintended pregnancies and maximize health before conception to improve pregnancy outcomes. So we're talking of women, young women, and women of the reproductive age as well, whether it's type 1 or type 2. So the risk assessment, you would look into the biochemical parameters, you would look into the complications. You would assess the maternal social deprivation, unplanned pregnancy, and then yes, we know women are taking alcohol and smoking in any form. Then preconception visits and a thyroid function test is extremely important. So you need to set targets, better glycemic control, monitoring for progression of retinopathy, nephropathy, and changing any prior medications. So what do the guidelines tell us? So this is for women with pre-gestational diabetes. We need a checkup, we need a counseling, we need A1C, the dosage of folic acid and the timing, an ocular assessment, a renal assessment, if there is reduced GFR, a nephrology consultation, blood pressure, medications need to be looked into, and screening for coronary artery disease as well. Then look at what about the statins, thyroid function testing I've referred to, weight reduction. If they're overweight or obese, weight management is very important. Then for women who have had gestational diabetes, the follow-up, the postpartum testing is mandatory, and then a routine checkup every 1 to 3 years, and lifestyle counseling to prevent type 2 diabetes after gestational diabetes. And where to catch them? I think Sunil has rightly said, yes, when they go with their babies for the vaccination. So if you educate a man, you educate just a man. If you educate a woman, you educate a generation. And women are the real architects of society. And like Dr. Ambedkar said, that I measure the progress of a community by the degree of progress that women have achieved. So it's a challenge. There are many special concerns. Mala rightly said, yes, promote physical activity. Nutrition counseling should be individual, a comprehensive care program, and CV risk reduction. We need to be very aggressive. And remember, for women, diabetes is usually well below the family. So the family comes first for most women, and be the healthcare partner and the advocate. Thank you. Thank you very much.
Thank you, Sarita. I think what we'll do is dive right. We only have about 4 minutes left. Dive right into a discussion. I'm just also looking to see if there are any questions in the chat box. I don't see any questions. Neeta, do you have any questions that have come in?
No, there aren't, but I would like to ask you to actually, supposing there came a woman who actually came for preconception care, what would be the algorithm, or what would be the quick points that we need to look at to make her pregnancy ready?
So in general,
in terms
or
of diabetes and obesity? Yeah.
Oh, so I think Sarita has outlined it, but I'll just crystallize it, just saying, first is we have to stop the medications that are not approved. For example, statins and ACE and ARBs and certain OHAs, all OHAs, and switch to insulin and the insulins that are allowed. And then, of course, get a baseline A1C and green light the pregnancy only if the A1Cs, I would say, at least below 6.5, even though ADA and others say 7. But that we'd also have to individualize a bit, because if they have other complications, you may want to look at 7. But otherwise, I would look at 6.5. And now, cardio obstetrics has become the emerging big field, because it's not, heart complications of women who get pregnant is now become the biggest complication. And also for the babies, fetal echocardiogram is needed. So making sure that there are no cardiac complications, especially in type 1s and long-standing, type 2s. And as Sarita said, check out the thyroid and educate the women about self-monitoring of glucose, set the targets, and start a fetal surveillance with everything from anomaly scan to fetal echo to the quadruple testing. The whole process goes on. And later on, very importantly, of course, and that's into pregnancy already, but in preconception, it's making all these changes and getting her ready. in a nutshell.
Yeah, can I, Nita, we also can add the screening of other vasculopathies pre-existing. So if someone has diabetic retinopathy, we'll have to warn them that it may get, there can be progression of diabetic retinopathy. Those who already have proteinuria in overt diabetic nephropathy, there can be a risk of progression. We also have to look into now cardiomyopathy and associated macroangiopathy, what Dr. Mala has already said. So I feel, and Dr. Sarita Madam has said, so I feel we'll have to also assess the micro as well as macroangiopathy, which might get further exaggerated. And there are some strict contraindication. Our delegates should know what is the contraindication for pregnancy to a person with diabetes. If someone has autonomic gastroparesis, someone has EGFR very low, some patient with CKD, patient with cardiomyopathy, I feel such there should be even that should be told to people.
Yeah.
So I would like to add the folic acid is extremely important.
Yes.
And apart from the checkup for the micro and the macrovascular complications, including retinopathy, I think that progresses enormously during pregnancy. So that must be kept in check. Statins, the statins we have to stop. And a lot of the women, of course, we know may be on statins. And the weight reduction, because that oodles of weight that they're going to add on in pregnancy and the postpartum period. If we are going to prevent subsequently type 2 diabetes, and we know that gestational diabetes is a form fruste of type 2 diabetes. I think all these points are extremely important.
Usha, there is a question from Dr. Robin Maskey from Nepal who has logged in, who has said an excellent talk, ma'am. And what about screening of fundus in GDM and how frequently you do the screening?
Short answer, we don't do screening for GDM. It's only for pre-gestational so, but if I diagnose GDM early in pregnancy, right, then it's possibly someone at first booking, for example, it's probably someone who's walked in with undiagnosed pre-diabetes. Yeah. And we know that in pre-diabetes itself, you can have, retinopathy. So, getting a fundus exam then makes sense, but there's no official recommendation.
Yeah, we have, I think, one more minute.
Nita, we can also add to this that possibly he's asking for pre-gestational diabetes also, but by mistake he's written GDM. Yeah. But we should also tell them that if the person has no retinopathy before conception, then there is no risk of development of retinopathy due to pregnancy. No microangiopathy is likely to start because of pregnancy. It is only pre-existing microangiopathy which will progress. That is one important thing. But if someone has, say, mild to moderate NPDR and some in such situation, then they can even go for laser therapy during pregnancy. Laser photocoagulation is not contraindicated during pregnancy. That is another message. But if someone has PDR, proliferative diabetic retinopathy, it is one of the relative contraindication for pregnancy.
Yeah.
No, I think, Sunil, I would like to add that the basic thing is how frequently. So during pregnancy, like Usha, even if it is gestational, these lines are very overlapping. So yes, even in gestational, I would get a screening first time as soon as it's diagnosed, and then every trimester. So I would look into it every trimester. So at least three times it should be looked into. And of course, if there is, like Sunil is saying, then we have to have an ophthalmologist on board to look into the management part.
One last quick question to the expert panels. If a woman is obese when she comes to you for preconception care, would you ask her to defer pregnancy until she has lost some weight?
I was just going to say that, see, I am very worried about obesity in preconception for several reasons, not just the fact that they may have trouble conceiving or gestational hypertension or GDM, but also we are learning a lot about autism spectrum disorders and ADHD and neurocognitive defects and, serious problems with even babies subsequently. So we don't want to medicalize pregnancy. We don't want to scare anyone or anything, but I think gently we have to help this person defer pregnancy for 6 months to 1 year. I mean, it's a luxury if they come for preconception care. And that is going to be my mission for 2022 to make preconception care a specialty.
Right.
Yeah, but
Okay,
Usha,
so-
see, that won't it depend on the age of the woman who's coming to you. If she's already coming at that cusp where pregnancy is going to become more and more difficult, I would any day want her to get it over with and then look at, because 6 months to a year may be, I know, like very crucial window. And
I'm sure
women are
it's,
marrying late, trying to conceive late. I think the age would be very important.
no, I agree, but I'm just saying that those are, exceptions, but majority, most of them, I think, must see they are anemic, they may not fully vaccinated, they're nutritional deficiencies, they may have mental health issues, they may have other things that we need to address. They may be taking medications that they are not supposed to over the counter or prescription medicines. So there's a lot of stuff that needs to be, or bugs to be, removed and fixed before they can walk into that pregnancy. And if we can popularize this, evangelize this concept, I think this will catch on, just like women are taking folic acid now routinely. So making it popular like that.
Thank you very much,
if
Usha.
everything else is in order, then obesity should not be a deterrent. If everything else, like you're saying, all that other aspect is managed, but she has not lost weight, or maybe gained a couple of grams, milligrams, kilograms, then I would still advise her to please have a baby and then move on.
Thank you. Thank you very much. Very reluctantly, I'm having to close this session. I think the masterclass has shown up more, thrown up more questions than answers, but that's how the subject is. And thank you all very much for joining us this morning. It's been a wonderful masterclass. Thank you.
Sorry for the mess up. I'm really sorry for the mess up.
That's perfectly all right. These things happen.
Thank you. Thank you,
Thank you
Neeta.
very much.
Thank you, Anjali. That was very nice.
Thank you.
Bye, Sunil, Usha,
Thank you, everyone.
Bye, madam.
Thank you.
Thank you, Usha, ma'am. Bye.
So now we come
you,
to
Vijay.
the next masterclass, which is a very important one. And the masterclass is diabetes and COVID-19, the evidence so far, the risks and the management protocol. And to lead this EBM masterclass, we have none other than Dr. Vijay Neglur. All his credentials are here for you to see, but I would like to introduce him as a person who knows his basics so well, and that's what makes him a fantastic clinician. He is he's on the advisory committee of the Idec, and he is also a very good friend. He's an excellent clinician with many feathers in his cap, and I am sure he is going to tell us everything that we know so far about diabetes and COVID-19. Over to you, Vijay, to introduce your speakers and also to take the masterclass forward.
Thank you, Neeta, for this brilliant idea of evidence-based masterclass. We have three talented speakers. The first is Dr. N.K. Singh. He's a diabetologist from Dhanbad, the director of Diabetes Heart Center, Dhanbad, chairman RSSDI, Jharkhand, and editor of www.comindia.in. Next. Then we have Dr. Arvind Gupta. I think his CV is quite crowded, make it very short. He's diabetologist from Jaipur and Rajasthan Hospital he's attached to. He has 34 years of experience in the field of diabetes. He has more than 75 publications to his credit, and an excellent speaker and a very, very talented diabetologist from Rajasthan. And we have, of course, young, charming, dynamic lady from Mumbai, Dr. Purvi Chawla, who is consultant diabetologist at Leena Hospital, Diabetes Center, Mahavir Hospital, and Bharatiya Arogya Nidhi Hospital in Mumbai. And she's investigator for many trials. So this is our force on discussion in diabetes and COVID-19, evidence so far, and risk and management protocol. So welcome, everybody. As I said earlier, this is a fantastic idea by Neeta and Sanjay, and of course, Anjali. And I really appreciate the hard work they put in to create a fantastic program. Thank you very much for the invitation. And to set the stage, we all know this is the Wuhan market, wet market. In December, people who visited this Wuhan market developed a kind of a peculiar disease, which was through the bat and pangolin, and it caught the entire world in the great in the great difficulty, and therefore we see this pandemic, which was declared in the month of March 2020. So this respiratory disease outbreaks is become very common for the last 25 years. And we had the Spanish flu as the mother of all pandemics, which was again in 1918, which we saw 500 million patients with 50 million deaths. And now, of course, in 2019 and 20, we have the outbreak of COVID, which has more than 215 million patients and more than 4 million deaths. And this is the worldometer, which is put by the John Hopkins, and the fantastic minute-to-minute update. It's a unique, this is updated yesterday, which looked at 219 million patients and more than 4 million deaths that you see across the globe. This is the publication which looked at the prevalence of the diabetes amongst the patients who had COVID and the intensity of diabetes based on the problems of intensity of the disease. And we see here this geographical representation looks at the mortality of patients of diabetes with severity of the disease. And we all know it's because of various factors, because of ACE2 expression, increased furin levels, and T cell and complement defect that they have, increased interleukin-6, and that the CDC said that hospitalization were 6 times higher and deaths 12 times higher for COVID-19 patients with reported underlying condition like cardiovascular disease, diabetes, and chronic lung disease. This is again a meta-analysis which looked at the 8 studies, more than 3,000 patients, and said that the new onset of diabetes is roughly to the tune of 14.4% in these patients. That's a new onset of diabetes, and it's very robust evidence to say that the onset of diabetes can be in the beginning. We just discussed about pregnancy, and COVID infection is also quite common in the pregnancy, and they required an intensive treatment, and these people, they do well, but they require a mechanical ventilation. Sometimes they have a prolonged hospitalization as well, but the outcome is not bad. There are data of 538 participants in the world. And we know that there are temporary changes in the diagnostic methodology of GDM during the pandemic episode. People have stopped doing OGTT, which is the gold standard to evaluate the patients of GDM in pregnancy. So this is a study which again looked at 7,000 patients from China, which said that the cause of survival is difficult if the sugar is beyond 180, which is the 11% death. If it's below 180, the sugar survival is better. So therefore, the idea is to keep the sugar below 180. This is again a meta-analysis by Kamlesh Kunti looking at more than 2 million patients from United Kingdom. And what is interesting is that the mortality was seen much more common in people who consume DPP-4 inhibitors and insulin. Of course, this is just an association. Maybe the patients came in a critical condition at that point of time, and therefore the mortality is very high. It only talks about association, but not causality. And therefore, in this context of COVID-19 pandemic, there is no clear indication to change the prescribing of the glucose-lowering medication in type 2 diabetes. But then we saw again, from frying pan to fire, that we saw the growth of mucormycosis in patients of COVID, and especially with the hyperglycemia, with excess steroid, excess free iron, thromboinflammation, dysregulated immune response, and eventual immune exhaustion. And we have how to take the bitter with the sweet. We'll discuss again with the panelists. We'll go into details of this, about the various receptor and how you get mucormycosis. And then we face the second wave somewhere in the month of May. And this could be because of governmental relaxation, the travel, the pandemic fatigue that people got, the variants of the virus, and of course, the vaccine hesitancy. And that has brought to us what is called a long hauler. This is a study from Italy, which looked at 143 patients who presented with anxiety, depression, cardiac disease, interstitial lung disease, post-exercise fatigue, malaise, chest pain, and so on and so forth. We'll discuss this also during our discussion. And we have getting a lot of these waves, and the second and the third wave affected the interrupted care for the chronic disease, especially diabetes. And that saw the birth of telemedicine in a big way. And we could bridge the gap between patient and a doctor with the help of technology and the telemedicine, and we could reach our patients. This is the projection of the post-pandemic SARS-CoV-2 by CIDRAP, the Center for Infectious Disease Research and Policy from Minnesota, which talks about the peaks and valleys. And so we expect this pandemic to continue till next year, January. Maybe it can extend up to June next year. And this is the expedition of vaccine development pathway that we see. And routinely, it takes about 10 to 15 years, but because of pandemic, we have, speeded up to 12 to 18 months, and we have plenty of vaccines. There's a vaccine war, and there's a lot of hesitancy regarding vaccine. This is what you see, people responding to vaccine therapy. And we all discussed today on all these matters, which has showed as a curtain raiser. And to that, we have these talented speakers, and we introduced them already. So I'll stop sharing slides here and request Dr. N.K. Singh to discuss about new onset diabetes during the COVID infection, hyperglycemia and COVID outcomes, COVID diabetes and pregnancy, a perfect storm, and obesity and diabetes mortality. So over to Dr. N.K. Singh. And after N.K. Singh, we'll introduce Dr. Arvind Gupta. Over to you.
Excellent, sir. You have set the stage. And I think everything important has been already told by you. Next 10 minutes, as you given the task to me to, let me just first say, have the slide show. 1 minute. Yeah, I think it is, I'm audible and slides are being shown on your screen.
Yes.
So, yeah, yes, sir. So I think this is a very, very important EBM session with all the things which we need to know in the COVID related things. So new onset diabetes is a very important issue, and hyperglycemia has many aspects in COVID, and COVID, diabetic and pregnancy is a very perfect storm could be, and obesity and the diabetes mortality is a very important. So my first part is that definitely, yes, as you shown, how the prevalence is occurring of the new onset diabetes. You saw Dr. Vijay has shown a very, very important data just now. So an interplay of insulin resistance and possible insulin secretory effects has been recently proposed as a possible pathogenic mechanism of new onset hyperglycemia in patients with COVID-19. So with new onset diabetes, one thing I will say that it has worse outcomes. People with new onset hyperglycemia, even without disease, have poor outcome compared to individuals with pre-existing diabetes or normoglycemic subjects with COVID-19. So this is very important, how all these things are happening, and you can see the striking plots here. The inflammatory cytokines are increasing, hyperglycemia, vascular endothelial damage, so many things occurring at the same time. So many of these patients may have undiagnosed diabetes too, I agree, or impaired glucose tolerance that could have been exacerbated by a stress, counter-regulatory hormones, increasing insulin resistance, autoimmunity, and plausible beta cell stress due to concomitant hypoxia and inflammation of islet microvascular. So this is very important. So definitely, we have got new onset diabetes, severe metabolic complications of pre-existing diabetes, including diabetic ketoacidosis and hyperosmolarity, of which we have seen in our ICU that exceptionally high dose of insulin are needed. So this is very important again. So how this well-recognized stress are doing, it is being shown here. So a story so far is, nevertheless, the large question is whether new onset diabetes in the setting of COVID-19 is directly related to COVID-induced beta cell damage. You can say it happens, but we cannot say with concrete evidence at present. This can only be substantiated by documenting beta cell loss through histological evidence in large autopsy-based studies, which are currently lacking. And hyperglycemia could occur in COVID pandemic by so many things: effect on beta cell, effects on systemic COVID-19 infections, effects of lockdowns is also there. So new onset hyperglycemia or diabetes or worsening or glycemic control in pregnancy. So lots of things is being shown here. So you can have COVID-induced diabetes, pre-existing diabetes, COVID treatment-related hyperglycemia, stress hyperglycemia, and very important glucocorticoid-steroid-associated hyperglycemia. But the odd ratio for death for COVID-19 among people with or without diabetes, you can see here in type 1 diabetes, with one study it has been shown 3.5, but in type 2 it is 2.0, it is not less. And even type 1 diabetes less than 70, it is 6.3 here. And type 2 diabetes less than here 70, it is 3.7. So you can see the problem. So no increase pre-existing diabetes if it is happening. So there is no increase of COVID-19 infection, but there is increased risk of adverse infection outcomes like severe disease, ICU admissions, need for assisted ventilation and mortality, and also increased risk of long COVID has been found now. So I will say here that few reports have indicated that there is an increased risk of acute metabolic decompensation in people with diabetes, including DKA, in both type 2 diabetes and type 1 diabetes, as well as new onset diabetes. So it happens, you can see here 2-3-fold increase. I am giving you the severe meta-analysis conducted, and few of these meta-analysis additionally report a significant 2 to 3-fold. So this is happening, and this meta-analysis suggests that patients having severe COVID-19 and dying are more likely to have diabetes. The second part is a COVID, diabetes, and pregnancy, and there is a perfect storm. Yes, it could be. You guys, lots of things are happening. Suppose in pregnancy, some metabolic things like arterial hypertension, dyslipidemia, visceral obesity, or new alcoholic hepatic steatosis. So retrospective analysis has been done, and this has shown higher risk for severe pneumonia, release of tissue injury related enzymes, excessive uncontrolled inflammation responses, hypercoagulable state associated with dysregulation of glucose metabolism. So these things can happen in pregnancy. So remember, so this happens in pregnancy. So next part is here, very interesting, is that there are clear hints that prognosis of patients diagnosed with COVID-19 and diabetes may be associated with a simplified viral uptake by receptor H2, as you know. So a higher basal value of pro-inflammatory cytokines, which facilitate a cytokine storm, is a possibility in pregnancy. So what happens here, see that as per these data, the rate of COVID-19 diagnosis in pregnant women attending or admitted to hospital is something around 10%. And pre-existing diabetes was associated with severe COVID-19 in pregnancy, while GDM was not. So data exists, whatever we have today, that suggests that the higher risk of pregnancy complications, including preterm birth and preeclampsia. So these things have been shown, how the possibility of vertical transmission remains, could be there, and some reports also suggesting that placental infection happens in diabetes. So many experts conclude that patients who are diagnosed with diabetic are more susceptible to inflammatory cytokine storms leading to deterioration of COVID-19. As we are also aware that the diabetes is a pro-inflammatory state. So pro-inflammatory state in the first part, to anti-inflammatory becomes it in the second part, and to second pro-inflammatory state in the third trimester. So this is happening in pregnancy. Having this in mind, the hypothesized cytokine storm caused by this COVID may lead to more severe inflammatory state in pregnant women, resulting in severe morbidity and mortality. So these things are happening. So diabetic pregnancy clearly need a special care, number one, and complex interplay of diabetes and scar are currently unknown. And prognosis of pregnant women with diabetic and COVID-19 may be associated with potential underlying mechanisms such as simplified viral uptake by H2, a higher basal value of pro-inflammatory cytokines, being hypoxemic, as well as platelet activation, embolism, and preeclampsia. So in the context of transgenerational programming and COVID-19, lifelong consequences may be programmed during gestation. This is very important. And by pro-inflammatory inflammation, hypoxia, or over or under expression of transporters and enzymes, and epigenetic modifications based on changes in the intrauterine milieu. So this is a big danger which you can see could happen. So COVID-19 may cause new onset diabetes also here, and that vertical transmission from mother to may be possible. So these are things which are very important in relation to the pregnancy. Last part, obesity and diabetes. You see here the data that several hundred studies are there, and the recent study is suggesting that 5 to 10% higher risk for COVID-19 hospitalization per every kg of square meter higher BMI. So genetic data occur with hazard ratio increasing by 14% per year. And so BMI to COVID-19 links differ markedly from prior BMI infection associations are further supported as likely caused by multiple biological pathways. So this is very important. You can see here the danger of extra kilos, how this is going to give you the problem for the hospitalization. So this happens. You can see here. So I will say here that this obesity contributes to metabolic derangements, poor vascular health, and greater thrombotic potential, and can also adversely impact lung and renal function. And there may be also indirect links between obesity and COVID-19 outcomes, such as adverse diet-induced microbiome impact on immune deficiency. So what is the mechanism? The systemic factors are there, biochemical factors are there, leading to increased vulnerability of this infection, increased likelihood of severe course of COVID-19, and high mortality rate. So lastly, I will say you various studies are there, and this is showing how even the BMI from 25 to 29, 30 to 30.9, and even 40, how this is changing the risk of critical hazard. So there are clear-cut measures I showed you. So lastly, I will tell the final points that this COVID leading to beta cell damage, cytokine storm, at admission hyperglycemia, worsening of metabolic control in patients with diabetes, and well, I will not say it is documented, but there is possibility of new onset diabetes, which now where more and more data is coming, then we will be able to say it. So lastly, the last point is, my conclusive remarks are that the type 1, 2, and type 1 diabetes are associated with increased risk of COVID-19 related hospitalization and severe outcomes, including morbidity, mortality, particularly in people with poor glycemic control. And recent data has suggested an increased risk associated with development of new onset diabetes following COVID-19 hospitalization. However, long-term follow-up data will determine if this diabetes is permanent. Currently, there is limited data on maternal, fetal, and neonatal outcomes of pregnant women with SARS-CoV-2 infection available. However, the data that exists suggests higher risk of pregnancy complications, including preterm birth and preeclampsia. And lastly, there are several hundred studies provide powerful evidence that the body mass index is a strong linear risk factor for severe COVID-19 outcomes, with recent studies suggesting 5 to 10% higher risk for COVID-19 hospitalization per every kg you get. So I will end here with thank you very much. King cannot kill queen while king is in the check. So think to check the king in COVID-19, that is diabetes and obesity. So I will stop sharing here.
Thank you, Dr. Singh, for setting the stage and understanding the scope of the problem to treat the COVID during the pandemic of diabetes. Sorry, diabetes in the pandemic of COVID. Now we'll carry on with Dr. Arvind Gupta, who will be discussing with us about the management of diabetes. We will discuss about prevention of ketoacidosis, steroid controversy, and of course the mucormycosis that we have. And of course, what I mentioned about telemedicine. It's over to Dr. Arvind Gupta.
Thank you, Dr. Naglur, for your kind introduction. Do you see my slides?
Yes, sir. Yeah. Yes, sir.
Okay, just a minute. And at the outset, I also want to thank the IDEC team, especially very dynamic Dr. Neeta, Dr. Anjali, Dr. Vijay Naglur himself, Dr. Sanjay Agrawal, and all the team for putting the excellent scientific program, which is the IDEC. Now, regarding today's deliberation regarding the management of diabetes during COVID is very, very important thing and very sensitive part, and how to prevent the ketoacidosis by judicious use of insulin. And steroid controversies are definitely there. Previously, we never thought of the high doses of steroids in any disease, and particularly COVID era has shown us that high doses of steroids were used and with good outcome. Of course, with the use of so many steroids and other drugs, the mucormycosis-like things have come up like anything. And of course, Dr. Naglur has set the stage that we need teleconsultation, and Government of India has recently recognized the teleconsultation as a legal thing. So regarding how to manage the diabetes during the COVID, the most important thing is we have to be very careful for the glycemic control. That should be very optimal. I can say not very intensive, but optimal glycemic control is important. And most of the studies suggest that the glucose concentration in the airway secretion is directly proportional to the blood glucose concentration. Hence, the glycemic control is important. And of course, appropriate glycemic control limits the complications associated with the hyperglycemia as well as the COVID complications. And if you want to prevent the diabetes complications, you have to have the diabetes control optimally. Now, before I'll go for the diabetes control, the most important is how to monitor the blood sugar. That is important thing. And most of the protocol, this is AIMS protocol, and which says that if you have no hyperglycemia at admission, but as far as the mild to severe disease, if you see here, you have to reinitiate the blood glucose monitoring several times in a day, just to see at what time the blood sugar rises, and accordingly you have to manage. If the steroids are already on the board, then you have to have a very frequent monitoring. And if steroids are given once a day in the morning, I think it is the afternoon blood sugar or before noon blood sugar is very, very important to control. So depending on the high risk individual, cardiovascular disease, obese, or if elderly patients, you have to monitor very frequently the blood sugar. So self-monitoring of blood sugar as well as the monitoring in the hospital is very, very important. Now, how to start the oral glycemic drugs, oral anti-hyperglycemic drugs. This is very important during COVID. What about the very recent study which is published 1 week before, which says that if you don't have any complications, patient is stable, there is no contraindication for any oral glucose lowering agents. That is the first thing. So if your patients are settled, don't worry about it. But during the mild COVID and some mild hyperglycemia, into that, then you have to see what drugs to be given during COVID. The relatively safe molecule is the DPP-4 inhibitor. I think if a mild COVID patient is not hospitalized or even patient hospitalized in the ward, don't worry, you can very well give the DPP-4 inhibitors, and all DPP-4 inhibitors are okay. Now, to be cautiously given the metformin and sulfonylureas. Metformin for the risk of lactic acidosis, because the patient may not be hydrated, patient may not be taking nausea and vomiting, or some patients are not having good the food, or maybe they are hemodynamically unstable or hypoxia. I think metformin should not be given. Sulfonylureas for the risk of severe hypoglycemia, again, I think you should judiciously give or don't give. Then if the patient disease severity increases, the SGLT2 inhibitors, because of the risk of severe dehydration, and maybe patient may go into euglycemic ketoacidosis. Pioglitazone, again with the risk of fluid retention and edema, I think should not be given. So dear friends, the relatively safe are DPP-4 inhibitors, and patient is having absolutely hemodynamically stable, metformin can be given. Now, the most safe and the better is the insulin. So how to prescribe insulin? If there are contraindications to use the oral glycemic agents, anti-hyperglycemic agents, then definitely during the moderate or severe COVID, you have to give the insulin. There are different regimes for giving the insulin, but I think the better is the basal bolus regime, where you have to give 3 times bolus and 1 basal insulin, and start with lower doses of regarding the 0.4 units per kilogram per day, and then it is individualized. I can't say that you have to start with a very low dose. You can start with when the patient is a severe hyperglycemia, you can even start with a little higher doses of insulin. Of course, deciding the basal bolus component is highly individualized. Now, the target of blood sugar during this period should not be very intensive. I told you we don't want hypoglycemia. Hence, pre-meal should be around 110 to 150, and post-meal should be around 140 to 200. Now, even we are not able to control with basal bolus, I think severe hyperglycemia, high doses of steroids, septicemia is there, patient is having already hemodynamically not very stable. In that situation, I think insulin infusion is the best thing. Start infusion, IV infusion at a dose of 0.05 to 0.1 unit per kilogram body weight, titrate it, up titrate, down titrate as per the blood sugar profile. But again, the target should not be very low, target should not be very high, it should be between 140 to 220 when you are giving IV infusion. So this is why I am telling this is important to prevent the diabetic ketoacidosis also. So you have an IV infusion to start with in a very severe hyperglycemic state. And I think when the patient is now new onset of diabetes, as Dr. N.K. Singh has said, or steroid induced diabetes, into that situation, you can have a very low insulin doses required patient. But if the patient is having already on the board very high sugars, even during the whole day, the fluctuations are there. So you can even combine insulin with the oral hypoglycemic agent. So you can give 1 or 2, DPP-4 inhibitors along with the insulin. So this is how we titrate the dose of insulin as far as the combination of oral hypoglycemic drugs are concerned. Of course, in a severe hyperglycemia, I told you just now, it should be the IV infusion. So dear friends, insulin regime is very, very important during the COVID situations. The basal bolus is the best and safest to start with. And once the patient is controlled, now if patient is, I told you, once they morning steroid that causes the severe hyperglycemia after in the afternoon. In that case, just 1 bolus injection before lunch will be sufficient to control the postprandial hyperglycemia. And of course, the basal insulin can be given in the night. So basal plus regime is also important. Of course, the correctional insulin with or without basal insulin can be recommended. But overall, I can say it is the monitoring of the blood sugar frequently when the patient is having even once a day, twice a day, or thrice a day steroids. So dear friends, the diabetes management revolves around the most important thing is adequate metabolic control is required. Regular self-monitoring blood sugars are very, very important, and sometimes you may require the continuous glucose monitoring. Of course, it is not feasible every time. So, but you have to have a combination of your team regarding the healthcare workers, and of course, sometimes in the patient is not hospitalized at home, you have a very frequent telemedication. COVID-19 vaccination is the most important thing which we have seen. It is a preventive to the serious complications of COVID. Of course, the carefully adjust the regular therapy. So dear friends, good glycemic control, frequent monitoring, stabilize your cardiac and renal station. The nutrition is the most important, it gives the good immunity to counteract with the hyperglycemia and the complication. Regular exercise if possible, meditation, medication, the yoga, along with the physical activity, and of course, self-quarantine during the active COVID is more important. Dear friends, second important thing is the controversies regarding corticosteroids. We all know about this fact that chronic use of corticosteroid leads to 94% higher risk of hospitalization due to diabetes complications. And they require to pay close attention to blood sugar monitoring. I told you there is a unpredictable hyperglycemic fluctuations during the day when the patient is on high doses of steroids. 20 to 50% patients without a previous history of diabetes show hyperglycemia. Dr. N.K. Singh Sahab has just told to us now, and 34% patients with severe acute respiratory syndrome who received glucocorticoid treatment were diagnosed as steroid-induced diabetes. So this is very important thing. How the steroids are helpful during the COVID situations. This is a very well, if you see the mechanism here, it is the glucocorticoid response elements. This is GRE is very important. So glucocorticoids action on the nucleus through the GRE, whether it's a trans activation, negative GRE effects, or trans repression, increases the annexin, increases IHB alpha, SLP1, or interleukin 10, simultaneously reduces the cytokine storm through the decreased NF-kappa B, interleukin 6, interleukin 2, TNF alpha, and so many pro-inflammatory cytokines are reduced by the corticosteroids. Hence, they are very, very helpful during the COVID. And this has been very well documented by a very important study known as recovery study. And recovery study has the first time demonstrated to reduce mortality in one that is instantly available and affordable worldwide, that is dexamethasone. And recovery trial has shown impressive 35% mortality reducing among the sickest patient on invasive mechanical ventilation and 20% reduction of mortality. So I think dexamethasone is very important, and it says that it reduces the 28-day mortality, reduces the duration of hospitalization, and progression to invasive mechanical ventilation. But this is important thing that so many effects of corticosteroids are there. I don't want to enumerate those things, but the important thing is that when to use steroid, that is important thing. Please don't use the steroids in a very, very early stage, because virus replications are there. And if you use steroid very early, then it may increase the replication of the virus. Hence, it is the second or third phase where the hyperinflammatory phase is there, the corticosteroids are being used. So I want to give a real precaution and take home message that please avoid corticosteroid at all costs in the early phase of COVID-19, especially the first 5 days from the symptom onset. This is very important. If they are giving steroids in the first week, I told you, it may actually suppress the body's immunity and lead to hyperglycemia and worsen the spread of infection. So dear friend, the final points are important thing is that the corticosteroids are very, very important drugs during the COVID inflammation. Data from observational cohorts were very inconclusive, of course, but recovery data has shown that the steroids are very effective, especially the dexamethasone. It can be any drug other than dexamethasone, hydrocortisone, or methylprednisolone at the dose equivalent to 6 milligram of dexamethasone to 5 to 10 days will be more than sufficient to use. So injudicious use of steroids are not at all warranted. And if you give, the modern thing is the mucormycosis. I think one of the questions you already asked about the mucormycosis. So people with diabetes with COVID are considered vulnerable to fungal infection already. And if patients are already having high doses of steroids, then it may impair the cellular pathways responsible for mucorales invasion in the diabetes. And ultimately, what is the mechanism? It is the phagocytosis is impaired, as well as the polymorphonuclear chemotaxis, and macrophages are unable to phagocytose the spores which are there of the fungus. Then it leads to a free spores in the tissues. Ultimately, these spores swell and form the buds that elongate into hyphae. And these polymorphonuclear cells are recruited, but impaired oxidative bus activity is associated with fungal growth. So dear friends, this is very, very important. So if the patient is already impaired immunity or cellular pathways, important thing is mucormycosis may develop. And with steroids, most of you have to control the hyperglycemia and monitor. So the time of presentation may be around 3rd week of onset of symptoms of COVID-19. And there were so many risk factors for that. Maybe uncontrolled diabetes, maybe rampant and irrational use of high doses of steroids, maybe new onset of diabetes where the hyperglycemia is very prolonged ICU stay is also important. So there are several risk factors other than the COVID. It is the AIDS, it is the desferoxamine where the patient is, taking iron chelation or something like this, diabetes and malnutrition. So many vague symptoms are there. You have to catch very early, like fever, nasal ulcers, necrosis, periorbital facial swelling, decreased vision, ophthalmoplegia, sinusitis, and headache. You have to control, catch very early these signs and symptoms. And when you see these signs and symptoms, please go for the investigations to see whether patient is developing mucormycosis.
Dr. Gupta, can you please
So I
because,
think, So I think the important thing is the treatment part, timely initiation of the treatment with amphotericin B is very, very important. And there are certain do's and don'ts, especially about the steroid, judicious use of the steroids, timely initiation of amphotericin B and insulin if it is required. I think more important thing. I don't want to give, the only government of India has recently legalized the teleconsultation, but with some limitations. So the COVID has given us the opportunity to have a good teleconsultation, and this Dr. Neglur has already said to us about that thing, but we have to use certain medications on teleconsultation, and certain medication we cannot prescribe, and especially like some of the drugs which are known as the list in the B or prohibited list, you cannot prescribe, like anti-cancer drugs, narcotics, as morphine and codeine, etc. You cannot prescribe. However, anti-diabetic drugs like metformin, glibenclamide, or DPP-4 inhibitors, SGLT2 inhibitors can be prescribed during the teleconsultation, and add on to other drugs also can be prescribed. But you have to see whether some drugs can be prescribed, and then you have to be very well versed with the A, B, and O list, which is already given by the government of India. Thank you very much, Dr. Neglur. I am sorry for if I exceed 1 minute time.
Thank you very much, Dr. Gupta. We are a little running short of time. Purvi, I think it's your turn now to talk about the post-COVID clinical manifestation, vaccines and breakthrough infection, the mental health of these patients, and the future prediction, third wave. I know we're a little short of time, but Purvi, I think you can take 8 to 9 minutes to finish your talk.
Thank you, the dynamic team of IDEC 2021, Dr. Neeta and Dr. Sanjay for having me here. Thank you, Dr. N.K. Singh and Dr. Arvind Gupta for navigating the tracks of COVID-19 and diabetes and running so well and passing on the baton to me. Thank you, Dr. Neglur, sir, for the mastermind behind this evidence-based masterclass, for assigning me COVID-related clinical manifestations post the acute illness, including mental health, vaccination and breakthrough infections, and then prediction of the third wave. So 10 to 35% of patients not requiring hospitalization develop post-COVID symptoms, regardless of comorbidities, and up to 80% of those hospitalized with severe illnesses had persistent symptoms for weeks or months after the initial infection, disrupting work and quality of life. This is nothing but the long-term consequences of COVID-19 ensuing the acute illness, which is now a recognized entity called post-COVID-19 syndrome, described last year and then refined by definition by Greenall et al., calling COVID-19 associated illness extending for more than 3 weeks after the onset of symptoms, and chronic COVID-19 as persistent symptoms extending beyond 12 weeks after the onset of symptoms. Several groups have classified the post-COVID syndrome differently. Becker et al. At University of Cincinnati Medical Center based on initial symptoms, duration of symptoms, period of quiescence, and delayed onset of symptoms from types 1 to type 5. Baylor College of Medicine, Amenta EM at group based on persisting symptoms, organ dysfunction, and even new onset of symptoms, and then so on and so forth. It's a plethora of debilitating symptoms and conditions, fatigue being the commonest, dyspnea, reduced exercise tolerance in particular, and even new onset and deteriorating dyspnea and pulmonary fibrosis. Chest pain, gastrointestinal symptoms, olfactory, gustatory symptoms with loss of sense of smell as well as taste, cardiac arrhythmias, persistently increased BP, myocarditis, sleeping, mental disorders like anxiety, depression, neurological manifestations as well, and cardiovascular disease related to thromboembolic phenomena. In particular, I want to draw your attention to the neurological outcomes. Severe psychiatric and neurological conditions may have been observed in association with Alzheimer's, in particular PTSD, Guillain-Barré syndrome, depression, and also cognitive impairment. In those with Parkinson's and COVID-19 who develop post-COVID syndrome, also there is worsening of motor function and increase in the levodopa requirement. Neuromuscular as well as neurocognitive impairment is the underlying defect which manifests differently. As well, there are several manifestations of profound pro-inflammatory cytokine response and hypercoagulable state. Just one piece of evidence, a retrospective study from the UK, which was recently published, that evaluated 201 low-risk patients, predominantly middle-aged females, with symptoms ongoing at least 4 weeks post the acute illness and recovery from that. When they analyzed through MRI, they found that, so many different organs affected, with at least 70% of them having one organ dysfunction. Multi-system inflammatory syndrome in children as well as adults is also a recognized and a more and more studied entity where patients may present with either shock, cardiac dysfunction, gastrointestinal symptoms, dermatologic or mucocutaneous manifestations, and increased inflammatory markers with distinct absence of severe respiratory illness. And this may be attributed again to endothelial damage and thromboinflammation, and RT-PCR may often be negative in this case. The pathogenesis is nothing but a multi-system infection with neurotropism, lung dysfunction, as well as affection of the pancreatic beta cells over a milieu of prolonged inflammation and cytokine storm, as well as the hypercoagulable state that is caused by COVID. Again, mental health and COVID-19 are well recognized because we know public health emergencies affect the health, safety, and well-being at both individual as well as community levels and bring about or trigger a range of emotional reactions, distress or psychiatric conditions, unhealthy behaviors, or non-compliance with public health directives as well. But in particular, females, elderly, and those with multiple comorbidities are more affected. Anxiety, depression, sleeping disorders have increased in patients of diabetes post-COVID. Manifestations also have included obsession and compulsive behavior, reduced social activity, poor concentration or aggression or irritability, and even an increase in substance use and cognitive defects. Post-traumatic stress disorder is another recognized entity which is increasingly being diagnosed, and diabetes distress definitely worsens in this scenario, decreasing the self-management skills as well as worsening glycemic control, which the previous two speakers have beautifully elaborated on. So future direction, clinicians definitely need to be trained more and more as more and more patients coming out of COVID and in the post-COVID scenario will be seeking our help, and registries need to be set up where we can study the full clinical spectrum of the COVID-19 or post-COVID-19 syndrome. And also vaccination seems to help in this post-COVID symptoms, even though there is no formal study reporting that, but definitely boosting of T cells and other immune responses may help with that. Now moving on, as of 2 days ago, 11% of India's population is doubly vaccinated. And despite this encouraging number, Dr. Catherine O'Brien of WHO has clearly said that no vaccine gives 100% of the people 100% of protection. And we have seen breakthrough infections as well, and typically described by the Centers for Disease Control and Prevention as an infection or the detection of SARS-CoV-2 RNA or antigen in the respiratory specimen collected from a person who is vaccinated, completely vaccinated, and post 14 days of the same. Characteristics: this breakthrough infection may be uncommon, may be driven by virus variants, and may be shorter and milder illness when partially or fully vaccinated patients. but some may be more vulnerable, like the immunocompromised, and it may be attributed to low neutralizing antibodies and lack of COVID appropriate behavior. This infographic gives out a very important message from Houston, Texas, where 130 hospitalized patients were seen. Only 9 were vaccinated, but of those 9, only 2 required ICU admission and 1 required ventilatory support when suffered from COVID-19. REACT study, one of the largest studies from UK involving 98,000 volunteers suffering from COVID-19, they found that unvaccinated people were 3 times more likely than fully vaccinated people to test positive for COVID-19. This is a breakthrough infection. Double vaccinated people in the most recent round were also had 50 to 60% reduced risk of infection, including asymptomatic infection, as compared to unvaccinated people. And those who were fully vaccinated may be less viable to spread the infection to others. 4% as opposed to 8% of the unvaccinated people reported a recent contact with a COVID-19 case tested positive. So with that, again, I want to show you that a New York study recently reported a case report where 2 women with post-vaccination had developed infection, and viral sequencing found that there were variants or mutations found E484K in 1 woman and 3 other mutations of the virus seen in both of them. So this means that the virus is constantly mutating and may escape the immune barrier which is given to us by the vaccine. Again, a few studies have been reported from India as well, but I'll take this one from Vellore, CMC Vellore, where 10,500 employees, 85% of them were vaccinated predominantly by Covishield. And among these, 10% developed infection 47 days after the second dose. Vaccination prevented infection by 65%, hospitalization by 92%, and ICU admission by 94% respectively. Another important report from JAMA last month said that the HEROES Recover Network study showed that vaccines reduce the risk of infection by 90%, and a new analysis in NEJM further corroborated the same findings, with further emphasis on improved recovery with vaccination. The Center for Infectious Disease Research and Policy, a subunit of University of Minnesota, has predicted several patterns of progression of the pandemic, but overall 18 to 24 months at least where significant COVID-19 activity will be seen. Similarly, National Institute of Disaster Management, a subwing of Ministry of Home Affairs, also released their report, and that they earlier said 67% would be required for us to, vaccination would be acquired for us to achieve herd immunity, but that has increased to 80 to 90% of the population to be vaccinated because of the new and mutant variants seen. Amongst others, we have this IIT Kanpur team that published a report in NIDM, which has predicted at least 3 scenarios for the third wave peak.
Neeta, is it possible to wrap you up 1 minute? Yeah.
Just one more minute.
Yeah. Okay.
Despite important experts giving us predictions on the third wave that is going to happen somewhere in this quarter itself. There are also experts who are emphasizing that the states individually need to look at the pattern data because there are geographical and seasonal variations as well. So is Delta Plus a variant driver of the third wave? Possibly, because it has increased transmissibility, stronger binding of receptors in the lung cells, and potential reduction of the monoclonal antibody response found across India, not found sparingly across India and a few countries as well. But we are yet to understand if it does. Is the third wave going to be affecting children more than adults? Well, there is no evidence to say so, but only children, even if they are affected, may have mild and shorter illness and less hospitalization and may recover very quickly. So vaccination is the key, my friends, and we need to increase the vaccination rate from 3.2% to much more. And if that is done, then we will have 25% less predicted cases. And the two main drivers are the slowdown in the rate of decrease in COVID-19 infections and the increase in the R value. R value is nothing but how many people are infected by one COVID positive person on an average. So, of course, encouraging vaccination and COVID appropriate behavior is the key. And thank you very much for this, rapid fire masterclass for me. But thank you very much.
Thank you, Purvi. I know you had to really rush through your slides because of the shortage of time. I think before we close, let me give some conclusions. And first of all, thank you all of you, Dr. NK, Dr. Arvind, and Purvi, for giving the fantastic presentations on the COVID and diabetes. And before we close, the few points, important relevant points is there's no conclusive evidence that the risk of developing COVID-19 is greater in those with diabetes unless it's uncontrolled. But if someone with diabetes develops it, there is a lot of evidence that in-hospital mortality and disease severity can be worse. Lockdown did adversely affect the glycemic control. There are a lot of financial and social reasons for that. And of course, lack of physical activity added to that. The current epidemic has been associated with higher incidence of diabetic ketoacidosis and a new onset diabetes. There's a presentation even in the cell metabolism of the mechanism, how you can get new onset diabetes, published on 3rd of August this year. And lots of opinion, observations, correlations, and hypotheses that we have in the COVID time. There's a time to test these hypotheses, especially if the glucose control can improve the outcomes. With those concluding remarks, I hand over back to Neeta. I'm sorry we short up little time, but I hope sometimes the big topic like this might require a little more time. Yeah. But anyway, thank you very much for this opportunity.
Thank you, Dr. Neeta, and all other IDEC team. Thank you all.
Thank you so
very
much,
much.
Dr. Neeta, Dr. Sanjay, Dr. Anjali, Dr. Archana, all of you. Thank you so much.
Thank me, Purvi.
Dr. Neglur, sir, you're the mastermind.
Dr. Neglur is the mastermind for me.
Thank you all very much. And we shall close this session. Thank you.
Thank you.
So after this wonderful session on an important topic, we have another important topic which needs to be spoken more than what it is currently spoken about. And we have all the people who are my personal favorites and dear friends, Chitra, Tejaldi, Dr. Nitin, Dr. Jayashree Gopal. Looking forward to this wonderful talk, and we are going to have Chitra as the lead of the session. And Chitra is an endocrinologist, a passionate endocrinologist and a dear friend from Bangalore, dealing with hormonal conditions, whichever come to her way in a fantastic manner. And we have been on board for a lot of things together. And over to you, Chitra. I would request you to first introduce your experts and then go ahead with the session.
Thank you so much, IDEC team, for that introduction and for the opportunity. I have 3 star experts with me today. We have Dr. Tejal Lathia. She's a consultant endocrinologist from Navi Mumbai, India, and she's my dear friend. We've been working extremely closely in the last 2 years, and like I say always, she's the find of the decade for me. The second expert that we have today is Dr. Jayashree Gopal. She's a consultant endocrinologist at Apollo Hospitals, Chennai. She's an excellent orator, and we've been running a book club for a while, and Dr. Jayashree is an active participant, apart from all the academic achievements that you can read. And she's going to take us through very important points related to bone health and diabetes today. And last but not the least, the only man on this masterclass, Dr. Nitin Kapoor. He is a professor of endocrinology at CMC Vellore, India. And today he's going to be showcasing much of the work that he's been doing in this area. And we have lots to learn from all the experts. So without much delay, let me quickly take you through why we need to have this topic and why we need to talk about another condition that you'll have to keep in mind while you're providing comprehensive care for your patients with diabetes. Can I request the host to allow me to share the screen, please? Perfect. Thank you so much. So I'm at the end of my brief introduction of about 3 minutes. you should be convinced that you should hang around in this masterclass and pay attention to why we're talking about this. Now, in the previous session, we learned about post-vaccination. We spoke about catering to mental health and anxiety issues in diabetes. And here we're talking about yet another thing that you'll need to bring up to address. And every new point that you have to address in your busy diabetes clinic is minutes taken away from your busy day. But let me provide the context by itself. Osteoporosis increases your risk of fractures, and this is just data related to hip fractures itself. After you have a hip fracture, about 40% of them are unable to walk independently after that, which means it seriously affects their quality of life. The mortality increases by about 20 to 24% in the first year after your hip fracture. About 60% of them require assistance for a year or longer, which means that caregiver burnout is going to be on the higher side. Also, maybe health expenditure. About 33% are dependent in a nursing home, and this is data from the US. But 50% of individuals who have a fracture now are at increased risk of developing another fracture within the next 1 year. So the risk of developing a second fracture is 50% higher. So it's an important factor which could affect not just mortality, also affect quality of life. And if you're trying to look at the risk of fracture in individuals with diabetes, this is the most recent systematic review and meta-analysis published in 2021, which took a look at 22 cohorts of studies, which included close to 64 lakh individuals. And what they found was that presence of diabetes, be it type 1 or type 2, increases the odds of all fractures, but specifically fractures at the hip, both type 1 and type 2. So that's the point that we're trying to get at, that this diabetes mellitus, although it is a metabolic condition, does affect bone health by itself. Now, I want you to pay a little bit of attention to this slide, which is showing you the bone mineral density difference between individuals who have type 1 and type 2. Bone mineral density is one of the most important tools that we use to look for osteoporosis. Lower the bone mineral density, greater your risk of fractures. If you notice in the first bar, which is type 1 diabetes, the bone mineral density is lower as compared to individuals who are controls. But if you take a look at individuals who have type 2 diabetes, be it men or women, the bone mineral density remains the same as controls. So in the previous slide, I told you that the risk of fractures is increased in individuals irrespective of the type of diabetes. But in the second slide, I'm now telling you that the bone mineral density seems to be same in individuals with type 2 diabetes, but the fracture risk is definitely increased. So which essentially means that there is some risk of fractures which is not truly captured by BMD. And that's going to be a point which we're going to speak about a little bit more and try and learn how the diagnosis of osteoporosis in individuals with diabetes might be evolving rapidly. And in the last few years, there's a lot of work that has been done. This is a slide which is trying to temporarily tell you the changes which happen to your bone mineral density with age. So all of us gain up peak bone mass by the time we reach adult life, and from there on, there is a drop in your bone mass with age. By around menopause, women see a sharp drop in bone mass, whereas men continue to lose it gradually overall. Now, the presence of diabetes does overall blunt the amount of bone mass that you have. And this is data from children who've been diagnosed with type 1 diabetes. But the point I'm trying to make is that there's a progressive loss in your bone mineral density with time, which means that the risk of fractures also increases with age. So whether it is men or women, your risk of fracture increases sharply by around 65 years of age with women, and by about 70 years in men. Now, diabetes accelerates the onset of fractures in both men and women, and we are going to talk about a potential amend to the age at which we begin screening for osteoporosis, especially in individuals with type 2 diabetes. And take a look at this graph, which is trying to show you that the prevalence of diabetes broken up according to age groups. If the prevalence of diabetes overall is about 9% or 10%, As we see individuals who are greater than 60 years of age, you see that the prevalence goes up to 20%, which means every 1 in 5 individual over the age of 60 years, be it man or woman, could have hyperglycemia. So the connection between the two are the same. Both diabetes and osteoporosis are highly prevalent. The risk of both of these conditions increase with age. Both of them are usually silent and asymptomatic unless you're actively looking for it. And both of them come with serious consequences and mortality risk increase. Diabetes by itself does contribute to osteoporosis, and that is what Dr. Tejal is trying to, will be speaking to us next. Certain complications related to diabetes like vision or loss of balance or presence of neuropathy does increase your risk of fall and fractures. We also have the thorn that we don't want to talk about, which is drugs, which are used for diabetes and their risk for fractures. So, and it's also important to remember all the time that osteoporosis is not just a disease that affects women, it's also something which is plaguing men as well. So with that, we'll move on now to talk about how to assess bone health in individuals with diabetes, what are the changes that we are looking at, the relationship between diabetes and osteoporosis, management strategies, and what the latest guidelines are looking like. So to discuss these important topics, I welcome our speakers. The first speaker for the day is Dr. Tejal Lathia, and she will be talking about the connection. While Dr. Tejal Lathia is sharing her screen, I'll request the audience to be typing in your queries into the chat box, and we will be taking questions at the end of the session. Over to you, Dr. Tejal.
At the outset, thank you, Dr. Neeta Deshpande, for the kind invitation. It's my first time at IDEC 2021, and it's really great because Dr. Anjali is here, who's a dear friend. And Anjali, all of our MBBS friends are actually coming to my house today, so you would be glad to know. I wish you could be here. So Chitra has set the stage by telling us why is it important to talk about this topic at all. And she's also talked about the difference in the bone health in people with type 1 diabetes and type 2 diabetes. So I know that my eyes should be on the clock, and I have roughly about 8 to 10 minutes to finish my presentation. So it is not possible for me to go into the depths of the pathophysiology of diabetes and how it impacts bone health. What I would rather do is give you an overview of what are the critical points where diabetes impacts bone health. And then Dr. Jayashree Gopal and Dr. Nitin Kapoor will tell us more practical issues of how to assess bone mineral density and how to treat it. I think this slide is very important, that we need to start thinking about skeletal deterioration as one more complication related with diabetes. All of our focus is on microvascular complications and macrovascular complications of diabetes, but skeletal deterioration as an inevitable complication of diabetes is something that we usually kind of put at the back of our mind, even though we are aware of it. So what I'm going to do is I'm going to start with my take-home message first, because that will also help me. So this is my agenda come take-home message. What we need to understand is that not only is the risk of fractures increased in people with diabetes, but also the fracture healing is delayed in people with diabetes. So there are two aspects to this, that yes, a person is more likely to get a fracture, but also that the fracture is likely to take longer to heal. The second point, which already Dr. Chitra made, and I cannot emphasize enough, is that people with type 1 diabetes have a much greater risk of a fragility fracture as compared to people with type 2 diabetes. So our type 1 diabetes patients do require extra focus, and we need to look more closely at their skeletal health. A BMD assessment underestimates the risk of fracture. And I was going to put this slide, and I'm glad that Dr. Chitra did, that if you look at the bone mineral density in people with type 2 diabetes, often the bone mineral density is normal. However, the risk of fracture is increased. In people with type 1 diabetes, there is a reduction in the bone mineral density. However, the risk of fracture is disproportionate to the reduction in bone mineral density. So increased risk of fractures, delayed fracture healing, type 1 diabetes being at greater risk as compared to type 2 diabetes, who in turn is at greater risk than the general population. BMD alone underestimates the risk of fracture. And the mechanism by which diabetes affects bone health is not only the direct effect of glycemia, but there are a lot of indirect effects we must consider, the comorbidities which are associated with diabetes. Like in type 1 diabetes, you have celiac disease, rheumatoid arthritis, vitamin D deficiency, as well as the impact of the medications that we give for diabetes, which also have an impact on the bone health. Type 1 diabetes, if you look at the relative risk, there's a 5 to 6 times increased relative risk of having a fracture as compared to the general population, while the risk in type 2 diabetes is up to about 2.5 times as compared to a general population. What is very interesting is that the healing time is increased by almost 87% in somebody with diabetes as compared to somebody who does not have diabetes after a fracture. And one very important point which we often don't consider is that when there's a hip fracture in somebody with type 2 diabetes or type 1 diabetes, they're hospitalized for the same. Around this time, these people are also at a greater risk for cardiovascular events. We all know that falls have a lot to do with the risk of having a fracture. And in diabetes, we have a myriad of reasons why these people are at risk for falls, but mainly they can be divided into vision-related problems, cataract, retinopathy, hypoglycemia, blurring of vision, fall, or it could be gait and balance related problems, peripheral neuropathy, foot ulcers, frequent visits to the bathroom. An elderly patient can't rush to the bathroom, stumbles over something which is there in the night, has a fall, and then has a fracture, and delayed reflexes. However, just the bone mineral density along with the falls still does not explain the disproportionate increase in fragility fractures that people with type 2 diabetes often have. So then how do you explain it? And I think the two words which explain the entire pathophysiology is bone quality. We all talk about bone mineral content and the calcium content of the bones, the bone mineral density. We talk about all of these things very often. But there's a lot more to the bone except only that. There's a lot to do with the protein and collagen content. What is the secondary structure of this collagen? What is the microstructure of the bone? What about the bone cell activity and the dynamics? All of these things contribute to bone quality. And of course, in diabetes, because of the accumulation of advanced glycation end products, like every other tissue in the body, bone is also affected with it. And the two words which explain the pathophysiology and the impact of diabetes on bone health is bone quality. I think we're so fortunate to live in this time where this is a latest paper published from India in our premier endocrinology journal by Dr. Sanjay Pedada's group, where they've actually looked into bone biopsies, looked at the mechanical, material, and compositional determinants of human trabecular bone quality in people with type 2 diabetes. So what they did is, in a person with type 2 diabetes who has had a fracture, they've actually taken a bone biopsy and looked at the determinants of bone quality. There's a lot of complicated procedures that they subjected the patients to, which I won't go into. But what they surmised is that hyperglycemia's detrimental effect on trabecular bone quality occurs at multiple scales. And all of these together reduce the ability of the bone to absorb the impact of the fracture. So there's lower energy absorption, and the toughness of the bone is compromised in people with type 2 diabetes, which indicates an increased propensity to bone fragility. So bone quality, reduced toughness of the bone, less ability to absorb energy, and therefore the increased risk in bone fragility. It is not only the trabecular bone that is affected, but if you look at this is controls, and this is people with diabetes, and the cortical porosity is also greatly increased. And these small things, that is the trabecular bone quality, as well as the increased cortical porosity, is not captured by a simple DEXA scan. And I know Dr. Nitin Kapoor is going to talk about other ways that we can assess bone quality over and above a DEXA scan. I don't want to think that only India has the copyright on exploring with bone quality, and there's data from across the world where microindentation techniques, which look at the material strength of bones, shows that in people with type 2 diabetes, either not adjusted for BMI or adjusted for BMI, shows that the bone material strength of people with diabetes is less than that of controls. So is it just the bone quality? Is there anything else? So bone quality definitely over and above bone quantity determines the risk of fractures that people with diabetes have, as of course the risk of falls as well. Can we go just a very little bit deeper in the next 2 to 3 slides? And we look at type 1 diabetes, where of course hyperglycemia, but also hypoinsulinemia with a drop in IGF-1, which is responsible for bone turnover and increasing bone mass, is affected. Autoimmune inflammation that often accompanies people with type 1 diabetes, be it celiac disease, be it rheumatoid arthritis, or any other autoimmune condition which accompanies type 1 diabetes, will also impact the bone quality, and of course, vitamin D. So ultimately in type 1 diabetes, one important point which is different than type 2 diabetes is hypoinsulinemia, which contributes along with the other factors and autoimmune inflammation. All of this together reduces bone strength and quality, impacts bone mineralization, and increases the risk of fractures. And of course, the younger the age, greater the duration of diabetes, presence of other complications requiring large doses of insulin, lower body weight, compromised renal function, all of these together over and above the lower bone mineral density that these people with type 1 diabetes has, impacts the risk of fracture. Just one last point that I wanted to make before I move on from type 1 is that, as Dr. Chopra showed a beautiful graph, that in people who have diabetes early, that's exactly like type 1 diabetes, because the hyperglycemia comes at a very early age, there's an impact on the mesenchymal stem cell proliferation, and less mesenchymal stem cells will proliferate into osteoblasts, which will impact the accrual of peak bone mass. So the point I'm trying to make here is that at the start of diabetes, people with type 1 diabetes, because if they get diabetes prior to their pubertal stage, they start out with a lower bone mass. And then obviously, as the diabetes years continue, greater and greater impact is then there on this bone mineral density, which worsens. That is why it explains that 6 times increased risk of fracture. So not only did we start with lower bone mass, but then because of diabetes, the bone mass deteriorates quicker. And the point that I already made, that the celiac disease and the rheumatoid arthritis, the lower body mass, are additional factors. In type 2 diabetes, just one point which is different, how in type 1 diabetes, lower insulin levels, lesser IGF-1 was a unique point with autoimmune disease. In type 2 diabetes, the inflammatory cytokines which are generated from our adipocytes, so the fat mass, visceral fat, generates a lot of inflammatory cytokines which have effects on the osteoblast and the osteoclast as well. If I could explain with this diagram in very short, the adipocytes, the inflammatory cytokines, lead to a lot of reactive oxygen species. Now, this reactive oxygen species affect the mesenchymal stem cells, and instead of becoming osteoblasts, more and more of them become adipocytes. So what happens is the adiposity in the bone marrow also increases. Of course, there is an effect of this reactive oxygen species on osteoblasts, its ability to make collagen, its ability to respond to insulin, IGF. So this ultimately will lead to decrease in the bone turnover. And of course, vitamin D, PTH, the hyperglycemia have their own independent effects. But in type 2 diabetes, the adipocytes, greater proliferation of adipocytes in the bone marrow, lesser amount of mesenchymal stem cells, and the chronic inflammation that is there in a person with type 2 diabetes has its own unique impact on the risk of bone density. So I would like to go back to this slide, which says that basically it is the quality of the bone, the quantity of the bone, both of whom, along with the risk of falls, will increase the risk of fracture fragility. I'll just finish in the next 2-3 minutes. So one thing that we don't consider in people with type 2, when we're treating people with diabetes, is the effect of anti-diabetic drugs on bone metabolism. There are a lot of studies out there which have looked at the effect of individual drugs on bone mineral, on bone markers, and on bone mineral density, and the risk of fractures. And if I just can take your attention to the last column, in metformin, the risk of fractures does not seem to be disproportionately increased. Thiazolidinediones, especially when we're prescribing them to postmenopausal women, we have to be cognizant of the fact that they do impact the risk of fracture. With sulfonylureas, there is conflicting results, but I think the risk of hypoglycemia with sulfonylureas does impact the risk of falls and the increased risk of fracture. With GLP-1 receptor agonists, there isn't enough data. DPP-4 inhibitors seem to be neutral, but our new blockbuster drug, which we all are talking about, there is again conflicting conflicting data. There's some data which suggests there's an increased risk of fractures, some data which suggests it's neutral. And I think time will tell us what is the long-term impact of SGLT2 inhibitors on the risk of fractures. Insulin, of course, because of the risk of falls, hypoglycemia will also increase the risk of fractures. So not only must we look at whether it is type 1 or type 2 diabetes, we should look at what are the associated features like celiac disease, rheumatoid arthritis. We have to consider autoimmune inflammation, chronic inflammation because of adipocytes, as well as the impact of anti-diabetic drugs on bone metabolism. So I had a lot of help from a host of review articles and original work that I had, which I referred to. So to end my presentation, I will just reiterate my take-home message. Yes, there's definitely an increased risk of fractures, but we must also remember delayed fracture healing. Type 1 diabetes is disproportionately affected. And now we know that in type 1 diabetes, because the peak bone mass, which is accrued right at the time of puberty, is lower, as well as because of the lack of insulin and its anabolic effect on bone, that affects and increases the risk of type 1 diabetes patients having a fracture. Type 1 diabetes patients have about 5 to 6 times increased risk of fracture as compared to the general population. In type 2 diabetes, again, the risk of fractures is increased. In type 2 diabetes, we must take into account the effect of medications that we use for the treatment of diabetes. We're clear that bone mineral density, of course, is very important to ascertain fracture risk, but we must remember that bone mineral density assessment alone underestimates the risk of fracture, and the risk of fracture in people with diabetes is disproportionately elevated. There is a direct effect of glycemia, not only on the collagen and the cross-linking of collagen, not only on the bone mineral density, but there's a direct effect on osteoblasts, on mesenchymal stem cells, and the bone marrow adiposity in type 2 diabetes. We must always remember the associated conditions which go hand in hand with type 1 diabetes, and we must now henceforth think of skeletal deterioration as one more complication of diabetes that we must always take into account. Thank you so much.
Thank you, Dr. Tejal, for that beautiful summary of the impact of diabetes on bone health. And thank you for reiterating the take-home messages. I think it's quite clear. We'll now hand over to Dr. Jayashree Gopal to take us through the assessment of bone health in individuals with diabetes and briefly present the treatment options that are available. Over to you, Dr. Jayashree.
Thank you. So I'm going to be talking predominantly about management. Dr. Nitin is going to be touching upon methods of assessment and 1 minute. Sorry, I'm just trying to share my slides. Yeah. Very briefly in the next few minutes, and I have turned my timer on, I'm going to be talking about management of osteoporosis in people with diabetes. And is it different? I think we had a good lead-in into this topic with Dr. Tejal's talk. And before I start, I would like to thank Dr. Neeta and the organizers for inviting me to Idec this year. And very happy to be sharing the platform with very illustrious speakers and very good friends. Thank you. So when we look at the management of osteoporosis in general, I just want to talk about this, little slide, one slide. Any person who presents with either osteoporosis or a history of fragility fracture or a high probability for a fracture, I think one of the most important things as endocrinologists we need to do is to evaluate for causes of secondary osteoporosis, make sure we address the calcium and vitamin D deficiency, and recommend pharmacological therapy. I'm not going into detail about this, but if they have a very high risk or a prior fracture, the recommendations are slightly different from if they've not had a prior fracture. This is not the purpose of the talk, but one of the things I did want to mention was after we start the specific therapy, whether we're going to be using the bisphosphonate or whether we're going to be using biologics like denosumab, we do need to reassess yearly for the response to therapy. And depending on the type of therapy that is used, so if you're going to be using bisphosphonates, then at the end of 5 to 6 years, it is recommended that we give a break and assess therapy and see if the benefits on bone mineral density is maintained. If you're using biologics like denosumab, then the therapy needs to be continued for as long as we assess that the risk of osteoporosis and fracture is there, which pretty much is going to continue. So this is roughly the therapy that is recommended in all people with osteoporosis or with a high, with a history of a fragility fracture. Now, is it any different in people with diabetes? And the brief answer is no. The general management principles are the same. However, what we do need to be aware of is something that Tejal had referred to. It's very important that we consider that managing the blood sugars, getting the glycemia under control and reducing inflammation is as important as the specific anti-osteoporosis therapies in terms of reducing fracture risk. So ensuring good glycemic control is very important. Regular exercise, as I will show you in a slide, what is consistently turned up in the studies that have looked at osteoporosis and fractures in people with diabetes is that the people with diabetes tend to exercise less, and this itself puts them at a higher risk of not only poorer glycemic control, but also higher risk of a fracture and lesser bone quality. Adequate vitamin D replacement, and what we need to keep in mind in people with diabetes is that a lot of times people who are obese with a high BMI are going to require a higher than normal or higher than recommended vitamin D doses to maintain the vitamin D levels above 30. And there is some association between lower levels of vitamin D in people with diabetes. So ensure that the person with diabetes with osteoporosis or fracture, check the vitamin D, ensure we give adequate, more than adequate replacement. The weight and BMI is what I would consider Goldilocks. You need to have the weight just right. As Tejal pointed out, too low is also bad and too high can be misleading. So if the BMI is high, remember that the BMD estimate that you get can be misleading. So as always, it's important to keep the weight in the correct Goldilocks zone, not only for the diabetes, but also for the BMI and fracture risk. And of course, there needs to be a proper intake of dietary protein and fiber, which also contributes to bone health. So specifically in diabetes, I think one of the most important things is exercise and vitamin D replacement. One of the questions that I had when I was starting to prepare for this talk was, are anti-osteoporosis therapies less effective in people with diabetes? And there is actually surprisingly very little data available, but this was one of the earliest studies that was done using bisphosphonates with diabetes. And when they looked at the subgroup of people with diabetes, a fracture intervention trial, it came out more than about 15 years ago, looking at the effect of alendronate in reducing the risk of osteoporotic fractures. And if you look at the baseline data, what it showed was that the people in the diabetes group were more likely to have had more days in bed. So more likely to have been sedentary, less exercise, with less physical activity. So that itself, a priori, puts them at a higher risk of having a lower BMI and developing a fracture. So this is something we always need to keep in mind when we are treating people with diabetes. If you look at the response of the people with diabetes, women with diabetes responded to alendronate with similar increase in the lumbar and the spine BMD as the non-diabetes group. So that was not, that did not change. And if you looked at bone turnover markers, also they responded similarly in both groups, in the diabetes versus the non-diabetes group. So at first look, it does seem that the people with diabetes respond the same to at least the bisphosphonates. We do not have data with zoledronic acid, which is probably the bisphosphonate that is used most commonly along with alendronate in our country for treatment of fractures. There isn't a subgroup analysis that I could find looking at zoledronic acid. There is some data with denosumab. So they took a subgroup of people from the big trial with denosumab, which was the Freedom trial. And out of the total number of people in that group that was treated, which was 7,800, they took about 500 people with diabetes and they did a subgroup analysis. And what they showed was that the improvement in the lumbar BMD, in the hip BMD or the femoral neck BMD was not different whether we looked at the group with diabetes or the group without diabetes. So at least in terms of the improvement in the bone mineral density, there is no difference. And that has to be reassuring for us in people with diabetes as compared to non-diabetes. And if you look at the reduction in fracture risk, the reduction for new vertebral fracture was the same in the denosumab group in the people with diabetes as compared to the non-diabetes group. However, the risk of non-vertebral fractures actually seemed to increase in the group that was put on denosumab. So this was a little bit worrying data, but the risk, if you sort of look at the whole non-vertebral fracture group, then the risk of fracture was seen to be increased, but the hip fracture was reduced. So that is again reassuring. And if you look at teriparatide, again, one study which looked at a subgroup analysis, and what that showed was that the risk of reduction of fractures with the use of teriparatide was the same in the people with diabetes after the first 6 months. So with teriparatide, we need to remember that the risk of fracture reduction does not happen immediately. It only happens if we keep them on it and look at the data for more than 6 months. So when we are looking at using recombinant PTH or teriparatide, the duration of therapy becomes important, whether it is in diabetes or the non-diabetes group. The improvement in the bone density was the same in the spine and in the femoral neck, and symptomatic treatment and tolerability was the same, whether it was the diabetes or the non-diabetes group. This systematic review, which looked at the efficacy of anti-osteoporotic medicines in both type 1 and type 2 diabetes, basically the bottom line was that the improvement in the bone density was seen across all of the commonly used anti-osteoporotic therapies. So whether it be the bisphosphonates, the SERMs, or denosumab or teriparatide, the bone mineral density did increase. The risk of fracture was not different from the non-diabetic group. However, the only it was either the same or it was slightly less compared to the non-diabetic group. So overall, to answer the question that I had posited, are anti-osteoporosis therapies less effective in diabetes? Overall, the answer is no. The only sort of note of dissent that comes is for the non-vertebral fractures with the use of denosumab in the FREEDOM trial. But again, that was a very small subset of a relatively small population. But I think it drives home the point that Tejal was making, that we need to address inflammation in people, particularly with type 2 diabetes, if you want to realize the full benefits of anti-osteoporosis therapies. And apart from just putting them on the bisphosphonates, we need to keep in mind that we need to prevent recurrent falls. And people who have had long duration of diabetes, that itself is a risk factor for fracture. So people who have had diabetes for 20, 30 years, we need to be extra careful about making sure that we maintain their bone strength. So people who have had diabetes for 20, 30 years, make sure that we give them adequate calcium, adequate vitamin D, make sure that we do not increase their risk for falls. And there was some question in the literature as to whether osteoporosis therapies per se have any effect on glycemic or metabolic control. And the brief answer is no. I'm not going to talk about this. But I do want to talk about this a little bit. Do we need to modify anti-diabetes therapies after a fracture? If so, how? And again, this is from that review paper, which looked at the effect of the commonly used anti-diabetes therapies on effects on bone mineral density and risk of a fracture. And what we can conclude at the end of it was that metformin, if anything, has a beneficial effect, probably because it reduces inflammation, helps to reduce weight, and because of the glycemic control. So after a fracture in a person with diabetes, we can continue. It may actually have some benefit in helping bone density and reducing the risk of a fracture. Sulfonylureas, you will continue, but make sure that we reduce the risks so that we don't have a hypoglycemic episode, which may lead to a fall. So that is what we need to keep in mind with sulfonylureas, but overall it does not reduce bone density or it does not increase the risk of a fracture. There is no data specifically with alpha glucosidase inhibitors. Probably we can continue with this after a fracture. DPP-4 inhibitors, again, shown to be safe. It does not alter BMD. It does not increase the risk of a fracture. We can continue after a fracture. With SGLT2 inhibitors, again, we have to be a little bit careful because with CANA, the initial CANVAS trial did show an increased risk of a fracture. However, with subsequent Credence and the CANVAS-R studies, it did not show any increased risk of a fracture. However, any person who is on CANA, who's had a fall or a fragility fracture, severe osteoporosis, consider if we can consider either changing the SGLT2 inhibitors. DAPA, the trials with DAPA and MPAR did not show any increased risk of fracture. With all of the SGLT2 inhibitors, what we need to be careful is to make sure that they do not fall, so reduce fall risk. GLP-1 analogs may be beneficial for the bone, similar to the DPP-4 inhibitors. Certainly, we can continue after a fracture. Insulin, definitely continue, but reduce the risk for a hypos and a fall. I'm just going to summarize now. So the general management principles for management of osteoporosis and fractures in people with diabetes is same as the non-diabetic population. Emphasis is more on glycemic control and reducing inflammation. Always keep in mind whether the medications we are giving is going to cause a hypoglycemia or increase the fall risk, and thereby modify the anti-diabetic therapies after a fracture or after a diagnosis of osteoporosis. I shall stop here and answer questions after all the talks are over. Thank you very much.
Thank you, Dr. Jayashree, for that reassuring talk on management strategies for osteoporosis in individuals with diabetes. And now invite Dr. Nitin Kapoor to talk to us about what the latest guideline tells us about diabetes and bone health. Over to you, Dr. Nitin.
Thank you so much, Chitra, and thank you, Dr. Neeta, for this kind invitation. It's always good to be back at Idec. I remember about 2 years ago, Dr. Chitra and myself did a workshop on osteoporosis at Idec in Pune, and I think it was very well attended. And ever since, the flyer for this particular masterclass has gone on the social media platform. There has been a lot of interest. I know of colleagues from Australia, China, and a lot of friends from India who logged in for this masterclass in particular. And over the next 7 minutes or so, I shall take you through what do the latest guidelines tell us. And of late, very recently, we have the Indian Society of Bone and Mineral Research who come up with their position statement on diagnosis and treatment of osteoporosis. And this specifically highlighted the important aspect of diabetes as an important risk factor for osteoporosis. So conventional teaching, I think all of us, what we've learned is that there are modifiable risk factors, there are non-modifiable risk factors. In short, we know that an elderly postmenopausal woman is at high risk for developing a risk factor. We know the modifiable risk factor, the vitamin D, the calcium, rheumatoid arthritis, steroids. But today, type 1 and type 2 diabetes have emerged as significant risk factors, and this is well cited in the guideline. But the point that has been highlighted so far is that the bone mineral density may not be as low in people with type 2 diabetes, despite having a high risk of fracture. So how do we go about this assessment, even though they are at high risk of fracture, but the BMD does not tell us the truth? And when we look at the other guidelines, and this is by the American Society of Bone and Mineral Research and the ISCD, these guidelines again published this year in April 2021, and their statement is that we should not look at BMD alone, but look at something called the trabecular bone score in people with diabetes, and that will tell us the actual truth. So what is TBS? It's basically nothing very fancy, something that comes out of the same DEXA machine that we use for BMD. It's just an additional software, no extra time. It can be retrospectively recruited from the BMD images. And when we look at the cutoffs, what we know is a value which is less than 1.2 is considered as degraded bone microarchitecture. So is there data with respect to that from India? And we recently published data in about 200 postmenopausal women with type 2 diabetes from our center. And what you can see in this slide is that the BMD in people with diabetes, in women, postmenopausal women with diabetes, is similar, rather even higher in people with diabetes, but the trabecular bone score is much lower. About 33% of these women had fracture, but 50% have low TBS. So TBS is an important marker. Trabecular bone score is an important DEXA tool that we can use to assess the true aspect of bone health. Yes, hip structure analysis is another way, but that's not very commonly available. Something called as buckling ratio. If it is high, it tells us poor bone health. But yes, do not look at BMD alone. The fracture risk is high, and trabecular bone microarchitecture is something that helps us. So what if we change our gears and we were talking so far of a person with diabetes coming to our clinic and we are evaluating for osteoporosis, but what if a person with osteoporosis comes to the clinic and we need to evaluate that patient? And yes, we always ask for calcium, phosphorus, we ask for vitamin D. But today in the ISBMR guidelines, inclusion of glycemic status has also been written as something that is part of secondary osteoporosis evaluation. So if you have an elderly patient with osteoporosis, yes, you evaluate everything for bone. Yes, you're supposed to screen probably everyone in that age for diabetes, but specifically for secondary osteoporosis, you can do that. The common way that in clinic we assess osteoporosis is using the FRAX, but here again, there's a setback, and this is the ACE guidelines again published in May last year. and they have told that the FRAX also probably underestimates the fracture risk, and therefore the FRAX has a facility to incorporate the TBS value, and if you have that, probably that will help. But more recently, literature is suggesting that we can change the FRAX in a way that we can use it for people with diabetes. How do we change FRAX? Now, if you remember, the FRAX has several risk factors. One of them is rheumatoid arthritis. It has been suggested to replace the rheumatoid arthritis with diabetes. FRAX, when we add TBS, tells us a true value. When we and that will tell us the right risk, or we reduce the age that we are entering in FRAX by 10 years. Yes, the ISBMR guidelines has taken note of that, and today they suggest that we should start treatment in people with diabetes. If you're not even looking at FRAX, just a T-score, not at -2.5, but at -2, at a lower threshold. And similarly, treatments like we always know that people who are taking steroids, we need to treat them for osteoporosis while they're osteopenic. Diabetes has also been included as an important risk factor to consider for treatment when they already have osteopenia or low bone mass. Talking about treatment, Dr. Jayashree did mention very nicely, yes, we have to avoid certain anti-diabetic agents. Some are beneficial more than the others, but a very recent ECNA article on treatment of osteoporosis tells us that there is more data that is required in this field. Recently, in the Trendo conference, which was led by Dr. Jayashree, there was an interesting poster from JIPMA, which looked at the zoledronate effect on people with diabetes. And so, yes, there is data emerging, but as of now, by and large, the treatment remains the same. In conscious of the time, I think I'll stop here and we'll take questions. Thank you.
Thank you so much, Dr. Nitin, for being sensitive to the time constraint. But if I can quickly ask you a question, how do I source the software to calculate the TBS score on my DEXA machine? Is it compatible with all DEXA machines?
Right. So it depends on the kind of machine that you have. We need to contact the vendor. So we use the Hologic machine here in Vellore, and Hologic does provide the TBS software. It needs to be incorporated in the same machine. It's nothing very fancy, nothing very big, can be done in most machines.
And what is the cost like, Dr. Nitin?
Right. So cost would vary again based on the model that you have, but yes, it is costly to the scale of around 5 to 10 lakhs, depending on the machine.
Okay, all right. Thanks for that bit of information. If I can ask Dr. Jayashree a question. So the guidelines do recommend that we change the T-score cutoff to -2 in individuals with diabetes. Have you been implementing that in your practice, ma'am? And what are your thoughts on that?
Actually, I was going to ask Nitin that question. I have not. Honestly, I have not. And I think it is about time we do it. I should start doing it. I have not really been doing it. We're just so used to, as you know, looking at the bone score from the -2.5 aspect that and what do you think, Nitin? Is it time that we start doing that?
Yes, I think we've started doing it off late, and I think it makes a huge difference for those patients because the fracture risk is definitely high. And I think what has been said in all the 3 talks, I think what I really want to highlight is that the bone fragility is just one aspect in diabetes. We have to look at the big picture of complications, risk of falls, retinopathy, neuropathy, and all that adds up as a big misery. So I think we should.
Okay. If I can ask another question to either of my experts, when we looked at the cascade of management of osteoporosis, Dr. Jayashree, in the slide, you had broken them down into very high risk and high risk, right? And then the treatment protocol was different. So on what basis do we do that segregation?
So that's just partly to do with the T-score. When the T-score is very high, then we consider it a very high risk. Or if a person has had a fracture with a relatively normal T-score, then that also puts them at a high risk. So what we call a fall from a standing height. So someone who just say trips over in the house and falls. So every time a person comes in and says they have had a fracture, the question always should be, how did you get the fracture? So if they say, I just fell from some of them, they just fall down from 1 or 2 steps and they had a fall. So a fall which normally should not cause a fracture, but causes a fracture is for me a consideration for a fragility fracture, among other things. So these two are the most common ones that we see in the clinic, either a very high T-score or a fracture after a fall from a standing height.
All right. So Nitin, inputs any different from Dr. Jayashree's?
No, I concur completely.
Perfect. So I have 15 seconds and I'm going to attempt to summarize. Diabetes and osteoporosis are both silent illnesses and they increase in prevalence with age. We have understood the relationship between diabetes and its effects on bone health by itself. There is a recommendation to reduce T-score cutoff to -2 in individuals who have type 2 diabetes. There's also a recommendation to add trabecular bone score to your diagnosis methodology when you're using your DEXA machine to assess for osteoporosis in individuals with type 2 diabetes. And of course, treatments which are available for management of osteoporosis are just as effective in individuals with type 2 diabetes. And thank you so much, Idec team. Thank you, my stellar speaker. And I hand back over to Dr. Neeta Deshpande.
Thank you. Thanks, Chitra.
Hello. Thank you so much, Chitra, Dr. Nitin, Dr. Jayashree, Dr. Tejal, for this wonderful subdivision of the topic, wonderfully coordinated EBM masterclass, and a very wonderful and precise message to be taken to the clinical practice. Thank you so much. I hand over Neeta to you for the next session.
Yeah, thank you. We have just had a wonderfully crafted masterclass, and I'm sure our delegates are very happy about it. It was about bone health in type 2 diabetes. Now we cut across to the other very important part in diabetes, and that is type 1 diabetes, and specifically to address certain issues that are not always addressed. And for this type 1 diabetes masterclass, the forgotten issues or the not talked about issues, we have with us a very robust panel, and that is being led by none other than Dr. Sujoy Ghosh. May I have his introduction slide coming up, please? Yes, he actually needs no introduction. He is an endocrinologist in the field of endocrinology and diabetes. He is very much a big presence on the Indian scene. He's a consultant in the Department of Endocrinology at the AMRI hospital in Dhakuria, and he has huge experience. And I'm going to hand over this session now to Sujoy so that he also introduces his expert speakers on his panel, and I ask him to take this forward. Over to you, Sujoy.
Thank you, Dr. Neeta, for that kind introduction. And it's indeed a pleasure to be part of such a wonderful conference and be part of such a wonderful team that I have for today's session. And without wasting much time, we are going to talk about type 1 diabetes and the issues that we usually do not discuss, because whenever we talk about diabetes and when we discuss about issues of type 1 diabetes, it's mostly about monitoring, how to have healthcare access, weight gains, growth, and stuff like that. So we are going to first talk about the first issue that's not talked that much is about non-insulin therapies. We all know that insulin is the backbone of therapy for management of type 1 diabetes. But what about the other anti-hyperglycemic agents that we could possibly use? And to talk on that, I have none other than Professor Vagish Iyer, who's an endocrinologist that all of India knows. He's had great publications, great teacher. Over to you, Dr. Vagish, for your bit on non-insulin therapies.
Thank you, Sujoy Ghosh, for your kind introduction. Thank you, Neeta and Dr. Anjali, for your invitation. Next, can I share my slide? I think I need a permission to share.
We introduce the other speakers as we go along.
No, yeah, I got it. Yeah. So next 7 or 8 minutes, I'll take you through a journey of non-insulin therapies for type 1 diabetes. We know that type 1 diabetes results from beta cell destruction. Insulin therapy is a cornerstone in the management, but it has its own limitations and drawbacks. That's why I think everybody was thinking something much more than the insulin can be given for these individuals, which are used in even other types of diabetes. So what are these drugs which are commonly used so that we can implement in patients with type 1 diabetes? The most common one which was thought of was a metformin because it was available for a long time. But The trials involving metformin in type 1s are very, very limited. The among one that was a removal trial involving around 420 excess type 1 patients. And what they looked into is somebody is above the age of 40 years, somebody is hypertensive or obese. They wanted to look at the carotid intima thickness in this trial. And what they found that there was no effect of carotid intima thickness, but HbA1c came down by 0.34%, but most patients had a GI intolerance like any of our type 2 patients. Then many more came, beta course trial and the other one in 2018, but all of them, what they showed is, yes, there is some amount of a weight loss and the HbA1c reduction, but this is not sustained. So what the final thoughts about metformin in type 1, HbA1c comes down initially, but it's not sustained if you use it for a long time, but it does reduce the daily insulin doses. But we need to look at the weight loss, that is also initially is there, but long-term data is lacking. But most important, it doesn't increase the severe hypoglycemic events. So when used in type 1, initial benefit with HbA1c and the weight is there, insulin dose comes down, severe hypoglycemia doesn't happen, but we don't have a great number to support for a common practitioner to use metformin in type 1 diabetes. Then we'll move to the next drug that is the most happening drug, that is SGLT2 inhibitor. So there are lots of evidence to support, and also there are some recommendations to use this in patients with type 1 diabetes. It has been observed that it does reduce the HbA1c, and also it doesn't increase the risk of a severe hypoglycemia. That is one of the major concerns with patients with type 1 diabetes. So this is a meta-analysis which is available, published this year. So it looked into the, I think, more than 2,000 publications which were there, but they were all small, not properly controlled. In the end, they could get only 17 studies which would address the issue what they wanted to look into it. And they found that there was significant reduction in the HbA1c when they used SGLT2 inhibitor in patients with type 1 diabetes. And also there was reduction in the body weight. Most of these patients were using insulin, then that's why there was no increased risk of a ketoacidosis, which was seen with type 2 diabetic patients when it was used as a fourth add-on instead of insulin. So good reduction in the HbA1c with good reduction in the body weight with the SGLT2 inhibitors in patients with type 1 diabetes. Then comes the next agent, that's the GLP-1 receptor agonist. So it's quite fascinating to know the mechanism of action of GLP-1 receptor agonist, so that it slows the gastric emptying, it stimulates the insulin secretion, but that doesn't happen in patients with type 1 diabetes, but it does suppress the glucagon secretion. Hence, they thought of using this in patients with type 1 diabetes, but there are very, very small studies. I think you can see from 2016 to 2017, there are hardly 4 or 5 studies involving in excess of 2,000 patients studied from anywhere from 6 months to 1 year. But what that has shown is none of these studies have shown the impact of this GLP-1 analog on HbA1c. That is one of the most important glycemic parameter. What we look in patients with type 1 diabetes has not happened. But what has been happened is some amount of decrement in the bolus insulin has happened, mainly because of the action on a glucagon. But otherwise, there is no major impact of this drug on type 1 diabetes. Then comes the palamitide. This is the one which is in use from 1987. Quite promising action because it gets co-secreted from pancreatic beta cells. It makes the person to feel full. Hence, the meal size comes down, the appetite comes down, and it has also got some benefit on the glucagon secretion by suppressing it. Hence, they thought this can be used as an adjuvant therapy in patients who are on the overweight side, so that their meal size comes down, even the weight comes down. These are the few studies which have been done using pramlintide in patients with type 1 diabetes. There are around 1,000 plus patients studied anywhere from 1 month to 1 year. And we have seen some beneficial even in the small studies. Thing is, there was a positive effect on the HbA1c and the weight. Total daily insulin doses came down, but it was not very clear in all the studies across it. There was reduction in the postprandial hyperglycemia that was quite strong indicative across the studies from 1 month to 1 year. There was no increased risk of a severe hypoglycemia, but main concern is already these patients are on minimum 4 subacute injection they need to take additional 3 to 4 subcut injection when they are using pralimilitide. That's one of the major concerns, because their monitoring plus pricks, totally that puts them anywhere close to 10 plus pricks per day. What about the DP4 inhibitors? These are in the use from past 1.5 decades. There is quite widespread use of DP4 inhibitors in patients with type 1 diabetes, but none of them were randomized control trials. There is no convincing effect on HbA1c with the use of DP4 in patients with type 1 diabetes. But only thing which has been very much promising, that probably it will preserve their beta cell function so that endogenous insulin gets retained, but no firm conclusions have been reached out of any of the studies they have done. Probably the agent requires much more research, and probably will get more clarification in years to come. So this is a meta-analysis of all the drugs which have been used in patients with type 1 diabetes. You can see right from the metformin, which I studied, AGI, very few numbers. That's why I didn't go in detail with ZDs and the EGI, GLP-1 receptor analogs, DP4 inhibitors, SGLT inhibitor, and pralimilitide. These are all the drugs which have been done, but very few are properly randomized control trial. In the end, you are left with handful of studies which are of some conclusive research messages. What they say in the end is the glycemic control is overall good compared to the placebo in patients in whom they use this adjunct therapy in addition to the insulin, with good reduction in HbA1c and the body weight. Dosage of insulin reduced in most of the studies, and risk of hypoglycemia, especially severe hypoglycemia, was less in these agents. So to conclude, it is clear that treatment of type 1 diabetes is evolving even now from past 100 years. Short-term results up to 1 year with adjuvant therapies are not encouraging when it comes to the HbA1c and the weight aspect to the great extent, but we require long-term studies where they can look into the glycemic profiles, fluctuation, even a CV outcome, so that this adjuvant therapy can be made to useful for patients with type 1 diabetes. I think I stop my presentation here. I'll hand over to Sujay for his next speaker.
Right. Sir, would you stay back at the end, or shall we take your questions right away?
I can take my questions, no problem.
Right. There are no questions in the chat box, but if I could ask you from a practicing clinician's point of view.
Yeah.
Now, we have the evidence in front of us, which you've summarized quite well, saying that these drugs might be useful adjuncts in terms of reducing the risk of hypoglycemia, possibly improving in terms of reduction of insulin doses, but we still don't have much of an evidence consistently about weight reduction or consistent HbA1c reduction in the long term. So from a clinician's point of view, if you have to use any of these drugs, where would you be using these drugs, and which ones would you be recommending use in patients with type 1 diabetes?
I think I'll be using a metformin, to some extent SGLT2 inhibitors, to a greater extent somebody who is obese, has got features of insulin resistance and a difficult weight to shut down. Fine, that is the one which I'll be using. And other one which I have used earlier but not continued was GLP-1 receptor agonist, because none of the studies were encouraging. But if patient is ready to take a prick, one which will be confidently I'll be using is pralimilitide. That is the one which will be the most safest thing to use. Rest all, I think, with lots of
is it readily available in India?
No, it's not available. They can procure from West.
Okay. So and I'm being naughty. How many patients have you actually used SGLT2 inhibitors in type 1s? Because I haven't.
No, I have got only one patient who was taking it. I continued it. I didn't discontinue. So I was part of using it, but not the recommending physician.
Right. So I would completely agree with you that there's a significant proportion of kids or young adults with type 1 that I do use metformin, particularly ones requiring higher doses, ones who are putting on weight, and ones who are not having that greater response to whatever doses of insulin. And what about pioglitazone? That's again a drug which maybe a couple of years ago we were still using more in patients with type 1s with less fear of weight gain, because particularly the under-insulinized kids, weight gain was not an issue.
Yeah.
I think there as well.
My experience with pioglitazone is almost close to zero with the type 1. only thing, but now use of pioglitazone itself is on the marginalized even in a type 2. So probably I think we have a less future for it compared to what we have discussed already.
Right. And the last question, I see a lot of clinicians, and I've used this off-label as well. See, someone is on a basal bolus insulin, taking 3 shots of boluses, and then there's an evening snack or an afternoon snack, and the kid refuses to take another shot of insulin. What about using an AGI in that situation? And I know this is a completely off-label indication that I'm talking about, but what is your experience, sir?
I think I recommend them to take a rapid-acting insulin shot rather than a AGI. So even the studies regarding AGI is very less, except confined to our Asian subcontinent. We hardly get anything from a Europe or a US this literature. Probably, I think if we are using it, I think we should pool our data, make it more acceptable for the publication.
Right. So I would summarize and say that metformin is probably the one that we would be using most commonly in our kids with type 1 diabetes. Thank you so much, sir. That was wonderful. Not
Dr.
only
Sucha?
the presentation, but the practical aspects. Yes, ma'am.
May I add, just off-label use, I must admit, I have used metformin in quite a few, especially older girls who have post-puberty, they are overweight, and even SGLT2 inhibitors with adult above 28 BMI requiring large amount of insulin. And to date, I have 5 patients who are doing very well. It's all off-label, so I'm admitting it here. And also AGIs have worked well, especially the ones who have a very high carbohydrate. Because I work in rural areas, their major meal is carbohydrate. They cannot often afford the evening snack, which is not. And when it's not possible to, we have tried it. So far with good results, and I agree with sir, it should be documented and followed up. But so far so good.
Nice.
Thank you, ma'am. Thank you, ma'am. Thank you, Professor Vagish, for that excellent presentation. We move on to our next speaker, Professor Ganapati Bantwal, who needs no introduction. Sir is right now the president of the Endocrine Society of India, and it's a pleasure for me to work under his guidance. And sir is professor at St. John's, Bangalore, in the same institute as Dr. Vagish. And sir also has published numerous publications and is a teacher of several of the currently young generation DM endocrinologists. And sir is going to talk on cardiovascular risk in type 1 diabetes. We look at cardiovascular outcome trials in type 2 diabetes and so many drugs and so many things about statins, hypertension control and glucose control in type 2, but type 1 is probably one area which is relatively neglected. Sir, the stage is all yours.
Thank you, Sujay, for that kind introduction. Let me thank Dr. Neeta Deshpande for giving me this opportunity to speak in this forum. I'll share my slides. Yes, as Dr. Sujay told, yes, we have a lot of data actually coming from type 2, but not much data is there on CV risk reduction in type 1. We have had the longest DCCT trial and the Idec, which was followed up to 20 years also. So some amount of literature, a little bit coming from that also. So there was actually in 2014 comment from the AHA and the ADA on this. So as you know, type 1 diabetes is associated with a premature cardiovascular disease. Even at age less than 40 years of age, men and women with type 1 have a 5 and 10-fold increased risk of experiencing a coronary heart disease event. And this risk is still higher if you still have a younger age of onset. And it has been found that by the age of 20 years, life expectancy is reduced by approximately 12 years in absolute terms, with approximately 1/3 being attributable to cardiovascular disease. Like all CVDs, which is decreasing in the general population, the same thing is happening even with the type 1 diabetes also. But then in a recent meta-analysis or in a recent analysis of more than 10 million individuals in the UK National Health Service, type 1 was still more strongly linked to CVD outcomes than any other disease. It was also linked to a higher incidence of heart failure than even type 2 diabetes. And as you know, unlike the traditional risk factors, hyperglycemia They have a more profound effect on cardiovascular risk in type 1 than type 2. And the other risk factors like hypertension, dyslipidemia appear to be having a synergistic rather than an additive role. And if you see the standardized mortality ratio attributable to cardiovascular disease is 5.7 for men and 11.3 for women with type 1. And by the age of 45 years, more than 70% of men and 50% of women with type 1 have developed coronary artery calcification. Though there has been an improvement because of the improved management of the traditional cardiovascular risk factors, there has been an improvement in survival. There's a 29% reduction in the relative risk of death over a 10-year period. Such that right now, the risk for CVD is 2.3 for men and 3 for women. There's an increased mortality. In the first decade, acute infections, hyperglycemia related, dead in bed syndrome, hypoglycemia related. Second decade, CKD and cardiovascular accidents. Third decade, so that is 30 years of diabetes history. Now, the cardiovascular causes the most important, being the most important reason for mortality. So the UK cohort study showed that patients with a history, diabetes history over 30 years, there was an increase in CVD, such as hypertension, cardiomyopathy, heart failure, and MI. Risk factor, as I told you, HbA1c, blood glucose assessed by HbA1c, most powerful risk factor. Others like blood pressure, LDL, they have a contribution, but then it's only after 15 to 20 years of diabetes. And in the Swedish National Diabetes Register, type 1 diabetes who had an A1C, approximately say 6 millimoles or lesser, rather 6%, they had an increased risk of death from cardiovascular cause, which was twice as high in the risk in the general population. And this risk increased with more higher HbA1c concentration. And it's also related to more strongly to fatal rather than non-fatal CVD events. So in the Swedish trial, they found that every 1 millimole increase in LDL, it translated into a 9% increased risk of CVD in individuals without lipid-lowering medication. And though LDL is, when you treat LDL, it does come down, but then it is not a good marker for cardiovascular risk in primary prevention in patients with type 1. Similarly, the Eurodiab study also found that LDL not predictive of CVD. So what's happening? We are probably, because of this, there is a tendency to develop an atherogenic lipid profile, which is actually hidden. So what could be the reason for this? They have more amount of intermediate density lipoprotein, increased small dense LDL, and HDL, which may be even more, but they are dysfunctional. And this HDL levels are even high unless the control is poor or nephropathy has developed. Hypertriglyceridemia can also occur. As you know, hyperglycemia can lead to hypertriglyceridemia, and this is also, the risk is associated with it stronger than in the general population. Coming to the differences between the specific cardiovascular risk factor and CVD events in type 1 versus type 2. Hypertension, more effective for type 1. Cigarette smoking, the same. Inflammation, the same. Hyperglycemia leading on to inflammation. High LDL, it's more for type 2 than for type 1. Low HDL, not so much for type 1, but then significant for type 2. Triglycerides, mainly for type 2. Microalbuminuria is a significant event in both type 1 and type 2. As you know, it heralds the onset of hypertension, and it suggests there is an endothelial dysfunction throughout the body. In other words, the cardiovascular dysfunction is also happening. Insulin resistance, big contributor in type 2, but not so much, and poor glycemic control in both of them. How hyperglycemia causes atherosclerosis, as you know, it leads to oxidative stress, generation of superoxide anions, and leads to the activation of all the pathways, the protein kinase, the advanced glycation end products, hexosamine, and the polyol pathway, and inhibition of protective pathways like the endothelial nitric oxide synthase and prostacyclin synthase. So you can see here, decrease in insulin leads to hyperglycemia, increased age, leads to inflammation, leads to endothelial dysfunction, decreased nitric oxide. There's a reduction in the reverse transport. So we have an increased dysfunctional HDL, increased IDL, small dense LDL, increased oxidized LDL. All this contribute to the CV risk. Recently, they have found that another factor which could actually contribute to this is the development of anti-myosin antibodies, which could probably lead to inflammation and finally to the atherosclerotic vascular disease. They have proposed this. So we don't have much data. So these are some of the studies where they have found. So you have the UK GPRD study, the General Practitioner Research Database, duration of 15 years, follow-up of 7 points. So what they found was MI, coronary revascularization, stroke, and acute CHT deaths were more in men and also women in type 1. Similarly, the coronary heart disease was once again more, threefold in men and around 7.6-fold in women. Similarly, in the nurses' health study for CVA, fatal and non-fatal stroke, excluding silent strokes, were more common in women 6-fold compared with women without diabetes. And similarly, the peripheral arterial disease were once again incident non-traumatic lower extremity amputations were more in these patients. So, as I already told you, in the UK GPRD, compared with the general population during a 4.7-year follow-up, there was increased risk of coronary heart disease. And this cumulative incidence of coronary heart disease ranged between 2.1 to 19%, with the cumulative incidence of 15% over 15 years of follow-up. And the mortality rates over 14 to 18 years were between 6 and 8%, was higher in men than in women, and higher in those more than 40 years of age than in those less than 50 years. So cerebrovascular events were also once again higher in the type 1 diabetics. Similarly, it was the same thing seen in the Wisconsin epidemiology study of diabetic retinopathy, an incidence of 6% over 20 years, 0.3%. And the Eurodiab also reported 0.74 incidence of cerebrovascular events. Peripheral vascular disease, you have various methodology by which you can have an occult disease, by which you can assess it by an ABPI, extremity arterial calcification, or lower extremity non-traumatic amputation. And this was actually higher in type 1. And by 65 years of age, the study from the Swedish database, it was around 11% for women for lower extremity amputation and 20.7% for men, which is actually 86-fold higher. And similarly, they had even developed calcification of the extremity arteries in around 5%, more so in individuals more than 30 years of age. Now, what are the predictors of this? So when we say actually CVD, it includes coronary heart disease, the cerebrovascular disease, and the peripheral arterial disease. And the predictors were age, male sex, history of foot lesions or ulcers, diastolic blood pressure, LDL cholesterol, HbA1c, diabetes duration, hypertension, albumin excretion rate, GFR, smoking status, and retinopathy. And a meta-analysis found that with every 1% increase in A1C, the risk of peripheral arterial disease increased by 18%. And one important observation was glycemic control did not reduce that incidence. Subclinical CVD is also seen. So there was a study known as the cacti study, the coronary artery calcification in type 1 study. So they found there was an increased coronary artery calcification in type 1. And similarly, carotid intermediate medial thickness was also increased in children, adolescents, and adults also in patients was seen. And this was seen in a very early age. Now, coming to risk stratification in type 1 diabetes. So common recommendations, they only consider diabetic retinopathy in the high CV risk. But in the absence of nephropathy, and various societies have not yet established consensus score to stratify the cardiovascular risk in type 1. So we have non-invasive tests like the intimal medial thickness, the ABPI measurement. So they provide a tool, opportunity to identify patients at high risk, CV risk after a 10-year history of diabetes. Patients with a high cardiovascular risk, if you have an IMT more than 1 mm or an ABPI less than 0.9, here you should do more aggressive treatment like lifestyle modification, ACE inhibitors, statins. We don't, they don't recommend stress testing or coronary angiography indicated only for very high CVR. Coming to the risk engines like the UKPD's the Framingham, what happens with this is they do not account for glycemic control, duration of diabetes, or the presence of microvascular complications. So we had the Pittsburgh EDC study. Here they found that baseline A1C, duration of diabetes, low insulin dose, impaired renal function, increased albumin excretion, higher diastolic blood pressure and lipid profile were all predictive of CVD. Similarly, the Steno type 1 risk engine once again had around identified 10 risk factors: age, sex, diabetes, duration, HbA1c, systolic blood pressure, LDL, GFR, and albuminuria, and smoking and exercise. And age was the most significant risk factor, followed by time-weighted mean A1C. So the Steno type 1 risk engine, the QRISK, and the UKPD's risk engines. Coming to prevention strategies: stop smoking, increase physical activity, avoid weight gain. Glycemic control is very important. The Idec we found 42% reduction, control of lipids with statins, hypertension control with ACE or ARBs. So this is a summary of the CVD risk. What do you do? Hyperglycemia, screen using A1C at least once in 3 months, target less than 7. Increased intensity of glucose monitoring and manipulation of insulin dosage you should consider. Diabetic kidney disease, of course, you do a urine albumin to creatinine ratio yearly, beginning 5 years after diagnosis. ACE inhibitors keep blood pressure less than 130 or less than 90th percentile for children. Dyslipidemia, what do? You do a fasting lipid profile, LDL less than 100, non-HDL less than 130. Children, once again, LDL less than 100. You could do the lipid profile once every 3 to 5 years. If they are adults with CVD, see that the LDL is less than 70. Because you have to use statins in these type of patients. And the goal is LDL less than 70. Hypertension, see that the blood pressure is less than 140/80. Start with lifestyle modification, low salt, a DASH diet. You could use medications like an ACE or an ARB and other drugs if required. Pre-hypertension, low salt diet, fruits, vegetables, regular exercise. And for thrombosis prevention, age more than 21 years. If they are an adult with CVD, then you can actually use an aspirin. So this is my last slide. As you know, not much data has been there for type 1 diabetes regarding the cardiovascular. Though we have a follow-up of the Idec, the number of events were less, so it's very difficult to predict what is the exact strategy. So from the pooled analysis, whatever we have is whatever I told you now: hyperglycemia, DKD, dyslipidemia, hypertension, pre-hypertension. These are the things we have to stress on: control glycemia, avoid smoking, increase physical activity, and weight reduction. I think with this, I will stop. Yeah.
Right. Thank you so much, sir. You have managed to summarize so much of data in that 7 minutes. Awesome. Right. Couple of practical issues. You know, if you look at, for example, the lipid guidelines, whenever it comes to the type 1 bit of lipid guidelines, clinicians are confused. So from a practical point of view, when do I start a statin or lipid-lowering therapy in a patient with type 1 diabetes?
Yeah, so one thing is, we have a guideline for patients with familial hypercholesterolemia. And there they say, if you're aged more than 10 years, or if you have attained puberty, whichever is earlier, actually you can start them on statins. I think the same thing applies here also. If they have an LDL which is high, then actually I will start them on statin. Now, when will I start? Once they have attained puberty, then probably I will start them on statin in these type of patients. And I want them, I wouldn't say less than 70, I want that LDL to be less than 100 in these type of patients. So completion of puberty, and then I start them.
So completion of puberty, and what do you mean by high, sir, in starting? I'm sorry.
Well, say I want the LDL to be less than 100.
Right.
Though, as I told you, LDL is not such a thing. But then with a longer duration of diabetes, so more than 10 years down the lane, anything LDL more than 100, probably I will start treating them with a statin and try to keep it below 100.
Right, I'll come
This
to
is my
Dr.
personal
Archana. I'll probably come to Dr. Archana on this a little later. One of the things you very clearly mentioned was, unlike type 2s, the risk is much, much, much higher in type 1s. That's something that the clinician should remember, because, unlike type 1s, the type 2s, the type 1s might not have that bad an LDL cholesterol unless and until they have double diabetes. They might not have that much of obesity. Their liver fat might not be that bad. Their hypertension might not be there even unless and until the individual develops renal complications. And I think we are very laid back when it comes to cardiovascular risk management in type 1 diabetes. That's my take. Maybe one of the things that happens is everybody is happy for them to, reach that age of 25, and then things fizzle out in terms of management of type 1 children, because there is no transition of kids from young physicians to the adult physicians. So I think things go wrong there. So risk assessment is very important. And like you've pointed out, unlike in type 2s where you have a lot of good validated risk engines, in type 1 we don't have that kind of a validated tool which would actually be useful. And in terms of hypertension management, again, would you be very aggressive? Because in that particularly one slide, you clearly showed us that, again, if I have to find out which of those risk factors were probably one of the worst, one of them was hypertension. So again, when would you suggest starting to screen for hypertension in these children or young adults for management? And what guidelines would you use? Because the adult criteria don't fit in for the kids, because you need to have normative data for adolescent and young adults.
Once again, it's a tricky question. What I will do is, I would have been following up the patients. Of course, the moment they develop, even say 130/80 with microalbuminuria, definitely will be starting. Pure hypertension, if they have had, say, previously normal values and there is an increasing trend, that's a time when actually I will start using them on an ACE or an ARB. And the cutoff could be anything more than 130, above 80. So they have been 110/70. And over a period of an year or two, I find that that's increasing, repeated readings, more than 130/80. Probably that's a time I may start on ACE or an ARB. Of course, once again, post pubertal thing. One of the things which has been found actually is the pre-pubertals. Of course, this is what we were when we were taught. Pre-puberty doesn't contribute much to the complications. So post-puberty, I find an increase. That's the time I will actually start them.
Right.
And
Last question, which Dr. Archana will actually continue in our talk. Now, what about double diabetes? We have a lot of type 1s who have other features of metabolic syndrome. What about cardiovascular risk in them?
I think it's increased in them because they also develop some features of insulin resistance, and there's some contribution. See, I put it in that slide, the difference in type 1, the contribution of insulin resistance is just 1+ compared to type 2, where it's 3+. So in this type of patients, probably it is +2 or going to +3 as the contribution of that to cardiovascular risk. So yeah, in them, probably I'll be a little bit more aggressive. But then I hardly can remember anybody having that type of a diabetes, because I have majority of my type 1s are very lean. Exceptions are there, where in fact I put them on even liraglutide actually for one of the patients, and she did lose weight also. So these are the type where I'll actually be more aggressive in treating the cardiovascular risk factors.
Sir, may I ask?
Yeah, sure.
So what about the prepubertal persons with type 1? What do we do if the lipids are high and the blood pressure is on the higher side?
If they are high, definitely we will treat them.
Okay.
Definitely we treat them. See, now I told you, including familial hypercholesterolemia, though it was considered 10, they have brought it down to 8 now, in fact. So I will probably treat them with a statin. If there is hypertension, yes. But the general rule is pre-puberty doesn't contribute to the complications. A general rule, I won't say 100%. So that's a reason. But if you find them, please treat. You have to treat them.
Okay, sir. Thank you very much. And we'll move on to Dr. Archana Sharda for the last bit of this particular session. Madam, I think, needs no introduction when it comes to type 1 diabetes. Probably one of the best clinicians looking after type 1 children and young adults. Quite a role model for all of us. when we talk about management of type 1 diabetes. And ma'am is going to talk about weight gain issues in type 1 diabetes. Like Dr. Ganpati sir said, that maybe a significant proportion of our type 1s are lean and thin, but the moment we actually start treating them properly, this bit of so-called leanness actually goes. And a significant proportion, I would say in my cohort, at least about 20% of children and young adults with type 1 diabetes are actually ones who are overweight or obese as per whatever guideline or cutoffs you use. Ma'am, the stage is all yours.
Thank you, Dr. Sutra. I'll just share the slide. Yes. Yes. Thank you, Dr. Sujoy, for the introduction and the topic. I think we've been going through this, the new drugs that we talked about, the CV risk, and now again, weight gain. This is a topic. These are three topics which are normally not talked about. And hence, it's very important. I also had to think about, is it a fact? Is it something they're just worried about, or is it really happening? And then we realized that, yes, it's a fact that although it was once rare, we always thought about lean people with type 1 diabetes. It's now an increasingly frequent problem. There's a lot of evidence which is now emerging, as was mentioned by Dr. Panthi also, that obesity contributes to the insulin resistance, dyslipidemia, and cardiometabolic complications in type 1 diabetes, as we were talking about double diabetes right now. So if we look at the observations, do we have studies showing this is happening? Yes, there's so many studies, the Search for Diabetes in Youth study, which use the anthropometric measures. And the important thing in this study, I will not go through the numbers, there are multiple studies. I could not come across any Indian studies which would show us obesity studies in type 1 diabetes. Maybe it's time we start doing that. But the strength of these findings were in that the comparison of the same period and ages while contrasting individuals with and without type 1 diabetes. So that was very important. Again, in the type 1 diabetes exchange registry, which was seen from Germany, Austria, and United States, the greater BMI index was seen as compared to the WHO international norms for respective country-specific national norms. So it is definitely there. And as Sir also mentioned in the Idec, there was a large increase in the weight, which was seen from 1% baseline to 31%. And that was in the intensive arm of insulin treatment, which we will be talking about. So although the limited studies are there, but all of them, when they are matched for age, sex, and time frame, they are now showing that there's a trend of obesity in individuals with type 1 diabetes. This is also, as Dr. Sujoy just mentioned, that 20% of his population is he's seeing people who are overweight. And with my case also, although I work in the rural area, yet I am finding more and more people, maybe because of the lifestyle change or the factors which we are going to talk about now. But yes, we are finding more and more people shifting from the lean to the obese side. Now, this is a very famous, well-known fact. And in the DCCT, we found that the intensive insulin therapy and the tight glucose control gave two untoward actions, and that was the weight gain, which was threefold higher than in the intensive arm. So that's like around 4.5 kg was observed in this, and also more hypoglycemic events. Does that mean we will not give them a tight control? Absolutely not. And that would be the final take-home message, because ultimately we are preventing, as shown by Dr. Ganpati, all the other cardiovascular risks. But again, weight gain is a significant factor which is now contributing. And there we come to the point which was just taken of double diabetes. Already we are talking about the youth with type 1 diabetes is predisposed, as was shown in the last talk. But when they're on top of it getting overweight and it becomes a double diabetes, there is insulin resistance to their exogenous insulin, and that itself becomes a much higher risk for cardiovascular disease. So the whole reduction of risk, the risk factor, risk scores, the methods that we had talked about, now it becomes a very serious issue when we are talking about our young people for type 1 as well as type 2 in their cardiovascular risk. So what could be the mechanisms of these weight gain? First thing I thought is what's most important is what we do every day. And that is our insulin therapy. So the intensity of insulin therapy, as we said, the TCCT trial showed us that the tighter the control, the more the weight gain was seen. But can we do away with tight control? Probably not, and we should not. And then again, the thought is of the type of insulin therapy. There are very limited studies, but these studies have shown the NPH had more weight gain as compared to Detamir. Detamir had more weight gain as compared to Glargine 100, and Glargine U100 had more weight gain as compared to Glargine 300. So limited studies, but there is something probably that we can do about it. Again, we know the growth hormone and the insulin-like growth factor. This non-physiological mechanism causes an imbalance between the catabolism and the anabolism. So these could be some of the factors. Double diabetes we have talked about, so I'm not going to go into it. But again, the weight gain and the insulin resistance cycle has to be recognized and treated early. That is the point we're going to take home today. And the lifestyle. So nutrition, I think it goes without saying, and that will be that has happened even in my rural kids are now swigging and having all kinds of junk food. So high carbohydrate diet, lack of physical activity with digitalization, and very, very important part is the behavioral and the psychological, social factors. This is also what is influencing the nutrition and the physical activity. So even in young people, even without type 1 diabetes and type 2 diabetes, this is a very important factor. So with type 1 and type 2 diabetes, of course, all the peer risk factors and the emotional factors do play a big role. So the family factors, the personality factors, when was the diabetes diagnosed, was there weight gain, weight loss, and then the intensive insulin treatment once it started, there can be a recurrent hypoglycemia, which leads to binge eating, again leads to depression, and that cycle keeps on going on. The other side is a weight gain, which leads to a very strict eating, lots of carbohydrate counting, parental pressure, which again leads to eating disorders. So both sides, swinging to both sides, can be creating eating disorders in the young ones. Hypoglycemia, surprisingly, is a very important factor. I just mentioned it can lead to food craving and binge eating, but just a thought that the last point that I mentioned, that 15 gram, that is just 60 calorie carbohydrate rescue for hypoglycemia once a day, which I find so many young people will do to access something they want to eat, can cause 2.7 kg weight gain throughout a year. So we know that young people end up consuming much more then does this. So to go very quickly, because I'm aware we are short of time, there's the energy imbalance that occurs in type 1 diabetes. The other mechanisms for the phenotype, obesity phenotype in type 1 diabetes could be genetic, epigenetic, microbiome, adipose tissue dysfunction, mitochondrial dysfunction. All these are under research in a very, very intensive way. It's too elaborate to mention here, but something we should be aware of. Another very important thought I felt we should share is the achievement of well-controlled type 1 diabetes due to insulin intensification. It reduces the urinary glucose losses, the resting energy, the thermogenic energy from the food, but does not affect the food intake. Hence, there's a net positive energy balance and weight gain that we see. What can we do about it? We have talked about all the drugs, so I need not go into that. And I also mentioned that I have used some of them off label, but the obesity drugs, anti-obesity drugs are again something to think about. Bariatric surgery has been recommended. But nutrition therapy, physical activity, and exercise ultimately remain the cornerstone. What we really need today is a very intense study where we can go for a type 1 diabetes specific weight management recommendations, which take everyone's expertise, as well as an integrated evidence-based characterization of obesity in type 1 diabetes. So if we could have that, and it's time to go forward. And thank you so much. I just wanted to make that point here. And these are the references that I used while presenting this. Thank you so much. So,
thank you, ma'am.
So Joy, I was very quick. Yes.
Yes, you were. Very crisp and to the point presentation. In terms of weight management, I think one of the things that you've highlighted is it's not as uncommon as we thought before. And it should not deter us from going for tight control. So, and what you have highlighted is the overcompensation for an hypo leading to weight gain. And again, the concept that it's double diabetes that actually is an entity. So I'm not going to ask you any more questions, ma'am.
Yes.
I'm just going to 30-second summary of what we've learned today in this entire session. We first started up with non-insulin therapies. There we realized that it reduces the risk of hypos, all of these drugs that we're using. They are all off-label uses. They probably reduce the dose of insulin requirement, but we don't have definitive evidence of improvement in A1Cs and weight and long-term outcome data. And probably metformin is going to be the one that we are going to be using most commonly. The second bit of the CV risk, these are the highest risk people in terms of CV risk, in terms of comparison with the general population. And 1% HbA1c translates into 18% increased risk of cardiovascular disease in type 1 diabetes. We need to be very, very, very aggressive. And glycemic control is probably much bigger contributor of CV risk in type 1s compared to type 2s. But the other CV risks will also actually have to be tackled. And good glucose control reduces the CV risk by about 42% in type 1s, unlike in type 2s. In terms of the weight issues, very common, shouldn't deter us from going for tight glycemic control. We've got to think of the insulin regimes and the adjunct drugs, and maybe probably looking for eating disorders as well, and try and not overcompensate for hypos and avoid hypos. So that's what I have learned from all of you and the experts in the last half an hour. Thank you very much for an excellent session, and I hand over to Dr. Neeta. Thank you once again, ma'am, for giving me this opportunity.
Thank you, Dr. Sujoy.
Thank you very much. Thank you so much, Sujoy and the entire team. You all have done exceedingly well. And we have some very good takeaways about these important, not so much talked about points in type 1 diabetes. Thank you all very much. It was a lovely session. And with this, we move on to another very, very interesting session. And for this, I hand over to Dr. Anjali Bhatt to carry forward.
It's great to have the experts in technology to have a wonderful discussion and take home messages on a topic that is one of the most talked of topic in technology in diabetes today. That is time in range, what methods we use, how do we translate what we call as normal, what will get translated into its association with the complications. So I'm sure we have exciting subtopics under this, and one of the most sort of speakers who can talk about technology. I welcome all of you, Manoj Chawla sir, Jyoti Dev sir, Dr. Mangesh Tiwasar sir, and Dr. Amit Gupta. I'll hand over the mic to Dr. Manoj Chawla, who we all know as a director and consultant diabetologist at Leena Diabetes Care, Mumbai. A very passionate clinician, have been working in diabetes for so long. Many credentials to his cap, and I would request him to take over the session. First, introduce our expert speakers, and then start the discussion. Over to you, Manoj sir.
Thank you, Anjali, and thank you, Neeta and Sanjay and the whole team of Idec for inviting me for the conference. I'm hearing a lot of echo. Is it me or everybody's hearing that echo?
I am also getting the echo.
Yeah, great. Thanks. Okay. So thanks for inviting me. And I believe the only reason I've been asked to be the lead for this EBM is that I have more gray hair than Jyoti and Mangesh and of course Amit. So that I see that as the only reason that I'm here amongst the experts in technology in India. And thank you organizers for also sending me this coat to wear. I was told that Dr. Jyoti always wears one, so I should also wear it. So Neeta, thanks for the coat which came in. Let me introduce the panelists for this session that we have on time in range. I begin with Dr. Mangesh Tiwasar, who will be joining us on this soon. Well, Mangesh has had an extremely illustrative career, I must say, gold medalist for his MD Medicine. He's the Honorary General Secretary for National API. He's the elect editor-in-chief. This February 2022, he takes over as the chief editor for JAPI, and we'll be all reaching out to him for various articles. A lot of publications to his credit, and he's the MRCP examiner as well for the Royal College of Physicians, UK. Can I have the next slide? Dr. Amit Gupta is the Director for Center for Diabetes Care at Greater Noida. He's an advisory board member for American Diabetes Association and an extremely influential member with ADA and ACE, taking recommendations from the Indian physicians for the kind of programs that you want to see and as part of the subcommittees there. He is part of the RSSDI National Social Media Committee member and extremely active again
in the entire drive for Defeat Diabetes and the social media platform as well. He is an Apex body member for the Art of Living, and we see his visits with Shri Shri, and he's been instrumental in including Shri Shri in the launch of the new app for RSSDI Defeat Diabetes, and he's an endocrine practice reviewer and other credentials to his credit. May I have the next CV slide? Extremely difficult and humbling for me to introduce Dr. Jyoti, whom I consider the actual technology man and who's been an inspiration for many of us trying to do some bits of work in the technology area. Dr. Jyoti runs his diabetes centers at a couple of places in Kerala, his main center being in Trivandrum. He is the chairman of Jyoti Des Diabetes Research Center at Trivandrum, Kochi and Attingal, managing trustee for the Kesav Des Trust, which does a lot of work in terms of education and charity and literary activities. He's the editor-in-chief for International Journal of Diabetes and Technology, extremely active in talking about technology, in conducting and being at the forefront for trying out new technologies and enlightening us as well. So great pleasure to have all the three speakers today in this EBM masterclass. Took me a while to understand what EBM meant, and then of course I realized that you're talking about evidence-based medicine, and sometimes you start thinking very deep as to what this could be. I was trying to think in EBM, I don't find a Sanjay initial, I don't find Nita or Anjali, so what does this EBM stand for? But then it made sense as to what we're talking about. So yes, Mangesh, I can see Mangesh finally, and Mangesh is busy at his clinic, but will be sparing time to speak to us. Over the next 45 minutes, we will have 4 short talks divided amongst various aspects of time in range, and then throw it open for questions from all of you. So we invite questions from all the participants who are joining us. Let me start by sharing my screen. Okay. I think I've gotten my slide in here. My full slide can be seen, I believe. Somebody will help me here with that. Yes, okay, great, thank you. We're going to be covering different aspects in this masterclass about time in range, methods, evidence, interpretation, and indications. The time for each expert is about 7 to 8 minutes, and hope and request that all of us, including myself, stick to the time. I'm going to be talking about the concept of time in range, some of the limitations of HbA1c, the glycemic variability, its implications, and the practical implications or applications of time in range. Now, standardizing CGM metrics and reporting. So this has been the journey for CGMs being introduced and approved in the US in the early 2000s, to first proposal of standardizing a CGM report. And we know that before that, there was just too much of data. And as it is said now, that a lot of data can actually be a cluster, and a cluster would mean lack of clarity. So it was good that there was some standardization in the form of AGB proposed by Maze, Bergenstahl, and others in 2012. And then in 2013 to 17 was the gradual introduction of CGM metrics, including time in range. 2019 saw an international consensus on CGM TIR targets. And Jan 2020, which was last year, you see the ADA including CGM in 2020 standards of diabetes care, and 2021 has gone a step ahead, and I'll be coming to that. So what exactly is time in range? Time in range refers to the time spent in an individual's target glucose range, which is usually 70 to 180. For some, it would be 70 to 140, and some even 63 to 140, especially in pregnancy and diabetes. It is the percentage of time also which is spent below range or time spent above range, and there will be a lot of light thrown on this aspect in talks ahead. Time in range may be used as an appropriate endpoint in clinical research and as a measure of glycemic control in patients with diabetes. And there is strong emerging evidence that TIR is inversely correlated to the development of both micro and macrovascular complications in diabetes. Now we talk about the limitations between HbA1c and TIR. And we need to understand this, that HbA1c, it evaluates a single HbA1c value ideally at every 2 to 3 months, compares 3 months, does not capture hypoglycemia or hyperglycemia, so doesn't tell you much about glycemic variability. any immediate effect of therapy changes cannot be understood or recorded. It has bad correlation to patient-reported outcomes, high susceptibility to interference with anemias, hemoglobinopathies, laboratory issues, and so on. And the favor for HbA1c, or the point in its support, is still extremely good correlation to clinical endpoints and long-term studies. So the hardest endpoint today that we have of link between poor control and complications is still with HbA1c. TIR, on the other hand, evaluates continuous glucose levels, compares different time periods, captures all the glucose values, immediately detects any acute effects of therapy, whether it's going into hypoglycemia or reduction of hyperglycemia, good correlation to PROs, low susceptibility to interference from any of the aspects mentioned earlier, and correlation to endpoints is still unclear and emerging evidence, so not yet substantiated. You can have similar HbA1c but different glucose variability. These are amongst the classic slides that we always show as to why the need to move beyond HbA1c, because your patients with same HbA1c can have completely different glycemic patterns and variability, and hence the need to look more closely to the movement through the day. There is correlation between HbA1c and TIR. There are a couple of models postulated. The most accepted one is the Vygotsky calculation, which tells us that why a particular, or what a particular HbA1c will denote in terms of time in range. So if you look at 70% time in range, it would mean an HbA1c of 6.7 in percentage, and that's what we understand. The simple further understanding is for absolute 10% change in TIR, there would be a 0.8% reduction in HbA1c. There is a strong link with complications of time in range, which is emerging, and Dr. Jyoti Dev would be speaking about with the link with complications. How do we really measure TIR? So CGM is the ideal tool to measure TIR. SMBG can be used, but if you don't have sufficient data points or points in range, you will not get the accurate TIR. So more than 5 times per day is required. The more, the better. If you're using SMBG to calculate TIR, there's a simple formula. You will have values in the target area. So if your target for the patient is 70 to 180, you will have those values in the target area divided by the number of values into 100 to get your percentage reading. For example, if you've done 7 readings in a day and you have 5 in the target range, it's 5 by 7 into 100, you'll get 70% as your time in range based on SMBG. Not as accurate, but in limited resources, you can start using this as well. Now, this is time in range through CGM. I'm showing this because this is one of the newest CGMs called Glunovo real time, which we are currently evaluating. And this is a recent data for a patient who's using this, which not only tells us the real time glucose value, but is also showing the time in range. And you can clearly appreciate here that no time below range, about 66% time in range and about 34% still above range. This individual where we're trying out the Glunovo real-time CGM. There has been evolution of glycemic target. So the 2021 ADN, this is what I was talking about earlier, talks about glycemic control being best evaluated by a combination of A1C and time in range. So we talk about moving beyond HbA1c, but not discarding HbA1c. So everybody, when there is a debate in conferences like this, A1C versus TIR, well, it's kind of rubbish because you need both these metrics today. You need HbA1c, but you also need TIR to further substantiate and look at the glycemic stability. Time in ranges are going to be time above range and time below range. Everything's important. And Dr. Mangesh will be speaking much more about all the recommendations and describing in further the levels of time above and below range. Why are they important? Because both these aspects are going to have consequences. You have low sugars, there is going to be hypoglycemia unawareness, increased mortality risk, cardiac arrhythmias, and a lot of undetected hypo. You have high sugars and it's going to cause increased risk of ketoacidosis and complications. Now, this is one aspect of really understanding and picking up the time above range. So when you start doing CGMs and start looking at the data, we need to understand that every 5% increase in time in range is going to be clinically beneficial. 1% is approximately equal to 15 minutes and 5% is 75 minutes. So if you are able to increase your patient's time in range by 75 minutes in a 24-hour period, that is going to have clinical benefits, and that's important for us to note. Now, this has been some of our work and papers. the CGM recommendations that we came out with the blessings of various experts here, which spoke about the need for more regular CGM in our practice. This is the consensus statement on AGP led by Dr. A.G. Unnikrishnan, and again, many of my colleagues who are either organizing this conference or part of this masterclass being co-authors for this consensus. And then we had two papers which were presented at ATTD last year. This was Insights to the Time in Range, and this was a multi-centric. We saw data from our centers at Leena Diabetes Purvi and myself, Dr. Bansis, Dr. Jyotis and team. And we saw that the average time in range, even at these centers, was somewhere closer to 60%. We wanted to look and see that how you have an average HbA1c in India, whether you can have an average time in range that the patients are achieving. This was the initial effort, and we look forward to collaborating with many centers across India to try and understand an average time in range for Indian subjects. This is again an important aspect, that when we talk about adoption of time in range and technology, there is a gender bias. We still are not seeing a lot of work being done in the female gender. Again, collaborative work with Dr. Archana and many of the experts with Purvi. And this paper was again accepted and presented at the ATTD. Now, quickly, I'm going to talk about some practical applications of TIR in clinical decision making. This is clinical utility of HbA1c, which is enhanced when used as a complement to time in range. So when you talk about HbA1c, you can see here patients with the same HbA1c, but when you do their CGMs and you look at their AGPs and you look at the time in target, these two patients with the same HbA1c, this one has 46% in target, this one has 64%. So clearly depicting that only HbA1c is not sufficing. You want to start looking at their time in range metrics. This is again time below target, picking up hypoglycemia trends in different HbA1c subgroups. We are talking about different A1Cs, somewhere close to 5.5 or 6.3. You expect some hypoglycemia. So you are seeing 18% time below target and 11% time below target. But here, this is somebody with an A1C closer to 10%. Of course, estimated A1C does not mean actual HbA1c, but these patients from our profile had A1Cs closer to the numbers we are seeing. And here also you see a time below target spend 10%. Somebody who has an HbA1c of 9 or 10, if we think that they are not spending below range, that's mistaken. The other clinical utility is using this tool to understand impact of lifestyle and medications. This is purely lifestyle. We had an individual who chose to stick onto lifestyle and worked onto it, and we did 3 serial CGMs over regular intervals. And we see the time in target here improving from 41% to 65 to eventually 74%, extremely satisfying for the patient to understand and move ahead. Finally, impact of medication in drug-naive patients. Some patients would be afraid or want to see how they are responding. So this is, you're doing a CGM here, and you are evaluating the time in range. From day one, when the patient has started therapy, when the time in range is only 4%, eventually till the end of the AGP or CGM period, you are again seeing the time in range improve to 82%. Extremely satisfying for the patient looking at that time in range improving. So treating type 2 diabetes, friends, is without data is like flying blind, and we need to see where we are going. The world is changing. HbA1c is moving towards time in range, and I said earlier that this has to be complementary to each other. Different countries are adapting this. I'm extremely glad that India and physicians in India are adapting this much earlier than a lot of countries in the world. Everyone's been talking about time in range, and that's what we are going to be taking ahead in today's session. The take home for all from my presentation, and we'll of course discuss at the end of all talks, is that this clinical tool is simplifying life for our patients, increases patient understanding about their diabetes, increases patients' onus about self-care, helps reduce HbA1c and better manage diabetes, helps people with diabetes reduce long-term complications, and helps us reach a more targeted treatment option. To understand this better and see this more in clarity, may I now invite the rest of the experts for their presentation. We are starting with Dr. Jyoti. Is that right, Jyoti?
Yes.
Yeah, please.
Am I visible?
Yes.
Okay. So first of all, thanks to my dear friends, Dr. Manoj, Dr. Mankesh and Amit. And thank you very much, Dr. Neeta, Dr. Sanjay and the group, Idec, for inviting me. And hello to Anjali. So this is going to be a continuation of what Dr. Manoj has said. So I will be spending another 7 minutes. Manoj, I got a red one. So I am going to discuss on the methods and the evidences. So Dr. Manoj and we have decided that we will split the topics amongst us, and I'll be focusing on the methodologies. So Dr. Manoj has discussed about TIR in detail and a brief introduction on the CGM devices. So what are all the devices which are available with us for assessing the continuous glucose monitoring? Because you need 14 days of continuous glucose monitoring, of which 70% of the data is available for a meaningful evaluation of time in range. And the time in range can be for 7 days, for 14 days, and even beyond that. So these are some of the devices. I'll be, of course, making a brief demonstration of some of these devices. But how do you classify it? So the broad classification of continuous glucose monitoring devices will be, number one, the real-time devices. The real-time devices are those devices which will display the values in real time all the time. So one example is the Guardian Connect, the sensor, which is very popular, which can be applied over the abdomen, or even nowadays it can be applied over the upper arm as well, the generation 3 sensor. And then the example of an IS-CGM is a flash glucose monitoring device, that is the intermittently scanned CGM. And then you have the blinded CGM, and in the blinded CGM, you will download the data at the end of recording, and that can be at the end of 7 days or at the end of 14 days for Libre Pro. So Pro stands for the provisional version. iCGM is currently not available in India, and these are examples of CGMs which can integrate with a third-party device. It can be a connected insulin pen, it can be a connected insulin pump, or it can be a third-party dosing algorithm which is integrated in the smartphone. So very recently at the American Diabetes Association, we presented this data. So Dr. Manoj just presented the data on the correlation between A1C and the time in range. So a time in range of around 70% correlates with an A1C of 7%, which is the data which has accumulated from the studies which has been conducted by Vygotsky, McMahon, and these were in Caucasian population. So we tested in our population, and we also found that it is closely correlating in our population, and exactly what Dr. Manoj said, aligning to his observations and the recommendations. TIR and A1C are different. If you look at this chronic care model from our telemedicine, A1C less than 7.5% is achieved by 67.5% of the patients. And this is the data. But if you dissect, and if you look at the TIR data, it is quite different. Those TIR more than 70%, that is achieved by only 36% of the subjects. So these two are completely different. So even when the A1C is the same, the TIR is going to be entirely different. And more the TIR, if the TIR is different, and if it's more of glucose variability, these are the patients who will come and complain to you that, doctor, I'm having mood swings. Doctor, I'm having tiredness all the time. And I feel exhausted all the time. And the TIR, what is the significance in clinical practice? This is the DCCT derived data. If the TIR is less by 10%, assuming that the TIR is 60% and not 70, or from 80 to 70%, 10% lowering of TIR increases the chances of retinopathy by 64 and microalbuminuria by 40%. Neuropathy increases by 25%, and there are evidences to show the increase in surrogate markers of macrovascular complications such as carotid intima media thickness, again related to TIR. So these are some of the devices. Let me stop sharing now, and I will spend a couple of seconds here to demonstrate. So this is a Dexcom reader. Of course, it is not available in India, but Dexcom is supposed to be one of the best devices. And this is supposed to be the gold standard with the lowest MARD and the highest accuracy. And this is, of course, the sensor from Medtronic, which connects to the Medtronic devices, the Guardian Connect, and the Guardian Connect connects to your iPhone or any compatible other phones.
One sec, Jyoti. Can I ask the organizers to pin on Jyoti, because he's going to demonstrate, so we have him on the screen? Can the IT guys just spin Jyoti's video currently?
Yeah,
So
to spotlight. Thank you very much. Thank you very much, Dr. Manoj. So Manoj has asked me for a demonstration. So I will show these once again. So this is the Dexcom sensor, and this is the Dexcom transmitter, not available in India. We are just demonstrating this from our clinical research department. And this is the Dexcom, which is a monitor. Of course, we can also use a smartphone. And you have two sensors for Libre, the Freestyle Libre Pro and the Freestyle Libre. The Libre Pro comes with a reader which is white in color, and this is there with your office all the time because it is a professional device. Whereas for the Libre, it comes with a reader which is black in color. And let me have a demonstration because I have put a sensor over here for the demonstration, and it takes only a couple of seconds. I will say that microseconds to have this flash glucose monitoring. So this is an example of intermittently scanned device. So every other minute I can scan. See, I am scanning over my clothing, and this is my glucose value 124. So these are the popularly available devices currently in our country: GC, Libre Pro, and Libre. And this is a publication from Dr. Mangesh Divaskar. So all of us are involved in generating evidence from our own country. And this is a reality in India. And this is from our own Dr. Manoj Chawla, his consensus and recommendations on the use of CDF. And this is Guardian Connect in the beginning. And this is 25% time in range. And in the end of 3 weeks, it is 100% time in range. So this is the beauty which Dr. Manoj has already described on how you can gather the data, interpret it, and translate into therapeutic decision making and better outcomes in diabetes. And this is how you can scan, and the reader can also display the data on time in target, below target, above target, and the arrows in the reader or in the Guardian Connect that indicates the magnitude and the direction of change of glucose. So the arrow is pointing upwards vertically, then the glucose is rising very quickly. If it is slanting, then the glucose might be increasing only by 30 milligrams in the next 30 minutes. And this is sharing a glad news and exciting news with you. Maybe for the first time in the history of AS, American Association of Clinical Endocrinologists, in their 2021 practice recommendations in technology, they have incorporated an original research from India on continuous glucose monitoring. And we have been using the virtual COVID IP care. We are still very active with our VCIP because COVID is still a nightmare in our state in Kerala, with a lot of patients even dying every day. And this is how we are doing interventions, including corticosteroids and injectables at home with remote monitoring. And in this new interventional home care model with more than 99.95% success, we have shown that it is possible to keep more than 95% time in target, more than 95% time in target with less than 1%, that is less than 15 minutes time below 70 milligrams per deciliter. So this is an urgent need. This is Dr. Benchi Sabu and the group to implement time in range as a target is an urgent need all over the world. And this is exactly what we are discussing today. Thank you very much, Dr. Manoj and the team.
Thank you, Jyoti, for taking us through all the newer papers, the evidence for the same, the link with complications, and we will continue to discuss and take questions from the audience. So we now move to the presentation by Dr. Mangesh, and Mangesh will be speaking to us about the different recommendations and explaining in detail what really aspects of the time in range, above range, and below range mean. Mangesh.
Thank you very much, Manoj. Thank you, Dr. Jyoti, Dr. Amit, and entire team Idec, Neeta and Anjali and everybody. And Manoj, you really spoke beautifully as far as the context setting, and most importantly, you really set the ball rolling as far as how important to understand the importance and the value. And if you remember the post that you presented in last year's ATTD, it was last year's ATTD 20, probably it was ATTD 2010, was it? Where for the first time the concept of time in range was discussed, right? It was that time, and now see almost a decade down, now even the guidelines have started speaking about it. So this is how the whole, I would say, the concept of time in range and the importance of glycemic variability has changed. Okay, so that is very important for you to understand. And as we progress, as we have appreciated Neeta's efforts and the team IDEX efforts to appreciate our all Olympic gold winners, let us also put our hands together for Paralympic gold and the medal winners. And till yesterday evening, probably the tally was 13, 2 golds, 5 silvers, and 6 bronzes. So that is how our Paralympic champions also doing well. So let us appreciate them as well. So talking about time in the range, what are the recommendations, as Dr. Jyoti and Dr. Manoj has beautifully, set in the context. This is what Dr. Jyoti was talking about, how important it is that more the time you spend outside the range, the likelihood of both micro as well as macrovascular complications are very high, but especially macrovascular complications, which are very difficult to treat, are one of the most challenging areas which can be effectively addressed by just monitoring the patient's time spent into the range. So this Manoj has already shown you what exactly you mean time in range, but how much time and how do you classify various ranges? See, we need to understand the regular range for most of the diabetic people is between 70 to 180. In few of the occasions, it can be up to 70 to 140. In diabetes in pregnancy, especially when it is type 1 diabetes, the range can be still tighter, and the time in range needed to be spent inside the range also goes up significantly. So let us look at various ranges. If you really see, this is the green which we are seeing on the screen is the time which is required to be spent in range, that is in between 70 to 180. And majority of the times the patient is expected to spend more than 17 hours in this range to have the minimization or the reduction in the target organ damages. Now, if the range is, in the range of 181 to 250, then that is called as level 1 of hyperglycemia. And here, probably the patient is allowed to spend not more than 15%. And even lesser percent of the patients are allowed to spend in the level 2 hyperglycemia, which is usually about 250 milligrams. And remember that this range between 250 and above should be as low as possible. Similarly, if you really look at time below the range of 54 to 69 is called as level 1 hypoglycemia, and lower than that is called as level 2 hyperglycemia. And at no point, patient should be spending less than 4% or less than an hour's time in the time below the range. So these are various different, I would say, recommendations for the time in range for different diabetes populations. You can clearly see that garden variety type 1 and type 2 diabetic patients, this is what we exactly have discussed, that the patients are expected to spend more than 70% time in range, and then the time above range should be less than overall 30%, but the higher or the level 2 hyperglycemia should be less than 5%. And this is what we talked about, the time below range is that less than 4%. When you look at this older population, high risk population, type 1 diabetic with the high risk population, probably the time to be spent in range is little liberal. People are little liberal, and there you can have your patients to spend around 50% of the time in range, and then you may have 50% or lesser time spent above the range. But at no point you should be allowing them to stay below the range as much as possible. As Dr. Manoj has already spoken to you, look at this. If it is type 1 pregnancy, then you need to spend a lot of time in the tightly controlled time in the range of 63 to 140. And you are supposed to spend more than 70%. Either the lady has to spend that much of time in the range to avoid complications related to pregnancy. But if it is type 2 pregnancy or a gestational diabetes, then almost nearly the range is same. But the thing is this, that the majority of the time the patient has to spend the time inside the range. But then probably Dr. Sanjay Kalra and team thought that we need little better clarification on this. We need little more, I would say, diversification of the recommendation. And that's the reason why an expert group of 15 countries, including India, which included Nepal, Indonesia, Ghana, and some of the African countries. And they came out with the similar concept, but then they came out with a very, very specific population-based guidelines. Like, look at this, adolescents, probably the same time in range, 80% or more for type 1 diabetic patients, garden variety, and 70% or more of type 2 diabetes patient, garden variety, to be spent in the range. Time above the range, same 15% for type 1 diabetic and 25% for type 2 diabetic, and time below the range at no point of time should cross 5%. Adults with type 2 diabetes is and fairly well controlled people, the time in range roughly stays same. Pregnancy, same, we have not to go ahead. But then elderlies, you need to look at this. The range have changed itself from 170 or 180 to 200. Now, this is what is the difference. And here also, the elderlies, those who are not having any comorbidities or they are having a normal life expectancies, then probably they should be treated as the regular adult patients, and the time in range criteria should be the similar application as for the any other people. People those are with high risk of hypoglycemia, having renal and hepatic disease as well, should be also spending time in range for more than 70%, but little still better monitoring. But then what is most important is the microvascular complications and the macrovascular complications. For all these populations, the time in the range needs to be very tightly controlled, and at no point of time they should be allowed to go below the range by more than 5%, that is for sure. People with concomitant infections and comorbidities, the time in range stays same. I think this is for my part of the story. Early over to you, Manoj, for the further talk.
Thanks, Mangesh. I think that's extremely important today, that when we're talking about time in range, for everybody to understand what these numbers are. Just the way today we can rattle out the blood sugars and HbA1c numbers and explain to the patient, these numbers are important, especially when we're trying to explain to the patients and passing the control and the onus of control back in the patient's hands. So those numbers were extremely important. We'll of course discuss the other guidelines which you showed for adolescents and adults, and that Asian paper from Sanjay and others that you showed. We'll discuss that in the chat session. Now we move to final presentation here by Dr. Amit Gupta, who's going to be talking about an important aspect. Now that we all understand that time in range is complementary to HbA1c, how do we really improve the patient's time in range, reduce the time above range, and minimize or avoid any time below range? So over to you, Amit.
Thank you, Manoj sir, for giving me this opportunity. At the outset, I would like to thank Dr. Neeta and Dr. Sanjay sir for giving me this opportunity to present at this very, very prestigious forum. Sir, as you have rightly said, we have already discussed, you have elaborated well in detail that what is time in range, and it is not the same as the HbA1c. And secondly, you also told us that what are the targets, and Dr. Jyoti Dev sir has already demonstrated various devices that how do we calculate time in range. So now for the next 5 to 6 minutes, I will be speaking, is there anything which we can do to improve time in range? So this is a very, very important thing. And I would like to highlight upon the strategies which can be there. My full screen is not visible, sir.
Not yet, Amit. We'll have to make it full screen.
Just give me a second, sir. I hope it is visible now, sir. So I would just like to highlight that there are intraday as well as the interday glycemic variability, and we have seen that these are the risk factors in people with diabetes. And now there are several factors which have been proposed to help reduce glycemic variability and improve TIR. And one of the strategy is to change the TIR is the insulin treatment. And the factors which contribute to improving glycemic variability and TIR are timely insulinization, choice of insulin, initiation of the right dose, proper timing of the injection of the prandial insulin, systemic and the adequate titration, and the prompt intensification when indicated. And the stepwise intensification is also important. And keeping the regime simple and dosing flexible is again very, very important to keep to improve the timing range. If we look at this, we have to identify. Now we know that we have 2 generations of the basal insulin. The first generation, that's insulin glargine 100 and the insulin detamir, and the second generation basal insulin, we know the glargine 300, the insulin degludec. And it is important to understand the differences between the first and the second generation basal insulin analogs. It is again very, very important to highlight that as far as the efficacy is concerned, that is the ability to bring down the HbA1c, it remains the same with all the first generation as well as the second generation insulin. However, the newer analogs have longer and more stable PK and PD profiles. They have low variability with predictable and stable glycemic control beyond what we achieve with the older insulins. They have longer duration of action, more than 24-hour coverage, reduced glycemic variability due to more stable PK profile, and better injection time flexibility. At the same time, there is a lower risk of all-day hypoglycemia as well as a nocturnal hypoglycemia, and there is a greater improvement in treatment satisfaction, patient-related outcomes, and the quality of life. So if you see, Just a second, sir. If you look at this slide where we are talking about the improved control over glucose variability, one of the study by the Yu et al. Compared the real world benefits of the Glargine 300 versus Glargine 100 in lowering nocturnal fluctuations in the blood glucose levels and the nocturnal hypoglycemia in people with type 2 diabetes. And the mean nocturnal glucose level was, however, similar, but there was a significant difference in the variability in mean nocturnal glucose levels, which is defined as standard deviation and the coefficient of variation, and the mean amplitude of the glucose excursion between nights. They were significantly lower when the Glargine 300 was used in comparison to the Glargine 100 for the duration of the treatment. And also, Glargine 300 is comparable to Glargine 100 in providing tight glycemic control, but it had a greater potential to reduce the frequency of nocturnal hypoglycemia. At the same time, its significantly lower glycemic excursion was observed during the last 4 hours of the 24-hour injection interval when it was compared to the Glargine 100. And irrespective of the morning or the evening injection, mean 24-hour glucose curve for the Glargine 300 groups were smoother than for the Glargine 100 group, again indicating lower glycemic excursions. As we have seen that the HbA1c of 7.2 in 2 different patients may not be the same, and the path taken to achieve this HbA1c may be totally different. So improving glycemic variability can actually improve the outcomes in patient, as highlighted by Dr. Mangesh sir. Another study by Yamamoto et al. In type 1 diabetic patient, it investigated the difference in glycemic variability between Glargine 100 and Idec using CGM. And what the result, the results of this study was that the mean amplitude of the glycemic excursion was significantly reduced with Degludec, as was the area under the curve for daily blood glucose levels, and Degludec confirmed reduced hypoglycemia and daily blood glucose variability in participants with type 1 diabetes as compared to the Glargine 100. Another study by the Idec et al. In patients with type 1 diabetes found that the fasting interstitial glycemic variability on the CGM curves was significantly less with Idec than Glargine 100, and the authors of this study concluded that while the hypoglycemic episodes were similar with both Idec and Glargine 100, treatment with Idec was associated with lower glycemic variability. We know their second generation basal insulin Glargine 300 as well as insulin Degludec, and they have been also compared with each other, and a study compared the PK and PD profile of Glargine 300 versus Idec 100, and what they found is that Idec demonstrated that an evenly distributed PK profile and better steady state PD profile with Glargine 300 in people with type 1 diabetes with once daily dosing regime of 0.4 unit per kg per day. However, another study reported that Idec 200 had lower intraday variability and interday variability compared to Glargine 300. As we know, the BRIGHT study was the first head-to-head clinical trial which evaluated the efficacy and safety of Glargine 300 versus Idec 100 in insulin-naive adults with type 2 diabetes who were inadequately controlled with OADs. And both the insulins provided similar glycemic control, but with relatively low and comparable hypoglycemia incidence and rates during the overall study period. Another study, that is the CONCLUDE trial, reported that incidence of overall symptomatic hypoglycemia was not significantly different when we compared Glargine 300 and Idec 200, and the study could not meet its primary endpoint, so secondary endpoints were considered exploratory and not conclusive. And a small-scale study also used CGM for comparing the safety and efficacy of Glargine 300 and insulin Degludec. So this was the results of the CONCLUDE trial, which we have already discussed. And again, one of the important key findings was that the mean percentage of TIR was similar with both the insulin types, but the percentage of time in hypoglycemia was significantly lower with the Glargine 300 when compared to the Degludec, and the percentage of the time which was spent with nocturnal or severe hypoglycemia was also significantly lower with Glargine 300 with insulin Degludec. So the study showed that during insulin Degludec treatment, the mean percentage of the time with hypoglycemia, especially nocturnal hypoglycemia, significantly correlated negatively with albumin level, possibly as a result of the reversible binding of the insulin Degludec to the albumin. So it is important to understand that although the use of CGM allows better assessment of the glycemic control, taking TIR into consideration, large-scale studies based on CGM to compare the safety and efficacy of the Glargine 300 Idec are still lacking. And the InRange is again an ongoing multi-center phase 4 study that will collect CGM data over 20 days in adults with TM and DM receiving either Glargine 300 or Idec 100. So what do we get? What are the clinical insights on TIR recommendation which are available now based on the modality of treatment? Second generation insulin like insulin Degludec and the Glargine 300, they score better than insulin regimes in terms of increased duration of action, lesser glycemic variability, improved quality of life, reduction of the diabetes distress, better adherence, prevention of the cognitive dysfunction and long-term complications. And in practice, they perform they have lower hypoglycemia compared to first generation insulin. And TIR recommendation, we need to understand, they remain the same regardless of the modality of the treatment. It doesn't change with whether you use OHA or the insulin or the GLP-1, and the treatment should be directed at achieving the TIR, as we have seen earlier why it is important. And this can be achieved with basal insulins, especially the second generation basal insulins, though there are minor differences among them also, but we need to have more data to say something more conclusively. And the TIR target remains the same regardless of whether the patient was on any insulin or the OADs. So with this, I would like to conclude this presentation, and I would hand it over again back to Manoj sir for the presentation.
Thank you, Amit. And well, I think let's have everybody here into the. Yes, so we have. Great. So I think everybody's finished in time, and we have some time for our question and answers and discussion. Would invite questions again from all the faculty. Yes, can we have the spotlight on the gallery, or we already have it?
It's there already.
Okay. I don't know. I'm still continuing to see Amit in 3D. Okay. We had different talks, and I would again ask Dr. Anjali and organizers if there are questions from the delegates to post that to us. Let me ask start by asking Jyoti. Right. So Dr. Jyoti, there is some criticism of the entire time in range thing, and I'll give a practical example in asking. Now, there may be individuals who may be starting their day in the morning in the sugar range of 150. And you see their CGMs and you see that they are starting at 150s, and probably after each meal, you will see them jumping from a baseline of 150 to 200, 210, and then it starts coming down. So if you see they're starting at 150s, 160s, staying there, there is a certain peak after a couple of meals. But when you look at their time in range, you get a time in range of about 75% within range, because you have kept your time in range standard as 70 to 180. So they're getting a 75% time in range, but their actual HbA1c is stuck around 7.8 or 8%. Now imagine this scenario. And there are a lot of those out there with who are starting the days at 150. So how, the other point here is that one feels that probably getting the time in range to more than 70% is much easier than having your HbA1c under 7%. Comments from Jyoti and all Mangesh and Amit. And
absolutely. There are 2 or 3 points. I will have quick answers to your question. Number one, all the CGM devices are not having the same accuracy. Number two, like what has happened with the glucose meters over the last 40 to 45 years, the CGMs are also advancing in their accuracy. And there are only 1 or 2 CGM devices which are approved by US FDA for non-adjuvant use. So non-adjuvant use means you can use it without the glucometer for either a calibration or for verification. So when you are using the devices currently available in India, please remember they are fairly very accurate, but you should be, even if in the absence of a calibration, the patient should be taught that they should be cross-checking with the glucometer, because sometimes there can be a difference of 20 or even 30 milligrams per deciliter or even more. And in the same subject, the difference will remain the same for 14 days. And the last point that we discussed, Dr. Manoj, as you have said in the introduction, it all depends upon the duration spent in hyperglycemia. So there is a level 1 hyperglycemia and level 2 hyperglycemia. And the time in range is picked up only if it is at least 15 minutes. So if the 200 or 240 is 30 minutes or 1 hour after the meal, and if it is very transient for 5 or 10 minutes, it disappears. It is not picked up in the TIR. So that is okay. And of course, if it is relevant enough, then it will be shown in the TIR. And that is exactly the reason why, Manoj, you also said in the beginning, you should be treating TIR separately and you should be treating A1C separately. So if the postprandial glucose excursions are significant enough, that is an indication that you have to change and you have to modify the therapy.
Thanks, Jyoti. Yeah, sorry, Anjali.
Yeah. May I have a question over this, sir? Sir, I mean, it may be too early to say anything like that, but I think HbA1c is a marker of glycosylation of the hemoglobin. It may not always correlate with the glucose level in the blood, because there are many processes between the blood glucose in the blood being, the glucose level in the blood being high and the hemoglobin getting glycosylated, because I think there are different people who have different types of glycosylation. What do you think, sir? What would correlate more with complication, glycosylation or the level of glucose?
So I think so far we've had, because we were not looking at the glucose levels as closely as we are doing now through CGMs in time in range. I personally feel that the link with TIR with complications is going to be much stronger evidence. But prior to this, as HbA1c was the only verified metric, we use that. Today, we know that HbA1c in the normal range also has a huge variation between Asians and Black Americans and Africans and Caucasians. But that 7% has been more generalized. But today, we still have that strongest link. Probably things will change as we move on, which actually gets us to the next question. And I can see Dr. Shashank has also joined in and put comments from him, Mangesh and Amit to this next question. And the doctors asked us, and it makes sense that for Indian patients, should the time in range be from 70 to 180 really? Or you think maybe moving it up to 80 to avoid more time below range and hypoglycemia, and probably the upper one at 160 may give us more a better insight if we change it from 80 to 160, especially the lower one. Mangesh?
Yeah, so I would probably answer this in a couple of ways. First and foremost is these are all the developing areas where we are still working on it, and there are no specific I would say data which have been really as HbA1c has gotten hard outcome data which we have.
Mangesh, quick answers. The moment you see Neeta on screen, that means you guys have to shut up and get out.
Probably I think we need to stick currently to the recommendations at present. We need to still generate the data.
For global parity, stick to the current data.
Yes.
Because you have a point, two things. We need to validate it in Indian circumstance. And you and Jyoti should take a lead and do that. Yes. Because, in the Indian circumstance, actually, the Indian true fasting is 66, which a study was done at KM Hospital of our diabetology students almost 20 years back. And it is published also. And that, the normal Indian fasting sugar is 55 to 65. So if it is 55 to 65 as normal Indian sugar, then we need to really work it and develop an Indian norm. But I think you and Jyoti Dev can have a CGM norm or an interstitial fluid glucose norm. Yes. That is a work in progress.
I think that's a great point by Shashank, because we've been doing CGM in a lot of pre-diabetics and even normal glucose tolerant individuals because they wanted to study. And it's not surprising to see the sugars in the 60 to 70 for non-diabetic individuals without any symptoms. So absolutely right that, the lower normal, and this is not on the first and the last day, which may give us errors, but actually readings being in that range. I think we've had a wonderful session on time in range. I can see that the time's up. Hopefully this session has been an awareness creating session for many physicians attending today to understand the emerging concept of time in range better, and appeal that let's understand this. Let's include this metric as far as possible in our regular clinical applications, because this will be one metric which may improve the lives of people with diabetes, and importantly, hand the control to them to understand this better and work towards improving the overall time in range and avoiding hypoglycemia. Most importantly, avoiding the time below range. Thank you so much for having all of us here. I hand it back to the organizers.
Thank you.
Thank you so much. Thank you.
Yeah.
Thank you very much, Manoj and team. Dr. Mangesh Divaskar, Dr. Jyoti Dev and Amit, thank you so much. It was a wonderful session. And we will now move on to the next session that we have on our agenda. And it's an entire afternoon of drug reviews and therapeutics. And for this, to start off and kick the proceedings along, we have our very first speaker, none other than Dr. Shashank Joshi, who is now going to take up the first talk in the drug reviews and therapeutics session. And Dr. Shashank is going to talk to us about reviewing the evidence, glycemic control and weight loss with dapagliflozin. And absolutely, I'm sure that Dr. Shashank Joshi needs no introduction at all. And he is a very good friend, excellent speaker, orator, great academician. And his bio data will run into several pages. So I won't go into the details because everyone is aware. And I am now going to ask Shashank to please proceed with his talk.
Thank you, Neeta. Thank you, Sanjay, Neeta, Anjali, everybody, for keeping this. You will have to allow me to share the screen, please. Hello?
Yes, it's done.
Not able to share the screen. You'll have to.
Are you enabled now?
Can you see my slides?
Yes, I can.
Yes. So this is a talk. I have duality and conflict of interest for this talk because it's with micro labs, and I also have a duality and conflict because all the four actually SGLT2 inhibitor companies have some relationship with me either as a speaker bureau, advisor, or research trials. So thank you, Dr. Agarwal, Dr. Deshpande, Dr. Sarda, Dr. Bhatt. We are going to review evidence on glycemic control and weight loss with dapagliflozin. And it is going to be in context because DAPA now has become generic as far as India is concerned. So we all know this very well. Diabesity is the predominant driver of type 2 diabetes in India. And we know its complications like cerebrovascular disease, cardiovascular disease, micro and macrovascular events, renal complications, dementia, cancer, and even eye disorders are well known. We also know that in the Indian scenario, generalized obesity is around 58% when we use the Indian cut points, and combined obesity of diabetes and obesity is around 53.4%, and abdominal obesity is around 81%. We also know that clearly the risk with the BMI going up, just like A1C going up, the risk of prediabetes and diabetes goes up. And the lifetime risk of progression of prediabetes to type 2 diabetes is increased by BMI data and waist circumference data. The Rotterdam study showed us very early. And we know that the age of onset of prediabetes was around 10 years later for adults with normal weight strata compared to the obesity strata. Now, we as an ethnic group, Asian Indians, are more at risk both for diabetes and obesity. And probably the Asian adults have a 5-year risk of progression to type 2 diabetes within years versus Caucasian. So we have a malignant transformation from pre-diabetes to diabetes. And the prime driver in that is probably obesity. Because we know obesity drives inflammation, which is chronic, in the adipose tissue, liver, hypothalamus, pancreatic islets. And eventually it leads to systemic insulin resistance and beta cell dysfunction. And that's really the core. We also know that we need to do a tighter glycemic control in people with type 2 diabetes and obesity, because we know the diabetes patients, the prevalence is high and most of them have a very poor diabetic or a glucose control. And obesity is a determinant of poor glycemic control or metabolic control. So glycemic control in obese patients with type 2 diabetes is very key. And in order to prevent microvascular complications, because it significantly affects quality of life as well as outcomes. So currently we have a lot of challenges with weight gain during anti-diabetes therapy. We know considerable amount of anti-hyperglycemia therapies have considerable effects on patient's weight, and careful consideration for weight loss therapy in people with diabetes and obesity is now the standard of care. For example, glitazone, sulfonylureas, glycides, insulins all cause weight gain. We know gliptins, fixed ratio insulin, GLP-1s, and various other therapies are weight neutral. And it's only that the ones which promote weight loss or maybe weight neutral are metformin, SGLT2 inhibitors, GLP-1 receptor agents, alpha glucosidase inhibitors, and amylin myelomatics, in which top on the pecking order is SGLT2 inhibitors. In fact, it's the era of SGLT2 inhibitors. And clearly we know that an OHA which improves glycemic control and reduces weight is clearly the need of the hour. So SGLT2 inhibitors have arrived, and their role in weight loss is dual. They essentially have an impact on body weight in diabesity through two mechanisms. One is by increasing urinary glucose excretion, they cause caloric loss and weight loss and reduction of fat mass. And second is by reducing the insulin to glucagon ratio, they increase lipolysis and they actually melt fat and they cause weight loss and reduction in fat mass. So clearly, and without affecting the lean body mass. So this is very, very significant that clearly they shave off the fat through the lipolytic mechanism by reducing the insulin to glucagon ratio and by causing simple glucose urea and calorigenesis, they are able to lose weight. So Asian type 2 diabetic patients with abdominal obesity, the clinical recommendations are very clear cut. And it is recommended to promote weight loss, to reduce visceral adiposity in Asian patients with type 2 diabetes and obesity. So it's a recommendation from Asia to promote weight loss. We can use SGLT2 inhibitors. In fact, 2/3 of the SGLT2 inhibitor induced weight loss is attributable to reduction of body fat mass. And it also reduces waist circumference, ectopic fat deposition in non-adipose tissue, improves adipose tissue function, quality of life, and patient-reported satisfaction. Clearly, some time back, this was an evidence-based consensus position statement, which was come out with several authors. And you can clearly see that weight reduction due to loss of fat mass is primarily from the abdomen rather than lean mass. It's not only the weight loss and the glucose control, but it's durable, it's sustainable. So both the glycemic control, body weight, and blood pressure reduction with CV benefits and renal protection is sustained without any risk of hypoglycemia. And there is a persistent calorie loss. So clearly this is sustained, durable glucose control, blood pressure control, cardio-renal control, cardiometabolic control, and that of course Gaganpriya will talk on it. But my predominant focus today is on weight loss. And reduction of body weight, more visceral fat mass loss than subcute fat, reduction in insulin resistance, and improvement of beta cell function is what SGLT2 inhibitors do. So in the Indian patients, we know they have more abdominal obesity and visceral fat at any given BMI, and SGLT2 inhibitors by evidence-based in India reduce that. The higher waist circumference and higher waist to hip ratio is reduced. The lower adipokine and higher plasma leptin levels are reversed. The lower rate of glucose disposal is modulated and increased, and the beta cell function and insulin resistance is improved. Also remember, SGLT2 inhibitors in combination therapy have a huge impact. For example, SGLT2 inhibitors combined with drugs which reduce food intake like GLP-1 receptor agents on energy intake and energy expenditure and their compensatory effects. Clearly you can see here that they can have a greater weight loss in two ways. They increase food intake by evoking energy loss during SGLT2 inhibitors, and that can be partly prevented by appetite reducing therapy. So clearly you can see the equations on both the sides of the curve. The SGLT2 inhibitors will increase the EE via glucosuria, and the food intake inhibitor like a GLP-1 receptor agent will decrease EE via cellular metabolism. And the combination of the two is clearly synergistic. And the reduced cellular energy expenditure occurring after weight loss achieved by the GLP-1 receptor agent is balanced by the urinary caloric loss secondary to glycosuria. So these complementary mechanisms of actions again make it very attractive for weight loss. So what do the guidelines say with diabetes and obesity? Clearly, if you see the ADA 2021, obesity management can be progression from pre-diabetes to diabetes and is highly beneficial. In fact, off-label, many of us in pre-diabetes with obesity are using the SGLT2 inhibitors after it has become generic. There is modest and sustained weight loss which improve glucose control and reduce the need of glucose-lowering medications. And this is the evidence based on that. And it is pretty compelling as the BMI goes up. Clearly, beyond diet, physical activity, behavioral therapy, when choosing a glucose-lowering medication, one must compare the impact of that medication on the body weight. And after metformin, SGLT2 inhibitors is clearly there. Of course, there are other agents also, but they are minimalistic in that recognition. If you look at the American College of Clinical Oncology ACE recommendations, they again say it is individualized therapy, try to reduce body weight by 5 to 10%, and probably SGLT2 inhibitors have a glucose-uric effect with reduced A1C, weight, and systolic blood pressure. So clearly they are there. The RSSJ ESI therapeutic whale was made in 2020 when the finance F feature SGLT2 inhibitors were not generic. And now we know that it is generic. So obviously, I think it's the only anti-diabetic agent with this feature with cardio-renal protection, weight loss, and is economical as well. Obviously, the efficacy is something which we need to establish. Is there evidence base for DAPA with established type 2 diabetes for efficacy on weight loss? Clearly, you can see that the clinical considerations are clear-cut. It lowers glucose independent of insulin action. It has a sustained effective glycemic control, reduces body weight, low risk of hypoglycemia, very well tolerated as monotherapy or as an add-on, reduces blood pressure, rate of cardiovascular death and heart failure, hospitalization, and progression to renal disease. This is data whether you add DAPA on monotherapy, add on to metformin, SU, MET and SU, gliptin with or without metformin or insulin. It is consistent. If your A1C is 8 to 9%, 0.5 to 1% drop in A1C in DAPA has been observed consistently. So the clinical trial data and the real world data, both are consistent. Both the data, the RCT data and the real world data, shows that A1C drops by around 0.8, 0.9 or 1%, as well as the weight loss is also achieved. So dapagliflozin achieves a comparable reduction on A1C and weight in real world practice as seen in randomized clinical trials, and we have seen this in clinical practice. And it also has a very, very important impact on energy metabolism, which I was talking to. This is a RCT which was done, and you can see here in this RCT, clearly, Go et al. Showed body weight was significantly reduced by dapagliflozin versus placebo. And in 5 weeks itself, within 5 weeks, there were metabolic adjustments mimicking caloric restriction. Fat oxidation was increased. Hepatic and adipose tissue insulin sensitivity was improved, and 24/7 energy metabolism was improved. So clearly you can see that in real world practice, it achieves quick A1C control. 80% have more than 1% A1C reduction, and 65% show both an A1C drop and a weight loss. Clearly this data is consistent. It maintains glycemic control and weight loss over a period of time. That's also very crucial, that it must last. It should not rebound back, and that is very consistently seen. And the data is consistent in Indian patients also. Dr. Vijay Vishwanathan's study I'm quoting here, where he has shown with DAPA, clearly it is a sustained effect not only on A1C, but also on the BMI, body weight, and waist hip circumference. So clearly now we have data from that study, which was an Indian pan-India study where DAPA was well tolerated. A1C and body weight came down in 6 months, and it achieved a significant weight loss. And various other replicative studies have also shown that it not only causes weight loss, but if you study the body muscle mass and muscle fat content, it is only the fat mass which is lost without reducing muscle mass. So this is a very, very crucial study by Sugiyama et al. From Japan, where they studied, because the big fear is that people suddenly will say that we have lost a lot of weight, we'll lose muscle mass, but muscle mass is preserved and only fat mass is. What is unique about this molecule is that it also inhibits the hepatocyte death, because clearly it induces the reversal of NASH. You can see our SGLT2 inhibitors reduce inflammation, tag accumulation, and tunnel positive apoptotic cells in the hepatocytes. They reduce the insulin resistance in the liver, reduce the de novo lipogenesis in the liver, and increase the fatty acid oxidation in the liver. They reduce the inflammation, the reactive oxygen stress, as well as response, and hepatocyte death capsase 3 is reduced. So clear-cut down regulation is seen, and fatty liver, it chops off the fat. This was a RCT with DAPA, where hepatic and visceral fat was clearly reduced in a 12-week study, and this is some compelling data which is there. Also, when you add it with insulin with OADs, usually it is very well tolerated, body weight is reduced, and many a times we are able to chop off the insulin as well. Also, this is a meta-analysis where you compare 2.5, 5, 10 milligram and 20 milligram of DAPA. You can see the weight loss reduction is consistent. So you can see it's all on the left side favoring dapagliflozin, and clearly you can see that weight loss reduction is dose dependent. So higher the dose, the better is the dose reduction, and body weight is significantly reduced in people with different doses of SGLT2 inhibitors, and it is statistically significant dose dependent. Clearly you can see that weight reduction is significant, it is compelling, and it is impressive. So the key insights which we learned today is that SGLT2 inhibitors on body weight is an important component for obese people with type 2 diabetes with consistent weight loss, which is vital for effective management. And that is why SGLT2 inhibitors have become universal agents. I call them versatile agents and universal agents now. They probably might replace metformin. The data is coming up so much that the cardiologists and nephrologists have already taken them away. And I'm certain that in times to come, the obesity experts will also take them away, because they are originally diabetes agents. But the data is so overwhelming that particularly Asian patients with type 2 diabetes, whether in combination or in monotherapy, they promote weight loss. DAPA maintains glucose and weight loss, which is sustained over a year or two. And early use of DAPA enables not only better glycemic control with weight loss, and can become a standard of care in routine practice. Thank you for a patient hearing. Thank you for a patient hearing.
Thank you so much, Shashank, for excellent deliberations.
Thank you so much, Shashank, for excellent.
One second. Yeah, my question to you, Shashank, at this point is, since we are talking about weight loss with dapagliflozin, if we had to actually use an agent for weight loss with good glycemic control, Obviously, SGLT2 inhibitors are the choice nowadays. But do you see any difference between the weight loss effect of different SGLT2 inhibitors?
So that's a good question, Nita. Is it a class effect or is there a differential effect of different agents?
Yes.
So currently, if you ask me overall, if you look at the SGLT2 inhibitor ability or capacity, you have CANA, which is the broad spectrum, then DAPA, which is intermediate spectrum, IMPA, which is restrictive spectrum, and REMO, which is again a broad spectrum. So from the SGLT2 inhibition perspective, it doesn't impact weight loss so much. If you ask me, more or less, we will expect it to be similar for all. The data is best generated in terms of liver fat, visceral fat, RCT data, Asian data with DAPA. So when it comes to evidence base, it is most documented with DAPA, but I would not be surprised if it also is replicated by other agents. See, each SGLT2 inhibitor has its own molecular nature, and each one of them will have some impact. Now, one thing is sure that CANA 300 mg was supposed to start a study called CAN-FEN study for obesity. And they had to abandon the study because, CANA got associated with amputations.
Right.
And that is why they had to take up the study. Dr. Panikar and myself, a couple of years back in JAPI, published our own data from Lilavati on various SGLT2 inhibitors. We found that by and large weight loss was similar, but CANA 300 may have a little more weight loss, was what was observed. But currently, as I said, CANA has its own challenges with adverse events. And DAPA is probably having much better data on kidney and heart. And that is why probably the preference as a universal agent on weight impact is better. Also, the energy metabolism studies, Nita, which I alluded to, have not been replicated with other SGLT2 inhibitors. With CANA 300, there were 2 trials which were attempted. Both the trials showed weight loss, but no energy metabolism study has been documented. Fatty acid oxidation studies are universal for all the 5 SGLT2 inhibitors, including ertugluflozin and remogliflozin. But those are early phase 2 trials. So from a data standpoint, DAPA has an advantage. DAPA has been the agent now, this is a SGLT2 inhibitor year, if you ask me. Next year might be a semaglutide year. So and DAPA has become generic. It is easily available and accessible to most of our patients.
Right. There is one question from the audience. Dr. Sunil Mewada wants to know, can DAPA be given in non-diabetics for weight loss?
So off-label, whether it should be given or not in a research trial, it can be given. I have used it off-label in pre-diabetics. But in absence, normal glucose, I may not use it. But our cardiology colleagues and nephrology colleagues, now that it's actually approved to use it for other indications. So I am certain that SGLT2 inhibitors will find a space in the obesity space as well. They will get very close competition, and Nita will agree with me, from oral semaglutide. Right. Only thing is, oral semaglutide does not have CV outcome. The SOUL study is a soul searching study. If that SOUL study comes positive, then they will be in neck to neck with an agent like DAPA. In absence of the SOUL study, the current agent of choice probably, which is affordable, accessible, available, is probably DAPA. It's worth trying, but I would not say, because you also remember every agent which works has adverse events. So it can cause genital mycotic infections, it can cause urinary infections, it can lead a patient into euglycemic diabetic ketoacidosis. A lot of our patients do these fat diets like keto diets. So it can also be deleterious at times. So you need to be a little cautious and careful when you use some of these agents.
Right. There's one question that I would like to ask you, Shashank, and we have all seen in practice that and in the clinical trials that it's about 3 kg weight loss is what we expect when we start, and it is pretty much durable. But then there is a subset of patients who lose far more, and we have also documented that. So can you explain why some people lose so much more weight? What could be the determinant so that it's easier for us to focus on those patients for weight loss?
So Nita, this was studied by Sugiyama et al. And this was studied in that study. I would send you the full text of the paper. 2 things. See, the glucose urea is same for everybody.
Yeah.
The only difference is the fatty acid oxidation and the lipolysis. Some people will have more lipolysis compared to the others. So a patient A may lose 11 kgs, patient B may lose 3 kgs, patient C may lose 1.5 kgs, patient D may lose 7 kgs. The differential in the weight loss is accounted by the lipolytic pathway. and lipolytic pathway is probably the differentiator. But this is again early. I cannot say it with certainty.
Yeah.
This is what the Japanese literature says, and it's an interesting concept because we have these responders or super responders, as you are saying, which have much more weight loss compared to the others. Probably their ability to do beta oxidation is more robust. There, as there is another company which propagates now a concept of metabolic flexibility.
Yeah.
Their mitochondria are more. If you talk to Dr. Nair, my mentor, he will say that their mitochondria are more metabolically flexible. Just like we need muscle flexibility, there is mitochondrial flexibility. It could be a postulate. But these are all postulates, mind you. These are hypothesis generation. These are postulates, but these are interesting postulates. So I think they are super responders. And I have also seen in my practice some people lose dramatically up to 10 to 12 kgs.
Yes.
And they actually come and tell us that, sir, I have now dried up. Everybody's saying I'm sick.
Okay.
So they don't want the agent sometimes.
Right. Yes.
May I have one question?
Yes, Anirban.
Yeah, Dr. Joshi, the one small question, because we many times face from our physicians that because of the generic data, so many generic data available in the market from different Indian companies. So what is the difference between this with that of the innovator company? Whether they are same as far as efficacy is concerned, and whether they are same as far as their safety is concerned. What is your opinion?
According to me, I don't see any difference. This is a very honest question and honest answer. Okay, though there is a lot of duality and conflict of interest in all this, but I would be very honest. I think, at a molecular level, these are not biosimilars like biopeptides. These are easy to make. So I don't see there is major difference in all this. People will score brownie points, but I doubt it. We all know it now, and let's not get there. Sanjay and Neeta will throw me out from here, but I don't think there's any difference. I'm being very honest about it. Unless Neeta has a competing point, I think that's it.
No, that's fine. Thank you. So I don't see any other questions in the chat box. Thank you, Shashank, for a wonderful session and taking us through the glycemia and weight loss effects of dapagliflozin. Thank you for being with us. Thank you very much.
Thank you. Bye-bye.
Bye.
Finish 3 minutes earlier.
But we are on time now for your session, Dr. Anirban.
Yes.
So we now move on to the next drug review and therapeutics talk, and that is anemia in type 2 diabetes, a subject that is often ignored and not talked about much and not treated and looked for. So to take us through this important session, we have with us Dr. Anirban Majumdar, whom I would like to introduce now. He is professor at the KPC Medical College and Hospital, Kolkata, and is also the conjoint professor, School of Medicine and Public Health, the University of Newcastle, Australia. And he's the fellow of the Indian College of Physicians. He is also a ACE fellow and also has an FRCP. He has good number of publications, both national and international, and has been a principal investigator for clinical trials. So I present before you Professor Anirban Majumdar to talk on anemia in type 2 diabetes.
Thank you, Dr. Neeta. May I share my screen? Okay, I think. Is the screen visible?
Yes, it's visible. Please put it in screen show mode.
Is it all right?
Absolutely. Please.
Okay, thank you. So I'm going to talk about the anemia in diabetes. I convey my sincere thanks to the organizer for inviting me, and also to the MQ who has actually sponsored this talk. But importantly, this is a very good topic. And as Dr. Pandey has already introduced, that we actually conventionally don't evaluate the anemia among our type 2 diabetic subjects. Now, if you look into this important publication, it's just the same what Dr. Pandey has already pointed out, that it remains unrecognized, often undetected, and very, very importantly, even if it is detected, people are not actually treating those anemias in their clinical practice. So therefore, most of the patients with diabetes are rarely tested for anemia. And number two, if you at all tested for the anemia, if you find that there is an anemia, then very small number of patients receive the treatment. Majority of the situation, they don't receive any treatment, even though we know that the anemia has got a significant impact on the quality of life of the patients of diabetes mellitus. So let us have a look into the impact of the anemia on HbA1c. Now HbA1c level increases in iron deficiency anemia because the RBC lifespan goes up, and that is why the HbA1c value goes up. So screening for anemia before commencing treatment for diabetes is better. If you are diagnosing the diabetes on the basis of HbA1c, then you may be wrong if you are actually diagnosing on the backdrop of anemia. And when you are setting a treatment target on the basis of HbA1c, then anemia must be corrected beforehand. Otherwise, you actually are giving a wrong target in front of your patient. And strict HbA1c control is not recommended unless and until your anemia of your patient is well corrected. So with this small introduction, let us have a look into the prevalence of anemia in our country. I will also evaluate the impact of anemia on diabetes complications, the pathophysiology, some of my experiences, and the take-home message. Now, if we look into the prevalence of anemia in our country, it is almost everywhere. You will find in the children, in adolescent girls, in women, in pregnant women, including in the men. We have a roughly around, say, 50% of our population have anemia. It is slightly less among the men, slightly higher among the women. That is true, but the anemia is very, very prevalent disease in our country. And 2 to 3 times higher risk of anemia in patients with diabetes than those without diabetes. Second, the patient, those who have poor glycemic control, they are at higher risk of developing the anemia. And third, if you have a renal disease in the backdrop, we all know that the anemia and chronic kidney disease are very intimately linked, and therefore the risk of anemia further increases with the onset of kidney disease among our type 2 diabetic subjects. Now, looking into the screening of anemia in diabetes, this is the categories of anemia. This is conventionally, we divide the anemia in mild, moderate, severe. So the simple test that we can do is just get a complete blood count. And if you get a blood count, you quite naturally, you can identify the presence of anemia, number one. And number two, you can categorize the anemia, whether it is a microcytic anemia, it is a normocytic anemia, or it is a macrocytic anemia. And on the basis of that, you can further progress to your evaluation, and actually we can address the problem. We at the same time will evaluate the comorbid condition, as we know that the chronic kidney disease is a very, very important factor which can lead to the development of anemia. And we'll also have to look into the medication history. The very, very important drugs which are associated with anemia in the diabetes is topmost cause is the metformin, definitely, because it causes B12 deficiency. Now we have the ACE inhibitor ARB that can cause also anemia. And third is that the pioglitazone often can cause some kind of dilutional anemia among our patients. Now, looking into the impact of the anemia on diabetes complication, we know that the diabetic patient has got anemia. The prevalence of anemia is 2 to 3 times higher among our diabetic subjects. But does the presence of anemia has got any impact on the diabetic complication? Now, this is the study which actually showed that this is one of the many studies which actually showed the importance of the anemia in the risk of progression of diabetic nephropathy. So anemia is a risk factor. So if there is an anemia, there is a more progression of diabetic nephropathy, there is more progression of retinopathy, and therefore, if you look into the microvascular complication, all the microvascular complication, neuropathy, nephropathy, retinopathy are closely linked with that of anemia, and the prevalence of anemia is higher. And it is not that the prevalence of anemia higher among patients with microvascular complication, but the important fact is that the presence of anemia is associated with more progression of the microvascular complication. And then we have this very, very important publication that anemia is a risk factor for cardiovascular disease. And there are numerous publications of the link between the anemia and the higher cardiovascular events among our type 2 diabetic subjects. And I have taken 2 publications from 2 sides, one from the nephrology side, another from the cardiological side. And both categories of the publication actually showed that the anemia is a very, very important risk factor for the cardiovascular disease or events. Not only that, this important study has looked into the mortality with respect to anemia. You may say that the patient, those who have anemic or those who have anemia, they have higher comorbid condition. Yes, but this study actually done after adjustment of the other independent predictor, and the anemia was associated with a 57% increase in mortality, and this is an independent predictor as far as the mortality is concerned. So therefore, what we have come to know that the diabetic patient have higher possibility of anemia. This is number one. Number two, if you have anemia, the progression of microvascular complication will be more. If you have anemia, there is a high possibility of cardiovascular event. And number four, that the patient who have anemia has got a higher possibility of death. So there are a lot of factors, a lot of importance as far as the anemia is concerned in the backdrop of diabetes. Now, why there is anemia among our diabetic subjects? So there are a lot of mechanisms. It is not a single mechanism. I have already discussed about the presence of chronic kidney disease. All of us are aware that the presence of chronic kidney disease is associated with more prevalence of anemia. Now, with a progressive fall in the GFR, you can see there is a progressive rise in the prevalence of the anemia, both in type 1 as well as in type 2 diabetic subjects. Now, if we look into the possible contributing factor to the anemia among patients with diabetes, the topmost cause is definitely the chronic kidney disease or the reduced renal production of erythropoietin. But the other factors are also there: reduced red cell survival, the deficiency of the iron, and then the systemic inflammation. The obesity itself can cause inflammatory process, and the anemia of chronic inflammation can develop in the backdrop of significant obesity. There may be occurred blood loss. Many type 1 diabetic patients have celiac disease, and as I've told you, their drug therapy, many drugs what we use in our clinical practice for the management of the diabetes are associated with anemia, and also the possibility of hemodilution. Now, after bariatric surgery, the anemia is a very, very important issue. Many people, those who are seeing patients after bariatric surgery, must have experienced that anemia is a very, very common issue, because 2/3 of the patients who had bariatric surgery suffers from anemia. And iron deficiency is one of the very important cause, and therefore it is recommended that all patients who had bariatric surgery should receive iron supplementation for a long period of time. Obesity itself can cause chronic inflammation, may be responsible for the anemia of chronic inflammation. And then there is some other micronutrient deficiency, which is also common after the bariatric surgery, especially the zinc, copper, and also the deficiency of vitamin B12 and folate. So after bariatric surgery, people actually advise a lot of supplementation, including iron, to prevent the deficiency disorders, including the anemia. Now, another important fact which I have mentioned about the effect of AC inhibitor and ARB, which we commonly use with our type 2 diabetic subjects, both those who have a renal disease and also those patients who have hypertension. So almost all our type 2 diabetic subject receives either AC inhibitor or ARB, and they actually have an effect on the hemoglobin level, and they can cause anemia. So therefore, looking into the cause of anemia among our type 2 diabetic subjects, it is not a single factor which is responsible for the development of anemia, but a multiple factor which are responsible for the development of anemia. Chronic kidney disease is at the top of the list. The presence of chronic hyperglycemia, abnormal RBC lifespan, use of the drug, malabsorption, especially vitamin B12 deficiency when you are using metformin, chronic inflammation of obesity, from obesity, maybe testosterone deficiency. So all these factors cumulatively actually contribute to the development of anemia. They reduce erythropoietin production, they produce some functional deficit of erythropoietin action, and all these factors leads to the anemia. Coming to a few of my experiences with the anemia. Now, this is a 34-year-old woman who have diabetes for the 4 years, hypertension and normal periods, mother of one child. She was on metformin 1 gram and glimepiride and telmisartan. She had some kind of dyspnea on exertion, BMI 29. And when we evaluated this patient, we found that she had significant anemia with hemoglobin 8.7. Other other parameters are more or less normal. HbA1c was slightly higher, but otherwise the patient was more or less perfect. Now, when we look into the anemia among our type 2 diabetic subjects, how we should proceed, this is basically a diagnostic approach for the anemia. As I have told you, we have to look into whether the patient has microcytic anemia or normocytic anemia or macrocytic anemia. Now, if the patient has got a macrocytic anemia, so quite naturally, it is possibly because of vitamin B12 or folate deficiency, maybe drug induced, say for example, patient is receiving metformin for a long period of time, may be associated with hypothyroidism because 10 to 15% of our type 2 diabetic subjects has hypothyroidism detected or undetected, and liver disease or chronic alcohol use may be the other factor. Now, those who have a normocytic anemia, it may be because of iron deficiency or vitamin B12 deficiency, but they are basically of anemia of chronic disease or chronic inflammation, maybe because of some infection. And then we have the anemia with microcytic. A microcytic anemia is commonly because of iron deficiency or thalassemia. So what we have to check, we have to test the ferritin level. When you find that there is a microcytic anemia, the next best test is the ferritin. If the ferritin is low, it is iron deficiency. If ferritin is normal or high, possibly we are dealing with the thalassemia or the thalassemia trait. Now, coming to the evaluation of this particular case, we find that this patient has got a mean corpuscular volume 74.7. That's quite low, microcytic anemia. So it is possibly because of iron deficiency, because the serum ferritin value was also very low. So how we should treat this patient? The patient is usually treated with the iron supplementation. Now, what should be our target hemoglobin? Now, this is basically a position statement which says that we should target based on the age, clinical status, and treatment response. Very important to understand that in the backdrop of chronic renal disease, we usually don't target more than 11. So your target should be around 11ish, because if we target more than 11, there is a possibility of adverse events in the backdrop of diabetic kidney disease. So usually we do not target at least more than 12. So we should target about 11ish, maybe up to 12. So if it is more, if the HbA1c go beyond 13, there is more possibility of cardiovascular events and mortality. So in other situation, the target will vary according to age and clinical status, but in the backdrop of chronic kidney disease, our target will be around 11. Now, we should treat the patient with iron in an iron deficiency anemia. Either you can give orally or we can give intravenously. There are a lot of preparations available in the market as far as the oral iron preparation is concerned, as far as the IV iron preparation is concerned. We conventionally use the ferrous sulfate. Nowadays, the other available preparation is there in the market. They are actually cause less GI side effect. The most important side effect of iron, all of you are aware, is the GI side effect. So the compliance becomes low. And when you are giving iron then orally, then you have to give it for a very long period of time. However, oral iron preparation has many advantages because it is effective in most of the situation. It causes low risk of side effects and cost is very low. On the other hand, if you want to give IV iron preparation among the patient, those who are not responding to the oral iron therapy, then you can give the ferric carboxymaltose. That is a preferred preparation nowadays. And we give roughly around 2 doses of 750 milligram or 1000 milligram dose once at a time. It is effective for most of the patient very rapidly. It corrects the anemia, resolution of the symptom, compliance is assured, no GI side effect. However, you have to monitor the intravenous infusion. There is some rare cases of allergic or infusion reaction, and you have to supervise this infusion, and the cost of therapy is high. So it means that the oral iron preparation has its own advantage and disadvantage. Intravenous iron therapy has got its own advantage and disadvantages. Coming to the second case, almost same case, but the issue is that this patient has got the HbA1c same 8.7, except that the mean corpuscular volume is low, but this patient has got a very high ferritin 167 or the normal ferritin level. So when there is a normal ferritin level, it indicates that we are not dealing with iron deficiency anemia, And therefore, we have to look into the other cause of microcytic hypochromic anemia. And the second most important cause of microcytic hypochromic anemia is the presence of thalassemia. Thalassemia minor is quite common, or thalassemia trait is quite common in our country. We have diagnosed thalassemia even after the age of 40 or 50 in many of our patients. So we have the second most important test we can do is the hemoglobin electrophoresis. When you do the hemoglobin electrophoresis, you can actually diagnose thalassemia minor. And if a patient has got a thalassemia, the first thing we should do is to avoid giving any iron. This is the first step. The second is we can start the folic acid supplementation. And if a patient has got a concomitant iron deficiency, then only the question of iron supplementation will come. Otherwise, we don't give any iron supplementation. The very, very important issue is to look into the genetic testing and counseling, especially for the patient, those who are in a childbearing age, because that has got a very, very important issue when we are dealing with a beta thalassemia minor. Now coming to the third case, this is a 62-year-old presenting with fatigability, dizziness, dyspnea during moderate effort, diagnosed with diabetes mellitus in 2010, on metformin therapy 1 gram twice a day with sitagliptin 100 milligram once a day, on beta blocker, no alcohol abuse or smoking, BMI 29. And you can see hemoglobin, again, we can take 8.7, that's very low hemoglobin. And when we look into the mean corpuscular volume, it was high. It means the patient is suffering from macrocytic anemia. There is no iron deficiency. Serum ferritin level is normal. So what is the cause of macrocytic anemia? As I've told you, in most of the cases of diabetes, macrocytic anemia because of malabsorption of vitamin B12, and often related because of the long-standing use of the metformin therapy. So this is the topmost cause is the vitamin B12 deficiency as far as macrocytic anemia is concerned. So we have looked into the vitamin B12 level and also the liver function test, because chronic alcoholism also leads to vitamin B12 deficiency, and many of our diabetic subjects do consume alcohol. So I've looked into the liver function test. It was absolutely normal, but vitamin B12 deficiency was actually vitamin B12 deficiency was there. So now how we should treat this megaloblastic anemia or macrocytic anemia? We may stop the metformin therapy because in most of the situation it is caused by metformin. However, if you're using metformin with a high dose 2 gram and you are using metformin for a long period of time, say more than 4 or 5 years, then and then only the possibility of megaloblastic anemia appear. And this particular patient was receiving metformin for a very long period of time and with the dose of 2 gram. So therefore the vitamin B12, the stopping metformin is maybe an issue in front of us. And second is we may start the insulin therapy to control HbA1c, and we have shifted and we have started the vitamin B12 replacement in intramuscular injection, initially 1000 microgram per week over the first 2 months, then the every 2 weeks, 1000 microgram every 2 weeks. So that is the recommended dose. So let us have a look into the metformin use and vitamin B12 deficiency. It is usually found among 10 to 20% of the patients who are using metformin in type 2 diabetes subject. Metformin actually decreases the absorption of the vitamin B12 from the GI tract. When you're using 2 gram dose for a long period of time, then there is a possibility of developing vitamin B12 deficiency, and there is a 13% increased risk of vitamin B12 deficiency per year of total metformin use at 13 years since randomization. This is the Diabetes Prevention Program outcome study. Now, this is a mastermind study which has looked into 2 randomized controlled trial, ADOPT and Eucopedias, and they have looked into a real world study also, GODARS. And these 3 important studies, they have evaluated to see the impact of the metformin use with the prevalence of anemia. And they have found that the use of metformin is associated with higher possibility, almost 2 times higher possibility of anemia compared to sulfonylurea use. And in Eucopedias, it was found to be almost 2 times increased possibility, or 3 times increased possibility of anemia with the use of the metformin. And similarly, it was found in the real world study also. So in the RCT as well as in the real world study had shown that the use of the metformin is significantly associated with increased risk of megaloblastic anemia. coming to the case number 4, a 54-year-old woman with a diabetes for the last 14 years, hypertensive for the last 12 years, mother of 1 son, and on gliclazide and linagliptin, amlodipine, mild dyspnea on exertion. And we find that this patient has got a 8.7 hemoglobin with creatinine 2.7. So it clearly indicates that this patient has got a chronic kidney disease, and that chronic kidney disease leads to the anemia. So we know the chronic kidney disease is very commonly associated with the development of anemia. So this study has looked into the progressive low eGFR and the progressive rise in urinary albumin excretion ratio are intimately associated with the prevalence of anemia. Combination of the two is associated with a higher possibility of the anemia. So if you have very low eGFR, if you have very high urinary albumin excretion, then the possibility of anemia is the highest. Now, why there is an anemia in chronic kidney disease? Erythropoietin, all of us are aware that the erythropoietin is a very, very important issue. It is produced by the kidney, and that is also responsible for the generation of RBC, because they are very, very important erythropoietic factor. And second is that the hormone hepcidin, which is produced by the liver, and hepcidin is intimately associated with the absorption of the iron from the GI system. So high hepcidin actually inhibits the absorption of the iron from the gastrointestinal system. Third is that the uremia can inhibit the erythropoiesis. The RBC lifespan is shortened in a uremic state. And lastly, there may be increased blood loss, because the CKD patient often have GI blood loss. So there are multiple issues which actually contribute to the development of anemia. Now, coming to this particular patient, on further workup, we found that transferrin value is normal and serum ferritin level is normal. It rules out the presence of background iron deficiency. So many patients with chronic kidney disease may have simultaneous iron deficiency also, where actually we should give iron supplementation to correct the iron deficiency, and then we check the hemoglobin and then decide what we are supposed to do. So this patient has got enough iron store, and therefore we have to look into the other therapy to improve the hemoglobin. So the target hemoglobin, as I've told you, should be around 11ish. We will not target 12 or 13 or 14. If there is an iron deficiency, we should correct the iron deficiency before we start erythropoiesis stimulating agent. Now, there are two erythropoiesis stimulating agents we conventionally use in our clinical practice. One is epoetin and another is darbepoetin. I usually use epoetin. Usually we give 4,000 to 10,000 units subcutaneously once weekly, or 10,000 to 20,000 units every other week. So we start with 4,000, and then actually we can increase the dose depending on the response of the patient. However, the use of erythropoietin stimulating agent is not free of side effects. There are a lot of side effects: the rise in blood pressure, rapid rise in hemoglobin, thrombosis, cardiovascular events, and malignancy, and the presence of hypertension, uncontrolled hypertension, and the history of thromboembolic event are contraindication to start erythropoietin stimulating agent. And there is a very, very important study which actually looked into the evidence for the correction of the anemia in the chronic kidney disease. There is no conclusive evidence that correcting anemia significantly improves clinical outcome in patients with CKD, especially if we look into these two primary composite outcomes, that is death and cardiovascular event. So therefore, the use of the erythropoietin stimulating agent in the backdrop of CKD should be considered with this understanding that it will not improve the death, renal event, or possibly the cardiovascular event. Rather, if we use the erythropoietin stimulating agent, it may cause increase in the stroke. So therefore, the evidence in its favor is not very strong. However, there are a lot of data which suggest that if you correct the anemia, there is an improvement in the quality of life. There is a reduction in the retinal exudates, macular edema. There is reduction in the hospitalization with heart failure, and there is a protection for the development of neuropathy. So you may have some benefit in microvascular complication, also improvement in the heart failure hospitalization, quality of life indices, but As far as death and cardiovascular event, there is no evidence that it will have beneficial effects. So therefore, whenever we give the erythropoietin stimulating agent, we should be very careful. So take home is that the in patient with diabetes mellitus, prompt detection and correction of anemia is important due to reduce the risk of diabetes complication, because they are associated with progression of diabetes complication, and to improve the quality of life. Iron deficiency, thalassemia, trait, vitamin B12 deficiency, diabetic kidney disease are the 4 major cause of anemia and diabetes, which needs to be corrected. Treatment with oral or intravenous iron preparation and erythropoietin stimulating agent needs to be individualized based on the patient clinical status and comorbid condition and risk. And excess correction of anemia, especially with erythropoietin stimulating agent, could lead to adverse outcome. I stop here. Thank you very much for your patient listening.
Thank you so much, Dr. Mazumdar, for that very comprehensive review of anemia in type 2 diabetes, a very important aspect, and you have covered it so very well. I do not see any questions in the chat box, and I would like to thank you at this point for being a part of IDEC 2021. Thank you so much.
Thank you.
We move on now to another very important topic, and for this we have Dr. Rakesh Sahai. I would like to introduce him now. Dr. Rakesh Kumar Sahai is a very well-known personality in the field of diabetes and endocrinology in India today. He's the president-elect of the Endocrine Society of India, and he's the vice president of SEFI's, former secretary of Endocrine Society of India. He's held many positions, received plenty of awards, and has several publications to his credit. He's a very good speaker, and today he is going to talk to us about the role of vildagliptin 100 milligrams OD in type 2 diabetes with high HbA1c. Over to you, Rakesh.
Thank you. Thank you, Dr. Neeta, for the kind words of introduction, and thank you for inviting me to be here. And also thanks to the entire IDEC team for having me here. I should also congratulate you for the excellent program being conducted. I'll now move on to the presentation. I'll be speaking about, is my slide visible?
Yes, it's visible.
Yeah. So I'll be speaking about role of vildagliptin in particularly the 100 mg OD in terms of therapy. So basically what I would like to highlight here is that vildagliptin is a very a good DPP-4 inhibitor which has been available to us from a long period of time. I mean, and it has been one of the earliest DPP-4 inhibitors that got introduced into the Indian market, and we have seen a significant increase in the use of DPP-4 inhibitors over the several years, while the newer agents have also come in with the introduction of the SGLT2 inhibitors, which have several cardiovascular and renal benefits. We still have DPP-4 inhibitors as a sheet anchor in the therapy of management of type 2 diabetes. And today, while we are going through this pandemic of corona, we were already in the pandemic of diabetes, and the COVID scenario has actually caused a significant increase in the glycemic burden of people with diabetes. We could see that, you know, the HbA1c levels of the entire population of diabetes has gone up significantly, as was even seen in several different studies conducted during this period. And we are seeing that we are facing a significant burden of hyperglycemia amongst these patients with diabetes. And so how does this category of drugs, the DPP-4 inhibitors, which bring about a control of diabetes without increasing the risk of hypoglycemia and without causing weight gain, fit into this entire scenario of managing patients with type 2 diabetes. So if you look at the algorithm today regarding, in the management of diabetes, we know that whether you look at the ACE algorithm, or whether you look at the ADA ESD algorithm, or you look at what the European Society of Cardiology is saying, or across different societies, and even if you look at at our own Indian guidelines from the RSSDI and the Endocrine Society of India, we are speaking of metformin as the first line of therapy. And then when we come at looking at the agents to be chosen to be combined with metformin when metformin alone is not enough in managing our patients with diabetes. We always look at different classes depending on their characteristics. We do not say that the second line should be one particular class of drugs. It has to be individualized to the patient's requirements. And if you look and what across various guidelines, what we are today seeing is that based on the evidence that is available for the SGLT2 inhibitors and the GLP-1 analogs, we speak of using them as the preferred second line agents whenever there is established ASCVD or CKD. And in some situations, we would also think of replacing metformin also in this scenario. If we have a good glycemic control with metformin alone, we may even think of using these agents ahead of metformin also. So this is what the current scenario is. But in patients who do not have established a CVD or CKD, that's almost about 60% or 70% of our patients coming to our OPD. I mean, these are not the very long-standing diabetics. They are the ones who are having diabetes for an average, say 4 or 5 years of diabetes and not having established a CVD or not having CKD. In these patients, what is the choice? In these patients, certainly what we are looking at is we are worried about weight gain in such patients, because most of our patients, even though they may not be obese, they are significantly having abdominal obesity, and we are concerned about weight gain, because even a single kg of weight added causes a significant metabolic disturbance. And therefore we are looking at agents which cause minimal risk of weight gain, and they have a low risk of hypoglycemia also, because hypoglycemia also has been shown in different studies to be a harbinger for the development of cardiovascular disease and initiating and developing various arrhythmias, and can ultimately lead to significant increase in morbidity and mortality among patients with diabetes. So when you're looking at these agents, we are looking at the DPP-4 inhibitors, which fit in very well here. And if you're looking at weight loss as a major goal, for a primary goal, then you're looking at SGLT2 inhibitors or the GLP-1 RA. And when you're looking at the cost, again, SUs was put in here, but what we see today is that there is a change in the scenario with vildagliptin going off patent and available at a much lesser price than what it used to be priced earlier. We see that there is a very significant increase in the use of vildagliptin in this category, because cost is also now favorable for vildagliptin. And this is how vildagliptin fits in, not only in terms of these parameters that we spoke of, and also because of the cost of therapy coming down significantly. Now, coming quickly, I'll review the available evidence regarding the efficacy and safety of this class of drugs, or vildagliptin as such. And if you look at vildagliptin, we have seen that, I mean, if you look at DPP-4 inhibitors as a class, we see that they bring about the reduction of HbA1c to the tune of 0.5 to 0.8% as monotherapy. And when they're combined with metformin, the reduction in HbA1c can go even up to as much as 1.3, 1.4% of HbA1c reduction. And this is shown in several different studies which have been done and with vildagliptin. And we have data from these studies which are on the average about 6-month studies, which have shown that there is a similar benefit seen with when you look at vildagliptin versus sitagliptin or any of the other newer gliptins. Now, if you look at differentiating between the gliptins, because we have a choice of 6 different gliptins available today, and if you're trying to, and we also know that the gliptins have a significantly greater benefit in patients of Asian origin. We see that as compared to all other ethnic groups, Asians tend to have a better benefit seen with the use of the gliptins. And also we also see that this is shown not only in one or two studies where we have seen that initially, but a meta-analysis of 55 clinical trials has shown that the glucose lowering efficacy of DPP-4 inhibitors is higher in Asians than other ethnic groups. And the difference may be contributed by differences in the BMI, or it could be other factors which are hitherto not clearly understood. In addition, the insulin secretory defect is higher in patients with of Asian origin because of the greater amount of visceral fat for every given BMI or given waist circumference, we have a greater degree of visceral fat, we have a lower beta cell mass and lower beta cell function, and that could account for the greater benefit provided by this class of drugs, which increase the insulin secretion in a glucose dependent fashion. If you look at effects beyond the DPP-4 inhibition also, I mean, beyond the glycemic control provided by the DPP-4 inhibitors, we also see that many of the DPP-4 inhibitors have shown benefits in terms of bringing down the proteinuria, and this has been shown in different studies. And these renal effects of DPP-4 inhibitors are shown in now quite clearly established with several, and we see that they can be used for, although they have no clear evidence in terms of reducing the fall in GFR, but the reduction in proteinuria has been shown in different studies. But however, we look forward towards a better, well-designed trials like the ones which have recently been conducted for the SGLT2 inhibitors, with renal outcomes renal outcomes being the primary outcome measures. And with such trials, we would be able to find out whether DPP-4 inhibitors, the benefit that is been shown in some of the trials in terms of the antiproteinuric effect, can in fact lead to reduction in the renal outcomes. Now, coming to the other aspect, trying to understand how vildagliptin can be placed amongst the DPP-4 inhibitors in terms of the choice between different the DPP-4 inhibitors. If we look at this meta-analysis of 69 studies, which had more than 28,000 patients, it was shown that vildagliptin was as effective as any other anti-diabetic agent, bringing down the HbA1c by 0.7% without increasing the risk of hypoglycemia. The concern regarding pancreatitis was also not shown amongst these this 69 studies, which had more than 28,000 patients, and it was therefore concluded from these meta-analysis that vildagliptin is an effective and safe therapeutic option for patients with type 2 diabetes, both as a monotherapy and as an add-on treatment to either metformin or to any of the other classes of anti-diabetic medications. Now, looking at a comparative study here, which is compared vildagliptin with sitagliptin and linagliptin. In this study, which was done in Chinese patients with type 2 diabetes who were not controlled on metformin alone, who were randomized to either of these three agents, vildagliptin group had the greatest reduction in HbA1c, and this was standing out as compared to the other two gliptins that were used in that study. It was 0.84% reduction with sitagliptin, 0.81% reduction with linagliptin, and vildagliptin, it was 1.33% reduction in HbA1c, which was statistically significant. And then there are other studies which have looked at, which was in the same study, what we also see is that the required insulin dose was lowest amongst the patients who were on insulin and who were randomized to these three drugs. So a similar study which looked at a combination of oral anti-diabetic medications and who were requiring insulin also. And in this group of patients, we saw that with the use of these three gliptins, there was a reduction in the dosage of insulin, and the reduction was probably to the greatest extent seen in the vildagliptin group. Now, what we also, when we look at the difference in terms of the adverse events, that is hypoglycemia or the other adverse events which are seen in some patients, is in terms of gastrointestinal adverse events and infections, the nasopharyngeal infections or chest discomfort. So these were the common adverse events seen in this trial when you compare, which looked at the comparison of these three gliptins, and there was no difference in the adverse events amongst the three groups of gliptins. Let's look at the verified trial. Coming to the verified trial, which is probably one of the most landmark trials in the recent times, which looked at using a combination of vildagliptin metformin at the onset of diabetes, right from the onset of diabetes, trying to establish whether early combination therapy does provide a benefit in managing patients with type 2 diabetes, because we know that patients with type 2 diabetes often have been failed to get control with a single agent, and we progressively or sequentially add additional therapies. So this study was trying to see whether early combination brings about a change in terms of the durability of glycemic control. And what was the primary outcome was to look at the treatment failure. So the incidence of initial treatment failure during the 1 year period was 429, was 43.6% in the combination treatment group as compared to 62.1% in the monotherapy group. So those who were getting a combination upfront were doing better, and they had lower risk of, they had almost similar or slightly higher risk of hypoglycemia, but they had both the treatments were therefore safe and well tolerated, but they had a greater degree of, greater duration of control, being achieved with the combination as compared to using only monotherapy, that is only metformin. So the use of vildagliptin in patients who have HbA1c in the range of 6.5 to 7.5 did lead to a greater a longer duration of control with this combination. Early intervention with a combination therapy of vildagliptin plus metformin provides greater and durable long-term benefits compared with current standard of care, that is initial metformin monotherapy for patients with newly diagnosed diabetes. So this has been a significant change in our thinking in terms of use of early combination of agents in patients with newly diagnosed diabetes. Now, let's look at some of these studies. The Vildal study, which looked at a combination of vildagliptin, addition of vildagliptin to insulin in patients with type 2 diabetes. And this was at 12 weeks of use of into this study, where the daily insulin doses decreased by 11% in the vildagliptin insulin group, whereas they increased by 2.3% in the insulin only group, with a statistically significant between group differences also. So showing that the addition of this agent to insulin does help in reducing the requirements of insulin and provides a better glycemic control. In fact, the risk of hypoglycemia was lower in the group that was receiving vildagliptin and insulin as compared to those who were receiving insulin alone, because the requirement of insulin was lower in the group that was receiving vildagliptin also. This is another study which looked at evaluating the effect of adding vildagliptin versus glimepiride to ongoing metformin on patients with diabetes who had symptomatic coronary artery disease. So what was seen was that in patients with type 2 diabetes and symptomatic CAD, the addition of vildagliptin to the ongoing metformin compared to metformin glimepiride therapy showed better glycemic control, lower inflammatory markers in the form of IL-1 beta and hsCRP, higher protective markers like adiponectin and HDL cholesterol, which are the protective markers, and improvement in the lipid profile. So overall, what we see is that the cardiovascular risk markers did significantly improve with the use of vildagliptin as compared to use of glimepiride. Now, coming to the effect of vildagliptin on glycemic variability, this is something which has recently become a very common parameter that is being assessed in many of our patients. We are assessing the glycemic variability by measuring the time in range, and let us look at some of the data on comparing vildagliptin with the other gliptins in terms of the glycemic variability. So this was one of the earlier studies which looked at comparison of vildagliptin and sitagliptin in patients who were undergoing the continuous glucose monitoring, and the MAGE values, if you see, were higher with sitagliptin as compared to vildagliptin, and the mean amplitude of glycemic excursion was the parameter which was very commonly used when this study was done, which was higher, which was significantly improved in patients who were receiving vildagliptin as compared to those who received sitagliptin. This is if you look at the blood, the fluctuations in the glucose levels, you could see graphically that there was a significantly lower glycemic variability in patients who were treated with the vildagliptin, and there were significantly lower postprandial blood glucose levels in these patients who were receiving vildagliptin. Does this lead to any change in terms of the cognitive functions and metabolic outcomes? So this was studied in a study which looked at patients with type 2 diabetes who where addition of vildagliptin to was looked at in terms of studying their cognitive functions and comparing it with the metabolic control that was achieved. And since type 2 diabetes shares several pathophysiological mechanisms which are similar to Alzheimer's disease, studies reported anti-diabetic treatments such as intranasal insulin, GLP-1 analogs, and DPP-4 inhibitors have been postulated to improve the cognitive function. And DPP-4 inhibitors may have dual benefits by improving the glycemic control and also having some degree of improvement in the cognitive outcomes. Now, coming finally to vildagliptin OD, which is the new kid on the block, which was approved by the DCGI recently in the sustained release formulation of vildagliptin 100 mg, was approved by the DCGI as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes. And let me show you some of the data which has looked at that. If you look at some of the PKPD studies, you look at the dissolution profiles of vildagliptin 100 mg SR formulation, we see that the optimized formulation F3 was the one which showed maximum release 98.43% in 10 hours of the dissolution studies. And this was the one which has been used in various preparations. And this is a study looking at vildagliptin SR 100 versus 50 mg BD. And this clearly showed the similarity in the pharmacokinetic profiles of vildagliptin SR formulation, which showed a sustained plasma concentration over the 24 hours. And if we look at the other aspects of the pharmacokinetics also, we see that it has similar bioequivalence as compared to the vildagliptin 50 mg BD dosing. There's one study which was published some time back, which was published quite a few years back in 2007 in Diabetes Research, DRCP, which assessed the efficacy and tolerability of 50 mg once a day, 50 mg twice a day versus 100 mg once a day. This 24-week double-blind randomized multi-center trial showed had 354 patients who were drug-naive with type 2 diabetes. And in all the groups, what we see was that HbA1c decreased progressively up to 12 weeks, and the adjusted mean change from baseline to endpoint HbA1c was 0.5% in the vildagliptin 50 mg once a day dosing, 0.7% in the 50 mg twice a day, and 0.9% in the 100 mg once a day. And the percentage of patients achieving the target HbA1c of less than 7 increased proportionately with the dose that was used. So the adverse effects occurring in a significant number in all the treatment groups is listed here, and doesn't show any significant difference in between the three groups, that is vildagliptin 100 mg once a day versus 50 mg twice daily or 50 mg once a day. The AEs probably were similar in all the groups. So this is another study which looked at vildagliptin drug-naive patients, 24-week double-blind randomized multi-dose study, looking at patients with high baseline HbA1c. There was a greater reduction with either 100 mg dose compared to with either of the doses. With 100 mg dose, it was much more than compared with the 50 mg twice daily or 50 mg once a day. So clearly, the 100 mg once a day does show a better benefit in patients starting off with a higher HbA1c of more than 8% at baseline. So I would like to conclude by saying that DPP-4 inhibitors achieve clinical meaningful glycemic control with lower risk of weight gain and hypoglycemia. Vildagliptin has shown greater HbA1c reduction compared to sitagliptin and linagliptin in some of the studies. Vildagliptin has shown better control of glycemic variability compared to sitagliptin in one of the studies earlier done. And vildagliptin sustained release formulation has the potential of improving patient compliance along with effective glycemic control. So I thank you all for the patient hearing. I'll be happy to answer any questions. Yeah.
Yes. Thank you very much, Rakesh. That was a very nice and comprehensive. 1 second. Yeah. So there is a question here from Dr. Gagan Priya. where she asked that a thorough QT study has shown that slight QT prolongation just above the safe cutoff of 5 milliseconds with Wilda 100 and 300 at 1 and 8 hours, but not with 50 milligrams twice daily. So would this impact the, the prescription and the safety of this formulation in high risk populations?
Yeah, so I think we just have this 100 mg introduced into the market, and I think we need to further look at some of these aspects like the QT prolongation that has not been adequately studied in the earlier studies, and I think there is need for such a study. But the one which you are mentioning is about comparing 100 versus 300. 300 probably had the highest prolongation. So I think we need to look at even the 100 closely and see the QT prolongation in these patients who are receiving 100 mg. But the earlier studies have not shown that convincingly.
Okay. So I had a question, Rakesh. Are there any head-to-head studies with vildagliptin, 100 milligrams OD, sitagliptin, and any of the other OD gliptins in terms of efficacy?
Yeah, I'm afraid that I don't think there are any studies like that which have been done, but there is clearly no need for that for these studies. The only study which I could find is that 100 mg OD was compared with 50 mg BD and the 50 mg OD preparation. So there is a need for these preparations. These preparations have been focusing on the benefit in terms of OD dosing, and they've compared the pharmacokinetic properties and showed that they do as good as the 50 mg BD dosing. But what is clearly required is in terms of the clinical outcomes when you compare with all the other gliptins, whether you have any additional benefit or a similar effect as seen with sitagliptin OD or any of the other linagliptin once a day, as you have rightly mentioned. Yeah.
Right. Thank you. I don't see any more questions in the chat box. Thank you very much, Rakesh, for being here with us at IDEC. And we've really enjoyed your talk. Thank you so much.
Thank you.
Yeah. We now move on to the next talk, a very interesting molecule again being talked about so much. And the topic is dapagliflozin, preventing the progression of cardiorenal metabolic complications. And for this, we have Dr. Gagan Priya with us, who is going to deliver this talk. She is an endocrinologist, a senior consultant endocrinologist at the Fortis and Ivy Hospitals, Mohali. She has also been SCOPE certified by the World Obesity Federation and has had the IGEM Award for Best Review Article in 2018. She has been an editor of the book Lipochronology, Glucochronology, and Hypothyroid Disorders, and is a section editor for another book called Urja, and over 65 publications, book chapters, and she has been the founder president of FLAME, which is Forum of Ladies in Medicine, and has also been the ambassador from India for diabetes. So over to you, Dr. Gagan Priya.
Yeah, thank you so much, Dr. Neeta, for this kind words of introduction. And thanks to the organizers of IDEC for inviting me for this, and thus for sponsoring this session. So what we'll talk of here is basic science, evidence-based medicine. And what I would like to cover in the next few minutes is the science behind dapagliflozin. We saw it as a molecule that began with, just management of diabetes. And honestly, when this molecule came into the market, all of us were skeptical using a drug that caused glucosuria, the very symptom that we were trying to prevent. But now we know that these are game changer molecules, SGLT2 inhibitors. And this is what I would say upfront, because this is very true for diabetes care. We were born not knowing anything about diabetes. And in the past, almost a century, ever since the discovery of insulin, we've had very little time to change that here and there, but we have made some seminal changes. What we do understand now, diabetes is not just a progression of beta cell dysfunction in the face of insulin resistance. There are also so many things that pathophysiologies that are going across a continuum, right from accumulation of cardiometabolic renal risk factors and development of target organ damage, including cardiovascular, vasculature, CKD, and other organs, including liver, obstructive sleep apnea, etc. And further on into target organ damage, where the patient becomes symptomatic and reaches end-stage disease. So the aim of treatment for such a disease, a multi-system disease, should also be multi-systematic, and that should include cardiometabolic and renal care. So it is no longer just effective sustained glycemic control. It also includes low risk of hypoglycemia and reduced risk of weight gain or promotion of weight loss. But we also have to focus on reduction of cardiovascular risk, including heart failure and renal comorbidities, as well as ensure the patient remains on the same track that we do as clinicians. Now, if I were to tell you that there is a single drug that can do all of these, I would be what this person here is, and that's a quack. There is no single drug, so it's a combination of treatments we'll be looking at. But today we'll focus on dapagliflozin. So we'll take quickly 3 case scenarios: an elderly gentleman with 10 to 15 years of diabetes, established coronary artery disease, low ejection fraction, and stage 3 CKD. A young lady this patient is at the end of the spectrum. A middle-aged lady who has 7 to 10 years of diabetes and hypertension, who has uncontrolled diabetes, LVH and microalbuminuria. And then we look at a patient who is early in the spectrum here, a 34-year male with 1 year of diabetes history uncontrolled, but struggling with obesity and NAFLD, obstructive sleep apnea, etc. So let's look at the very first patient. An elderly gentleman with 10 years of diabetes on metformin, had a recent acute coronary syndrome, has undergone a PTCA but has reduced ejection fraction. A1C is 8.3, creatinine is 1.7. So stage 3 BCKD and the urine albumin creatinine ratio is macro range. So what are the needs of this patient? He needs good glycemic control and low risk of hypoglycemia. He also needs reduction in cardiovascular and heart failure risk, which he clearly is at risk of. And we also need to have therapies to prevent the progression of nephropathy. Now let's look at the evidence with SGLT2 inhibitors. We do know patients with established ASCVD. We have had 3 large CV outcome studies: EMPA-REG, CANVAS, DECLARE, and then VERTUS also is there in this entire group. And what you can clearly see is that patients with established ASCVD, there is a clear reduction of MACE events with SGLT2 inhibitors. The study population in each of these trials was different, but eventually this is what you get at. What about hospitalization for heart failure? You see a very, very significant benefit in patients who have established ASCVD, and that's where the risk reduction lies. So you do have benefits in terms of hospitalization for heart failure. What about cardiovascular deaths? There's only one study, EMPA-REG, which has shown a clear reduction in cardiovascular deaths. DECLARE was a mixed population, so you're not really finding that signal. And we cannot emphatically say that, yes, dapagliflozin also reduces CV death, because we don't have that evidence in this kind of a patient scenario. More recently, we've had very revolutionizing results from the DAPA-HF trial, which was a trial of about 4,700 patients with NYHA 2 to 4 heart failure with ejection fraction of less than 40%. And these patients had diabetes in 45%, but 55% of this population did not have diabetes. So what was seen after a median follow-up of about 18 months, there was a substantial 26% relative risk reduction in the composite of cardiovascular death and worsening of heart failure. And you see the same kind of evidence, 30% reduction in hospitalization for heart failure, as well as reduction in cardiovascular death. So yes, in this patient scenario, now we do have the data. Both first and recurrent hospitalization for heart failure, all-cause mortality, etc., were reduced. And what was the number needed to treat one event? To prevent one event was just 21. If you go back to statin trials or trials of ACE inhibitors, etc., the numbers needed to treat actually much higher, 30, 40 for each of these drugs. What about the effect on atrial fibrillation and atrial flutter? We have the sub-analysis from DECLARE-TIMI showing significant reduction in the risk of first atrial fibrillation or flutter, as well as recurrent events. And the benefits last. The same kind of benefit persists whether or not patient has ASCVD or risk factor heart failure or no heart failure, or prior AF or no AF. What about the renal outcomes, which is another point of concern for us? Again, throughout all the major CVOTs of the SGLT2s, you can see one clear benefit. Irrespective of baseline eGFR, you have a substantial reduction in hard renal endpoints. Mind you, these were not just prevention of albuminuria or regression of albuminuria. These endpoints were something like doubling of serum creatinine or reduction of eGFR by more than 40-50% or the need for dialysis. However, one can argue that the renal events numbers were not very significant in these CVOTs, and they were not designed to actually assess renal outcomes. So more recently, we have the CREDENCE trial with canagliflozin showing very impressive studies, data. And now we have the DAPA-CKD. Another interesting study which took about another 4,300 participants, and the eGFR categories used were from 25 to 75 in the DAPA-CKD. About 2/3 of these patients roughly had diabetes. The others were non-diabetic chronic kidney disease. They did take patients with albuminuria only. So 200 to 5,000 was the albumin creatinine ratio being taken. And again, you can see almost a 39% reduction in the primary composite endpoint, which was doubling of creatinine, need for renal replacement therapy, renal death, or cardiovascular death. Renal specific endpoints also, you can see significant reduction. Benefits in terms of reduction for hospitalization for heart failure persist, and they're quite impressive here. And the death from any cause, all-cause mortality is significantly reduced. Like all other SGLT2 inhibitors, what is seen as very classically with dapagliflozin also in this trial was what is called as the check mark sign. Nephrologists now call this checkmark sign that possibly this is an indication that the drug is actually correcting hyperfiltration. So the initial small decline in eGFR of about 3 to 5 indicates that there was hyperfiltration in the pathophysiology, and the SGLT2 inhibitor is being shown to correct that. This checkmark sign is also very typical of the other drugs which correct hyperfiltration, and that is the RAS blockers. So you see an initial small decline, but thereafter the decline actually slows down compared to the placebo group, with actually a small advantage in the end that the slope of eGFR decline actually is slower. So if we look at dapagliflozin, now we have evidence for heart failure, for CKD, even outside of diabetes scenario. We do have primary renal outcome and heart failure data. So that means possibly this patient, let's look again. Does dapagliflozin offer improved glycemic control? We've heard a beautiful talk from Dr. Shashank Joshi earlier, and yes, it does. Reduction of cardiovascular and heart failure risk? Yes. Reduction of renal risk? Yes. So in this particular patient scenario, yes, these class of drugs do offer the hope of cardiorenal protection. What about our second patient, a middle-aged lady, BMI 29? She's on metformin and glimepiride, and she's complaining of hypoglycemias with just 1 milligram glimepiride. She also has LV hypertrophy. She has an eGFR which is relatively good, but a UACR of 265. So what are the needs of this patient? In addition to good glycemic control, low risk of hypoglycemia. So this drug needs to be taken off here. She needs weight reduction. She needs regression of albuminuria and reduction of cardiovascular risk, because she's already having cardiovascular risk factors like LV hypertrophy and microalbuminuria. Now, we have in the first part of this talk looked at this category of patients who had established ASCVD, but what about where our patient falls in is in this category. So DECLARE-TEMI was one of the studies which included 60% population like our patient. So they had multiple risk factors. CANVAS also had 35% of patient population with multiple risk factors. And these were from the renal standpoint, relatively healthy. eGFRs were quite good for these patients. So let's look at the bottom panel of this table. So patients with multiple risk factors, what does dapagliflozin offer us? It offers reduction in hospitalization for heart failure. Definitely we see that. What about the renal composite endpoints? Does it give us benefit in terms of that? Yes, we can clearly see that there is a clear reduction in renal endpoints, even in patients with multiple risk factors and no ASCVD, no CKD. What about this figure? We've been talking about this on and on. So we do know that patients with prior MI or established ASCVD, you do get with SGLT2 inhibitors, very good reduction in MACE events. And you don't have too much data for patients with multiple risk factors. But what about the composite of cardiovascular death and hospitalization for heart failure? The benefits and the renal outcome benefits, they persist throughout the continuum. So we do have clear evidence for this category of patients as well as this category of patients as to what benefits to expect. Now, looking at the standards of medical care of ADA and of course the other guidelines say the same thing now, that patients who are having established ASCVD or risk factors, we should be considering drugs with proven cardiovascular benefit, and these include SGLT2 inhibitors or GLP-1RA. And the same goes particularly if there is heart failure with reduced ejection fraction, because we have DAPA-HF study clearly showing benefits. SGLT2 inhibitors are the first choice drugs, and they should be considered even on the background of metformin use or irrespective of metformin use at whatever A1C the patient is having. And more recently, the Emperor Preserved study has also shown that these benefits possibly also extend to patients with preserved ejection fraction, not just HFrEF, but also HFpEF. And also in CKD, we do have data as of now only for patients with kidney disease and albuminuria, because our trials were looking at that kind of a patient population. So SGLT2 inhibitors are the front indications for that category of patients. We will have data of EMPA kidney coming in a couple of years that is also looking at a subcategory of patients who have non-albuminuric chronic kidney disease. So SGLT2 inhibitors should be recommended independent of glycemic control in patients with CVD or at risk factors for CVD and DKD with albuminuria. So does this patient, benefit from dapagliflozin? Again, asking the same question. Yes, it offers improved glycemic control. It reduces the risk of hypoglycemia. Weight reduction is there. And there is regression of albuminuria and cardiovascular risk, particularly with regards to the risk of hospitalization for heart failure. Now, looking at the third and last patient, which I'll go through quickly, a young male with 1 year history of diabetes, BMI 27.5, has A1C of 7.8, has non-alcoholic fatty liver disease and obstructive sleep apnea. At present, his renal functions are normal, albuminuria is not there, hypertension is well controlled, and you don't see LV hypertrophy. So what do we need for this patient? We need early intensive control, hit early, hit hard, to make sure the risk factor accumulation does not happen. We do need reduction in adiposity, obesity-related comorbidities, which are present in this patient. And what if we can reduce long-term complication risk? So this is a very common saying, prevention is better than cure. So true prevention is not waiting for the accumulation of risk factors, but actually preventing things from happening in the first place. So looking at, in one nutshell, what dapagliflozin offers, it offers early intensive glycemic control with very low risk of hypoglycemia. Higher the baseline A1C, greater is the HbA1c reduction. Whether it is in monotherapy, it's an add-on to 1 or 2 drugs or add-on to insulin. Also, these glycemic lowering efficacy is persistent throughout. It does offer about 2 to 3 kgs of weight reduction. Unfortunately, it does not go beyond that. So where weight reduction is a major priority, possibly GLP-1RAs would have a clear edge there, but that 2 to 3 kg is important for us. It does offer reduction in hypertension, so systolic and diastolic blood pressure reduction. And more recent studies have also shown that there is a better 24-hour BP profile in the terms of nocturnal hypertension is taken care of well with SGLT2 inhibitors. We've already heard Dr. Shashank earlier about the effect on body weight, and you can see that all indices of adiposity would be improved, whether it be the body fat distribution, visceral fat, the inflammatory markers from the fat, they would be reduced, the pro-inflammatory markers would be reduced, and anti-inflammatory markers would actually increase. What about effect on NAFLD? Again, this is currently possibly just a hypothesis as of now. We do have some proof of concept studies in patients with NAFLD, that SGLT2 inhibitors might actually be helpful in reducing the intrahepatic fat content, and there might be a beneficial effect on liver enzymes, on insulin sensitivity, possibly directly because of weight loss as well as lipolysis. However, these are proof of concept studies and we need more data. We do have with empagliflozin the E-LIFT study from Medanta, which was an interesting paper in itself, but we also need biopsy-driven studies to really show the impact of SGLT2 inhibitors on NAFLD or NASH-related cirrhosis. What about obstructive sleep apnea? Again, another proof of concept study in a small number of patients, wherein it showed a reduction not just in body weight, A1C, and lipid parameters. There was a reduction in apnea-hypopnea index. There was an improvement in hypoxemia that was occurring during sleep, in the snoring frequency, and there was a decrease in the ESS scoring for the obstructive sleep apnea. So definitely, again, an area that needs further evaluation. So for this patient, what we can clearly say, it offers us the chance of early intensive control and weight reduction and a possible reduction in risk of comorbidities. And we can't really say that, yes, 20 years down the line, we will see a clear reduction in MACE events, but that's where we are. Very interestingly, SGLT2 inhibitors, our understanding of these drugs has undergone a sea change as just molecules which cause glucosuria. So we thought it's just a drug that reduces the blood glucose by flushing it out into the urine. But we now also understand natriuresis is a very important component of its action. In the renal tissue, there is also increased erythropoietin and increased hematocrit. There is a blockage of the sodium hydrogen exchanger NHE3, both in the renal tubule and NHE1 in the myocardium. There seem to be multiple mechanisms of action, plus, of course, anti-inflammatory effects, anti-fibrotic effects, and a clear reduction in plasma volume. There, in the renal tubule, a very clear benefit which drives possibly the renal benefits in addition to all the other mechanisms is restoration of tubular glomerular feedback, which reduces glomerular hyperfiltration, reduction in sympathetic tone, improvement in endothelial function, etc. So where not to use, of course, we have to remember acute hyperglycemia, osmotic symptoms or catabolic features, medical or surgical acute illness, active or recent UTI, and recurrent genital mycotic infections, which are hard to manage. And we should be cautious about certain signals like significant risk of UTI, prior amputation of peripheral vascular disease, or significant foot ulcer. And patients on multiple diuretics, we might just want to be cautious with the doses of loop diuretics. So I'll conclude here. There's a Chinese proverb that says, the inferior doctor treats actual sickness, the mediocre doctor attends to impending sickness, and superior doctor prevents sickness. But I think what we need to understand is the balanced patient-centered doctor takes care of all three. So I'll conclude here and thank you so much.
Thank you so much, Gaganpriya. Your last slide was indeed very, very fascinating, and that is so much the truth. Thank you so much for taking us through dapagliflozin as a molecule that prevents the progression of cardiorenal metabolic complications. I do not see any questions in the chat box. Thank you very much for a very illuminating lecture, and thanks for being a part of Idec.
Thanks, my pleasure.
Right. Thank you so much. So we shall now move on to the next session in drug reviews and therapeutics. And for this, we have with us Dr. Nilakshi Deka. So Dr. Nilakshi Deka is a consultant endocrinologist in Guwahati and is associated with the International Hospital and the Dispur Polyclinic and Nursing Home. And she has also been a visiting consultant to Excel Care Hospital. And she's had wide experience in managing patients with type 1 and type 2 diabetes, obesity, and metabolic disorders. And she also has an avid interest in areas of thyroid, pituitary, and adrenal disorders. Dr. Nilakshi is going to talk to us about gliptinization, how the roadblocks can be addressed. So over to you, Dr. Nilakshi.
Thank you, Dr. Neeta Deshpande, for that wonderful introduction. In order to be more frugal on the net connection, which is quite erratic in my place, I would like to switch off my video while presenting the session, if that is not a problem.
Absolutely.
Thank you so much. I'll be sharing my slides now. I hope my slides are visible to everyone.
Yes, yes, it's visible.
So this is a very interesting topic which I have been given to speak on, gliptinization, addressing the roadblocks. So gliptins have been with us since a decade, maybe now, more than a decade actually. So it's a molecule we are well versed in when we are treating patients with diabetes in different countries across the globe. Now, the topic which we are going to discuss is gliptinization. What are the roadblocks associated with initiating gliptins in an individual, and how do we address these roadblocks? Now, first and foremost, why? Like, since we have chosen a molecule to treat diabetes, why do we need incretin mimetics? And why do we think that they are more suitable for Indian patients? Now, there's one good news for Asian patients is that incretins in Asians are more effective compared to that of the Caucasians. So let us see if how this mechanism of action of incretins in Asians proves to be more effective than in our Caucasian counterparts. Now we see that intact GLP-1 levels are considerably low in Japanese, and meal-induced enhancement of GLP-1 is negligible in the Japanese compared to the Caucasians. However, the intact GLP-1 levels are comparable between non-diabetics and type 2 diabetes, suggesting impaired insulin secretion in Japanese type 2 diabetes patients. The reduction of postprandial active intact GLP-1 in Asian type 2 diabetes patients could possibly be due to increased activity of the DPP-4 enzyme. So since in our kind of a population, we have increased activity of DPP-4 enzyme, hence a molecule which would inhibit this enzyme, that is a DPP-4 inhibitor or a gliptin, would prove to be more effective in these population rather than in Caucasians who already have it, already have that enzyme activity lower. Now, it has been seen that there has been a correlation between the circulating plasma DPP-4 levels, which correlate positively with the waist to hip ratio, total intra-abdominal adipose volume, liver span, fasting serum insulin, LDL cholesterol, triceps skin fold thickness, and total intra-abdominal adipose tissue volume. So there's increased DPP-4 enzyme activity in Indians with type 2 diabetes, and this activity is even more increased in non-obese Indian patients with type 2 diabetes. When we use a combination of gliptin and metformin, we tend to address a number of pathophysiologic defects which actually lead to type 2 diabetes. Now, we know type 2 diabetes is an intriguing disease in the sense that it is not just one pathophysiologic defect which leads to hyperglycemia and its complications in type 2 diabetes. It's a multifactorial disease. There are a number of pathophysiologic defects, and when we use a combination of a DPP-4 inhibitor and metformin, we address reduced hepatic glucose output. We have moderate activity with metformin in reducing the peripheral insulin resistance, improves insulin sensitivity, and metformin to a certain extent also increases the GLP-1 secretion. When we use a DPP-4 inhibitor in combination with metformin, we see that in addition to what benefits we achieve with metformin, that is improvement of insulin sensitivity, decrease in peripheral insulin resistance, and increase in GLP-1 secretion, we see that with DPP-4 inhibitor addition, what we achieve is an increased insulin synthesis, increased insulin secretion, again, reduced hepatic glucose output, and indirectly it leads to improvement in peripheral resistance, insulin resistance, improves hepatic insulin resistance. It reduces the glucagon secretion, improves the GLP-1 levels, and leads to gastric inhibitory peptide stabilization. So when we are using a combination of metformin and DPP-4 inhibitor, we are addressing, or we are already taking care of multiple pathophysiologic defects which leads to hyperglycemia in type 2 diabetes and its complication. The efficacy of DPP-4 inhibitors, as we just discussed, is higher in Asians compared to non-Asian, and this slide shows the HbA1c reduction in Asians, which is this dark blue bar, compared to non-Asians, which is this light blue bar. So we see that reduction in HbA1c is more profound with DPP-4 inhibitors in Asian individuals compared to non-Asian individuals. When we speak on a broader term, what are the roadblocks for widespread utilization of any anti-diabetic agents in India, not only just gliptins, but when we speak of addition of any anti-hyperglycemic agent in individuals with type 2 diabetes, these are the concerns which we commonly face. That is efficacy of the molecule, the safety, durability, compliance, and of course, the logistics parts is also very important because in India, patients pay out of their pockets, and hence a molecule being economically improves the compliance, improves the adherence, and helps achievement in the targets, HbA1c targets, which we have. Now, speaking on the first concern is the efficacy of a molecule. Now, when we speak about vildagliptin in the context of vildagliptin, efficacy is not a concern. It is one of the most efficacious gliptins that we have. In this study, where the efficacy and safety of vildagliptin was compared vis-a-vis sitagliptin, linagliptin as an add-on therapy in Chinese patients with type 2 diabetes who were inadequately controlled with dual combination of insulin and traditional oral hypoglycemic agents, it was seen that there was a good reduction in HbA1c, as we see HbA1c reduction with vildagliptin compared to Sita and Lina. More number of patients achieved the HbA1c target with vildagliptin compared to Sita and Lina, and the dose of insulin requirement was brought down significantly by vildagliptin as compared to that of other molecules, other DPP-4 inhibitors like sitagliptin and linagliptin. So what best we can say is that from the various studies that vildagliptin is a good DPP-4 inhibitor with an efficacy efficacy which is at par, if not better, compared to other DPP-4 inhibitors. Now, vildagliptin is a molecule with an extensive real-world evidence. So in this study, where the initial combination therapy with vildagliptin plus metformin in drug-naive patients with type 2 diabetes, it was a 24-week real-life study from Asia. And in this, it was carried out in 4 countries across Asia, and total of 532 patients were there. It was seen that there was a robust HbA1c reduction with vildagliptin, significant HbA1c reduction from baseline at 24 weeks, and it was statistically significant, up to 4% reduction in HbA1c in patients who had a baseline HbA1c of more than 10%, and around 40% of the patients achieved the HbA1c target of less than 7%. So when we compare the effects of vildagliptin as regards the fasting plasma glucose, it was effective in reducing the fasting plasma glucose, effective in reducing the postprandial blood glucose levels, and it also brought about a minute change when used in combination with metformin in patients as regards their body weight. So at week 12, the body weight reduction was minus 0.6 kg, whereas at week 24, the body weight reduction was minus 1.1 kg. So the conclusion was that in a younger drug-naive Asian type 2 diabetic patients presenting with high baseline HbA1c and often associated with CV risk factors, initial combination therapy with vildagliptin and metformin was associated with a statistically significant reduction in HbA1c from baseline to week 12, and it was maintained up to a week of 24 weeks, regardless of the baseline age, BMI, and associated comorbidities. This was accompanied by good glycemic control and weight control. Now, going on to the next issue, which is of concern, is the safety. Whenever we are using any molecule in type 2 diabetes, we are always worried about the safety part, because if we are doing, even if we cannot do good to an individual, we should do no harm. So vildagliptin is one of the molecules with a proven safety profile in clinical trials as well as real-world studies. The incidence of adverse events with vildagliptin monotherapy was quite less, and they were very mild and insignificant adverse effects like nasopharyngitis, headache, dizziness, upper respiratory tract infection, diarrhea, nausea, and with very less hypoglycemic events. So safety-wise, vildagliptin has a proven safety profile and with insignificant or not clinically relevant side effect profile. In a meta-analysis of 40 phase 3 and 4 vildagliptin studies involving more than almost 17,000 patients, it was seen that vildagliptin was not associated with an increased risk of major adverse cardiovascular events relative to the comparators. In this first real-world cohort study on a nationwide population in Taiwan National Health Insurance Research Database, which had a mean follow-up of 9 months, it was seen that vildagliptin was not associated with an increased risk of CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And vildagliptin, now, other than cardiac events, the next most important complication, which is very disturbing or which is very relevant in individuals with type 2 diabetes, is diabetic kidney disease or chronic kidney disease in individuals with diabetes. And it has been found that in renally adjusted dose, vildagliptin is safe in CKD patients. Vildagliptin maintained the HbA1c reduction over a 52 weeks period in moderate to severe CKD patients, and overall safety profile is comparable with placebo in moderate to severe CKD. Now, going on to the third concern, we have seen that vildagliptin is efficacious, brings about good HbA1c reduction with a safety profile which is almost similar to that of placebo. The third important concern that is of concern to us is the durability of any oral hypoglycemic agent. And we have seen that vildagliptin has a proven durability in the various trials, of which Verify is one of the recent trials which stands as a proof to the durability of vildagliptin. Now, we know metabolic memory and glycemic legacy are of very important, are of great importance in individuals with type 2 diabetes. And we have seen that in UKPDS and VADT, that initial early and sustained glycemic control is the key to avoid complications at a later stage. So if there is initial and sustained glycemic control, we tend to avoid the bad metabolic memory which builds in the initial few years of bad glycemic control, so that even when we start good glycemic, achieving the glycemic targets after a period of years, the patient has already a bad glycemic legacy which drives the complications despite good glycemic control at a later stage. And we know good glycemic control is something which is rare in India, and one of the reasons for this bad glycemic control, or for most of the Indians not achieving the glycemic targets, is the sequential treatment approach, which is compounded by substantial inertia to timely intensification of therapy. So when we have a sequential approach, what happens is that we have a roller coaster kind of a glycemic control. So we have periods of good glycemic control, and then the glycemic control deteriorates. When we become proactive, add a second agent. So this leads to a bad glycemic memory. However, when we strive for initial, early, and sustained glycemic control, we tend to bring down this bad glycemic memory or metabolic memory. So the improvement in glycemic levels are there from the initial stage, and this in turn leads to avoidance of complications at a later stage. And the Verified trial stands as a robust scientific evidence to back up this notion. So we know Verify, which came out very recently, it's a multinational multi-ethnic trial where the combination of metformin and vildagliptin was used in individuals having an HbA1c of more than 6.5%, and it was seen from this Verified trial that early combination treatment half the risk of time to initial treatment failure versus monotherapy strategy. What happened is that when we speak of this primary endpoint, that is time to initial failure, the green is the use of metformin alone, and the blue line, blue dots, stand on the combination of vildagliptin and metformin. So time to initial failure was quite early with metformin monotherapy, whereas that was deferred for quite a certain extent with the use of a combination. Similarly, time to second treatment failure was also later in case of combination therapy rather than metformin monotherapy, and median time to failure was 3 years in initial monotherapy strategy compared to over 5 years in early combination strategy. When all patients were receiving combination therapy, the risk for time to second treatment failure was reduced by almost 26%. Both the approaches were safe and well tolerated. So coming to the fourth issue, which is of concern to the treating physician, is the compliance on part of the patient. Now, when a patient has to take lesser number of tablets for less number for a lesser frequency, the improvement, there's always an improvement in compliance. And we now have vildagliptin in sustained release formulation, which improves the compliance. OD dosing was found to be associated with significantly better adherence rates compared to BID. And this concept of vildagliptin 100 OD dose is actually not new, and it was there since the concept has been there since quite some time, and we have published reports to support that. Patients were randomized to receive at week 0 to receive vildagliptin 50 twice a day or 100 milligram OD. And it was seen that vildagliptin 100 milligram OD was comparable in efficacy and safety, similarly effective and well tolerated as the 50 BID dose regimen. And with the 100 OD, the patients were more adherent or more compliant with the treatment therapy rather than the BD dosing. The sustained uniform release of vildagliptin over a period of 24 hours was seen through technological breakthrough in the vildagliptin 100 SR formulation. So this is the high gel matrix technology, which leads to sustained uniform release of vildagliptin from that sustained vildagliptin 100 sustained release formulation. And there's a comparable PK/PD data for vildagliptin 100 SR vis-a-vis 50 BD. And coming on to the fifth issue, which is of concern to us, is the logistics. That is the cost of therapy. And with vildagliptin available now as an SR 100 formulation, and also with vildagliptin losing its patent and a number of companies coming up with vildagliptin formulation, vildagliptin has become one of the most cost-effective gliptin in India. So to summarize, gliptins are more suitable for Indian type 2 diabetes patients and achieve higher glucose lowering efficacy compared to Caucasians. Partners well with conventional therapies, it can be used across a wide number of oral hypoglycemic agents, or it used in combination with any regimen of insulin therapy. It is one of the most extensively studied gliptins in terms of its clinical utility. Vildagliptin remains one of the most efficacious gliptins when compared to other gliptins in the fray, and it achieves higher HbA1c reduction if the baseline HbA1c is high. There's no excess risk of hypoglycemia. It is weight neutral. It is neutral as regards the CV safety. And we have the verified trial, which is the first study to actually show the long-term benefits and glycemic durability of an early combination treatment strategy with metformin and vildagliptin compared with the current stepwise or sequential therapy in patients with newly diagnosed type 2 diabetes. Sustained release formulations of vildagliptin may further improve the patient compliance and thus help reach the glycemic targets for more and more number of Indian patients who have to pay out of their pockets, and the low cost would go a long way in improving the compliance and adherence in Indian patients. So now with that, I would like to thank you for the patient hearing. Thank you.
Thank you so much, Dr. Nilakshi. That was indeed a very nice and comprehensive lecture. There are no questions in the chat box, but I would like to ask you a question. Although not directed to be used in that way, there are many practitioners who use vildagliptin 50 milligrams OD and the rest of the day is covered with metformin. So what is your opinion and experience on this matter?
Yes, ma'am, that's a wonderful question which you have brought up, and actually that is a widely prevalent practice also. Even me in my clinical practice, I tend to write vildagliptin 50 OD in patients once a day, or in those patients where I am scared of hypoglycemic events. So even with a 50 OD dosing, it is efficacious in certain individuals whose requirement is less. And that has also been seen in studies where a reduced dose of 50 OD was used in individuals having chronic kidney disease, and it proved that the glycemic efficacy or efficacy as regards reduction in the glycemic levels was good with even vildagliptin 50 OD.
Right. Yes. So because a lot of practitioners use it that way.
Okay. Yeah, I also use it times in certain patients.
Yeah.
That is sometimes even vildagliptin metformin 50-500 combination once a day. maybe that is also effective in certain patients, because every patient differs actually. Some patients would have a normal fasting level and only their postprandial glycemic levels would show excursions. In them, perhaps giving a vildagliptin 50 with metformin once a day before breakfast would help control the glycemic levels throughout the day.
Right. Thank you. Thank you so much, Dr. Nilakshi. Thank you very much for this talk, and thanks for being a part of IDEC. And we will now have the next session from none other than Dr. A.K. Singh, who is such a well-known figure, especially when it comes to research and meta-analysis and different drug reviews. So I would be chairing this session, and Dr. Avdesh Kumar Singh, everyone knows him. He's been a very successful endocrinologist for the last 18 years, and he is the chief endocrinologist and diabetologist at GD Hospital and Diabetes Institute, Kolkata, and Sun Valley Diabetes Hospital, Guwahati. And he is going to be talking on the evolving evidence with newer DPP-4 inhibitors. So we shall now have a recorded session from Dr. A.K. Singh.
Thank you, Team IDEC, Dr. Sanjay, Neeta, and entire team. So my job is to take you through the promise and potential of a new DPP-4 inhibitor, that is evogliptin. Remember, this session is sponsored by evogliptin maker in India, that is Alke. Now, what is this new DPP-4 inhibitor is all about? Let's go through the data of evogliptin. So evogliptin is a highly selective and a very potent reversible inhibitor of DPP-4 enzyme, and it has been extensively studied with regard to their phase 3 program that studied efficacy and safety of evogliptin. On your right hand side, you can see the approval of evogliptin initially in the Korea. It is available in the name of Suganon, and it was approved in South Korea in 2014. And followed by, it was approved in various countries, including Russia and India in August 2018. Right now, evogliptin has got a prescribing information to be used in the treatment of type 2 diabetes as an adjunct to diet and exercise to improve glycemic control when you used as a monotherapy or in combination of metformin. Now, where from this indication came for the evogliptin? What is the evidence for 5 milligram once daily evogliptin in the treatment of type 2 diabetes? Now, let's look into some of the pharmacokinetic and dynamic properties of evogliptin. As you all know, DPP-4 inhibitors blocks the DPP-4 enzyme on various, anchors. As you can see, there are 5 anchors. The primary one is S1 and S2 anchor associated with one large S2 extensive anchor for DPP-4 to get attached with the enzymes. And there are some additional anchors like S1 prime and S2 prime. When you talk about DPP-4 inhibitor, different DPP-4 inhibitor anchors through either 1, 2, or 3 of these anchors, in the DPP-4 enzyme substrate. Now, the fundamental requirement for all DPP-4 inhibitor that it must anchor to S1 and S2. Now, if any DPP-4 inhibitor has additional anchoring ability, this would allow the DPP-4 inhibitors to firmly adherent to the DPP-4 enzymes so that it produce a sustained DPP-4 inhibition. And on the basis of these binding, DPP-4 inhibitor has been classified into class 2 and class 3. All these are arbitrary definition based on X-ray crystallography, on the binding mechanism to the DPP-4 substrate. Now, as I said, some of these DPP-4 inhibitor additionally bind to either S2 extensive or S1 and S2 prime. But fundamentally, everyone has to get stacked to S1 and S2. 3 DPP-4 inhibitor like sitagliptin, tenaligliptin, and ibogliptin, they have been classified into class 3 type of DPP-4 inhibitor because they additionally bind to S2 extensive substrate other than S1 and S2. The other DPP-4 inhibitor, they bind to either S1 prime or S2 prime, but they do not bind to S2 extensive. Now, the beauty with S2 extensive theoretically suggests that if you bind to an additional anchor like S2 extensive, the DPP-4 inhibitor tends to have a very firm binding. Now, the exception is always in the rule, although tenaligliptin belongs to this class 3 because it gets, attached to S2 extensive. DPP-4 inhibition ability of tenaligliptin is meager among all the DPP-4 inhibitors. And if you look into the data of DPP-4 inhibition, which will come later on, the tenaligliptin binds as much as 65% as opposed to sitagliptin that binds to DPP-4 by almost 97%, and so is ibogliptin by more than 90%. So not necessarily these theoretical disposition will fundamentally lead to a really robust DPP-4 inhibition. Well then, now as a clinician, we are interested whether these binding translates into any clinical benefit, if at all a particular DPP-4 inhibitor has this ability to bind to additional anchor. Now, when it comes to selectivity and potency, this ibogliptin, look here, has got ability to DPP-4 versus DPP-8 and 9, very selectively. And if you compare with other DPP-4 inhibitor, it is apparent that ibogliptin seems to be a very specific DPP-4 inhibitor, unlike vildagliptin, unlike tenaligliptin, or even sexagliptin. Now, if you see the potency of the drug ibogliptin, it is as potent as, and perhaps most potent, very closely equal to linagliptin, and with the DPP-4 inhibition of IC50 of 1 nm, as you can appreciate ibogliptin, and therefore the potency of ibogliptin is the best among all the DPP-4 inhibitor in the line of linagliptin. Both linagliptin and ibogliptin is used in 5 milligram dose, as you can appreciate, as opposed to larger dose of other DPP, for example, 100 milligram of vildagliptin or 100 milligram of sitagliptin. But not necessarily potency, a better potency always leads to a better efficacy. However, in potency, as you can appreciate, ibogliptin is a very potent DPP-4 inhibitor, as well as a very selective to DPP-4 versus DPP-8 and 9. Remember, we don't want to inhibit DPP-8 and 9 while trying to achieve glucose control. It's the DPP-4 inhibition that is responsible for glucose control without any adverse event. If you block DPP-8 and 9 by a non-specific DPP-4 inhibitor, you tend to have many more, off-target side effects of DPP-4. And the example lies with vildagliptin and sexagliptin, which are non-specific, with regard to DPP-4, and they do have many unwanted side effects. For example, vildagliptin has got the highest potential of a skin reaction. In the same way, sexagliptin causes, lymphopenia, that is there in the trial and there on their prescribing level. So we need a very specific DPP-4 inhibitor which don't have much action on DPP-8 and 9. Now, with regard to the pharmacokinetic, as you all know, some of the DPP-4 inhibitor is primarily excreted through kidney, and therefore their dose needs to be reduced in patients with chronic kidney disease according to the EGFR, such as sitagliptin and vildagliptin, so as the sexagliptin. The linagliptin is one exception because it is primarily excreted through biliary route, and you don't need to reduce the dose of linagliptin in patients with CKD. Both tenaligliptin and ibogliptin are, equally excreted through liver and kidney, and therefore even these two DPP-4 inhibitor dose requirement is not necessary in people with chronic kidney disease or even a chronic liver disease. And I will explain you how this data came into the picture. So in the class of DPP-4 inhibitor, it's not only linagliptin where you don't need to reduce the dose in patients with CKD, it is also with tenaligliptin and evogliptin. But remember, the data for both tenaligliptin and evogliptin in patients with CKD is very small. Nonetheless, whatever data is available that recommends that evogliptin can be used without any dose alteration, irrespective of the EGFR. Now, where from this data came from? The data came from this study, although, as I said, pretty small study done in patients with various grade of kidney dysfunction, and it was found that there is no increased excess in the therapeutic concentration with the current dose of evogliptin, and therefore this study concluded that you don't need to reduce the dose of evogliptin in patients with various degree of kidney dysfunction. The similar data is with the evogliptin in patients with liver disease. Again, the caveat is these are very small studies at the moment, but this study in patients with hepatic impairment did suggest that there was no excess therapeutic concentration with a various degree of hepatic dysfunction, therefore suggesting that you don't need to alter the dose of evogliptin in moderate hepatic impairment. Remember, none of the DPP-4 inhibitor is currently considered in people with severe hepatic impairment. Well then, now let's come into the clinical data. As a clinician, we need the good efficacy and safety data. The evogliptin, I would tell you, and I can tell you with confidence, is one of the DPP-4 inhibitor, or rather a low-cost DPP-4 inhibitor, which came into the market, with a robust data. Now, I don't want to bore you with all those studies, but this slide suggests you that how many trials have been there with evogliptin before it got approval, and many more trials are still under progress. And I'm hoping that in the next couple of years we may have even a better evidence available with evogliptin in type 2 diabetes. However, I have picked up 6 landmark studies of evogliptin that needs attention very quickly. Now, as I said, this is one of the low-cost DPP-4 inhibitor that attracted me because of their robust data. And these data are not published in any XYZ journal, but these data are published in one of the highest impact factor in the world. So you have got 3 blue-colored study and 3 purple-colored studies, so total 6 studies in front of you. What is interesting to note that the first 3 studies are study done in patients who were drug naive. So it is a monotherapy trial. The first one is trial conducted against placebo, and from this trial result, they got approval in South Korea in 2013-14. And the next 2 trials are the trials of evogliptin that was done as a monotherapy in a drug naive type 2 diabetic patient and compared head-on to active comparator. So you can see the second trial was a head-to-head trial with sitagliptin, and the third monotherapy trial was a head-to-head trial with linagliptin. It's called Evergreen study, where evogliptin was head-on compared to the linagliptin, not only to the HbA1c, but also on a glycemic variability account. Remember, all these papers have been published in a good high-impact journal. The next 3 study was done in a patient with type 2 diabetes who were receiving metformin, and then were either added evogliptin or sitagliptin. You can see all the last 3 studies are head-to-head study with sitagliptin in a background metformin therapy. So out of 6, these trials and landmark trial, the 5 trials are a head-to-head active compared trial. Unlike other, low-cost DPP-4 inhibitor, which is available in the market, which came and got the DCGI approval in absence of any head-to-head trial with a standard care of drug like sitagliptin comparison, which all other, US FDA approved drug has got approval because of their head-to-head trial showing non-inferiority. So that's the beauty and the confidence, at least to me, gave when I look into these 5 head-to-head trials with one of the standard DPP-4 inhibitors, that is sitagliptin. Now, let me quickly go through these 6 trials in a one-slide agenda. So the first trial, as I suggested, was the head-to-head trial versus placebo in a drug-naive patient as monotherapy. And this trial got published in Diabetes, Obesity, Metabolism, as you can appreciate. And evogliptin was found to have a significant HbA1c lowering compared to placebo. Now, these HbA1c lowering was different depending upon the baseline. So someone having HbA1c of more than 7.5% had a roughly 0.7% reduction, whereas someone with HbA1c of less than 7.5 at the baseline had 0.2% HbA1c. And we always saw this kind of HbA1c change if the baseline HbA1c is different. Overall, if you combine the data, there was 0.5% HbA1c reduction against placebo in this monotherapy trial. And on the basis of this particular trial, the evogliptin got approval in the South Korea. The second trial, this is a bridging trial which happened in Russia. And in this trial, evogliptin was compared head-on to the sitagliptin. As you can see, this is a 12-week trial with a 3 different doses of evogliptin compared head-on to the sitagliptin. Remind you, these are double-blind, randomized controlled trial. And you can see in the 2 doses of evogliptin, 5 milligram and 10 milligram, HbA1c lowering versus sitagliptin was non-inferior, that both sitagliptin and evogliptin had a similar HbA1c lowering in this double-blind randomized controlled trial. The third study, which is called Evergreen study, again, this is a double-blind randomized controlled trial in treatment-naive type 2 diabetic patient where evogliptin was compared head-on to the linagliptin. You can see this is single-blind trial. For the initial 12 weeks, it was double-blind, and then it was the open level. And the head-on evogliptin 5 milligram was compared with linagliptin in roughly 100 patients. It was measured not only on the HbA1c, but also on a continuous glucose monitoring system. Now, if you look into the result of this trial, both on HbA1c and difference in glycemic variability, it was interesting to find that evogliptin was as good as linagliptin with regard to the HbA1c lowering. Now, numerically, in fact, evogliptin arm had little better HbA1c reduction. However, it wasn't statistically significant, thereby suggesting that both evogliptin and linagliptin had similar HbA1c lowering at the end of 3 months in this double-blind 12 weeks randomized controlled trial. If you see the percentage of people achieving the HbA1c target of less than 7% or 6.5%, you can find out it's pretty similar, thereby suggesting that evogliptin is as good as linagliptin when it comes to glucose control. What was even more surprising was on the glycemic variability. Now, this study, Evergreen, did find a numerical better glycemic variability reduction with evogliptin compared with linagliptin, although it did not achieve a statistical significance, suggesting that evogliptin is as good as linagliptin in reducing glycemic variability in whatever way you measure, either by mean amplitude of glucose excursion or by the change in standard deviation. There was no difference whatsoever, or if at all any difference was there, it was numerically better with evogliptin compared to linagliptin. So these are the 3 monotherapy trials, of which 2 head-on trial with sitagliptin and linagliptin that found evogliptin as good as a 2 standard of care when it comes to DPP-4 like sitagliptin and linagliptin. Now let's look into the other 3 trials, which was done in a background metformin therapy, and surprisingly, all these three background metformin trial of combining or a fixed dose combination of evogliflozin and metformin versus either a sitagliptin and metformin was very interesting. So this is a first head-to-head trial. This is a Korean study, and it is again double-blind randomized controlled trial, 6-month trial comparing evogliflozin to sitagliptin in a background metformin therapy, and you find no difference in HbA1c between two DPP-4 inhibitors. Although numerically sitagliptin had little bit better HbA1c at the end of 6 months, but then it did not achieve a statistic, thereby suggesting that in a background metformin therapy, evogliflozin and sitagliptin did a similar glucose load. The second study is an Indian study, and you can see this is called Evolution India study, and again it was done in a background metformin therapy. Look at the quality of the trial. These all are double-blind randomized controlled trial and published in one of the best journals in the world. And in this trial, in Indian population, again, there was no difference in HbA1c lowering between sitagliptin and evogliflozin in a background metformin therapy. So that's the fifth head-to-head evidence with evogliflozin when comparing either with sitagliptin or linagliptin. Finally, this is a study again compared evogliflozin to sitagliptin. This is a Russian and Korean trial. You can see here, and this trial is again double-blind randomized controlled trial comparing evogliflozin to sitagliptin in a background metformin therapy, and they find no difference in HbA1c control. So, ladies and gentlemen, out of 6 trial which I have shown you, in the 5 head-to-head trial, 4 versus sitagliptin and 1 versus linagliptin, evogliflozin was non-inferior to both the active components. Now how to choose? Now, in the Indian context, this is a very interesting slide, and this is my slides, and this is my understanding while looking into all DPP-4 inhibitor and choosing amongst the DPP-4 inhibitor. Now, so when it comes to the Indian context, we have got this 7 DPP-4 inhibitor right now in India: Sita, Lina, Sexa, Allo, Vilda, Tenaligliptin, and evogliflozin. Let's closely look into each data, separately. Remember, these are the trials which has not been done in a head-on fashion, so you can't exactly compare, that A is better than B. However, these trials were done in a different setting and does merit indirect comparison. Now, if you look into a percentage of DPP-4 inhibition, which is the crux of the glucose control pharmacokinetically, so amongst the different DPP-4 inhibitor, it is clearly apparent that the 2 DPP-4 inhibitor which has got perhaps the least DPP-4 inhibition is tenaligliptin, and which is pretty close to sexagliptin. I can tell you that there were 2 head-to-head trials of sexagliptin versus sitagliptin, and where in one trial the sexagliptin was found to be inferior to sitagliptin. So we do have some evidence with the Sexa versus Sita, and thereby suggesting that the DPP-4 inhibition does matter when it comes to glucose. So you can make out that this 2 DPP-4 inhibitor, Tenali and Sexa, has got least DPP-4 inhibition with a therapeutic licensed dose. The second important point while choosing DPP-4 is the DPP-4 selectivity, because we don't want to have the off-level target of DPP-4 inhibition. DPP-4, DPP enzymes are ubiquitous, and there are many DPP enzymes which is good for the human being. So if you block all the DPP enzymes, you may have a harm, with the drug, and therefore we need a selective DPP-4 inhibitor. Remember, treatment of type 2 diabetes is a lifelong business. So you need to have a drug which should not produce any unwanted or off-target side effects. And therefore, we need a very selective DPP-4 inhibitor. We don't want to inhibit any other DPP enzyme other than DPP4. And therefore, the selectivity plays a major role. Now, if you look into different DPP4 inhibitors, as I said in very beginning, hexagliptin and vildagliptin in particular has got a very less selectivity to DPP4. And many people claim because of this, non-selectivity, vildagliptin has got a highest skin eruption and the, dermatological side effects. And similarly, sexagliptin has got some unwanted WBC abnormality, which is there in the prescribing level of sexagliptin. Now, if you look into the dosing, of course, dose matters in the patient compliance, and we prefer to have a once daily tablet rather than a 2 dose of tablet. Here, the vildagliptin perhaps has got some disadvantage because it should be used in twice daily dose. The fourth important point is whether you need to alter the dose of the drug. Yes, there are, as I suggested in very beginning, there are few DPP4 inhibitors where their dose needs to be reduced as per EGFR, and some do not require. In the no require dose adjustment list, the linagliptin comes at the top with the highest data, and both tenaligliptin and imogliptin also has got a current prescribing information that you don't need to reduce the dose in patients with renal disease, irrespective of the baseline EGFR. The liver disease, here lies the catch. As we all know, vildagliptin is not at all allowed in any degree of liver insufficiency. So vildagliptin is totally out. Of course, in severe liver dysfunction, this child POF class C, we don't recommend any drug. And you can use any other DPP4 inhibitor other than vildagliptin in child POF A and B class. HbA1c lowering, very important and perhaps most important for clinician like us. If you see the active comparator trial, we do have some reference. If you take sitagliptin as an active comparator trial, we do have head-to-head trial with different DPP4 inhibitor. Linagliptin, sitagliptin has got nearly similar HbA1c lowering. In one of the trial, linagliptin showed inferior HbA1c lowering compared to sitagliptin. Now, we do have head-to-head trial also, as I shown you with imogliptin. We do have one trial now with tenaligliptin versus sitagliptin showing a similar HbA1c low. So basically, all DPP4 inhibitor, in one hand has got more or less similar HbA1c lowering ability, when in comparison. There might be slight 0.1, 0.2% difference with drug A versus B, but by and large, the HbA1c lowering with all DPP4 inhibitors are same. Now let's come to the safety part. So the last three, row is for safety, and what are those important points is QT prolongation. It's a mandate that all diabetic drugs has to undergo a mandatory QT prolongation trial in a supraphysiological dose, and ideally should be compared with moxifloxacin, because the moxifloxacin is an ideal drug to compare the QT prolongation, because that is the drug which causes highest QT prolongation among all pharmacotherapy in the treatment of human beings. So you need to conduct a head-to-head trial versus of DPP4 inhibitor. Now, if you look the data, we do have the studies which has been done with different DPP4 inhibitor. Amongst all the DPP4 inhibitor, tenaligliptin was found to have a QT prolongation, as you all know, and Japanese PMDA gave them approval and suggested them to conduct a dedicated cardiovascular outcome trial. Unfortunately, tenaligliptin do not have any cardiovascular outcome trial to know whether the QT prolongation seen in comparison with moxifloxacin has got any deleterious effect on the cardiovascular system. Cardiovascular safety, very important. In today's era, we don't need any drug which is not cardiovascular safe. Unfortunately, not all DPP4 inhibitor has undergone mandatory cardiovascular safety outcome trials. And the initial 4 drug, Cetalina, Sexa, and alogliptin has undergone their respective cardiovascular outcome trial, and they all were found to have a cardiovascular neutrality, except that sexagliptin had a significant signal of increase in heart failure. The alogliptin data is controversial, so that's why I put it in a capital, and this one, in the smaller font. The reason being that alogliptin data is controversial. I feel the alogliptin heart failure was unfortunate. There were some increase in heart failure, but with alogliptin, but it was not statistically significant. So it was unfortunate to club alogliptin in the heart failure causing DPP-4 inhibitor. However, still in the United States, they have got a warning for the alogliptin in a similar fashion like alogliptin. The last three DPP-4 inhibitor, neither Vilda nor Denali or evogliptin has undergone the cardiovascular safety outcome trial. So therefore, we don't know exactly whether they are cardiovascular neutral. And finally, in the Indian context, the cost plays a major role. Now, the initial 4 DPP-4 inhibitor that underwent a cardiovascular outcome trial, they are a costly drug, barring the alogliptin, because a generic alogliptin is available in India. That's why it's a cheaper, DPP-4 inhibitor. Now, if you look the last 3 DPP-4 inhibitor, these are the cheaper versions of DPP inhibitor in India. So if you look at this table, where this all endpoint looks to be in general fine. To me, evogliptin has got a case to make here, and you can see this is a DPP-4 inhibitor which is pretty cheap, available in India, which can be given in a once daily dose, which has got several head-to-head trials having a similar HbA1c lowering like sitagliptin, which can be used in a once daily dose. It doesn't need any dose requirement in people having a different degree of renal and hepatic dysfunction. The only issue which is there with evogliptin is at the moment is they don't have cardiovascular outcome trial, yet they do not show any QT prolongation, unlike tenaligliptin. So here is the case that evogliptin seems to be one of the good contenders amongst all the cheaper versions of DPP-4 inhibitor which is available. I hope I was enough to give you the entirety of evidence which is available with the evogliptin. The choice lies with your company and the evidence which is available with the evogliptin. Very much for your patience listening. And thank you, organizer, again for inviting me for this.
We are very thankful to Dr. A.K. Singh for giving us this recorded version of his talk. And there will not be any questions as because we're already running out of time. So I close this session of drug reviews and therapeutics. And in another 5 minutes, we will be starting the very exciting evening thematic plenary sessions, the first one of which will be given by Dr. Adrian Vella and is on a very important topic, and that is management of diabetes in pregnancy. So we will reconnect, we will stay connected, but we will start the session in another 5 minutes. So stay tuned and be with us this evening for the plenary sessions. Welcome, Dr. Adrian, and welcome, Anuj. So we will just wait for another 5 minutes before we begin.
No problem, it's okay.
Yeah. A very good evening and welcome back, delegates, to this very exciting session of thematic plenary sessions that we are going to have now. And we have some very interesting topics lined up for this evening. And the first amongst them will be by Dr. Adrian Vella. And to chair this very important session, we have with us Dr. Anuj Maheshwari, whom I'm going to introduce now. Dr. Anuj Maheshwari is a senior diabetologist, and he is Vice President of the RSSDI, Governor of the American College of Physicians India chapter, and Professor and Head in Medicine, BBD University, Lucknow. He has been a teacher for the last 10 years, presented several papers, has several publications to his credit, and he has many feathers in his cap, and he is a very active member of the Hypertension Society of India, and he has received several awards, and we are very happy to have him here today. And the other chairperson may join us in some time, Dr. S.R. Arvind, but I request Dr. Anuj Maheshwari to please go ahead and start the session by introducing our first speaker.
Thank you, Dr. Neeta, for the kind introduction and giving me invitation. So very good evening to all listeners. On this evening, we shall be having a very good discussion on diabetes in pregnancy, regarding its pathophysiology and management of diabetes in pregnancy. And we are having Dr. Adrian Vella for that. He is professor of the medicine and having a lot of accolades in his career. He is having professor of medicine at the Mayo Clinic College of the Medicine and has been on the staff of Mayo Clinic, Rochester since June 2001. So over to Dr. Adrian Vella without taking much time.
Thank you for having me. I'll go ahead and start by sharing my screen. We can go ahead and get started. So I was asked to speak about the pathophysiology and management of diabetes in pregnancy. These are my disclosures. Today, what I intend to do is I'll talk about the nuances of diabetes in pregnancy, pre-existing diabetes or diabetes discovered during pregnancy versus gestational diabetes, and then talk about the pathogenesis of diabetes and the effects of pregnancy on the pathophysiology of diabetes, as well as the rationale for management. We'll talk about outcomes and complications associated with gestational diabetes and speak a little bit about management at the end of this. So usually it is straightforward to distinguish between pre-existing diabetes and gestational diabetes. The management, at least the goals of management, overlap adequately. At the end of the day, it is all about adjusting therapy to the appropriate glycemic targets for pregnancy and ensuring that we avoid hypoglycemia and other complications associated with pregnancy. With pre-existing diabetes, especially long-standing type 1 diabetes, we have to consider microvascular complications and the possibility that these might worsen during pregnancy, things like retinopathy, which can progress, and nephropathy, which might have implications for fetal growth and development during pregnancy. Ideally, in these situations, the secret is to actually plan appropriately and have management plans in place before conception, but that is not always the case. And sometimes people show up 3 months pregnant with A1Cs of 10% and a history of proliferative retinopathy, which will need to be managed on a case-by-case basis. Gestational diabetes could also be a presentation of established type 2 diabetes. It just so happens that pregnancy is what brought people in for a medical examination. And there's also a possibility that type 1 diabetes is presenting as gestational diabetes for the first time. Both of these scenarios have significant implications for management and follow-up after delivery. It's also important to appreciate that GDM is the strongest risk factor for future type 2 diabetes. An interesting statistic to consider is that about 50% of women with gestational diabetes will develop diabetes within 10 years of delivery. The thing, though, is it's interesting because gestational diabetes likely represents an early failure of the beta cell. We'll talk about that in just a bit. But it's also interesting to consider that fully half of people with gestational diabetes essentially return to normal and stay normal. And that heterogeneity is interesting from a pathophysiology point of view, which we don't necessarily understand at this point in time. But that will require further work. So here I'm going to quote my mentor, Dr. Robert Rizza, about the defects in type 2 diabetes. And when Bob was always asked to define type 2 diabetes, he would always answer by showing this slide. So essentially, it's important to remember that people who are not diabetic have what we would consider to be normal fasting glucose and a relatively contained postprandial glucose excursion, so that by 120 minutes, they have returned back to their fasting baseline. In contrast, people with type 2 diabetes have a higher fasting glucose. Their blood sugars go a lot higher in response to meal ingestion and stay higher for a lot longer. In fact, it takes them close to 5 hours to return to their baseline. And this is because despite having higher fasting insulin concentrations, which are clearly inappropriate for the fasting glucose concentrations, their insulin secretory response is actually delayed and decreased compared to non-diabetic individuals. This relative deficit in insulin secretion is actually compounded by the lack of suppression of glucagon. And in fact, some people with diabetes have a paradoxical rise in glucagon concentrations in response to meal ingestion. So clearly, type 2 diabetes is a bihormonal disease, at the very least, in the sense that there are defects in both insulin and glucagon. And as we shall see, both are important in the pathogenesis and pathophysiology of diabetes. So I was trained to think that there are 5 physiologic parameters that we have to consider when considering the abnormalities of postprandial glucose concentrations. And all of these are extant in both type 2 diabetes and in gestational diabetes. The most important consideration, as I've already shown you, is insulin secretion. So insulin is secreted into the portal circulation. The only other factor that affects insulin secretion directly is hepatic extraction, because as insulin travels across the hepatic circulation, in health, about 50% of it is extracted. It is unclear as to whether this is a passive process or an active process. We do know that the amount of insulin secretion can actually modulate hepatic extraction. So in fact, as insulin secretion falls in diabetes and pre-diabetes, hepatic extraction decreases. In a way, it might represent an adaptation to allow insulin into the systemic circulation, perhaps to counteract hepatic insulin action, which is decreasing in type 2 diabetes. So insulin action, which is the inverse of insulin action, is insulin resistance, okay? But if we defined it from a physiologic point of view, we'd say that insulin action represents the ability of insulin to stimulate glucose uptake and suppress glucose production. And again, this is something that is impaired in people with type 2 diabetes and in people with gestational diabetes. Glucagon suppression is the third factor, if you will, that affects postprandial glucose concentrations. And I'll show you some data that directly implicates glucagon in postprandial hyperglycemia. And then there is another parameter which is also underappreciated, which is glucose effectiveness. And glucose effectiveness is the ability of glucose itself, rather than of insulin, to stimulate its own uptake and suppress its own production. So glucose, when it rises after a meal, will stimulate its own uptake into the periphery, into muscle, for example, into the liver to some extent, and suppress endogenous glucose production by the liver. And the final parameter to consider is gastric emptying, although that is not necessarily germane to the pathogenesis of diabetes per se, but directly affects postprandial glucose concentrations. Not particularly important in the pathophysiology of gestational diabetes either. So to take insulin action and insulin secretion in context, because I don't think you can separate them completely, I like to think of them in terms of the power to weight ratio of the beta cell. And I always use this example, so you'll have to forgive me here, but basically Concorde has 4 engines, okay, and flies at the speed of sound. HMS Ark Royal has the same engines, the same number of engines, but it barely makes 30 miles per hour. So despite having the same power, the speed is different. The reason for that is obvious, okay? So if you keep that in mind, you consider that when you talk about insulin secretion for the beta cell, you also have to consider, if you will, the size of the rock that insulin is trying to move up the hill. And in fact, this concept is expressed as something called a disposition index. And the disposition index is the mathematical equivalent of this hyperbolic relationship between insulin sensitivity and insulin secretion. So this is actually an example from Tom Buchanan's work. I'm going to show you another example of. Tom actually worked with Richard Bergman, but Richard Bergman and my good friend Claudio Cobelli actually invented the oral minimal model and conceptualized this hyperbolic relationship between insulin secretion and insulin action. So the whole idea here is that if you are a normal individual living on this disposition index, if you become insulin resistant, you adapt by secreting more insulin. If you can secrete more insulin, you stay on this curve. If your beta cell cannot adapt to increasing insulin resistance, you fall off this curve and get onto a curve which is lower and to the left, okay? So for example, in this individual, if you will, pregnancy caused an increase in insulin resistance, and because said individual was unable to produce enough insulin, they fall over and their disposition index decreases. So they live on this curve. After delivery, insulin resistance decreases, and obviously there can be a shift to the right, and you return back to your previous curve, and hyperglycemia resolves. In some people, it does not resolve. Okay, now Tom Buchanan actually harnessed this principle directly by treating people with a history of gestational diabetes postpartum with troglitazone, a PPAR gamma agonist, which now is no longer on the market. But the point is, he took people before treatment. Treatment decreased insulin resistance. Okay, so people moved to the right, and you can see the open circles here, with a consequent decrease in insulin secretion, and therefore what he called an unloading of the beta cell. He was able to show an improvement in glycemic control and an improvement in beta cell function subsequently. So this is a principle that underlies the pathophysiology of type 2 diabetes, which has clear relevance to the concept of gestational diabetes in this circumstance. I told you that impaired glucagon suppression is actually important. And in fact, this is an experiment that was being completed at the time that I joined Dr. Riza's lab by my good friend, Dr. Pankaj Shah. And Pankaj showed that even in normal, healthy people, I believe their average age was 28 and BMI was 24. If you gave them a normal insulin profile but failed to suppress glucagon, you actually had a small increase in peak and integrated glucose concentrations. However, if these people had a diabetic insulin secretion profile, the lack of suppression of glucagon caused very marked hyperglycemia compared to suppressed glucagon. And then glucose effectiveness. This was an experiment performed by my colleague, Dr. Andy Basu. And essentially the principle is that people have a an individually determined insulin infusion, which maintains euglycemia in the presence of somatostatin, and then they're given a glucose bolus. And the time necessary to clear and the area under the curve for that glycemic excursion represents glucose effectiveness. And as you can see, people without diabetes had lower peak and integrated glucose concentrations, accompanied by increased glucose disappearance into the body, out of the circulation, and increased suppression of endogenous glucose production compared to people with diabetes. And finally, when we talk about gastric emptying, it's important to appreciate that the upper gastrointestinal tract, in part with the neuromuscular plexus that controls enteric motility, and in part with cranial nerve input via the vagal nerve and the autonomic nervous system, has a set of reflexes, which also include the secretion of various hormonal mediators, which are designed to limit food output by the stomach. So the stomach is churning food into chyme, which can pass the pylorus, and the caloric content of whatever passes through the pylorus stimulates a network of both mechanoreceptors and chemoreceptors, causes neural reflexes as well as secretion of hormones that all integrate to delay gastric emptying, so that caloric delivery to the upper intestine is relatively fixed after a meal. And what's actually interesting is that the rate at which the stomach empties its contents is influenced by caloric content. So if it's just water, it empties very quickly. 50% of stomach contents would be emptied in about 10 minutes, 10 to 15 minutes. But as you can see, as the caloric load of ingested food increases, then the half-life, the time necessary to empty 50% of contents, starts to increase progressively. So that if you have a high-fat meal, okay, the time taken to empty 50% of fat content is about 180 minutes, okay? An order of magnitude higher than it is for water or other liquids. So, pregnancy is an insulin-resistant state. So you're going to impair insulin action, which you can compensate for by increasing insulin secretion. If you cannot do that, hyperglycemia is going to result. And then there's this question as to how the beta cell adapts to impaired insulin action. Is there beta cell growth or the growth of new beta cells in pregnancy? Alpha cell function has not really been studied, but may play an important role, and we'll talk about that briefly in just a bit. And then there are numerous animal models which suggest that things like prolactin, which obviously its secretion is increased during pregnancy, growth hormone, and serotonin contribute to islet adaptation. All of these contentions come from rodent models, and I'll submit to you that rodent models, at least in terms of beta cell growth and replication, may not have a lot of relevance to humans, in the sense that there is no clear evidence that beta cells turn over in humans at any rate comparable to what is observed in rodents. And in fact, it's interesting to note that the genetics of gestational diabetes overlap almost completely with that of type 2 diabetes. And in fact, TCF7L2, which is the variant with the strongest effect on predisposition to diabetes, to type 2 diabetes, is also the variant with the strongest effect on risk of gestational diabetes. And it's interesting because TCF7L2 was described in March of 2006 as being associated with type 2 diabetes. And in a sense, it ushered in the modern era of genetics in type 2 diabetes. We actually used it as a probe to understand the pathogenesis of diabetes. And in fact, in non-diabetic individuals, we were able to show that people with 2 copies of the diabetes-associated allele had a different hyperbolic relationship between insulin action and insulin secretion compared to people with the diabetes protective allele. So you can see that at the lower ends of insulin resistance, they needed to be more insulin resistant to secrete the same amount of insulin as their CC counterparts, who were age, weight, and sex matched, by the way. What's also interesting, actually, is that when subjected to acute insulin resistance, you can see that both behaved equally badly in those situations. But the other interesting observation that we made, which was completely unexpected, was that TCF7L2 actually also impairs the suppression of glucagon. And this effect is most marked in people with impaired glucose tolerance. So TCF7L2 actually predisposes to type 2 diabetes and gestational diabetes 2 ways. It affects insulin secretion weakly, and it also affects the suppression of glucagon in the postprandial setting. So that's actually extremely relevant to the pathogenesis of type 2 diabetes. Obviously, the higher the BMI prior to pregnancy, the more likely the prevalence of gestational diabetes. So if you have a BMI between 30 and 35, there's a 5.5% prevalence of gestational diabetes. And if it's higher than 35, then the prevalence of gestational diabetes increases even further. Now, how do you make a diagnosis of gestational diabetes? There's a lot of controversy about the importance of postprandial glucose concentrations versus fasting glucose concentrations. I think it's important to appreciate that one does not arise independently of the other. So it's a question of choosing the right glycemic targets. And if you choose the right fasting target, it's as good as a postprandial target or cutoff for the diagnosis of diabetes. What's actually interesting is that the IAPSG had actually suggested that glucose in the first trimester that is greater than 5.1 millimoles per liter could be diagnostic of gestational diabetes and would not require subsequent testing in the 24th to the 28th week of pregnancy. The problem was that this was rescinded because it was actually poorly predictive of glucose tolerance later. And that likely implies changes in glucose metabolism in early pregnancy versus the remainder of pregnancy. What's actually also important to appreciate is that cutoffs are actually somewhat arbitrary. And somebody who has, if, for example, we're taking a cutoff of 10 millimolars 1 hour after an OGTT, it's important to appreciate that people with a 9.8 millimolar value and people with a 10.1 millimolar value are being classified as completely different individuals, normal versus gestational diabetes, but biologically, they probably represent the same person. And so we are treating people differently based on an arbitrary continuum, which is glucose-based and subject to significant variability of its own in testing and retesting. So we have to keep that in mind. This is data from Gunther Boden, and I show it here. This is just euglycemic clamp data, just to show the differences in insulin resistance in the 3rd trimester compared to the postpartum period. So this is the insulin secretion rate necessary to maintain the same degree of glycemia, both in the 3rd trimester and postpartum. And you can see that there's at least a 2-fold increase in insulin secretion compared to the postpartum period. How is this achieved? Well, there's only one autopsy study in humans, for obvious reasons, that looked at beta cell size. And you can see, this was actually from the Mayo autopsy database. You can actually see that there was no evidence of beta cell replication, and there was no evidence of a change in beta cell apoptosis associated with pregnancy. What was actually interesting was that they showed an increase in beta cell area, i.e. the amount of insulin staining in a beta cell. And this is likely the adaptation that humans make to pregnancy. They increase the amount of insulin made per beta cell rather than necessarily increasing beta cell numbers, which is completely unlike rodent models, and hence why rodent models are likely not very relevant to the study of the human condition. As this audience knows, neonatal complications of hyperglycemia are typically things like macrosomia, neonatal hypoglycemia, and hyperinsulinemia. And as glycemic abnormality increases, the likelihood of these abnormalities, of these complications, increases. Same with fasting plasma glucose and large for gestational diabetes, large for gestational age, whose prevalence increases to 20% if fasting plasma glucose is consistently above 5.3 millimolar. In terms of pharmacotherapy, well, for pure gestational diabetes, lifestyle modification is the prime early therapy, and is the foundation on which any subsequent therapy is based. Over the years, there has been some tendency to use glyburide or other sulfonylureas and metformin as oral agents in the treatment of gestational diabetes. I think the American Diabetes Association and myself would firmly suggest that insulin is probably the medication that would be indicated, and the one that I certainly would be most comfortable using in these situations. There's a lack of long-term safety data with oral agents, and there's no clear evidence that treatment improves outcomes with oral agents. So I'll conclude by saying that islet cell function is the primary regulator of glucose metabolism in humans. Currently, there's a paucity of data as it applies to islet adaptation and expansion in humans during pregnancy. And certainly the evolution of gestational diabetes postpartum is understudied and ignored. How much of these abnormalities persist, accelerate, continue under prior decline? We don't really know that. We also don't know why 50% of people with gestational diabetes never go on to develop diabetes. We don't actually know if number of pregnancies, for example, increases your risk of type 2 diabetes very clearly. So there are some basic fundamental questions associated with gestational diabetes that we don't actually really know. I think management should be focused on glycemic control, and overall, I would tend to favor insulin therapy in these circumstances. So those were my conclusions. I'd like to acknowledge my study staff, my study subjects, my mentors over the years, and my colleagues at the University of Padova, who always have provided helpful advice and mathematical modeling for our data, for our studies. So thank you very much for listening to me. I'll stop here.
Thank you, Dr. Adrian Bella, for a nice, lucid presentation, and we really enjoyed and learned a lot about gestational diabetes. We many of the times have a temptation of using the oral medications in the pregnancy. Most of the time, most of the females are so young, or first time they are experiencing diabetes. So acceptability of the injection insulin is not so good. In that condition, if we, and some of the guidelines also recommend about the metformin uses in the pregnancy. What is your view, although you have given in your presentation that metformin crosses the placental barrier, but this amount of the metformin which crosses the placental barrier is really injurious for fetus, or something else is also there with metformin for which we should not use this?
No, so I don't think, I don't know that metformin would be injurious, and there isn't any clear data. My concern comes from the fact that studies that have looked for teratogenic effects are classically very underpowered to reliably detect a teratogenic effect of these medications. So we cannot say with certainty that they are not teratogenic. I mean, if we actually went so far as to split hairs, we would say that really the only insulins we should be using are regular insulin and NPH, because only those have been studied extensively enough that we know that they are not teratogenic. We use, at least in my practice, if somebody comes in with a prior history of using glargine insulin, for example, and they become pregnant while they're on glargine, I don't change insulin. Most of my colleagues do not change insulin. But strictly speaking, there isn't any data about teratogenicity with glargine like there is with NPH insulin. And the same applies with metformin. The better concern about metformin, so to speak, rather than teratogenicity, is the concern that there's been no convincing evidence that its use prevents fetal macrosomia more than anything else. The one thing that I neglected to say actually in the beginning is that most of the time fetal size is programmed within the first to the middle of the second trimester. And most of the time with gestational diabetes, we're screening at the 24th week and 28th week. And we're intervening to change glycemic control when already a significant amount of fetal size has already been determined and programmed. And in fact, that's a significant deficiency in how we manage gestational diabetes. I've already told you that in the first trimester, glucose is not really predictive of gestational diabetes in the third trimester. So we clearly need a better biomarker to be able to intervene therapeutically earlier. But we don't have it right now. And I don't think there's any harm associated with using metformin. There may not be as much efficacy as using metformin, is perhaps what I was trying to say.
Don't you agree with the MIG studies results, which has recommended metformin can be used in the pregnancy?
Yeah, I mean, again, no harm is likely to be coming from them. Whether I would feel comfortable that I'm actually doing something useful, I'm not sure. If that helps. In my experience, it's interesting you said that people are resistant to using insulin in this setting. In my experience, pregnant women would do anything for a period of time if they think it's going to be helpful for outcomes. So the concern about using insulin, I have never encountered, well, never is a strong word, but it's certainly less manifest than if you're starting a 50-year-old on insulin for the first time, if that helps.
Dr. Vela, there is another question comes most of the time before us. Sometimes a female is using glargine or any insulin and she gets pregnant without any planning. Then after 4 weeks and she knows that she has got pregnancy, and 8 weeks is the time when organogenesis is there. Is it right to switch her to some safer choice of the insulin which is recommended in the pregnancy, or we can continue with the glargine? Because from both the sides there is a harm, because I think keeping her hyperglycemic is bigger harm than switching over to the then continuing with the glargine. What is your idea with this, and what is your opinion?
I agree. I actually don't normally switch. I mean, we discussed the fact that technically they are not they have not been proven, but generally I do not switch. And I mean, modern insulins actually provide safer. I mean, it's not dramatic, but they are better at preventing hypoglycemia and allowing better glycemic control without hypoglycemia most of the time. And if somebody has become comfortable with using a particular insulin, probably that is not the time to start changing.
I have a question, Dr. Vela.
Yes.
Are there any biomarkers such as maybe serum adiponectin or vitamin D, which could be done in the first trimester and which could predict gestational diabetes in the third trimester?
Yeah, so excellent question, but unfortunately, no, there aren't. So in fact, we are contending right now, actually, that perhaps rather than doing a standard OGTT at 24 weeks or 28 weeks, perhaps if we did an OGTT at 3 months, but instead of basing our decisions on glucose, we based our decisions on beta cell function measured with the minimal model, perhaps that might be a better predictor and allow us to intervene early than just using glucose-based measures of health, so to speak, because of all the limitations associated with that. Of course, this is all hand-waving because it hasn't actually been tested. But we are proposing to do that actually in the near short term.
Another question is about the frequency of monitoring in those who are on insulin. It's pretty much clear, but then those who are diet treated gestational diabetics and are doing monitoring at home, how often should they be doing it and reporting it back to us?
Yeah, that's a great question. So so that probably needs to be individualized depending on the stage of gestation and the degree of hyperglycemia that's being observed. I certainly don't suggest that people check both fasting and 2-hour postprandial. I generally go with fasting blood sugars because those are easier to standardize. And most of the time, I think we start with 4 times a day, breakfast, lunch, supper, and bedtime. And then depending on the first 2 weeks of monitoring, we can adapt accordingly and cut back.
And continuous glucose monitoring has a role, the CGM?
Well, so I have a strange relationship with continuous glucose monitoring. So continuous glucose monitoring is probably very useful in people with type 1 diabetes and people with marked hyperglycemia. In gestational diabetes, where glucose concentrations aren't particularly abnormal, especially during the night, the incidence of false positives, false lows, and hypoglycemia alarms tends to make me discourage their usage anyway. So I don't routinely recommend it.
Right.
If that helps.
Most of the time in our country, we face a problem that gestational diabetes women, and they don't turn up after the 6 weeks after pregnancy is over. Then what do you do in your country so that they remain in touch with you, so that you may know whether they are converting to type 2 diabetes or not?
Yeah, well, so that's not a problem unique to you. I think so in actual fact, you could say, by the way, I should have said this early, that I am here under false pretenses, in the sense that I've never followed the gestational diabetes sphere all that much, but now I'm working with Dr. Egan, Aoife Egan, who worked with me for a year, and now I'm helping her develop her gestational diabetes program. And we've run a study where we specifically have been getting people back after gestational diabetes and studying them for 1 year. And in our experience, we're finding that they're okay showing up at 6 weeks. They don't come back at 6 months and 1 year. Well, they do, but it's a lot more difficult. And it's a lot more difficult because a 6-week-old baby is a lot easier to take care of than a 1-year-old, for example. I mean, that's one of the standard problems that we face when we're studying these people. But and it's interesting because there are actually abnormalities in alpha cell and beta cell function that clearly are persisting in the postpartum period. So there is data which suggests that beta cell function declines by 50% in 1 year after gestational diabetes. That's based on qualitative measures of beta cell function, like HOMA. We don't see that much of a decline, but clearly it is an active evolving problem in half of the patients with gestational diabetes. We still don't know how to define which half is the one that's accelerating or progressing and the one which isn't, or where it's resolving. But that is future work for Dr. Egan, I think.
If I may ask, what is the evidence now that we have regarding the usage of different drugs during lactation? After, if anti-diabetic medication is required during lactation, what would be the best thing to use and what is permissible?
Yeah, so sulfonylureas for sure are excreted in breast milk. Thiazolidinediones, they are lipid soluble. I would see no reason why they wouldn't be excreted. And I'm not sure I would want a baby exposed to a PPAR gamma agonist at that age, for example. Things like SGLT2 inhibitors are probably okay, although I don't think they are the right medication to be using in that setting from a pathophysiology point of view to the mother. Metformin, I think there's a lot of data and a lot of safety data in that regard. That wouldn't concern me. But again, I'm a very conservative insulin type person in these settings.
Because they would have used insulin for all of those months, and then again during lactation, which could be a good 1 year. So that would be almost 1.5 years of using insulin.
Yeah. So there's actually another interesting nuance there in terms of lactation and its effects on glycemic control. So it seems that lactation actually improves glucose effectiveness and glucose clearance, and is associated itself with improved glucose metabolism. That's another area which is of interest and deserves further study, for sure.
Dr. Anuj, you have any more questions? I don't see any in the chat box.
Have you experienced any time midnight or early morning hypoglycemia in pregnant women? Most of the time we see that pregnant women may go up to the 55 milligram per deciliter of glucose level. So have you experienced in your practice, and how do you handle these kinds of the situation?
Yeah, so we do experience it, and a lot of it is management of diabetes sometimes is actually managing the pharmacodynamics and pharmacokinetics of insulin most of the time. So those are situations where you might consider the timing of the insulin or perhaps a change in insulin. The only other complicating factor that I might bring up is CGMs. So CGMs are notorious for, at least notorious for me, because I have a significant hypoglycemia practice. So I see people with insulinomas, I see people with postprandial hypoglycemia after gastric bypass. And the kiss of death very often is that these people are given just continuous glucose monitors, and they come with asymptomatic low blood sugars during the night. Asymptomatic low blood sugars, proving that they're hypoglycemic. And there's a huge incidence of low blood sugars which are not hypoglycemia, that are detected as hypoglycemia by CGM. So that is one other diagnostic strategy to keep in mind as to whether this is true hypoglycemia or not. But obviously, understanding the timing of eating and the timing of insulin dosing is key to preventing future episodes of low blood sugars.
Can we take this message that we should not treat hypoglycemia until the patient is not symptomatic in pregnancy?
So no, That's not what I'm trying to say. What I'm trying to say is that we have to be suspicious of asymptomatic low blood sugars if that is the only manifestation of hypoglycemia when treating gestational patients with gestational diabetes. Certainly, a hypoglycemic episode an hour after eating, unless you've really overdosed on insulin, is going to be suspect upfront.
Yes.
Kind of.
Obviously, I can understand the tricky situation.
Exactly. It's these nuances. It's just the only thing I would caution is against blind acceptance of what a CGM is telling you overnight. That is perhaps the better message that I should be giving, if that helps.
Dr. Rita, do we have?
So thank you very much, Dr. Adrian Vella, for this very nice and stimulating talk on diabetes and pregnancy. Dr. Fida Bacha is having some connectivity issues. So keeping in line with the theme of special populations, we're going to have a talk from Dr. Anjali Bhatt about thyroid disease, and we will have this talk next.
Thank you for having me.
Thank you very much, Dr. Adrian Vella. It was really nice of you to be here with us.
Thank you.
So I think this is one of the curse of the technology, that even though we can get connected to people who are very far away from us, but then sometimes the technology can really be unpredictable and put you in such situations where we might have to change our plans. So till the time we keep trying to contact Dr. Fida, and if we can have her, we'll definitely have her talk right away there. But till then, keeping with the theme of pregnancy and the issues related to pregnancy, we had one of the most common problems that we are dealing with. One is diabetes in pregnancy. And let's look at the second commonest problem that we are dealing with in pregnant women, that is thyroid disorders in pregnancy. Let me just share my screen and help me if the screen is visible. Is the screen visible? Dr. Fida is here?
Yes, your screen is visible very much.
Okay. Okay. Thank you, sir, for the feedback. But I think we do have a pleasure of having Dr. Fida here back. So I think we'll go ahead with the planned session of Dr. Fida. I'll stop sharing. We can have this topic somewhere discussed sometimes later.
No problem.
Good morning.
Hi,
Good
Dr.
morning,
Fida.
Dr. Fida. Good evening from here.
Evening.
It's so good to have
Hi,
you.
greetings from Houston. How are you?
We are fine, and we're so happy we could connect to you.
Yes, absolutely. Me too. It's a pleasure to be presenting today, and thank you for this kind invitation.
Right. So over to you, Dr.
Thank you,
Anuj,
Dr. Fida, for ultimately. Yes. Dr. Fida Bacha is graduated from American University of the Beirut Faculty of Medicine in 1995. She works in Houston for as well as 5 other locations, and specialized in diabetes, endocrinology, metabolism, diabetes and metabolism, internal medicine, pediatrics, and pediatric endocrinology. She's affiliated with Texas Children's Hospital and Harris County Psychiatric Center. She will be speaking on approach to type 2 diabetes younger than 25 years. So over to Dr. Fida for this talk.
Thank you. Okay, it seems that you need to let me share my screen.
Yes, please share your screen.
Okay. Good morning, everyone, and thanks for being here. Good evening to you in India. I am pleased to be presenting today on the approach to type 2 diabetes in youth younger than 25 years of age. What's the evidence so far? We will start with talking a little bit about the epidemiology of youth diabetes, the pathophysiology, and present to you data regarding the high prevalence and rapid progression of cardiovascular disease risk factors in adolescents and young adults with diabetes. And then we'll tackle the approach to therapy with the evidence available to date. As probably has been presented in this meeting, type 2 diabetes is a major global health burden, with 463 million adults living with diabetes in 2019, 90% of whom had type 2 diabetes. An additional 374 million are living with impaired glucose tolerance, and that signifies a significant increase in risk for comorbidities in these individuals who do not know that they have diabetes. Already, the numbers of individuals with diabetes has surpassed any previous expectations. And right now, IDF, the International Diabetes Foundation, estimates that 578 million adults will be living with diabetes by 2030 and 700 million by 2045. In Southeast Asia, the picture is similarly concerning, with 1 in 11 adults having diabetes, and 1 in 5 people with diabetes in the world come from Southeast Asia, but 1 in 6 come from India. And about 1 in 4 live births are expected to be affected by hyperglycemia in pregnancy. This is particularly alarming to us in pediatrics, as it signifies significant increased risk for future comorbidities, particularly type 2 diabetes early in youth. The incidence of type 2 diabetes has been going up. This is data from the Search for Diabetes in Youth study from the US, showing about a 7.1% increase per year, with some variability according to race, ethnicity being highest in Native American and then in non-Hispanic Black youth. And not surprisingly, these latest data now from the Search study show the increased prevalence of youth type 2 diabetes between age 10 to 19 over the past 16 years, up to 0.67 per 1,000 youth in 2017. This is an absolute increase of 0.32 per 1,000 youth, with a 95.3% relative increase over 16 years. And the data are not so clear in South Asian youth. UK data that evaluated individuals between 0 and 29 years indicated no significant difference in incidence per 100,000 person years between non-Asians and South Asians. However, as you can appreciate here, type 1 diabetes was going down in South Asians, whereas type 2 diabetes was increased by 3-fold between 1990 and 2005. Recent data that compared Search to youth diabetes registry in New Delhi and Chennai regions in those less than 20 revealed that the incidence of type 2 continues to be higher across both sex and all age groups in the Search study. But what we can appreciate, there are some differences between the two registries. Research is more population related. The Indian data is more center related. And so maybe there is some ascertainment difference there. And also there was similar incidence of both females and males in India versus a greater proportion of females affected in the US data, and younger age of onset in Search. And so these data suggest that type 2 diabetes may be occurring earlier in children in the Western hemisphere, likely related to a more obesogenic environment. We will see what the future brings nowadays, with also seeing increased rates of obesity, particularly in relation to the COVID-19 pandemic. Youth type 2 diabetes is different from adult. I think we have seen a lot of data come up recently that supports this. When we were evaluating pathophysiology, and there were no direct comparisons between youth and adults until the recent restored insulin secretion study, or RISE. In our center in Pittsburgh, where I was previously, we had evaluated youth with early onset pre-diabetes, compared them to adults of similar percent body fat and hemoglobin A1C, and what we found is that youth had about 50% lower both peripheral and hepatic insulin sensitivity compared to adult of similar BMI, percent fat, and hemoglobin A1C. This was later verified recently in the RISE study, with again RISE showing about 46% lower insulin sensitivity in youth with early type 2 diabetes or prediabetes compared to adults at similar body composition, at similar BMI. And another feature of youth type 2 diabetes different from adult is that there is hypersecretion of insulin. This is data from RISE. And what you can see at every level of insulin sensitivity, the youth here in red compared to the adults in blue have a hypersecretion of insulin for their insulin sensitivity about 2-3-fold. We don't know the significance long-term of this finding, but it can indicate perhaps that there's hypersecretion may eventually lead to more rapid beta cell failure. This remains to be seen. In our studies also of type 2 diabetes use compared to obese controls of similar BMI, sex, race, ethnicity, very early on, we demonstrated type 2 diabetes youth have about 50% lower insulin sensitivity compared to their obese counterpart. We also showed that type 2 diabetes at presentation in childhood is already associated with about 50% lower insulin secretion compared to non-diabetic controls. And so when you look at the glucose disposition index, which evaluates insulin secretion for the degree of insulin resistance, youth with type 2 diabetes have about 85% lower glucose disposition index. Therefore, these youth are already presenting early in their diabetes within the first year with severe beta cell dysfunction. And therefore, when we evaluated the response to therapy in youth as part of the treatment options for type 2 diabetes in adolescents and youth, or today's study, what we can see is that when these youths were randomized to 3 treatment arms, metformin plus rosiglitazone, metformin plus lifestyle, and metformin alone. These were the agents that were available for treatment of type 2 diabetes in youth at the time of the design of the study in the early 2010, 2011. And what we saw in today is that there was a loss of glycemic control on assigned medical therapy in about 50% of these youth. Those on metformin and rosi did a bit better than those on metformin alone, with no significant difference between those on metformin plus lifestyle versus metformin. So with keeping in mind this beta cell dysfunction I talked about, this means this again adds to the picture of severity of youth diabetes, as this rapid loss and non-response to oral medications is much higher than what we see in adult studies of similar design. And what this also suggested is that about 50% may have durable control on metformin alone. The addition of another agent may be needed early on in the process. Metformin plus lifestyle did no better than metformin, unfortunately, in this group. And again, when we evaluated the data in today, compared to our use clamp data that looked longitudinally at beta cell function, what we found is there's rapid decline in beta cell function over time, with about 20% decline, whether you look at it with the clamp or with the insulinogenic index in the today's study, versus the lower progression in adults, about 7% using HOMA percent beta in the UK PDS, and about 10% per year in adopt a similarly designed study similar to today. That also verified that these youth are rapidly progressing in beta cell function deterioration. Other findings that we could gather from today is that, again, metformin can be effective in those with the type 2 diabetes less than a year duration, and about 50% responded long-term. Early addition of second agent, as I said, and we also saw some racial ethnic differences in treatment response, greater failure among non-Hispanic Black youth, and some sex differences as well. An important take-home message also from today is that when we looked at durability of glycemic control at 48 months in today, the baseline hemoglobin A1C and insulinogenic index at randomization in the study were determinants of how long someone continued to do well on metformin. And we saw that also in registry data from the Pediatric Diabetes Consortium. And what A1C level may help us predict who's going to respond. Again, looking at data from today, we saw that the ROC curve indicated that hemoglobin A1C of 6.3% after a few months on treatment, about 3 to 4 months, may be the optimal cutoff for correctly predicting who's going to lose glycemic control on metformin. Also, a rapid increase in hemoglobin A1C by about 0.5 over any period of time, also concerning for loss of glycemic control on metformin. So therefore, if your patient is not reaching this kind of reduction in hemoglobin A1C early on in their course, then you have to intensify lifestyle, intensify your metformin dose, and consider additional therapy until we meet A1C targets. We also learned from today that these youth have a high prevalence of cardiovascular comorbidities, with hypertension increasing from 11% at prevalence at randomization up to about a third having hypertension by the end of the study over 3.9 years of follow-up. We saw a microalbuminuria again tripled. Dyslipidemia doubled in these youth, despite that we initiated adjunct therapies to treat these comorbidities, and we saw at the end of the study about 13.7% had started developing retinopathy. And this is the most recent data that we just published from the Today study, looking at long-term follow-up. After Today was terminated, we started an observational period and continue following these youth until mean age of 26 years, so early adulthood. And as you can see here, by that time, the cumulative incidence of hypertension was 67.5%, kidney disease 54%, dyslipidemia in 50%, and nerve disease in about a third. And about 60% of these youth had at least one comorbidities, a third had two. And by follow-up 9 years into their follow-up, the cumulative incidence of any microvascular disease was about 50%. It rose to 80% by 15 years. So factors that were driving microvascular complications included race, ethnic minority, an increase in hemoglobin A1C, low insulin sensitivity, hypertension, and dyslipidemia in models adjusted for sex, race, and age at randomization. And we also know from other studies as well that in early diabetes diagnosed in young adulthood, between 18 to 44 years of age, versus older than 45, is associated with significantly higher risk for macrovascular complications compared to the general population. And when you look at the MI risk, about 14-fold higher risk of MI for those diagnosed in younger age compared to about 4-fold higher risk of MI in those diagnosed greater than 45 when in comparison to the non-diabetic population. And mortality is impacted by the age of diagnosis with greater mortality and lower expected mean survival in type 2s of young onset versus non-diabetic controls. Hemoglobin A1C is a major driver for complications, as we all know. So that comes as no surprise, and this has been shown in various populations. However, control of cardiovascular disease risk factors has a significant impact on lowering the risk of cardiovascular events in these intensive glucose lowering trials. So we should not forget about addressing this other need of control of cardiovascular disease risk factor in individuals with diabetes. How about youth type 2 diabetes therapy? What do we have available right now? The challenges, as I mentioned already to you, is that we have to address both insulin resistance and the beta cell dysfunction. And we may have to choose different agents for early onset versus most prolonged duration because of loss of beta cell function. And we have to keep in mind other racial, ethnic differences, sex differences, the TBT profile, and issues with adherence in youth and young adults. The goals is we need to achieve glycemic control, but also avoid excessive weight gain in these overweight and obese youth usually, avoid hypoglycemia, have a long-term favorable CVD outcome, and for young individuals who are usually, typically they have a hard time with maintaining control in this age group, issues of adherence and cost are major as well. So type 2 diabetes therapy needs to be individualized. A glycemic target of less than 7% is reasonable. Diet, exercise, and diabetes education are foundation of the therapy. Metformin continues to be the first-line agent, and insulin may be required to maintain glycemic control. And so keep that in mind very early on. Consider combination therapy and balance the benefit versus the side effects. And we also need to always consider CVD reduction as a focus of our treatment. So metformin, the older drugs that have been available, and until recently only metformin and insulin were approved for type 2 diabetes therapy in individuals younger than 18. Metformin decreased hepatic glucose production, increased muscle glucose uptake. It decreased A1C by about 1 to 2% and had a modest weight reduction effect. We have to be cautious about mild side effects of GI intolerance, and usually adjusting those helps with that. The sialolidine-diones, gamma agonists, have been utilized in adults. Mostly we used ROSI in the Today study, and they have significant effect to improve adipogenesis with healthier fat, increase insulin sensitivity, and decrease inflammation. However, they're associated with weight gain, slow onset of action about 2 to 4 months, and fluid retention, edema, risk of fracture long-term, and potential risk of heart failure. So they're not very favorable, and typically we are not recommending them routinely for use in the young population, but that can be individualized. Sulfonylureas have been around for a long time. They lower A1C by 1 to 2%. They have direct action on the pancreatic beta cell, KIR6.2 SIRT1 receptor. However, their effectiveness decreases over time, and they may promote loss of beta cell function. There's increased risk of hypoglycemia and weight gain. In youth, one study did not show a benefit compared to metformin, and therefore we do not recommend sulfonylurea in young population. I should say in less than 18. Insulin should be considered, but has a very favorable effect, as you all know. However, the side effects are hypoglycemia and weight gain, and need for monitoring blood sugars. And therefore, we were very happy that the newer agents came along. So in the past several years now, between 1995 and 2010, about 8 new classes of agents became available, and that has advanced therapy significantly in the adult population, with change in our recommendations for initiating a second agent, whether it comes from the ADA or other major national institutions. And I will not go over the details, but for oral agents, we have DPP4 inhibitors, bile acid sequestrants, dopamine 2 agonists, and SGLT2 inhibitors. And some of these will be discussed in a little more detail. And for injectables that are non-insulin injectable, we have now the glucagon-like peptide receptor 1 agonist and amylin mimetics. In addition, there's a new oral GLP-1 receptor agonist, semaglutide. Moreover, we are having more newer combination therapies that seem to be very promising. Incretin-based therapy, GLP-1 receptor agonist mimic the endogenous GLP-1. They have effects to increase insulin production in the pancreas, decrease glucagon. They increase, they slow down gastric emptying and increase satiety and body weight, reduce body weight through central mechanism. And overall, they would reduce hyperglycemia this way. The dipeptidase 4 inhibitors inhibit the enzyme that DPP4 that degrades GLP-1 in the circulation and therefore prolong the action of endogenous GLP-1. These medications have shown in several trials that they are very effective for reducing hemoglobin A1C, more so GLP-1 receptors versus DPP4 inhibitors. They reduce blood pressure, have positive effect in reducing triglycerides and LDL cholesterol, increasing HDL. Again, a little more effectiveness seen for the GLP-1 receptors, which are also associated with greater weight loss, about 3 to 4 kilograms, whereas the effect of the DPP4 on weight loss is not that marked. And however, we see an increase in heart rate with the GLP-1 receptor agonist. So these have one of the GLP-1 receptor agonists, liraglutide, became approved for pediatric use by the FDA within the past year. And the approval came after the ELLIPSE trial was done in young individuals average age of 14, 60% are females, significantly obese. Most of them were early in their diabetes, so with a mean duration of 1.9, about 20% were on insulin at randomization in the study. And what ELLIPSE showed is that there was a mean change from baseline of hemoglobin A1C of minus 0.64 at 26 weeks, when the primary outcome was defined, and continued about minus 0.5 at 52 weeks, whereas there is increase in hemoglobin A1C in the placebo group. And therefore, the estimated treatment difference was minus 1.06%, favoring liraglutide. There was some weight loss with the liraglutide, although it did not reach statistical significance. And now we have another agent approved for younger than 18, the exenatide once weekly. Again, a recent study, phase 3, was completed, showing that children in the treatment arm had significantly larger mean change in hemoglobin A1C with decrease of minus 0.25% versus increase of 0.45% in the placebo. And this led to approval of this agent in the past few months. So now a lot of drugs, particularly the sodium glucose cotransporter inhibitors, are heavily utilized in adults, and they have shown very promising results. In children, we are undertaking clinical trials, and so we don't have the results yet for these agents. Therefore, we still are not routinely utilizing them, although you can individualize the therapy, particularly in those that are older than 18, in which these agents are approved. problem with these agents is that they have some side effects of osmotic diuresis, increased genital mycotic infections, and the risk of DKA if there is insulin deficiency. However, they're effective for weight loss and have cardiovascular and renal benefits. So they may be favored for those who have early nephropathy or early or high risk for cardiovascular disease. So these agents have shown safety in major trials that looked at cardiovascular event reduction in adults. So we are more reassured about their use in kids and young adults. And therefore, this brings us to how do we approach right now the youth and the young adult with type 2 diabetes. First, we start at the beginning, when they are presenting to us with new onset diabetes. These were our guidelines from 2018, and a lot has changed since then. But our approach was to recommend that if hemoglobin A1C is less than 8.5% at presentation, we can start lifestyle modifications and start metformin POBID and intensify. If hemoglobin A1C presentation is greater than 8.5%, but no acidosis or ketosis, again, we can consider starting insulin and then escalate depending on response. Metformin should be started and titrated up to 2,000 milligrams. However, if someone presents in acidosis or ketosis, manage the DKA IV insulin until the ketosis acidosis resolves, and then subcutaneous insulin. At presentation, we are recommending pancreatic autoantibodies be checked because we don't want to miss someone with early onset type 1 diabetes brought with an accelerated presentation because of obesity. And therefore, if the antibodies are positive, we continue using insulin. If negative, then continue metformin. Try to wean insulin. If the A1C goal is met, great. If not, consider starting insulin. And now with the GLP-1 receptor agonist being approved, I think it's an option to try these even before insulin. And that's how we are now changing our clinical management. And then always consider other therapies and maybe add a second agent depending on response. So our aim is to rapidly intensify anti-hyperglycemic therapy to maintain glucose targets and individualize based on patient preference, their response to treatment, side effects, tolerability. And keep in mind that insulin may be eventually necessary for many patients. And if they go on insulin, we need to monitor blood glucose. And now we are being able to introduce continuous glucose monitoring for those on multiple daily injections. Address cardiovascular risk and comorbidities by treating these comorbidities according to best recommendations. We use ACE inhibitors, ARBs for nephropathy, treat dyslipidemia for target LDL less than 100, triglycerides less than 50, address hypertension, particularly it's a big risk factor for cardiovascular disease, as has been shown in many studies in adults, address non-alcoholic fatty liver disease, polycystic ovary syndrome, and sleep apnea, which are also more common in this population. New agents have definitely started to address the unmet need for better glycemic control in youth, because we have seen, again, in registry data and today, that over time, there is poor responsiveness to usual agents, and hemoglobin A1C continues to be high, about 9% or more in individuals that are started on insulin. So these new agents are very promising, and we hope that will change the trajectory of that we have witnessed for type 2 diabetes and address early vascular abnormalities. So I will skip this. We have covered it. In conclusion, youth type 2 diabetes has important unique features with rapid onset and progression of beta cell dysfunction, high prevalence of comorbidities, and often challenging socioeconomic features that we didn't cover today. Multidisciplinary management is essential, And we are very excited about changing the course of this disease with the newer agents and continuing to learn more about diabetes in youth. Thank you for your attention.
Thank you, Dr. Fida, for the wonderful presentations, and we really enjoyed that. As we think about adolescent type 2 diabetes, it is a long-term planning for to live with the diabetes. Is it really safe and good to start with the metformin in adolescent type 2 diabetes, or we should try something else also?
I think we have seen that the metformin is well tolerated. It has a good long-term safety record. In the Today study, we have not encountered major side effects from metformin, really. So I think it's safe to say that it should continue being a first-line agent, and then add newer agents as they become more available and we have more data in use.
What is your opinion about thiazolidine-diane?
Again, because of the concern for increased risk of fractures in adults, because it's associated with increased weight gain and with a possible increase in heart failure in adults, it has not been popular to use it in youth, despite that we saw a little greater effect in the rosiglitazone arm in Today. So therefore, we're not routinely recommending it. Some, in older adults, maybe some people are using pioglitazone, particularly for fatty liver disease. I mean, that remains an option in that population. They're good medications, except we're concerned about side effects, particularly for bone health and heart-related concerns. So we're not routinely recommending in younger than 18. Although I have to say, in the Today study where we did echocardiography, we did not see echocardiographic changes in relationship to the rosiglitazone, but we did see some, maybe possibly lower bone mineral density, and this is being evaluated more.
I have a question.
Sure.
So if a youth onset diabetic becomes pregnant and is an oral drug already, what would you like to do now?
Yeah, great question. We did have young people in Today who got pregnant, and we actually had about 3 or 6 pregnancies in Today. And we intensified treatment. We refer them to high-risk OBGYN. Metformin is now more acceptable to use in pregnancy, with with some concern about for the fetus. But typically, we want to intensify treatment in pregnancy and use insulin. Unfortunately, I have to say, our young mothers in Today had a high risk of complications in their babies, despite receiving very intensive treatment. And I will tell you, there was a greater increase of preterm deliveries, about 23%, compared to reference population of 6.9 to 9.9%. There was increase of SGA, LGA. There was also a problem with the infant at birth with increased hypoglycemia, and about a third. We have the increased cardiac anomalies in these babies. About 8.5% had a cardiac anomaly, compared to a reference population usually is about 1%. And about 12% had other congenital anomalies, again, much higher than reference populations, like around 3%. So it is a major concern. We should advocate really for good glycemic control for these young mothers to prevent complication both for the baby, but also for the mother, because when we saw these mothers back in Today after delivery, those who had gotten pregnant had significant increase in nephropathy compared to those who did not have pregnancies in Today. So also they had higher risk of higher prevalence of hypertension and dyslipidemia. Therefore, we need to do more for sure. And this is a very high risk situation.
Thank
May
you.
I ask a question here?
Sure.
Right. So you very elaborately, very elaborately, you spoke about the different anti-diabetic diabetic drugs to be used. I would like you to share your thoughts on what is the approach to manage the comorbidities like hypertension and dyslipidemia. Is the choice of drugs similar to adults? We don't have much of evidence on these things because most of the evidence is beyond 40 years. And so
very true. So given that we are seeing in these youth early vascular dysfunction with increased vascular stiffness that I didn't have time to cover today, we're seeing some echocardiographic changes that suggest early diastolic dysfunction and increased rate of heart failure in the future. We are also, seeing that these comorbidities increase significantly over time, and we are still trying to understand what causes these increased rates. And therefore, we are recommending aggressive control of comorbidities. We start statins, and we did start statins actually today, and despite that, we saw progression of dyslipidemia and vascular stiffness. So we start statins with a goal LDL less than 100, similar to what we do for type 1 diabetes. We may start also fibrates to control triglycerides to less than 150, in addition to diet, exercise, etc. For microalbuminuria and elevated blood pressure, we recommend ACE inhibitors or ARBs, first-line agent. You can add calcium channel blocker, beta blocker, or what have you, to get to good blood pressure control. These are very important risk factors to cardiovascular disease that we need to control in addition to hemoglobin A1C. So yes, we really are advocating therapy. And I didn't mention about, and today, by the end of the study, when these in young adulthood, and these kids who were diagnosed like average age 13, 14, we saw already 4 MIs, 1 stroke, some individuals with congestive heart failure, and renal failure. So those, we had 17 events in this very young population. So we're really pushing for better management of all cardiovascular comorbidities.
That's quite unfortunate.
Yes.
So doctor, if you had a choice, a youth would choose type 1 over type 2? As far as
both diseases are very taxing, chronic diseases. There's really no way to choose. I would say though, in directly comparing type 2s versus type 1s at about a similar duration of diabetes, and despite somewhat lower hemoglobin A1C in type 2s, some national data from various places have shown that there is more cardiovascular comorbidity and more concern for poor outcomes in type 2, including these differences in mortality that I've shown. So we need to learn more about what drives this in type 2 versus type 1. And we need, intensification of management in both diseases.
Thank you so much.
Thank you for the question. Thank you.
One more question is there on iPhone? No?
For how long do we need to stop these medications, which includes oral antihyperglycemic agents, statins, and ARBs and ACs, before we plan the pregnancy and then put them on alternatives?
Great question, and I do not have a good answer for this. Often they become pregnant while they're on treatment. There's no clear indication to stop the metformin before pregnancy, and we need to manage, their comorbidities during pregnancy. So what we do is refer them to high-risk OB, where OBGYN care, where they're really monitored and the baby's health is assessed longitudinally, aiming at really tight control during pregnancy. And despite that, we see all these problems with the children already. So,
but if you had a choice, how long?
I wouldn't stop the metformin. I would really not. Like if someone is only on metformin and there is not a good indication now, there There may be some concern for the baby in recent studies, but it has not been confirmed. Insulin has been around for a long time, and it is safe in pregnancy, and these mothers may be motivated for their child to really achieve good control and support them doing that. More CGM is being used in pregnancy as well to get to appetite control, and a treatment of high blood pressure, etc. We haven't seen increased rate of preeclampsia in today pregnant young females, but that also could be a concern in these individuals.
Can I ask a question? How long do you continue metformin? Do you do it the entire duration of pregnancy, or do you give it only in first trimester? Because of the results, that's been rather controversial about adiposities later and all those things. So
yes,
while the first 3 months are very clear, do you continue them in the second and third trimesters?
we do not manage the pregnant female. They're managed by their OB. I favor using insulin. And however, as I said, many of those individuals have not planned their pregnancy, right? So we may have a lot of them being on metformin throughout their first trimester, but I do agree it seems safer to do insulin, particularly in the first trimester.
Dr. Pida, we are approaching to the time limit, and now we'll have to wrap up. And thanks again for the wonderful talk and illuminating ideas about the management even in pregnancy as well as in adolescent type 2 diabetes. Now over to Neeta Deshpande.
Thank you so much.
Thank you. Thank you.
Thank you so much, Dr. Vacha. And that was indeed a wonderful session. And I thank Dr. Anuj Maheshwari for so beautifully navigating through both the talks. And now we will move on to the next session. And for this, we have two stalwarts as our chairpersons, nationally known in the field of diabetes, endocrinology, and obesity. We have Dr. Brij Makkar with us. He actually needs no introduction, but I would like to formally introduce him to this forum. Right. And we also have Dr. Krishna Sheshadri with us to chair this very important session. So Dr. Krishna Sheshadri is a senior consultant endocrinologist and diabetologist. He is American board certified in endocrinology and diabetes management, and he specializes in type 1, type 2 endocrine disorders, thyroid disorders, and hormonal disorders. He is at Chennai. And we also have with us, as I said, Dr. Brij Makkar. He is a diabetes expert, and he is also an obesity specialist and has got very good experience, great data. He has worked a lot for the RSSDI and also has several presentations and publications to his credit. Over to Dr. Krishna and Dr. Makkar for chairing this session.
Good evening, Neeta. Thank you for having us here. And can we have Dr. Tuttle's Tuttle. Okay. So Dr. Tuttle is a professor of medicine in the nephrology division of the University of Washington, an executive director for research at Providence Healthcare, and co-principal investigator of the Institution of Translational Health Sciences. She's an investigator in the Kidney Research Institute and oversees interests of the 5-state WWAMI region to the ITHs. She also directs the Northwest Participant Clinical Interactions. Her major research is in the area of clinical and translational science and precise medicine strategies to tackle diabetic kidney disease, chronic kidney disease, diabetes, and hypertension. Dr. Tuttle, this is all yours.
Hello, everyone. Let me share my screen. Just want to check and make sure that you can see my screen.
Yes, we can.
Dr. Tuttle, you're good. We can see you and see your screen and hear you. Thank you.
Good. Okay. Well, thank you. It's really a pleasure to be joining you from across the world this morning to talk to you about this very important problem of diabetic kidney disease, but where we certainly do have challenges, but we've had major progress, and I think there are possibilities to greatly improve lives as a result of this progress. These are my disclosures. They're all related to therapeutics for diabetes and kidney disease. Most are research grants and other support paid to my institution. So my objectives today will be to discuss the current approaches for chronic kidney disease and diabetes, to recognize use of newer therapeutic agents for chronic kidney disease based on the recent trials, and then to discuss advancing therapeutics in chronic kidney disease by more precise phenotyping. So I'm going to start with a centering point about the other pandemic, which is the pandemic of diabetes, well known to this audience and of course the topic of the entire meeting. But when we look at the worldwide burden, in 2019, we estimated there are 463 million people living with diabetes. But unfortunately, by 2045, this number is only going to grow substantially to some 700 million. And in the regions here, mostly south of the equator in the green box, all will incur more than a 50% increase. And in some regions, such as sub-Saharan Africa, more than 100%. And even here in India, it's projected to increase 74%. So while our aspirational goal is to prevent and cure diabetes, the reality is that for the foreseeable future, and really for our lifetimes, we are going to be taking care of more and more people living with diabetes. Living with diabetes means living with diabetic complications, and I'd like to make the case that diabetic kidney disease is one of the most serious matters. It's still very common in both type 1 and type 2 diabetes, about 30% in type 1 and 40% in type 2. And diabetes is now responsible for half of all cases of chronic kidney disease and kidney failure or end-stage kidney disease worldwide. But what we know is that the prevalence in the end-stage kidney disease population is more than half. It's 66 to 86%, depending on age and race. And this is largely related to the fact that people with kidney failure or end-stage kidney disease may have a different form of kidney disease and also have diabetes. But especially in the transplant population, we give people post-transplant diabetes by medications such as glucocorticoids and calcineurin inhibitors. And even from the standpoint of cardiovascular risk reduction, chronic kidney disease is a major amplifier of CVD risk. And in fact, almost all of the excess diabetes-associated cardiovascular risk occurs in those with albuminuria, low GFR, or both. So this is a very important group to target for cardiovascular risk reduction strategies. Speaking of risks, it's also worthy to spend a few moments thinking about what are the risks of diabetic kidney disease, also known as CKD and diabetes. Well, truthfully, only 10% progress to kidney failure or end-stage kidney disease. But that's not because they're healthy. It's because they're dying of other causes without reaching kidney failure. About half the deaths are cardiovascular, both atherosclerotic events and heart failure events. But the second leading cause is infection, historically pneumonia and sepsis. And with the current pandemic of COVID-19, where people with diabetes and kidney disease are even more susceptible to the infection and severe complications, one can only imagine the potential impact on mortality in this population. So now that we've rung the alarm bell about the seriousness of the problem, what can we do about it? Well, until recently, the only agents specifically indicated for the treatment of kidney disease and diabetes were the renin-angiotensin system inhibitors. These were the last two trials until recently shown to reduce risk of progression to kidney failure. And these were the ARB trials of losartan in renal and irbesartan in ID&T. And while these were celebrated at the time, notice that the relative risk reductions were modest, some 16% in losartan with losartan and 20% with irbesartan. And although these curves are drawn on slightly different scales, the absolute residual risk at 48 months was exactly the same in both trials, some 40%. So we had enormous residual risk. Moreover, at least in the United States, we haven't done a very good job of even applying these therapies. This is real-world data from two large U.S. healthcare systems, the Providence healthcare system where I work and UCLA Health, showing that over time, since those trials were published, there was an uptick in the use of ACE inhibitors and angiotensin receptor blockers. But overall in the CKD population, it was still only 15%. And if we look at the population who also had diabetes and hypertension, perhaps the hardest indication to use these agents, we still only use them in 25% of patients. At the same time, we were increasing our use of proton pump inhibitors and nonsteroidal anti-inflammatory drugs, potential nephrotoxins. And in fact, in the most recent time period through 2017, a third of people were getting a potential nephrotoxin, and only 25% or less were getting kidney protective agents. So it's really no wonder that the outcomes in this population have been so poor. We've had modestly effective therapies, we're underutilizing them, and at the same time, we're doing harmful things. Now, the lack of progress in terms of new therapies in this area has really not been for lack of trying. This is a representative, but certainly not all-inclusive list of many agents that have been under study for diabetic kidney disease, along with the current status. And while some completed without delivering new therapies, this was not always due to clinical or scientific reasons. In some cases, they were business and regulatory decisions where a sponsor simply walked away from an effective therapy because they decided that they weren't going to invest in that area, which is unfortunate. But in recent years, we've really had some major breakthroughs, particularly the new anti-hyperglycemic agents, endothelin receptor antagonists, and finerenone. And today I will be talking about the topics in the purple boxes. With regard to SGLT2, I'm only going to give a very brief introduction because that'll be the topic of the next presentation. But just to give a preview of how we got to these agents, it really came from the cardiovascular outcome trials that were mandated by the US FDA to show safety of these agents after approval for glucose lowering. And not only have these agents been shown to be safe, they've been shown to be very effective to reduce major adverse cardiovascular events, both heart failure and atherosclerotic events. And two agents in the class, empagliflozin in the EMPA-REG trial and dapagliflozin in the DAPA heart failure trial, reduced cardiovascular death. But importantly, the major secondary outcomes were kidney disease outcomes. And across the class, they also have reduced risk of albuminuria, GFR decline, and kidney failure. And I do want to emphasize that both the kidney and the cardiovascular benefits are present in this very high-risk population of patients with type 2 diabetes and CKD. And you'll hear much more about this in the next presentation. But this is just a sneak preview because this really is the major class that has delivered in terms of improving outcomes. But the other major class are the GLP-1 receptor agonists that were studied in exactly the same way. And similar to the SGLT2s, they've been shown to not only be safe, but to reduce atherosclerotic disease risk. And two agents in the class, liraglutide in LEADER and semaglutide in PIONEER 6, were shown to reduce cardiovascular death. But again, the major secondary outcomes were kidney disease outcomes. And across the board, in the cardiovascular outcome trials, these agents decreased macroalbuminuria as well as GFR decline. And uniquely in this class of agents, they've been studied in patients with very low GFR, with dulaglutide down to a GFR of 15, and the kidney benefits to preserve function are present even in advanced CKD. So this is very important because we do need treatments not only for glucose lowering, but preservation of kidney function, even in patients with advanced kidney disease. And again, both the cardiovascular and kidney benefits are present even in this high-risk population of people with type 2 diabetes and CKD. This is from a meta-analysis of the CV outcome trials that was recently published, showing the composite kidney outcome, including albuminuria. And without albuminuria, it's slightly less. But remember, selecting patients for cardiovascular risk selects a population who have either no kidney disease or early stage kidney disease. So the outcome we can detect in the early time period of the trials is really reduction in albuminuria. And this has now been replicated in the Amplitude-O study, another GLP-1. And actually just this week, in fact, I think yesterday, a new meta-analysis came out adding Amplitude and basically just further reinforced the data here and did not change the risk estimates. But this trial, Award 7, was conducted in patients with the lowest GFR to date. Note that the mean GFR in the patients in Award 7 was just 35. And this was a glycemic lowering study comparing insulin to a higher or lower dose dulaglutide, but the major secondary outcome was kidney disease outcomes. And you can see that in the insulin-treated group, there was an expected decline in GFR over 1 year, as we would expect in this type of population, but GFR stabilized in the 2 dulaglutide groups. And these are just the data shown at 26 and 52 weeks as bar graphs. Expected significant loss of kidney function in the insulin-treated group, but this was essentially abrogated in either dose of dulaglutide, with either dose of dulaglutide, such that there was no significant decline over 1 year and highly significant between group differences between insulin and either dose of dulaglutide. A major exploratory but pre-specified outcome were kidney disease endpoints, such as those we would use in a kidney disease outcomes trial, 40% GFR decline, or kidney failure requiring dialysis or transplantation. As you can see, these risks overall were reduced by more than half. And in the group that had macroalbuminuria, which was about half of the patients, in a time to event analysis, the hazards ratio was 0.25, so a risk reduction of 75%. How might this be happening? We think these work quite differently than the SGLT2 inhibitors. GLP-1 receptor agonists bind the GLP-1 receptor with high affinity. And outside of the pancreas, particularly in the kidney, there are anti-inflammatory effects mediated through an increase in intracellular cyclic AMP that blocks oxidative stress, apoptotic signaling, as well as pro-inflammatory and pro-fibrotic transcription. And GLP-1 receptors are present on intrinsic kidney cells, consistently in the endothelium and variably in proximal tubular cells. But remember that not all cells in the kidney are intrinsic cells. There's quite a profound inflammatory infiltrate, particularly in the tubular interstitium, represented in this cartoon here from a paper in Nature Reviews. And these infiltrating cells also contain GLP-1 receptors and really drive the inflammatory response. So in preclinical models, when we give a GLP-1 receptor agonist, this inflammatory infiltrate is markedly reduced, along with a reduction in the number of immune cells. So we think that in addition to glycemic lowering, that these agents act by an anti-inflammatory mechanism. These data from the cardiovascular outcome trials, Award 7, and the preclinical data provided the rationale for the first dedicated kidney disease outcomes trial called FLOW, which is now testing semaglutide versus placebo in a classic population with type 2 diabetes and CKD on the background of an ACE inhibitor or an ARB. And despite COVID-19, we fully enrolled this trial on time at the end of March. Retention is excellent, and we're expected to go at least another 2 to 3 years with this trial. So stay tuned, and this will hopefully show us whether or not a GLP-1 will specifically and intentionally reduce kidney disease outcomes in this population. So with regard to the new glucose-lowering agents, I mentioned at the beginning of the talk, in the real world, the uptake of ACE inhibitors and ARBs has been low. This paper was just published several weeks ago online in Diabetes Care, looking at the newer glucose-lowering agents, SGLT2s, represented in yellow and GLP-1s in orange, in relation to when these cardiovascular outcome and kidney disease trials were published. And as you can see, by 2019, as the evidence was accumulating and guidelines were beginning to recommend these agents for heart and kidney protection independent of glycemic lowering, we did see an uptick, but as recently as the first quarter of last year, it's still less than 15% overall. So I want to bring that out because if patients are to receive the benefits of ACEs, ARBs, SGLT2s, or GLP-1s, we really do need to focus on dissemination and implementation because they'll only benefit if they're able to receive the therapies. Now, stumbling on the newer glucose-lowering agents for heart and kidney protection reminds me a bit of this Jackson Pollock painting from 1952 that he titled Convergence. It's beautiful in its own right, but it's really rather non-directional, and we cannot depend on serendipity to keep discovering new agents that are so highly protective of the heart and the kidney, especially when there still remains residual risk. So as I mentioned in the context of the GLP-1s, inflammation and fibrosis is really a very important target. And the previous agents that we've had, such as ACEs or ARBs, lower blood pressure and interglomerular pressure. SGLT2s and GLP-1s are anti-hyperglycemic agents that have some off-target effects, but we really have not yet had agents that specifically target this most important process that drives a number of the mechanisms of kidney injury, both in the tubular interstitium and the glomerulus, that culminate in progression of CKD and kidney failure. So in this conceptual model from one of our papers, we illustrate the importance of inflammation, and it's particularly important in the tubular interstitial compartment. And as I mentioned, in addition to resident cells such as dendritic cells and myofibroblasts, there also are immune cells that invade the kidney, particularly macrophages and gut-derived T lymphocytes. And it turns out that the mineralocorticoid receptor is actually a very potent pro-inflammatory receptor. So when one of its ligands, aldosterone or cortisol, engages this receptor, it transits to the nucleus where it promotes transcription of a number of inflammatory and fibrotic mediators. This occurs to some extent in the glomerulus in both intrinsic cells such as podocytes and mesangial cells, but importantly in invaders, monocytes that become tissue-based macrophages, and again, importantly in the tubular interstitium where macrophages and fibroblasts are activated to produce inflammation and fibrosis. And it turns out that these are very profound effects in the kidney, as much or more so than homeostatic regulation of sodium and potassium transport in the distal nephron. So with regard to this target, one of the newest agents is a non-steroidal mineralocorticoid antagonist called finerenone. And it turns out that finerenone has very high affinity for the mineralocorticoid receptor and has potent effects to block inflammation and fibrosis, but interestingly enough, less effects on electrolyte transport. So we conceptualize this as being an anti-inflammatory therapy and it has lower risk than conventional mineralocorticoid antagonists to produce hyperkalemia because it doesn't have as much effect on electrolyte transport as it does on gene transcription. So that's the background. But importantly, in the Fidelio trial, which tested finerenone 10 or 20 milligrams versus placebo in type 2 diabetes and CKD on top of an ACE or an ARB, we see a reduced risk of the primary outcome, which was a kidney disease outcome, as well as the secondary cardiovascular outcome. But just last week at the European Society of Cardiology, the companion trial was presented. And this was Figaro, also done in a population with type 2 diabetes and CKD, but most of them had microalbuminuria and preserved GFR, so not as advanced with kidney disease. So in this case, the primary and secondary outcomes were flipped, such that the primary outcome was cardiovascular, and again, significant benefit, almost exactly the same effect size as in Fidelio. And then for the composite kidney disease outcome, which was secondary in Figaro, also a benefit. It has not yet been published, but they also presented Fidelity, which was a meta-analysis of Figaro and Fidelio together. And again, the risk estimates were almost exactly the same together, but there were some 13,000 patients followed for a median of 3 years. CV endpoint, hazards ratio 0.86, so about 14% risk reduction. But note that in the meta-analysis together, the kidney disease endpoint hazards ratio was 0.77, so an even larger reduction in risk, some 23%. Hyperkalemia was more common, with finerenone occurring in about 14% versus 7% in placebo, but this was manageable in most of the patients who stayed in the trial. The KDIGO guidelines in nephrology are our international guidelines that are evidence-based. Last year, not quite a year ago, the diabetes and CKD guideline was published based on the SGLT2 inhibitor data. And the main recommendation is represented here as a pyramid that all people with type 2 diabetes and CKD should have, if you will, a base of good risk factor management and healthy lifestyle. And most patients should have either an ACE or an ARB, as well as an SGLT2 inhibitor. And we would now make the case, based on the emerging data from the finerenone trials that an MRA should also be part of this regimen, and that a GLP-1 receptor agonist, even from the standpoint of glucose lowering and cardiovascular risk reduction in this population, is also useful in most patients. And we'll learn from FLOW whether or not it also reduces risk of kidney disease. And although we said some patients, I would argue that most patients also should have antiplatelet therapies to reduce the very high risk of atherosclerotic CVD. And now that we have this menu of therapies, we can think about how we apply them strategically in a patient. So this is just a case of a patient from our center where I think he represents how we personalize now care for type 2 diabetes and atherosclerotic CVD. So he's a 42-year-old indigenous man. He has type 2 diabetes diagnosed at a young age, 15 years, and he was referred to nephrology for advanced CKD. He has the classic full house of risk factors. He's on an ACE inhibitor, calcium channel blocker, statin, metformin, and insulin glargine. His blood pressure is a bit high. He's overweight. And although his GFR is quite low at 23, his potassium is still acceptable. He has macroalbuminuria. He's got an A1C that's high. Lipids is shown here, reasonable but not ideal. And he is known to have coronary calcification based on an incidental finding from a chest CT. So here, for example, based on award 7, we would pivot to a long-acting GLP-1 receptor agonist, dulaglutide, for glycemic control, but also for cardiovascular risk reduction. Of course, we're going to stop the metformin because his GFR is too low, and we no longer need the insulin glargine because dulaglutide substitutes his basal therapy. We need to get his blood pressure down by intensifying his antihypertensive therapy. We should add aspirin and provide high-intensity statin. And again, as always, counsel about increasing physical activity, nutrition, and weight management. And I would make the case that the GLP-1 will also help with managing weight. So finally, the last class I'll talk about just briefly are the endothelin receptor antagonists. And again, there is biological plausibility across hemodynamic, anti-inflammatory, and direct anti-fibrotic mechanisms in kidney cells. Another approach to more precise phenotyping was conducted in the SONAR trial of atrasentan. And after patients were stabilized on a renin-angiotensin system inhibitor during the run-in period, all of them were exposed open label to atrasentan for 6 weeks. And this was to screen for both safety and efficacy. This class had been limited in therapeutic development due to heart failure events. So they screened out people who had more than 3 kilos weight gain or a BNP above 300 picogram per ml because they were deemed to be at risk of developing heart failure and not safe to continue. They measured their efficacy outcome as an early 30% reduction in albuminuria after 6 weeks, but they randomized both the non-responders and responders to atrasentan. This study was presented and published on exactly the same day as Credence in 2019 at the World Congress of Nephrology. Credence published in the New England Journal and SONAR in Lancet. And even though SONAR has received less attention, note that the hazards ratio is very similar to that in Credence. And interestingly enough, there was no interaction in treatment response between responders and non-responders based on that early reduction in albuminuria. So in terms of precision phenotyping, SONAR delivered in avoiding heart failure events in a high-risk population, but it turned out that early albuminuria reduction was not a good marker of response. So basically, irrespective of the early albuminuria response, all of these individuals benefited. And so this suggests that endothelin may be acting via pathways that aren't necessarily represented in albuminuria reduction. So we need even better risk markers going forward. And the good news is that this is now being resurrected into therapeutic development. And in fact, in SONAR, we had the opportunity to look at the combination of SGLT2 inhibitors with an endothelin receptor antagonist because there was drop-in use. And in fact, in those who received both, there was a reduction in body weight compared to an increase with endothelin antagonism alone. And there was an even greater reduction in albuminuria over time, suggesting more clinical benefit. So with combination therapy, we propose that not only would we get more therapeutic efficacy in terms of kidney protection, but we could mitigate the risk of applying the endothelin receptor antagonist because the SGLT2 provided some diuretic effect and would protect from the risk of heart failure. So I'll wrap up by saying our standard of care for diabetic kidney disease has been an ACE or an ARB, but unfortunately these agents are underutilized in clinical practice. And this is something we really need to address if we want patients to benefit from the new agents such as SGLT2s, which you'll hear about in the next talk. But GLP-1s and non-steroidal mineralocorticoid antagonists are really poised to also deliver remarkable benefits. And with more precise phenotyping, we now, even with just based on clinical criteria, can improve patient selection for both efficacy and safety of the new agents. So thank you very much.
Thank you, Dr. Tuttle. We have a few minutes for questions. We'll wait for some on the chat box, but can I start off by asking, so in someone with declining EGFR,
Krishna, we have a panel after Dr.
After
Supra's
that, we can
class.
do that?
Yeah, together we can do the questions then.
That's what okay. So we can wait. Dr. Tuttle, you're okay with that?
That's just fine. I'm looking forward to the next talk.
Okay, perfect.
Dr. Tuttle, you have to stop sharing.
Rich, you want to introduce Sundar or Sundar there?
Yes, I'm here.
Dr. Makar, you have to unmute.
Hello?
Yes, we can hear you, my bridge.
Okay, okay. So, good evening, friends, and good morning, Dr. Sundar. Hope it's, reasonably good time for you to get up early in the morning. For the second presentation, we have a good friend here, Dr. Sundar Mudaliar from San Diego. He is clinical professor of medicine, University of California, San Diego, and also staff physician at the VA San Diego. He trained in India, England, and United States, so he has a global training, clinical professor of medicine at University of California, principal investigator in some of the landmark trials. And he also, gave the some very important background concept of the fuel energetics in improving the outcomes in with SGLT2 inhibitors. So Dr. Sundar is going to discuss the SGLT2 inhibitors and kidney outcome trials. Over to you, sir.
Let me first start sharing my screen. Okay, can you see my screen, please?
Yes.
Okay, thank you so much for the kind invitation. And it was a wonderful talk by Dr. Tuttle. And 3 years ago at the American Society of Nephrology, we both presented together, typically the same subjects. I presented on SGLT2 inhibitors and she did it on GLP-1 receptor agonists. And she's done such a magnificent job that I have big shoes to fill going forward, but I'll do my best. So the topic you gave me was SGLT2 inhibitors and kidney outcome trials. And I kind of added this in at the last minute, sweet success for the diabetic kidney. This is not my title, and this is from people in University of Washington, Ian DeBoer and Steve Kahn, a good friend of mine. So first of all, my conflict of interest disclosures are up there. I do speak for AstraZeneca, mostly in the Middle East, and I do get research support from the NIH. So I've got 3 objectives today. First, I will describe the results of renal outcomes with the SGLT2 inhibitors and describe how, as Dr. Tuttle said, a serendipitous secondary outcome for finding in the original CVOTs and also in the recent heart failure studies, but proven by dedicated primary outcome studies with kidney outcomes. Then I thought I would just review criteria to define kidney renal outcomes. It's all over the place to a non-nephrologist. Albuminuria, should we use albuminuria, EGFR decline, dialysis, renal transplantation, renal death? And finally, a subject near and dear to my heart, potential mechanisms. Why would we get such profound renal benefits in addition to cardiac benefits? And as was pointed out earlier, the heart failure and CKD benefits actually were a serendipitous finding in the CVOTs. Nobody, when EMPEREG was presented in September 2015, everybody was like, wow. But it was MACE outcomes. Heart failure was, by the way, over there, replicated in Canvas and then declared to me for DAPA. They were very, how would I say, clever. They went in and modified and added 2 co-primary endpoints because that was a lower risk population. They put heart failure right up over there. Now, the heart and the kidney are connected. That's why heart failure and kidney failure kind of tend to go together. The heart pumps more than 1 lakh times every day. Thousands of liters of blood is being pumped. And 1/5 of the cardiac output goes to the kidney to do its job over there. And the kidney, the glomerular filtrate is 180 liters per day if you don't have renal failure. So clearly disease of the one affects the other. And of course, as we all know, CKD patients are about up to 6 times more likely to die of heart disease than they will get to end-stage renal disease. And heart failure is a big problem in patients with CKD. Now, that's the bad news. The good news, Dr. Tuttle has very nicely shown us how the proven therapies for CKD, ACE, ARBs, SGLT2 inhibitors, GLP-1 has come onto it, but as she pointed out, we have to wait for the FLOW study for a dedicated, but all the indicators are pointing in the right direction. And of course, the non-steroidal mineralocorticoids, finerenone of late, which she very so elegantly described. But look at the proven therapies for heart failure. Now the Heart Failure Society of America, ESC, all of them say, you have to have people on this. No more going step by step by step. Start together, two at a time. Don't wait months. Wait perhaps weeks to a month. ARNIs are there, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists. So SGLT2s are there in both places, and MRAs are there in both places. And so far, the data is not as strong as it is for SGLT2 inhibitors, but obviously I'm biased. First came out in the EMPEREG outcome study, which showed that in patients with diabetes had high CV risk, slower progression of kidney disease. Replicated in Canvas. These are all secondary outcomes. Again, slower progression of kidney disease. Dapagliflozin, declared to me, again, showing beneficial effects on renal outcome. And last but not the least, even the Vertis, which was a little controversial, but again, it had effects on renal composite outcomes, but all secondary outcomes. And of course, those are exploratory outcomes. You need to confirm them. And that came with credence. And Dr. Tuttle briefly alluded to it. But in credence, in 4,400 patients with type 2 diabetes, albuminuric CKD, almost a gram of proteinuria, mean eGFR, this is what we see in our clinic, about 56. Canagliflozin decreased the primary outcome of end-stage kidney disease, doubling of creatinine or renal CV death by 30%. Renal specific outcomes, ESRD is defined there, dialysis, transplant, doubling of creatinine by 34%, and MACE by 20%, hospitalization for heart failure by 39%. I have to point out that this decline in the eGFR, doubling of creatinine and all are kind of all together. Some people say 40% decline and sustained decline in eGFR. Some people say 50, and doubling of serum creatinine actually is a 57%. But be that as it may, it was primary outcome was proven. And the study was stopped early by the DSMB. Along comes the DAPA CKD study, but now patients with and without diabetes, about a third of the patients did not have diabetes. Again, 4,000 odd patients, again, albuminuric CKD. Now the EGFR is lower, 43. What did DAPA do? Reduce the primary outcome of a sustained decline in EGFR 50%. There it was 57%. And of course, going on to ESRD or renal, they added CV death over there, kind of a little bit to hedge their bet, 39%. And of course, the secondary, if you take away CV death, it's still 44%. CV death, heart failure, 29. And this study, unlike Credence, all-cause mortality reduced by 31%. This, I think, is really profound and something really to note. Again, but this time, benefits unlike Credence, independent of diabetes status. And again, the study was stopped early by the DSMB. So what about, no, those were the primary outcome studies. So recently we had the 3 big heart failure studies. CKD, heart failure, they go together. So what happens in people who are documented to have heart failure? We had DAPA-HF, we had the Emperor reduced, and we had Emperor preserved. So first off the block was DAPA heart failure study in patients with reduced ejection fraction less than 40%. Now, this is a heart failure CV death study, but they did have secondary outcomes. And the worsening renal function, which they put in as a secondary outcome, look at that over there. Hazard ratio 0.71, but not significant. Okay, but this was not powered for that, but suggesting quite strongly that, hey, it might be. So what do? Then when they go back and let's look at the EGFR slope. And this is something which is still a little controversial, at least to a non-nephrologist. So they looked at 2 slopes. We all know, unlike the GLP-1 agonists like Dr. Tuttle showed, you actually get an increase in the GFR initially. Here with the SGLT2 inhibitors, with DAPA, you get a drop of about 4. Is that good or bad? But, as with the ACE and ARBs, we know that if you reduce it, it's intraglomerular pressure, which is reduced. And this has long-term benefits. And that is seen, the slope is now in favor of placebo because they don't drop as much. But in the long run, up to 2 years, now the slope for DAPA has slowed down over there. And the difference in slope is significant, although technically you should not use the word significant. New England Journal will not allow you to use it because it was not specified and powered for that. Anyway, coming to the Emperor reduced heart failure study. Now look at this. Their mean slope EGFR, again, significant. And they also had pre-specified analysis, composite renal outcome. And this was a 40% reduction, unlike 50% for the other one. And now 0.50 hazard ratio is well on the other side of unity, but you cannot use a p-value because it is a pre-specified analysis. It's not a designated secondary endpoint, which in and of itself is exploratory. But if you look at the EGFR, which was significant, again, the same thing that we see. Initially, EMPA drops about 4, but then flattens out as you go through. And over there, ultimately at the end, the slope is a lesser one, almost 2 ml per year slope, slower with empagliflozin over the 2 years of the study compared to placebo, which is good. And you can see the lines cross about 1.5 years, and then EMPA stays flatter. Then just last week, Emperor Preserved comes in. Now what did they do? So again, it's a heart failure study. These are all secondary outcomes, but heart failure, kidney failure go together. So they specified the EGFR CKD epi thing. And now what did they find? This was a secondary outcome and it was specified and they tested it in a hierarchical testing procedure. Guess what? The slope is less for EMPA than it is for DAPA, and the p-value is highly significant. But they also had a composite renal outcome, and now it was for more than a 40% reduction. This did not meet it. Of course, in the higher, you can't give a p-value or anything over there because that's over with the secondary outcomes over there. But, and if you look, this is what they showed at the, I did not attend the ESC. So clearly you can see the difference in slopes that you see. the slope at the end of the study was 1.36 ml slower with EMPA versus placebo. But they did an interesting thing as well. In 3,000 patients, they stopped the drug for about a month, month and a half. And then they found that the EGFR deteriorated less. If you calculated the slopes, now the slope is far more in favor. It's about a 2.4 versus 1.3 in favor of EMPA, because they didn't show the real curves. It comes up. And we saw that in EMPA-REG. You stop the drug, it's a transient effect on intraglomerular pressure. The EGFR comes back, and in EMPA-REG almost back to baseline. So this is fascinating, but they said very clearly this represents the unconfounded assessment of the treatment effect. But many people dispute this. How can you, not take into account this initial fall? This is the acute slope, the chronic slope. We're looking for the long-term progression. But be that as it may, it is all in favor of an SGLT2 inhibitor, a slower progression to end-stage kidney disease. But in a companion article in the New England Journal of Medicine, the main article was the Emperor Preserved. Dr. Milton Packer from Dallas, he wrote this and he said, although empagliflozin and DAPA have been reported to slow the rate of decline in the estimated GFR, changes in EGFR slope may not predict the effects of these drugs on major renal outcomes. And he said that for a while. He says, we should not be using the EGFR slope. And he gave this example. On the top is Emperor Preserved. So look at it. The hazard ratio I showed you over there, 0.95. Again, this is New England Journal. They will not let you put a p-value because this was not the secondary outcome. Clearly in favor of EMPA. So if you look at the estimated cumulative incidence, about 3% versus 6%. So there's a 50% reduction. But if you come to the Emperor Preserved, now the hazard ratio, as I showed you. So he says there is a discordance. The EGFR is coming down slower with empagliflozin in both studies. But hey, what happened to the major adverse renal outcomes? It is not significant here. But I think, to my mind, that is not an issue, and I'll tell you why. But the question is, does slowing of the EGFR translate into less renal outcomes in the long term? Basically, is EGFR decline a good surrogate renal endpoint? And the FDA struggled with this before they approved all the endpoints for the renal dedicated studies. What about albuminuria? Well, it's been around for a long time. We all check in fact, now most people don't even look at EGFR. Now slowly it's coming. Everybody's looking at creatinine and trying to translate CKD-EPI equation, KD-IgA, all the different equations are there. So just like MACE, how can we measure renal outcomes in long-term studies? So I think most people, at least in the nephrology space, and Dr. Tuttle can comment on this later, the EGFR slope is recognized as a pretty good surrogate. And this is from some pretty big people, including Guido Hirspink and all that. And they said, they looked at multiple studies. They said, if you have a sufficient sample size, a treatment effect of 0.7 ml per minute per 1.73 meters square year, or greater on the total slope over 3 years, or the chronic slope, predicts a clinical benefit on CKD progress with 96% probability. So yes, you can trust the EGFR slope. And they said with large enough sample size, these are thousands of patients, GFR slope may be a viable surrogate for clinical endpoints, because clearly you cannot wait years and years and years. Although, to be fair, in the Credence and DAPA, you got those endpoints which were powered for within 2.5 years, and the DSMB stopped the studies. Proteinuria, I've always said it, and people, Dr. Bakris also said, I said albuminuria is a better predictor of cardiovascular disease than it is of kidney disease. But we've always measured it over there. This was a large meta-analysis, 32 studies, 9,000 patients, evaluating 5 intervention types, ACE, ARBs, other drugs. Basically, they said, this is 2014. These results provide new evidence supporting the use of early reduction in proteinuria as a surrogate endpoint, but they do not provide sufficient evidence to establish its validity in all settings. And Dr. Tuttle very nicely pointed out the discordance between albuminuria and the renal in the, I had not known that with the endothelin receptor antagonists. And of course, now the renal field is moving like the mace. You heard of the mace, now we have to hear of the mare, and it's not a female horse. And the mare is major adverse renal endpoints, and Dr. Bakris is going to be speaking next, and he perhaps may want to speak to it. But what are hard renal outcomes? Because proteinuria is soft, eGFR is soft, it's a predictor. This is hard. So depending on how you define it, mare is 3-point mare, incident kidney disease, ESKD, death of renal cause. Mare plus 4-point MACE, like 5-point MACE. They put it all in. But to me, as a non-nephrologist, where is the detail of this? It's in the small print. The devil is in the detail. Each one is defined. eGFR defined as 40% on at least 7 creatinine measures, resulting in eGFR as defined over 2 years of slope. So this field, and I'd love to hear Dr. Tuttle's thoughts on this mare outcome. But bottom line, in the dedicated renal endpoint studies, Credence and DAPA, SGLT2 inhibitors reduce major adverse renal endpoints. I think that is very clear, and there's tantalizing evidence that the GLP-1 receptor agonist could do it, the finerenone maybe, and the endothelin receptor antagonist. But in the CVOTs and heart failure trials, these are secondary endpoints. SGLT2 inhibitors reduce eGFR slope for sure, and in some studies even major adverse renal endpoints. But again, they are either secondary endpoints or not powered specifically. But then to me, the bigger question is, why would SGLT2 inhibitors have such robust effects on heart failure and CKD kidney failure, which occur early? That's something puzzling. And for want of time, I could not use all my other slides. Just to put it into one sentence, several hemodynamic, is it endothelial function, is it drop in blood pressure, natriuresis, diuresis, metabolic effects, weight loss, all the things, molecular mechanisms, sodium hydrogen exchanger 1 in the heart, sodium hydrogen exchanger 3 in the kidney, and a whole bunch more things have been postulated, nobody knows yet, to explain the heart failure and CKD prevention benefits of the SGLT2 inhibitors. But in my mind, again, this is my opinion, I don't think they can explain the totality of the cardiovascular and the renal patient benefits in patients with and without diabetes. Before we thought of people, all diabetes, hyperglycemia does a whole host of bad things, inflammation, oxidative stress. But DAPA CKD says, hey, it happens in people without diabetes. DAPA heart failure benefits in people without heart failure. There's no hyperglycemia over there. So where did all that come from? And which drugs do this so early? The heart failure benefits, I couldn't show you the slides over there, occurring within 28 days for Amperec, and with the other studies, 17, 20 days, less heart failure hospitalization. The CV death occurs within 2 months, 59 days in Amperec. And CKD benefits take a little longer. They take a few months to occur. In my opinion, all of this in patients without diabetes, if you want one, at least partly, these changes partly can be explained by changes in fuel metabolism because it occurs immediately, unlike the other ones which take a little time to occur. But then, what is the problem with fuel metabolism in diabetes? Well, again, for want of time, I can't do it. I think the crux is hypoxia. Hypoxia in the kidney, hypoxia in the heart. And this is a paper from, Volker Wallin, who works in San Diego and is a good friend of mine, and I have long discussions with him. He wrote about, in Kidney International, the role of renal hypoxia in the pathogenesis of diabetic kidney disease, a promising target for newer renoprotective agents, including SGLT2 inhibitors. And he said in diabetes, there's a lot of increased ATP demand, hyperfiltration, tubular growth. See, hyperfiltration, you're pushing more stuff down, but the problem is the tubule has to take it all back. And it doesn't come free. You have to expend energy to take all that back. The glomerulus has the easiest job. It just filters it through. The energy for the glomerulus is coming from the heart. The heart pumps the blood through. The glomerulus is just a filter. The other part of the kidney, the tubule, it is doing all the hard work. It is pumping it all back. There's a proper regulation, RAS activation, vasopressin. And of course, on the other side, not only is there increased demand, there is decreased generation of ATP for various reasons. Less oxygen supply, decreased oxygen, fuel utilization, more of AMPK, mitochondrial dysfunction. And the one point I learned in the kidney is, in all other organs, in the heart, if you have hypoxia, what do? Increase blood flow. Well, at least you put more flow over there, you might get it, unless your PO2 is very low. In the kidney, you can't do it. If you put more blood flow to the kidney, guess what? It is filtered and the tubule has to work even harder to get everything back. So that's a problem for the kidney, especially in the inner medulla. Of course, in September 2016, we put our hypothesis saying, can a shift in fuel energetics explain the beneficial outcomes of EMPA-REG? And we said, we postulate that the cardiorenal benefits are due to a shift in the metabolism away from fat and glucose, which are energy inefficient in the setting of the diabetic heart and the kidney, and towards an energy efficient superfuel like ketone bodies, which improve work efficiency and function. Unfortunately, for want of time, I have studied renal fuel metabolism across the segments, the proximal tubule, S1, S2, S3, the loop of Henle, the descending limb, ascending limb tube. It is fascinating. Each segment has got a preferred fuel over there. But ketone bodies are a super fuel. Again, why? Because ultimately, whatever we do in the body, whether it is to grow our hair, grow our nails, pump the heart, the kidney, you need ATP. That is the universal currency in the human body. And you can gauge it by what's known as the PO ratio. How much ATP moles do you make per atom of oxygen consumed in the electron transport chain? Something like miles per gallon, kilometers per liter. Glucose is the best fuel, 2.58, provided it goes the whole thing round in the Krebs cycle. Palmitic acid, C16, one of the fatty acids, it's 2.33. It's about 11% less, but remember, minute to minute, beat to beat, it is not so efficient. Plus, it is a dirty fuel because it generates more reactive oxidative species. That's well known. That's one of the reasons the brain will not use fatty acids and prefers ketones, because the brain is a closed compartment, cannot deal with too much of oxidative stress. But beta hydroxybutyrate is 2.50. It's one, a cleaner fuel, it's water soluble, and three, actually the inherent heat of that equation over there is far better than even glucose. But as I said, small changes in fuel energetics occur immediately, and minute to minute, they could translate into large benefits over weeks to months. It's like you're on a slope and you're struggling. You reduce the slope, you can go faster. And if you have a better fuel, you go far longer distances. Quick question on why is there ketogenesis with SGLT2 inhibitor treatment? No other diabetes drug does that. In fact, tell me which other drug is causing ketogenesis. That has always puzzled me a lot. And I really cannot go into the details. People initially called it a pathological phenomenon. And I said no. And we published this in our paper. It's a physiological adaptation to fuel metabolism because there is continued loss of glucose, an essential nutrient in the urine, even if you're fasting. How much? About 100 grams in type 2 diabetes, 50 grams if you don't have diabetes and your fasting is about 90. And clearly, if you have kidney disease, it is even less, 10, 20 grams. But there is a continuing leak of glucose. And think about it. If your glucose is going out all the time, your blood sugar will come to zero. Or you have to eat all the time to keep your sugars up because you're leaking it out over there. There has to be some hemostasis. sorry, there has to be some hemostasis. And now for some reason, is it progressing? Okay, there. Sorry about that. So that loss of glucose is countered by an upregulation of SGLT1 transporters. Actually, it's not an upregulation. Volker Wallin always says, he says they're there, they're just sleeping over there. The moment it comes, they have high affinity, but low capacity. They only can take about 50%. So if you filter out to about 180 grams, you still will leak out 90 grams. So what about the other 90? The liver increases its hepatic production to supply the tissues. There's some evidence that the kidney also may do it. Why do we need the glucose? Why can't we use fat and ketones? Because there are 3 tissues which are almost completely dependent on glucose. The red blood cell has got no nucleus, no mitochondria. It cannot live if there is no glucose. It has to do glucose to the lactate thing. The inner medulla of the kidney, the PO2, depending on which reference, about 10-15 millimeters, not enough to support oxidative phosphorylation. And the brain takes time to switch to ketones and doesn't like fatty acids over there. So the liver takes acetyl-CoA comes into it, cannot go into the Krebs cycle, acetoacetate, acetyl-CoA is acetoacetate, and exported out as beta-hydroxybutyrate. It's an alternative fuel. It's about twice fasting in the twice the baseline levels. So if you have no diabetes, it goes from about 0.1, 0.2 to 0.3, 0.4. If you have diabetes, around 0.3 to 0.6, and it tracks that even after a meal. And actually, we wrote that in our paper. An SGLT2 inhibitor is similar to the state of accelerated starvation in pregnancy. I know the previous session was on GDM. Remember, the fetus is mainly glycolytic. It doesn't have the machinery for fatty acid oxidation. And a woman, you starve a woman, they go very quickly into ketosis. That's why women need to eat all the time. And I know the question was asked of Dr. Idin Vella. Glucose levels run far lower. That's one of the effects of you leaking out glucose. So just I will finish before my time. There. But that's all diabetes. What about people who don't have diabetes? Well, it's the pleiotropic effects of ketone bodies, because beta-hydroxybutyrate is more than just a fuel substrate. We knew this only in the 1980s that, hey, this is another fuel substrate. And of course, this is a very nice paper in Cell Metabolism. Beta-hydroxybutyrate has got receptors, the not-like protein 3 inflammasome, quite powerful effects to block inflammation. This is probably why the effects occur in IgA nephropathy in the DAPA-CKD. NLRP3 plays a major role there. HCAR2 blocks lipolysis, free fatty acid receptor lowers the metabolic rate. This is fascinating. Histone deacetylators, the sirtuins, partly through FOXO, reduces oxidative stress, inflammatory stress, and of course, beta-hydroxybutyrate can promote longevity. So bottom line is, ketone bodies are not only a fuel source, they suppress oxidative stress, they've got anti-inflammatory effects, they've got powerful effects on the powerhouse of the cell, mitochondrial biogenesis and function. This is one of my figures. The paper is still under review. In fact, one of the reviewers said this picture is too gaudy, tone it down. But I'm going to try and appeal that. Anyway, SGLT2 inhibitors block the transporters in the proximal segment. You get loss of glucose, essential nutrient, accelerated starvation, accelerated lipolysis, ketogenesis, about twice baseline. It is beta-hydroxybutyrate. More beta-hydroxybutyrate, improve fuel energetics, improve myocardial and renal oxygen consumption and work efficiency. And these powerful effects, I don't have time to go in, NLRP3, FFAR, antioxidative stress, hypoxia, HIF1, there's more erythropoietin, there's an increased hematocrit, which increases the oxygen carrying capacity of all the SGLT2 inhibitors, antifibrotic effects, seen in humans in kidney specimens, mTOR-C1, improve myocardial function, anti-sympathetic effects through GPR41. This is because unlike GLP-1 receptor agonists, SGLT2 inhibitors do not increase the heart rate. The blood pressure falls, the heart rate has to go up, does not go up with this. Bottom line, less myocardial and renal damage, less heart failure over there. But caveat, the data is mostly preclinical. There is clinical data. I don't have time to show you. It is not definitive by any means. It's far stronger for heart failure, cardiac output than it is for renal. It's a little fuzzy still. Of course, you have the other effects of the SGLT2 inhibitors, which are ketone independent, hemodynamic, vascular, metabolic, molecular, all of them. Few points. SGLT2 inhibitors have not been studied in CKD without proteinuria. The EMPA kidney is going to look at that. Not studied in type 1 diabetes. Not studied in polycystic kidney disease. They were excluded. Not studied in lupus nephritis, ANCA, for which you use other drugs, immune suppressants and all of this. But chronic glomerulonephritis, CKD, hypertensive CKD, IgA nephropathy CKD, yes, SGLT2 inhibitors. Finally, I always like to start with history. I've used this slide so many times. The first description of diabetes and its treatment is about 5,000 years. This is Hesira, a physician around 3000 BC. This was a stamp issued by Egypt in 1971. And this papyrus is available today in the University of Leipzig. And he described a disease like diabetes with polyuria. And he said, to treat it, take a measuring glass, fill it with water from the bird pound, fresh milk, beer, cucumber, mix into one, take it for 4 days, and the kidney. I mean, 5,000 years ago, before, the Greeks and the Indians figured out that, hey, this is the kidney. Of course, 5,000 years later, we had the keto diet with Elliot Jocelyn, the discovery of insulin, SGLT2 inhibitors. And when they came out in 2013, people said, turning symptoms into therapy. And many people said, you're going to destroy the kidney, you're going to fill it with sugar. Of course, I forgot to tell, there is a slight numerical excess of urinary infections, genital infections for sure, and DKA not really a problem in Credence and DAPA heart, HF, DAPA CKD. Very few or less with the SGLT2 inhibitors. And Subodh Verma, a good friend of mine, he said the pump, the pipe and the filter, do they cover it all? The pump is heart failure. I would suggest the kidney is also a pump. The pipe is the epicardial arteries. It reduces coronary artery disease. The filter, of course, is kidney failure. Do they cover it all? Yes. I know I have just a minute to go. I'm looking at my clock. And in JAMA, they said a novel cardioprotective therapy that improves glycemia. I would suggest probably cardiorenal protective therapy. But let me finish with this from the kidney literature. SGLT2 inhibition requires reconsideration of fundamental paradigms in CKD, diabetic nephropathy. I didn't go into DKD, CKD, IgA nephropathy, and podocytopathies. But look at this, he said. There are many potential indications. One is for sure. Nephrology after DAPA CKD will not be the same as it was before. Finally, thank you very much for your attention.
Thanks, Sundar. Sanjay, how much time do we have for questions and discussion?
We have about 20 minutes.
20 minutes.
Okay, perfect. So Sundar, let me start with you, and Dr. Tuttle can come back. One of the things that you saw in the Emperor Preserve, of course,
we have full 20 minutes of panel discussion. We can have.
Yeah, I finished 1 minute early.
All of them.
Okay. Sundar, so let me start you on this, because it's fun to start you on this. So remember that letter that came for the Emperor Preserved study. But I was reading the Emperor Preserved, and something that's very interesting is that the heart failure benefit was seen only if the EGFR was less than 60. So what I mean, and Dr. Tuttle can please join in this, but is there something that's happening that you need somewhat of a worse disease in one organ to help with the other? So
okay. A very good question. I had the slide, but for want of time, I took it out. Now we have to remember that it was 40% reduction. He transformed it and redid the data, Dr. Packer. He published that in the European Heart Journal. He made it 50%, and then he clearly showed, but this is all post hoc. that after 60, it doesn't work. The curves are beginning to go over there. I will defer that to Dr. Tuttle, but we have to remember that the people who were more than 60 apparently were women with more hypertension and more atrial fibrillation in the thing. So I defer to Dr. Tuttle, who has far more experience in why it would not happen.
Dr. Tuttle?
Yes, hello. Well, again, we really can only speculate at the observation, but those who have preserved ejection fractions and higher GFR are healthier people. And it may be that within the time frame of the study, there's just not enough opportunity to show a benefit on outcomes. And, I think that's one of the reasons, for example, in the other class of newer glucose-lowering agents, the GLP-1s, the cardiovascular outcome trials, it's easier to show an effect on albuminuria than GFR because they don't have very much kidney disease. And so by analogy, what I would say is that when you look at people with preserved ejection fraction and preserved GFR, they aren't as sick. And so within a short period of the trial, you're not going to be as able to demonstrate a benefit.
Except, if I may add, that we are looking at two different mechanisms of action with the GLP-1 RAs versus the SGLT2 inhibitors. In the SGLT2 inhibitors, you are seeing separation of curves in other things far too early. So how can the time argument, pardon my naivety, work with this?
Oh, well, what I'm talking about is not the time of the therapy, but the course of disease. If you're studying people who have preserved ejection fraction and normal GFR, it's going to take them a lot longer to have events. So in order to show any kind of treatment effect on the event, you have to have enough events to measure something. So I think people who are being studied earlier.
Yeah, I fully agree with Dr. Tuttle. The eGFR in the heart failure trials, the preserved was about 60, 61, 66 ml per minute over there. Whereas in the Credence trial, it was 53, and in DAPA CKD, it was 43. Plus, those people were albuminuric, so the more protein, almost a gram. These people didn't have that much protein. So it's two different populations, and as she rightly said, eGFR slope is a thing, and that's what was the pushback from the nephrologists against Dr. Packer. He said, first of all, it is hypothesis generating that more than 60 it doesn't work. But second of all, you need some more time. These are lower risk for the kidney. The heart, yes, they have heart failure. They have some kidney failure. Obviously, they don't have that much proteinuria. And the eGFR is still reasonable.
And of course, that even with the heart, it's the 40 to 50s that really showed benefit analysis.
Right.
So I think, it's a very interesting trial because it's sort of nuanced out some of the other things that came from the DAPA HF and CKD. Dr. Makkar, you want to add?
Just coming back to the eGFR thing, we saw the benefit even in DECLARE, which had a population with absolutely normal, well-preserved kidney function. So what do you say about that?
In DECLARE, it was mostly an effect on albuminuria, not on kidney endpoints. And you can detect that earlier in the course of disease. And so that's why for the cardiovascular outcome trials, people were selected for cardiovascular risk. And by design, they excluded people with more advanced CKD. So the effect is primarily on markers of early disease. But if you go further along the disease trajectory, like Dr. Mundalar said correctly in Credence and DAPA CKD, they had more advanced kidney disease. So still there was an effect on albuminuria, but they started having events. So then you could measure an effect of the treatment on the events.
Yeah, if I may add, please. Dr. Makkar in DECLARE TIMI, it was a composite renal outcome which included albuminuria.
But there was a benefit in terms of heart failure reduction also.
Correct.
So that was the interesting part. So we have a question from Professor Das. Do you see any differences between EMPA being, better than others, or, it's more like a class effect?
Is it for me or Dr. Tuttle?
Anyone
can answer.
Actually, both. We can have viewpoint of both.
Yeah, in my opinion, it's a class effect.
I totally agree.
Despite Vertis-CV.
But the renal one, see, there's people have argued long and strong about tugliflozin. There were 2 doses. There was 100. There was a 300.
Right.
There were problems with the dosing. If we are talking of a class effect, we're talking of a class effect, including the SGLT1/2 blocker, sotagliflozin.
Yeah.
So can I have both of you talk about this? Let's say a patient who's diabetic is now A2G2, has some amount of urine albumin creatinine ratio of around, about 300 and the EGFR is 60. What would be your hierarchy of drugs with all the data that we have? What comes first, what's second, and what's third?
That's a really great question, because if you look at the guidelines, the hierarchy has really been more dependent on when they received regulatory approval than really on the biological mechanisms or the effect size. So if we go strictly by the guidelines, we'd start with an ACE or an ARB and then add an SGLT2. But this may be a little controversial, but I'm going to go ahead and say this. If you look at the cardiovascular outcome trials, where about 20% of the patients were not on an ACE or an ARB, and irrespective of albuminuria, still demonstrate an effect on kidney endpoints, and not just on new onset macroalbuminuria, even substantial GFR decline or kidney failure. And then if you look at the effect size in the kidney trials, with hazards ratios of 35 to 40% on top of an ACE or an ARB, these are the biggest risk reductions we've ever seen for any therapeutic in kidney disease. And as Dr. Mundelaar correctly pointed out, both Credence and DAPA-CKD were stopped early for overwhelming efficacy. It's never happened in the field before. It hardly happens in any field of medicine. It's a high bar to stop for efficacy. We stop trials for safety or futility more easily. And then the other thing, too, that I also agree with him about is, even though it was a secondary endpoint, a 31% reduction in all-cause mortality from any condition with any treatment is remarkable. And so, to be honest with you, I wonder if we just started from a clean slate and we looked at the risk reductions, whether or not we would start with an SGLT2.
So, Sundar, you just mentioned about sotagliflozin. So, coming to the data from SCORED, this did not involve patients based on albuminuria as a criteria. And though, the renal endpoints were not analyzed for superiority, but there was a strong indication for renal benefit. What is your take on that?
And as I said, if it's a class effect, it's a class effect for that. Now, the people in the worsening heart failure, they were a little different population. Also, we have to take into account the studies were terminated early because of lack of funding. So they barely got, I don't know what percent of the original people, and they talked to the regulatory people, put it together. And second, now for what it's worth, the endpoints were not adjudicated because it costs money to adjudicate events. Now they presented data that adjudication really doesn't add much. It's what the investigator thinks. But we think a lot of things and we just say, hey, that is what it is. They did not adjudicate it. But there were multiple things. But let me point one thing out. People seem to think that an SGLT1 and 2 inhibitor blocks both SGLT2 and SGLT1 in the kidney. You cannot block the SGLT1. Then you will not live because all your glucose is going to get out. That's not possible. That SGLT1 effect is in the gut, where you get some more lowering and you get more diarrhea, which was seen with the thing over there. So how much SGLT1 adds to SGLT2 with that, I don't know. I don't believe I don't believe it is too much, in my opinion.
But the plus point seen with the dual SGLT1, SGLT2 was that they were still efficacious in glucose lowering, even at lower levels of GFR.
Yes.
So that was one big plus point.
Probably due to the GI effect rather than
whatever.
Yeah.
Sundar,
There is no
I
increase.
want you to take I want to take your view on the previous question, which I asked Dr. Tuttle. So an A2G2 EGFR, and the patient needs also glucose lowering. What will you do? What will you should we do? So the question is, a patient who comes to my clinic who's not who we have some, normally we would add an ARB and an SGLT2, but should you also add a MRA now and with the Fidaro?
The thing, what we have to remember, and Dr. Tuttle rightly pointed out, it is just when the studies were done. These came earlier. And now the ADA calls it a living guideline. Means anytime something happens, before there's to wait 1 year out before you did anything. So they're updating it. As of today, the diabetes guidelines says if you have atherosclerotic CVD, then go for a GLP-1. If you have heart failure or kidney failure, go for an SGLT2. If they cannot tolerate it, contraindicated, then go to a GLP-1. The only reason being is the studies have to come out with the dedicated. That's the only reason you will get an indication, and the payers, the insurance companies, will pay for it. In the US, everything is driven by payment. Who's going to pay for it?
Absolutely.
Personally, for me, if price is not an equation, I use it a lot. I use the combination of a GLP-1 and SGLT2. In fact, Mike Nock and Juris Meyer wrote a beautiful editorial in Lancet. They said SGLT2 inhibitors and GLP-1, a marriage made in heaven.
Got it.
I mean, but cost is an issue. And we have to study it together. We have not, and like you said, you put finerenone in the mix. Too little data to see what happens. And then the cardiologists have taken a bold step. If you read it, they said these are the 4, you got to be on it, and you got to get there within a month to 2 months, because after the sotagliflozin and the other studies, they said you wait 1 month, the people are already dead. The events have already occurred.
Right. So it also depends on the risk, isn't it? So can I have both your views on this? In terms of, we constantly are talking about ARA, right? A relative risk reduction. But in terms of absolute risk reduction, what is going to happen? For one, let's take 2 different EGFRs, one at 60 and another at 30, right? So do you think that at 60 you could say that okay, let me just use one agent, but at 30 throw in the towel? I mean, throw in the whole library on.
I think that's a really good question, and that's why I sort of alluded to it a little bit about more precise phenotyping of patients. And I agree with you, because particularly when GFR drops below 30, GLP-1s are very effective still at glucose lowering. So you can use that indication if you want. They have cardioprotection, but we have some very strong evidence that even in advanced CKD in Award 7, that there was a reduced risk of GFR decline in true kidney disease endpoints. And I didn't show you the data, but we had enough events, because even in that trial of 600 patients, we had 60 events in 1 year because they were very high risk. And more than half were kidney failure going on dialysis or transplantation. So indisputable endpoints, and they were comparably reduced. It wasn't just a GFR endpoint. So I do think we need to consider agents at more advanced CKD. And with regard to finerenone, I see George just jumped on, but in the Fidelio trial, people who were drop-in SGLT2 inhibitor users still had comparable benefits. So, we are moving into an era of combination therapy. I think we're still learning how to use them, but especially somebody at high risk of heart failure, that's another person where I would consider using finerenone together with an SGLT2.
Just a follow-up question, because both the MRA and the ARBs are prone to cause hyperkalemia, especially at lower EGFRs. If you would have to drop one, what would you do?
Well, you know what? An SGLT2 inhibitor actually helps control hyperkalemia. In fact, they just published a post hoc from the Credence. And really, again, I loved Dr. Mudaliar's presentation of physiology. This is why it's so important to understand mechanisms to help us apply therapy. So anytime you increase urine flow and distal delivery of solutes, including sodium and potassium, there's increased potassium secretion in the distal nephron. So actually applying an SGLT2 to an MRA can mitigate hyperkalemia, and again, combination therapies, not only for efficacy, but for safety, so that we can apply agents that we might otherwise not be able to use.
So, yeah, Anjali, you want to say something?
Taking that point forward, we have, clinically speaking, we have a lot of patients who are ESRD and on hemodialysis who need to really reduce the hospitalization for either heart failure or fluid overload. Do you see a point of using such drugs to reduce the hospitalization due to fluid overload? I know right now we don't use them, but do you see a potential over there? Because that's a tough thing to manage.
So that's a really good question, especially again with the physiology that Dr. Madaliar presented. There is rationale for using SGLT2s even in dialysis patients, especially from a heart failure and cardiovascular perspective. And there are groups right now, I'm involved in 2 of them, trying to get trials going in kidney transplant and type 1 diabetes in particular. But one of the challenges is that we will have to have governmental funding because pharma isn't going to cover those. And that's been our biggest challenge so far in the US, working with the NIH to try to organize some trials. But let me turn it over to Professor Madaliar and see what he thinks.
Sundar, this is last question. This is last question. Yes, Sundar.
No, I fully agree with Dr. Tuttle said.
Okay, so the closing question is, we have discussed in detail the nitty-gritty of SGLT2 inhibitors and trials, and with the GLP-1, RAs and everything. Large major. Yeah, we are closing. Last question.
No. So we have a question from Dr. C.S. Yagnik in the chat box. I think
it's a comment. It's a comment.
It's just a comment. So
it's a comment. So what is the large amount of people here? Most of the people logged in here are clinicians, and they need to understand where you position these molecules. We have discussed in patients with the kidney disease and heart failure. For a typical garden variety type 2 diabetes patients, what is your take on using these molecules and where you position them?
So the question is, in a patient's, I mean, I used to be on the ADA's professional practice committee, which did it. So I follow the ADA guidelines. I still use metformin first line, but now at least they've moved up to say if there is any, the CKD or any which way you define it, most of our patients usually are getting with metformin and an SGLT2 inhibitor up front. And to Krishna Sheshadri's point is, will I wait from 60 to 30? This is a lifetime burden. You don't want the disease to go down and then say, okay, I'm going to do it. It's far harder to stop it when you're down the slope than to prevent it. Do we have any evidence? No, but it kind of makes physiologic sense that, with the PCSK9, it's classic. It's a lifetime burden of that extra LDL sitting in your thing over there. So that is just my opinion. I have lots of patients on SGLT2, GLP-1, insulin. Let's not forget insulin. If you want good glycemic control, you need insulin, which is by far.
I think,
sure, sir. I think it was a wonderful session and very thought-provoking, very practically useful. So with that, I would like to thank Dr. Catherine Tuttle as well as Dr. Sundar Mudliar, as well as Dr. Brij Makkar and Dr. Krishna Sheshadri for having this wonderful session. I would also request all of you to look forward to another wonderful session coming up on hypertension and clinical practice guidelines. And I would like to hand over this proceeding to Dr. A.K. Dasar and Dr. Isha Bansal. I don't think this audience has any questions about Dr. A.K. Das's introduction. He's a very senior teacher to many of us, a consultant physician in endocrinology from Pondicherry. I may take a long time if I have to introduce him in detail, but thank you, sir, for being with us today for this. Dr. Isha Bansal is a new upcoming person, young passion in MD medicine, internal medicine from Hyderabad. Over to both of you, over to Dasa to take the next session, sir.
Thank you, Anjali. And indeed, it's a great session, a legendary session like the last one we had. And we have two talks being delivered by no less a person, the legend in the nephrology and hypertension, Dr. George L. Bakrish. And he is the professor of medicine and director at the AM Heart Associate Comprehensive Hypertension Center. Published over 900 peer-reviewed papers and book chapters on hypertension, nephropathy, and its progression. He is the editor, co-editor of 22 books. He's the co-editor of the third and fourth edition of the Hypertension, a companion to Brownwell's book on the heart. He has served on the Cardinal Advisory Board in the FDA and many of the guidelines, JNCs, and I'll be taking much time to introduce him. Now with this, Dr. Bakrish, I welcome you on behalf of me, on behalf of my two other chairpersons, Dr. Sachin Chitawar and Dr. Isha Bansal. You saw the photographs, beautiful photographs. They'll be taking over from me after your talk is over for the discussion. The first talk, my dear friends, is on a very important contemporary challenge. Dr. Bakrish is going to speak to us regarding the resistant hypertension, which is a big problem. How do you diagnose it? Pseudo resistant hypertension or true? And I don't know if you, but it's a get problem because even if you exclude the secondaries, in 75% of the essential primary hypertension, we do not have a cause for the resistant hypertension. And I think we were looking forward to listen from you, Dr. Bakrish, regarding the detection, the evolution, and the management of this very important entity, hypertension. I think, Sachin, you will take over after the talk is over for the next talk, to introduce the next talk, and then Isha will take over at the end for the question and answer session. Over to Dr. Bakrish. A hearty welcome.
Thank you. Thank you very much. And thank you for the invitation. And thank you to everyone. And I apologize because timing was off here. So I'm only going to be able to give you one talk. However, I'm going to sneak in and give you a hint as to what guidelines are coming up. And I heard some talks from my good friends here in the US. So guess what? I'm going to sneak right in and just tell you that, remember, okay, well, let me find my, hang on. Jesus. Okay, hang on. Number one, let me give you a hint here. The guidelines for next year. SGLT2s pretty much have to be put in the drinking water. As you heard correctly, this is a lifelong disease and you can use them down to GFR of 20, no problem. These are cardiorenal risk reducing agents that happen to lower glucose. And in fact, we know that they work even if you don't have diabetes. So they need to be used, period. That's point number one. Point number two, my good friend Kathy Tuttle was talking about using the non-steroidal mineralocorticoid receptor antagonists. Those are also going to be in the 2022 guidelines. And this is, make no mistake, this is not your mother's Spiro. That is another novel class of drugs defined by the FDA as a novel class of drugs, not related to Spiro, not related to finerenone. So keep in mind, those are going to be in the guidelines for 2022. That's what's coming. Now, resistant hypertension, here's the bottom line. You need to think about this in a different way than garden variety hypertension. The definitions are here. Less than 130/80. You know this. You have to be on 3 drugs, maximally dosed, not 5 of lisinopril, not 12.5 of hydrochlorothiazide, and 2.5 of amlodipine. No, that is not what you want. You want 10 of amlodipine, you want maximal dose ACE or ARB, and you want at least 25 of hydrochlorothiazide or something else. And then you have to make sure the patient's taking the drugs. Are they taking them? And if they are, then we can talk about resistant hypertension. Very important to understand that. These are the definitions by the ACC/AHA. European guidelines, which you may have read, not quite the same. They're still more traditional, but nevertheless, this is what's out there. Now, all of the following have to be true for someone to have resistant hypertension. Are they on a low salt diet? Big deal in India, because as you know, diet's not really low salt. Very important. Are they taking their meds? Are they sleeping well? This is a big deal. Are they getting 6 to 7 hours of sleep every night uninterrupted? If they are, great. If they're not, do they have sleep apnea? Do they have anxiety? Do they have some other problem? That will interfere, and that will cause big fluctuations in blood pressure through the day. This is a big deal, big deal. Now, we're going to talk about this. If you're on 3 drugs, are you really on the best 3 drugs for lowering blood pressure? There are differences. There's no question about it. I'm going to show you this as we go on to this. And you got to rule out secondary causes. Primary hyperaldosteronism, unappreciated, by far the most common cause, secondary cause of hypertension and responsible for resistance. And not everybody has hypokalemia. You can have normal kalemia and have primary hyperaldosteronism. So you got to think about it. So this is quick, just a review, just to remind you, the diet is critical. By the way, high salt diet, you can forget about ACEs and ARBs working. You've shut off the renin-angiotensin system. Those drugs are not going to work. You gotta have a low sodium diet, and low sodium, 2,000 milligrams. We're not talking no salt. You got to think about how these drugs work, and you got to think about treatment resistance. And this is a chart that kind of goes through things that affect blood pressure. Volume, we already talked about it. Heart rate, high heart rate is going to cause high pressures, indicating high sympathetic tone, something to think about. The renin-angiotensin system, we've already talked about. Adherence to medications, sleep, we've talked about all this. Very important points. This is an evolution of the guidelines. I just thought I'd show it to you, have some fun. But there's 129 different antihypertensive medications. 129. How can you not screw up? No, you can screw up. And guess, that's if you don't know what you're doing. So you got to know the pharmacology and you got to know this data. That's why I'm showing it to you. This is the holy trinity of therapy: ACE or ARB, CCB, diuretic. If you've done this well, you should be able to control about 80% of people with hypertension, maybe 85, depending on how you define it. And if that, the remaining is the true resistant hypertensives. This is just to show you from the clinical trials. This looks at hypertension, diabetes, and kidney disease clinical trials, the average number of blood pressure lowering meds, average number. You can see nobody's on 1 drug. Everybody's on 2, and most people are on 3. So keep this in mind. The approach, should you max out the dose? Well, for ACE or ARB, yes, but for everything else, no. Because this study looks at different classes of agents, including the ACE, by the way. And what they did is they either doubled the dose or added a second drug at a lower dose and looked at who achieved blood pressure lower. In every case, didn't matter, every case, if you doubled the dose, you got less blood pressure lowering than adding a second complementary drug, mechanistically complementary. So this is very important. And in fact, the American Society of Hypertension put out guidelines 10 years ago on acceptable combinations to be used in hypertension. It reduces the pill burden as a single pill, and they have synergistic effects. Very important point. And don't be using combinations, ACEs and ARBs, ACEs and beta blockers. They don't work for lowering blood pressure. Now, this is in the guidelines. Even 2017 guidelines are talking about combination therapy. They're talking about combination therapy. The British guidelines, Brian Williams, a good friend, put it in your face. You start with combination therapy because adherence is so bad. Just start with a single pill, 2 drugs, and call me in the morning. And that really is going to improve hypertension control rates. You'll see in a couple of years. No question about it. So this is the approach. So let's take a look at thiazide diuretics. Let's take a look at ARBs, and let's take at CCBs. They're not all the same. This is a paper we did with Brian Williams, looking at diuretics and different guidelines and looking at resistant hypertension and essential hypertension, or primary, now called primary hypertension. And you can see here for resistant hypertension, we're not talking about hydrochlorothiazide. We're talking about indapamide. We're talking about chlorthalidone. So very important to understand. Now, this is 24-hour, this is mean office blood pressure, but they also did ABPMs in this study. Hydrochlorothiazide versus chlorthalidone. You can see here very clearly chlorthalidone gave you the benefit over hydrochlorothiazide. You get additional blood pressure reductions. This is a study we did in referral patients. So this is a clear office study. Everybody was referred for resistant hypertension. Everybody was on hydrochlorothiazide. All we did is change hydrochlorothiazide to chlorthalidone at the same dose. And then we brought them back 6 to 8 weeks later. You can see blood pressure went from 152 down to 145. Significant reduction just by substituting diuretic, not adding drugs, not changing doses. Now, ARBs. There's a bunch of ARBs. You can see here they are. And the question is, are they all created equal? They have different indications. Different companies did different studies. Some are good for the kidney. Some are good for the heart. The bottom line, they're all good for the kidney. They're all good for the heart if you control blood pressure. So what are the differences? Here's a 24-hour ABPM study in 984 patients. Valsartan 320, azilsartan 40 or 80. I don't think I have to discuss this. This is obvious. The data speaks for itself in terms of magnitude of reduction. Now, what about against an ACE inhibitor? Azilsartan against ramipril. Here you go. Take a look at the graph. I don't think I have to say anything. The data is very clear on what's giving you the best blood pressure reduction. Now, we went back and we looked at comparisons with olmesartan, comparisons with valsartan, against valsartan in people with diabetes, normal glucose, and people with pre-diabetes. And here's what we found. So again, across the board, azilsartan gave you better blood pressure reduction. In some cases, not so much. In some cases, a lot. Against valsartan and against olmesartan. Although olmesartan, I have to tell you, is essentially the same as azilsartan. If you look at the conclusion, all the data, they're essentially the same. There's a 2 millimeter difference. I mean, they're essentially the same. But valsartan, losartan, forget it if you want blood pressure. Now, why? Well, if you look at the bindings, it has nothing to do with half-life. If you look at the binding, that's the key. Look at the left, that's before washout. So all of them look good, okay? But look at the right. This is after washout. Azilsartan is still tightly bound after the washout period. The rest have faded. Even olmesartan has faded at the higher concentration. So again, keep in mind, there are differences in binding. And in fact, losartan, about 57% binding, azilsartan, about 85% binding. So big difference in binding of the AT1 receptor. And in fact, when you look at this over time, going out 4 hours, you can see during the washout period, this is the same data, just pictorially different. All the open bars and circles and whatever are washout. And you can see azilsartan is still up here, whereas everything else is down here. Here's olmesartan, and then the rest are down here. So that's another way you can get blood pressure control. And then what about the CCBs? There are differences between amlodipine and nifedipine. And the differences are small, but they're there, 3 millimeters, 4 millimeters, amlodipine not being quite as good. Now, overall, amlodipine is a far better CCB than nifedipine, no question about it. But for blood pressure, there are differences. Can you combine CCBs? The answer is yes. This is a study that was done in the 1990s. Many people don't know about this, but you can combine a dihydropyridine with a non-dihydropyridine. This looks at diltiazem and verapamil with nifedipine, low doses. And you can see here, systolic pressure, nice reductions by both. And then over time, diltiazem has a better duration of effect. And we do this in people with asthma that can't get beta blockers. We do this in people that can't tolerate beta blockers, and it works quite well. Now, Pathway 2 says spironolactone is the number 4 drug. We put it in the guidelines as the number 4 drug. No question about it. Oh, this study, GFR 84. Whoops. You don't have to worry about potassium. GFR is 84. Can you do this in somebody with GFR 45? Well, if you use potassium binders, sure, why not? So what are the two most common non-disease causes? Non-disease causes of resistant hypertension. Number one, white coat, anxiety. This is a big problem. And poor medication adherence. Could be due to dementia, could be due to the patient being passive aggressive, not wanting to take it. Nevertheless, you have to figure this out. ARBs are the best tolerated. This meta-analysis shows best persistent drug ARBs. And adherence, it's been tested by a number of studies. These are two seminal studies where they actually measured urine metabolites in one. The other one they didn't. They actually just looked at pill counts and other things. Bottom line, both studies showed 45% adherence. 45%, 4-5. So the majority of people are not taking all the BP drugs. This is a big deal, and you need to get to the bottom of it. Sleep is huge. And I told you this already. This is a review on sleep and blood pressure. And here's the bottom line. Less than 5 hours of sleep is going to be associated with exacerbation of hypertension, exacerbation of movement of hypertension in terms of variability. And here you go, the Nurses' Health Study, 10-year follow-up, 10-year follow-up. If you're getting 6 hours of sleep, 30% relative risk for coronary heart disease events. If you're getting 5, 82% increase in coronary heart disease events. Not good. This is a study we did, recently published, where we took people that had sleep difficulties, nothing else, had large fluctuations in pressure. All we did is fix their sleep. That was it. And look at their blood pressures. Very, very impressive. This is not sleep apnea. A lot of these people had sleep apnea. They were on the blower. That was not it. We got them better quality sleep, getting to sleep and staying asleep. That's the big deal. Now, this is from the guidelines, hypertension, December 2018, that we published on resistant hypertension. And this goes through everything I just said in great detail in terms of the way to approach these patients with drug therapy, lifestyle, etc. And you can see the last choice, the last resort, is the potassium channel opener, minoxidil, which if you go to, and I prefer that over hydralazine, because you can get by with low doses, and hydralazine has a lot of side effects. So I think if you then look at what else you got all these drugs and everybody's talking about denervation and all that. Not ready for prime time, not approved in the US, approved in Germany. And this is a summary of 24-hour ABPM studies with different approaches to denervation. Bottom line, denervation, you get a 7 to 8 millimeter additional reduction in blood pressure. That's it, you're not cured. So here's your choice, denervation or spironolactone, or denervation or 2 additional drugs. I mean, that's kind of what you're talking about. It's not what people think, and it's very expensive, and it's a procedure. There's baroreflex therapy that's approved for heart failure and started off for hypertension, but it was an evolution. The carotid baroreceptors are critical and better, you get better results in denervation. This is the original on the left. So you can see, kind of scary, very cumbersome. And we did a study with that, and I'll show you the results in a minute. And then you got the new device on the right. That battery lasts 3 years. The battery on the left lasts 6 months. And the little device is on one side of the carotid. And again, much cleaner. You can see here, when you turn the magnet on, you get a nice reduction in the blood pressure. And then you turn it off, it goes up. You turn it on, it goes down. Very predictable. I've got people I'm following now 11 years after this was done. They're still doing well. This is the trial, the pivotal trial. We had open label, and then we had a device off. And then we evaluated him for 6 months and then turned everybody on. And what we found, this is who came in. You had to be on 3 drugs with a BP above 160. And we excluded people with atherosclerotic disease, basically. So we had an efficacy and a safety endpoint. And there they are. You can see them. And these are the criteria. These are the baseline characteristics. 5 meds. People are on 5 meds. Blood pressures were at almost 180 over 100. Very high pressures. And you can see this is the final result. The efficacy endpoints were good, but it was a safety issue in terms of procedures that you can see in red. And that's why the FDA didn't approve it. The company left, went to Europe, got it approved in heart failure, and now they're looking at hypertension. But you can see the long-standing effect. This is going out over a year, in fact, going out years. You can see blood pressure reduction was maintained. Side effects, year 2, we had a 3% incidence of carotid stenosis. Otherwise, everything was fine. And you can see that in this 207 patients. So putting it all together, you need to select your drugs carefully. You need to make sure patients are adherent. You need to make sure the combination therapy can be used because it'll improve adherence, and you got to focus on lifestyle. Spiro is your 4th drug if the patient can tolerate it based on kidney function. Don't forget sleep, very important. And if the patient has money and they're desperate, they can go to Germany and have an interventional approach. That's all I got for you, and be happy to answer any questions or comments. Thank you.
Very practical and very interesting talk that you gave regarding this resistant hypertension. Also did refer to the guideline. Thank you very much. Now I'll request Sachin and Isha. You can start the question session, then I'll take over. Isha, you are visible now. Sachin must be there. Isha, would you like to ask any question, or I'll start? You will take over from me. Isha, you are muted, I think. Not audible.
I'll ask in the next session, so we'll take over to the next session.
Okay. I think I just wanted to know that we had this concept of A plus C plus D, ACD, before calling anybody. And you also showed that beautiful triangle. And you had said the 4th drug beyond this is the spironolactone. And you said that beyond this, there are some other drugs which you also highlighted. Where do you place the baroreceptor reflex issue that you so beautifully highlighted with a lot of examples? Where do you bring it in? All along the course of therapy, or beyond certain number of drugs?
That would be beyond a certain number of drugs. That's a last resort. That's in people that you've got on 4 or 5 drugs. Their pressures are still 170, 180. And the problem is it's not approved. And so when it gets approved, that's what I would do before denervation, to be completely honest with you.
Dr. Bakris, you are a living legend on hypertension. I just want to know, how often have you found that the resistant hypertension, so-called, was actually not resistant hypertension, it is pseudo-resistant hypertension, because as you rightly pointed out, because of the dietary indiscretion, of the drug non-adherence, etc., etc. How often did you find that's the cause?
Well, I can tell you that if you really look at true resistant hypertension in people doing everything correct, it probably in the US probably is about 5 to 7% of patients. It's not very high at all. On the other hand, if you then look at people called resistant hypertension, probably 25, 30%. So true resistant hypertension is not that common.
Okay, and of course you were excluding all the secondary causes, known causes.
Oh yeah. All secondary causes are excluded. I will tell you, primary hyperaldosteronism, it's out there. We're seeing a lot more of it, and we've always looked for it, but we're seeing more of it because we're looking more aggressively. So you have to think about it.
And how often do you encounter? I mean, in our country, white coat hypertension is actually a bothersome issue, and we do not have access to home BP monitoring or the ABPM. Now, how often do you think that the white coat hypertension gives the level wrongly as a resistant hypertension?
I think it's actually a lot more common than you think. One of the things you can do if you don't have home monitoring, if you can do this, is to take the patient and put them in a quiet area, let them sit there for 15 to 20 minutes. And basically after 15 to 20 minutes in that area, go back, hook up the blood pressure monitor, and have the machine, if you can program it to go off by itself, and then you'll see the difference. The other thing is you have to measure the blood pressure 3 times consecutively. So have the patient sit if you can for 4 minutes, and then measure it 1 minute apart and take the last reading. Don't take the first reading. And then you'll see, especially if it's 15, 20 millimeter difference, no question, that's white coat.
Very good. And Dr. Bakris, you gave a very, you told us the secrets of the statins, and you said agilastatin is almost, it's the best, possibly the best, if I've understood correctly. The BP lowering is almost equal to olmestatin, but in some studies, olma and telma are also equally effective in reducing blood pressure. So if you have to choose between telma, olma, and telmastatin, which one will you put as the more effective drug?
I would say based on my experience.
Yes.
Based on my experience, I think all three of those are very good, and I use all three. But I will tell you, I have taken people off telma and put them on azilsartan or olmesartan and gotten a little bit better blood pressure control. Not much, maybe 3 millimeters, 4 millimeters better, but a little bit better. Telma, when it came out, I love telma because it really had a lot of benefits, but these other agents are further newer and have better binding. So I will tell you, I have a reputation in Chicago because I get these patients referred to me, and I put them all on azilsartan and they all come back much better controlled. So I think there's something to be said for that.
Yeah, I think it's a great message for our country, Dr. Bakris. I just wanted you to compare and contrast the hydrochlorothiazide vis-a-vis chlorthalidone, which got a new life. And one of our colleagues was also instrumental in giving the chlorthalidone story to the world. And you must have met him. He spoke about it very very eloquently. So how do you compare and contrast these two?
So chlorthalidone has active metabolites, and chlorthalidone actually lasts 44 hours. Hydrochlorothiazide with metabolites lasts about 11. So it's a much longer acting. Indapamide, by the way, not to be left out, is also good, lasts about 24 hours. And so there's some very good opportunities here for other options.
Sir, one quick question to Dr. Bakris. Sir, you mentioned the role, one of the factors being anxiety in patients with resistant hypertension, and the white coat hypertension also is partly related to anxiety. So normally now we are kind of keeping beta blockers at far end of the options. So you think that these patients can be candidates for adding beta blockers early in the course of disease, or you still want to keep them?
Yeah, I know where you're going with this. I can tell you I've tried that. And what ends up happening is the patients complain because then they don't feel right. And to be honest with you, I use benzodiazepines in those people. I don't think beta blockers are the answer. And I think if you try to chase blood pressure from anxiety with blood pressure medicines, you will always lose. That's been my experience. So I use very low dose like clonazepam, at very low doses, PRN. I try to educate the patient as to what's making them anxious and not to take their pressure at that time. Take that medicine, calm down, do some breathing exercises, some yoga. That actually works quite well if the patient is willing to do it.
Isha, you want to ask something?
Yeah. So, like regularly in ICU, in medical ICU, so we see the CKD patients who are maxed out on prazosin, then arcamine.
I'm sorry, I lost you.
You're muted. You're muted, Nisha. Dr. Isha, you're muted. Yeah. Please ask the question again.
Yes, very good evening, sir. So in ICU setups, like what we see in CKD patients, like we see many patients maxed out on prazosin, then maxed out on arcamine. Like what else can be used for these patients to bring out? Like it's very expensive for Indian patients to take these medications also, like prazosin and arcamine, including other medications also. Still they has this resistant hypertension, which I can call them like, instead of a pseudo-resistant thing, they actually have this resistant hypertension. So what else can we use for these patients, sir?
So prazosin is not a very good blood pressure lowering drug. And it also has tolerance. So I don't use prazosin at all. I would say in the ICUs here, they use a lot of labetalol intravenously. And they also use clobidipine, which is a CCB. So if you have access to an IV CCB, those work well together. Switching them off amlodipine at 10 milligrams with carvedilol, and I've gone as high as 50 BID, a diuretic depending on the kidney function. So I like torsemide because it's long acting and it's good for blood pressure. And then, you know, pick the ACE or the ARB that you have access to that reduces blood pressure well. And any of that combination, that should help you. But I have used minoxidil. I have used hydrolysine. So, I mean, that's it. But alpha blockers are not used over here.
And in these like ICU setup, like do you prefer giving nitroglycerin or labetalol infusions, or like you usually start with a?
I won't use nitroglycerin. I won't use nitroglycerin unless you have coronary disease. But labetalol, yes. IV labetalol works very well.
Yeah, both.
I have two questions for you, George. One is as an extension to what Dr. Isha just asked you. Very often when we have patients with CKD, ESRDs, and they're already on 5 and 6 antihypertensive agents, and yet you're not getting adequate control. And these are not hospitalized patients. These are all outpatients. And we tend to still have their, you know, they're taking very high doses of these medications, and yet their blood pressures continue to be high. Can we accept that, and what happens to them in the long run, you know, when you keep them at the higher level, despite the fact that you're taking so many medications?
Yeah, you should not accept that. You really should try to get them down. And minoxidil, for me, even if you have to go to 10 BID, as long as they've got good diuresis on board and good heart rate limiting agents on board, should work well.
And your patients with renal denervation, how long do you get a sustained control of the blood pressure? Do you see any changes? What happen, you know, maybe after 5 years or 10 years, what happens to these patients?
Well, they haven't been followed for 10 years yet, but for 5 years, it looks like it's pretty sustained. Again, not drama, but you're getting, you know, 7 to 10 millimeter reductions. So it's equivalent to 1 or 1.5 meds.
Bakris, you said about the addition of 2 drugs in the next guideline. I mean, I just wanted to know if you can share the status of SGLT2, Sundar is here, SGLT2 inhibitors, and the status of MRA. MRA.
So SGLT2 inhibitors, I was talking about the diabetes guidelines, not the blood pressure guidelines. But blood pressure guidelines, these are not going to be in any blood pressure guidelines. This is diabetes guidelines. But in the diabetes guidelines, hypertension, finerenone is not going to be in there because it does not lower blood pressure. That's the key. This drug works independent of blood pressure reduction. The blood pressure reduction you get with finerenone is like 2 millimeters, 3 millimeters, not very antihypertensive. I was referring to the diabetes guidelines.
Guideline. And do you believe, of course, will you be coming to the next talk on the relation to the diabetes?
Unfortunately, I can't. Because I have a conflict and I have to get back to the other thing. The timing was bad, but I promise next time I will be here for
Dr.
both.
Das,
so I'm sorry.
We're going to have Sundar, who's going to step in for Dr. Bakris as a second lecture. So, yeah, Dr. Bakris.
All right, I'm sorry. I'm very sorry.
No worries.
Oh, no, that's okay.
Next
Thank
time,
you very
don't
much,
send
George.
me Eastern time. Don't send me Eastern time. All right,
No
very
worries.
good. Thank you.
Thank you for being
George, how are you? George.
I'm all right. How are you?
I'm good, thank you.
All right, good to see you. All right,
So,
bye-bye.
Thank you, George. So we are very privileged to have back with us Dr. Sundar Mudliar, and he's agreed to step in for the second lecture for Dr. Bakris. There was some problem with Dr. Bakris to give a second lecture, but Dr. Sundar is going to talk to us right now on diabetes treatment from ancient times to present. And this is his entire journey that is going to take us from where we are today and where we started from related to diabetes treatment. I think he's already been introduced. So I'm not going to get into that. I think, Sundar, you can straight away share your screen and start the lecture. Thank you so much for stepping in.
Thank you so much for putting me on the spot, giving me peptic ulcer disease. And I hope people...
That's what friends are for. That's what friends are for.
And I hope everybody is not like, overdose of Dr. Mudaliar and you get indigestion.
You're so passionate in speaking, so it's always a pleasure to hear you.
But
Okay,
Sundar,
let me...
I think you did the right thing. You alone can do it. It's great.
Not in 15 minutes. I'll try.
Yeah.
And you'll make the best out of it. No worries.
Please. Please start, Sundar.
Okay. Hang on. Just bear with me a little bit.
Yeah. Take your time.
I am sharing my screen, but this other thing keeps popping in there. Hang on. Okay, you can see my screen and my slides.
Yes,
all right.
we can.
So thank you very much. And thank you, Sanjay. In case you didn't know it, Sanjay was my junior in high school in Mumbai.
Oh.
I don't want to say close to 50 years ago. So we are from the same high school in Mumbai. Thank you, Sanjay.
And that's why he could take the liberty.
Anyway, so I'm going to talk about a little bit different switch tracks, talk about diabetes treatment from ancient times to the present. So first of all, my conflict of interest disclosure. I do speak for AstraZeneca only in the Middle East, and I have research support from the NIH. So what am I going to do? I'm going to review the evolution of diabetes therapy over the centuries, how we used herbs, chemicals, starvation diets, till we came to insulin in 1923, almost 100 years ago. And then I'll tell you what a revolution it was after that, in all the drugs which we got. And some words about the FDA. Everybody calls it the mandate. It is not a mandate. When I wrote one of my papers, the reviewer said, go back and look at it. It is a guidance, but it's almost like they're twisting your hand. You better do it or you won't give it. But it's not a mandate. I'll talk about the CVOTs. And finally, what is the impact of the CVOT on our current guidelines? Just to refresh our memories. As you know, I used to start with this slide. The first description of diabetes, if you read all the Western textbook, is said to be from Arathias of Cappadocia, who was a Greek who lived in present-day Turkey. And he first, it is said, coined the term diabenin, which in Greek means a siphon, means the water just runs through you. At that time, they didn't know, diabetes insipidus, diabetes mellitus, and all that. Galen, who was about 100 years after him, also a Greek, and he said the kidney is the root of the problem over there. But if you really want the first history of diabetes, and I've looked at it, this is a stamp issued by Egypt in 1971. And so for those of you, I'm a big history buff. This stamp does not say Egypt. This says UAR 1971. In 1971, there was no Egypt. It was the United Arab Republic of Syria and Egypt. There was only one country. Then they split over there. Anyway, this depicts the physician Hisira, 3000 BC. He was the physician to the pharaoh Djoser in the third dynasty of the Old Kingdom. This is 1500 years before Tutankhamun. At that time, the Egyptians did not even know how to build pyramids. They used to build mastabas, and then they learned how to build it. And actually, I have been to where it is about 30 kilometers away from Egypt. If you go, you should go to Saqqara. That's where he's there. Anyway, he wrote something called the Ebers Papyrus. The Ebers Papyrus, actually, it's a misspelling here. Ebers was a German Egyptologist. He bought this in the bazaars in Luxor. And today, the original is still in the University of Leipzig. You can read it, and that is what it is there. But let me, another little historical point if you want. This is not hieroglyphics. This is hieroglyphics. The pictures of all these birds and all. So what is this? So the Egyptians wrote in 3 languages: hieroglyphics, hieratic, and there's another script called demotic. That's how we figured it out, because the Rosetta Stone had both of them together. Anyway, what did he say over there? So this is from Ebers' original translation. And he described a condition just like diabetes. And I showed this in my previous presentation. He said, if this condition like diabetes, you can use a rectal injection of olive oil. honey, sweet beer, salt, and seeds of the wonder fruit. You can anoint the phallus, or you can do this other thing, which is mixture, and all these things, fresh milk, beer, green dates. I've been in the Middle East. I asked people, what are green dates? Nobody's heard of it, but that's what the translation is. And he said, put it all and take it for 4 days and your diabetes is over. Then, of course, around 300 AD, and I listened to Dr. Mohan has published a great book on diabetes before insulin and with insulin in India. And it's a JAPI article. I really refer it to it, how insulin was first used in India right after it was available, and how insulin was treated in Kolkata in the 1800s. But Charaka, as far as I can find out, lived about 300 AD in the time of the Emperor Kanishka. And he, of course, described the concept of prameha and madhumeha in the Charaka Samhita. Now, Shushruta probably lived 200 years before him, and there is historical evidence for this. And those of you who are interested in history, I'm fascinated by history. The problem with India's history is we depended on Smruti and Shruti. We never wrote anything down. And for those who are interested, Indian history today is dated on only one fact. We have all the Puranas, Vedas. What time is it? The only time which we can fix in history is 326 BC, when Alexander came and defeated Porus. The Greeks wrote everything down. And that's how we date everything. And the Charaka Samhita and all, these are there in the Buddhist manuscripts found in China. They date back to 100 BC and 100 AD actually over there. So anyway, just my passion for history as well over there. So this, I looked it up online, but it is there in the Prameha Chikitsa. And just look at what he describes. So he says people suffering from prameha are two kinds of people: those who are obese and strong, and those who are emaciated. So I think he is describing type 2 diabetes and type 1 diabetes. Remember, insulin sensitive, insulin resistant was only described in 1933 by Himsworth over there. But he's already saying, and he's saying, if you belong to this one, give them nourishing therapy. And those who are strong and have more doshas, they should be treated with elimination therapy. And he says, for that, he says, the oleated fat patient should be given various recipes, and they have to eliminate metabolic waste products through both the upward and downward tract. Very clear, there over there. And after that, you do a lot of things over there. What happened after that? Over the centuries, various herbs, diets, chemicals were used to treat diabetes. Until the 1700s, now is when we get better literature. This was in 1797. This is the original book. For those who can read the Roman numerals, that is 1797. John Rollo was a Surgeon General in the Royal Artillery. So this is 1700s. We're not even in the 1800s. Guess what? He published 2 cases of diabetes mellitus with remarks on their progress and the nature of the disease. What did he say then? And what he gave was the meat diet. Okay. After that, in the 1800s, the father of diabetology is actually a Frenchman called Apollinaire Bouchard. And that is him over there. What he did was he resurrected Rollo's treatment, but he's the first one to say individualized treatment for patients. And now we are coming to precision medicine. He said, don't take milk because of its carbohydrate content. And he urged that patients eat as little as possible and masticate carefully. He's the first one who introduced the intelligent use of exercise in the treatment of diabetes. And he advocated daily urine testing to guard against a return of sugar without the patient's knowledge. Think about this. First, checking of the sugar, because if, what you don't know cannot affect you. If our patients, even if they're well treated, I tell my patients, check your sugar at least twice a week, because slowly your diet will go bad and it will come back. And he prescribed also sodium bicarbonate, chalk, magnesia, citrate, tartrate, ammonium, potassium salts. All this is in a great book, and thanks to Google, they have digitized these books. This book was written in 1919. If you're really interested, Total Dietary Regulation in the It gives you the whole history of treatment of diabetes. I think I saw Shilpa over there. This would be very interesting to you, Shilpa, and I would love to get your opinion on it. But if you want the original book, it's available on Amazon. Apollinaire Bouchard de la Glucosure. He wrote it in 1883. Let's come to the late 1800s. We're still in 1892. And Sir William Osler is considered the father of medicine in the US. He's a Canadian, actually, but this is his book, The Principles of Practice of Medicine. So 1892, what did he say? He recommended a dietary prescription of, look at this diet, 65% fat, 32% protein, and 3% carbohydrate. And he said, abstain from all fruits and all that garden stuff. He proposed to avoid worry and lead an even quiet life in an equitable climate. Use flannel or silk near the skin, take a cold bath daily and a Turkish bath occasionally, and get Turkish bath are the steam baths, and get moderate exercise or massage. But guess what more he said? He noted that no one drug has directly curative influence, but that opium alone stands the test of experience as a remedy capable of limiting the progress of the disease. So what primitive methods we had, but at that time it was standard of care. And then come to the 1900s, this is 10 years before insulin. Frederick Allen, and actually he was the mentor to Elliot Jocelyn, he proposed the oat cure. And he said, do not give any other carbohydrate because then you will get glucosuria. And he also said, no meat on oat days. Even eggs are sometimes harmful. And then he said, the oat and butter diet may cause diarrhea, which can again be checked by opium. And then, people can get edema, oat edema, diuretics such as thiosin can prevent the edema over there. Let's come to Elliot Jocelyn, 1916. See what he said. The treatment of diabetes mellitus, rather more success is achieved by surgeons in the treatment of general peritonitis than is attained by physicians in the treatment of diabetic coma. He said surgeons do a better job to treat peritonitis. This is in 1916. But he also said something fascinating. He said, whenever I'm asked to see a new case of diabetes, I tell the physician, don't change the diet or omit all the fat until the consultation takes place. Then when the patient comes for treatment, I first omit all the fat in the diet. After 2 days, the protein, and then half the carbohydrate, and then fast the patient. So now we come to the keto diets over there. 6 years later, of course, we got the discovery of insulin. This is one of the earliest vials. And this was made by the University of Toronto over there, and they could not keep up with the production. So in 1924, they sold the patent. Now, 4 people, as you know, were responsible: Banting, Best, McLeod, and Collip. But McLeod and Banting said, we don't want any patent on it. So the patent was in the name of Best and Collip, and they each sold their patent for $1 to the University of Toronto, and it was sold to Eli Lilly to do it. And you all know the price of insulin. After that, what happened is, after insulin came in 1923, we have had in the first 73 years, we only had NPH, Lente, Ultra Lente insulin. Then 1942, sulfonylureas, biguanides in the 50s. And then next 18 years, a lot of drugs, metformin, TZDs, insulin, and of course, the latest drug so far, the SGLT2 inhibitors. And what do these drugs do? Well, we know diabetes is a complex disease. You've seen this slide many times before, Ralph DeFronzo, defects in all the organs over there. But good news, we have drugs on all of these. What do they? And of course, we have insulin. All of these lower blood glucose levels. But the problem is that tight control of glucose, as we know, improves microvascular complications, but does nothing to CVD. In fact, in the ACCORD study, the NIH stopped the study early because there was more all-cause and cardiovascular mortality. I'm not joking. It's about a 20%. There I said, stop the study. And in the previous session, we discussed, very rarely are studies stopped. Usually they are stopped because of futility. And that was the look ahead study, which I was part of. The NIH came and said, no point doing it. This is a waste of money. Or for harm, like in this case, they said, stop the study. Or very rarely for benefit, like with the DAPA-CKD and the Credence Star, the DSMB said, stop the study. But anyway, tight glycemic control may be harmful. I was part of the VA diabetes trial. We saw a tendency towards harm. Yes, you get some retinopathy and kidney benefits, but not for cardiovascular disease. And I've shown this slide also many times before. I like it. Miles Fisher is a diabetologist from Glasgow. He said diabetes actually is premature cardiovascular death. You have chronic hyperglycemia and may be associated with blindness and renal failure. And the crux of diabetes, of course, is premature cardiovascular death. But we focus on treating glucose, bringing it down. I told you in the ACCORD study, tight glycemic control was bad. Not bad, I mean, it improved microvascular, but CVD harm. And then after the rosiglitazone episode, the FDA came and look at it. This is guidance. It is not mandate. But they said any drug diabetes going forward, this is the only thing for blood pressure, cholesterol, other diseases, they don't say it. You have to show cardiovascular safety. And that is where we got our CVOTs. Let me give you another interesting point. Where did the word MACE come from? MACE. I don't have the slide for it. MACE stands for Major Adverse Cardiovascular Event. The first use of the term is in 1993 in the American Journal of Medicine. It was coined to capture events taking place during stenting. At that time, stents were being put, and when people got stents, they had a stroke or they got an MI. And in the original article, it is major, adverse cardiovascular events. At this time, the FDA came, they didn't know what to do, take MACE and gave it. And you know what happened after that? We had the serendipitous finding of heart failure and kidney things. What did we learn from the CVOTs? I think DPP-4 inhibitors, without a doubt, really no MACE benefits, some benefits on albuminuria, no effects on going to ESRD, some molecules, maybe an increase in heart failure. GLP-1 till today, in the powered trials, MACE benefits, no CHF benefits so far. It is coming. It may be coming. And the real benefits so far, albuminuria, no hard outcomes on progression to kidney disease. Dr. Tuttle showed you those slides. Those are secondary outcomes from the award 7, the dual glutide side, but not proven. We have to wait for the string. But SGLT2 inhibitors, they have MACE benefits, they have CHF benefits. Now, granted, the MACE benefit is not so much for stroke and heart attack, but it's still there if you aggregate it all together. Renal benefits include progression to kidney disease. As I told you, albuminuria is a marker, surrogate marker, and albuminuria is a better predictor of cardiovascular disease, and we talked about that in the previous sessions. It doesn't predict renal failure that much. Why is heart failure so important? Remember, EMPA-REG got the MACE outcome. Canvas got the MACE outcome. Declare-TIMI was a low-risk population. Everybody did not have heart disease, only about 60%. So before they broke the blind, before the analysis, they went to the FDA and said, we are going to have 2 co-primary endpoints. That's when the heart failure came in. They sensed that something else is going on here. Anyway, heart failure, I think, this is my good friend David Bell. This he wrote almost 20 years ago. He said it's frequent, forgotten, fatal complication, highly prevalent in some populations, 1 in 5 patients, and it is hidden. You don't even find it. If you do it, HFrEF we pick up because people get, this thing. HFpEF early stages, nobody picks up. Ejection fraction is good, go away. HFpEF was only described in the latter part of the last century, 1990s. Now HFpEF is a huge deal. Anyway, anybody who gets diabetes and heart failure, the prognosis in a Medicaid database, median survival 4 years, about 10 to 20% mortality. That's seen in our placebo group in the heart failure studies. It's not a good disease to have if you get heart failure over there. And of course, I showed this before. The heart and the kidney talk to each other. Remember, the heart beats 1 lakh times a day. It's tens of thousands of liters, and 1/4 of it goes to them. They both have to talk to each other. If the heart doesn't pump, the kidney's in trouble. If the kidney doesn't do its job, the fluid backs up, that's guy in trouble. And I showed this before, patients with CKD more likely to die of heart disease, heart failure. So this is something I didn't show in my previous slide. Are there any differences in the cardiorenal outcomes between SGLT2 inhibitors and GLP-1? Now, nobody will ever do this study. This is an older meta-analysis from Zelnicka. But basically, I think it's still true till today. In trials to date, GLP-1 and SGLT2 inhibitors reduce atherosclerotic MACE to a similar degree if you have established atherosclerotic cardiovascular disease. I am not able to show you the slides for want of time, except in the VERTIS study. But SGLT2 inhibitors so far, marked effect preventing hospitalization for heart failure or progression to kidney disease. Across the board, all the compounds do it over there. In my opinion, so far, the GLP-1 receptor agonist benefits are mainly due to anti-atherosclerotic effects on the pipe, the epicardial artery. Of course, there is improvements in A1C, very good improvements in A1C, good weight loss, some blood pressure effects, some lipid benefits. And there are GLP-1 receptors on the vessels. It's got anti-inflammatory effects, endothelial effects. But so far, benefits are shown only for atherosclerotic disease, not so much for heart failure or kidney failure. Not so far, not as a primary outcome. I think it is coming because of the other effects. SGLT2 is mostly on the pump. It doesn't have much atherosclerotic benefits on stroke and heart. Why? Because its benefits on that is because, hey, it improves heart function, so you're pumping better. Remember, heart fills during diastole. So if your heart function is better, you're filling your heart better. And you remember, in patients with HFpEF, they barely get the ventricle is thick. It is squeezing the heart over there, and they barely can get any heart flow. But it has got some effects due to blood pressure, lipids, and all. And this, in some earlier studies, the GLP-1 receptor agonists actually had detrimental effects on the pump. Maybe it was due to an increase in heart rate. And these two studies are there, the FIGHT study and the LIFE study. There was actually an increase in heart failure, but not seen in the large CVOT so far. And perhaps now some IV studies with exenatide showed benefit, but so far we really don't have dedicated study for heart failure. So meta-analysis of all SGLT2 inhibitors, time to first heart failure, I think even if you include VERTIS over there, it is all in the right direction, about a 32% reduction over there. I don't have to tell you the studies, these have been discussed before. We saw it as a primary outcome in dapagliflozin, DAPA heart failure study. People with an ejection fraction 31, it reduced worsening heart failure 30%, CV death, all-cause mortality 17%. Didn't matter if you had diabetes over there, and also reduced progression to diabetes by 32%. Of course, we had Emperor reduced heart failure study, similar outcomes, except CV mortality was not there. Emperor preserved was just presented, and the mean of these people had an EGFR more than 40%. Again, effects on heart failure without a doubt. And in my previous session, I discussed the renal outcomes, how it slows the EGFR progression. What about kidney failure? The dedicated study, I discussed this before, so I'll just repeat it. In 4,400 patients. Again, it's worth repeating. If you have albuminuric CKD, mean EGFR 56, primary outcome, I've told you this, 30%, renal specific outcomes by 34%, MACE and heart failure. And study stopped early by the DSMB. Dapagliflozin, the big difference, about a third of patients, no diabetes over there. Again, really powerful effects. And Dr. Tuttle also pointed out, all-cause mortality 31%, on top of ACE, ARBs, anything else, statins and over there. Again, independent of diabetes, stopped early. But what effect does this have on our guidelines? So this is the label. I have to update it a little bit more, but it hasn't changed much. I think this is the most important thing. avoid clinical inertia. And I know Professor Kamlesh Kunti calls therapeutic inertia, where we have to keep following our patients. Metformin still first line, it has not been a thing. And just for your information, metformin's cardiovascular benefits have never been conclusively proven. In a sub-study of UKPDS 341 patients, MI was there. Yes, they did the legacy effect and all that. Actually, we in the VA, we're doing a study called the VA Impact Study. We obviously cannot do a placebo-controlled trial in type 2 diabetes because metformin is standard of care, but we are taking people with pre-diabetes who've already had a heart event, MI or stroke, and they will get metformin or placebo. But then the guidelines say, if you have established atherosclerotic disease, CKD, heart failure, consider independent of the baseline A1C. So if your A1C is already 6.8 on metformin, please, if there's ASCVD, then preferably GLP-1 or risk for this, or an SGLT2 inhibitor, or if it is heart failure, CKD, they say preferably SGLT2, if not tolerated. That's the guidelines so far. If you want to avoid hypoglycemia, of course, avoid SUs or insulin. Weight loss, then don't use SUs, insulin, or TZDs. And of course, if cost is an issue, they're out of luck, SUs or TZDs. So this was in reference to the DAPA heart failure trial. They said SGLT2 inhibitors are evolving into a cardioprotective therapy that incidentally lowers blood glucose. It was initially developed for treatment of diabetes, but now people with heart and kidney disease have at least as much to gain. So that's a real paradigm shift in diabetes. So again, I showed this before, a little bit of a twist. We've come a long way in 5,000 years from Hesira to Charaka. I misspoke before. He's 200 BC. It is the Charaka Samhita. Then, of course, we had the meat diet with Rollo. We had the oat cure with Frederick Allen. We had the keto diet with Jocelyn. We had insulin. And of course, I've shown you this before. SGLT2 inhibitors really turned symptoms into therapy, and they have taught me more about diabetes than I've learned in the last 20 years. I showed this before. They truly are a man for all seasons, like James Bond, like, the pump, the pipe, the filter, everything is covered, and also perhaps diabetes. And I think they have introduced a paradigm shift, as I said, not only in diabetes, but also in the management of diabetes and heart failure. Again, I use this term a lot. It's not my term. It literally is sweet success for the diabetic heart and the kidney. Let me finish. I have 2 minutes left. I use this a lot. I love Kalidasa's Malavika Agnimitran. And those of you, you should read Meghadutam also by him. Beautiful books over there. And he's a widely regarded poet. Again, we don't know when he lived. Probably 400, 500 in the court of King Samudragupta. And he said, do not accept anything as good just because it is old. So we are questioning metformin. Does it really have cardiovascular benefits in the VA impact study? He said, don't reject anything as useless just because it is new. SGLT2, everybody said, it's going to destroy your kidney. Yeah, there are side effects. I'm not saying no. And he said, the wise weigh the substance for themselves and decide for themselves. It is the unwise who are led by the opinion of others. And I think with conferences like this, you get the latest and the greatest from all the best people all over the world. And thank you so much for your attention.
Thank you very much, Sundar. And I'll hand this back to the chairpersons to take the discussion ahead. Sundar, can you stop sharing?
Yeah, let me stop sharing. How do I do?
Sundar, it was
Somehow
great.
I'm not able to stop sharing. Okay.
Yeah, now it is stopped.
And we have got Dr. George.
George is there. George.
And George has messaged the Sundar saying that we have time up to 9:25.
No, George is back, so we're going to take his. Yeah. We'll have
Sundar. Sundar is so good that I didn't want to miss it, and I get finished early.
He has messaged us that we'll take up some questions on the guideline 2022. So I'm very happy that you came back. And Sundar, I cannot thank you more. Thank you very much for the great talk you gave.
I thank you.
So I think, Isha, will you start? You said you'll be starting the second session question. And you can ask some questions. We have about 25 minutes to close. And Sanjay is the we'll decide if to close earlier, but we have 23 minutes. So Isha, please start.
Yeah. Before the next lecture from Sir is starting, I want to ask, Sir, is in this guidelines, do we have any timing like all the antihypertensive medication should be taken? Because there was one paper in Cardiology Journal regarding taking the antihypertensives during the bedtime usually decreases cardiovascular mortality. So is there any guideline on like when to take these medications as such in 2022?
Sundar, let me just say that the ADA clinical practice guidelines have been put to bed for 2022. There is nothing about this. And by the way, do not delude yourself. There is zero data supporting nighttime dosing. That one paper that you talked about has been retracted from the New England Journal. There have been 3 other well-done studies randomizing dosing nighttime versus daytime. We did one of those studies a few years ago. There is zero data supporting nighttime dosing for better blood pressure control, period. Interestingly, and this remains to be seen, there is a paper coming out from a study that we did, an ABPM study, with finerenone. And finerenone seems to improve, and this is not nighttime dosing, this is morning dosing, seems to improve nighttime blood pressure. And this needs to be further studied, but it's quite interesting. Daytime blood pressure doesn't do anything. Nighttime blood pressure seems to reduce it. So we don't know why. It's an observation. We'll see, but nothing for glucose. Forget it.
Dr. Bakris, can we change non-dippers to dippers by any way? I mean, patients who have non-dippers, and we know that they have a higher mortality.
Oh yeah. The short answer is to a certain extent. If they have sleep apnea and you improve sleep apnea, yes, that seems to help a little bit. Possibly finerenone, we don't know. Nothing else seems to really help. Weight loss, dramatic weight loss. I'm talking about people that have had surgery, 70 pounds, 90 pounds. There's some small studies, very small, that suggest maybe improvement there. But the true mechanism for why this is happening in the first place is unclear. People were postulating hypoxia. Probably not. Is it inflammation? Maybe, but inflammation you can blame for everything. So we don't understand it. We don't know. Just like I can give you 15 mechanisms by how SGLT2s work, and they're not all in the kidney. So we don't know.
In the 2022 guideline, is there any change in the targets of blood pressure in diabetics?
No, still less than 130 over 80.
130
still
over 80.
Less than 130 over 80.
And
Sundar,
yes,
sorry, please go ahead, sir.
Yeah, I was just asking, what are the other changes specific to diabetes with hypertension?
Well, Sundar actually touched on it. If you're seeing somebody with diabetes and they have either kidney disease, GFR less than 60, and or heart failure, regardless, HFrEF, HFpEF, they need to be on an SGLT2, period. Now, if you want to use it to control glucose, that's fine, but they need to be on an SGLT2. Now, you want to use metformin, please. Nobody's stopping you. Be my guest. Metformin is still there, but it needs to be married to an SGLT2. And Sundar made a good point. Let's say you don't have kidney disease. Let's say you don't have heart failure, but you've had an MI. Guess what? You need to be married to a GLP-1RA with the metformin.
Any changes in the other drugs like the ARBs being the other drugs which are specifically indicated in diabetes with hypertension?
No, come on. That's mom and apple pie. The ARBs, it's a given that you're going to be on an ARB or an ACE inhibitor. Right? That's if we're having a discussion about that, we have big problems. Okay. That you have to be on for sure for blood pressure, period. Now, for additional blood pressure medicines, the first question, very important question, did you measure the urine for albumin? If you didn't, I'll see you in court for malpractice. It's very, very important that you measure albumin. Otherwise, you really don't know what the level of kidney function is.
Yeah.
If you have large amounts of albuminuria, then ARB has to be on board, SGLT2 has to be on board, non-dihydropyridine diltiazem can be on board as an additive benefit. All of those things help in slowing kidney disease progression in the diabetic.
I think Sundar, you also said this point about albuminuria being one of the very important factors. Sundar, you also highlighted this, Sundar.
Yes,
You
and
also
I've
highlighted, about
but albuminuria, I know I have
you highlighted,
clarified this with Dr. Bakris, is a better predictor of cardiovascular disease than it is. But the biggest hookah there are people with normoalbuminuric kidney failure. They go down to zero, no protein in the urine. So that
that's a great entity. Bakrish, would like to say something about that non-albuminic.
Sundar is absolutely right, and it's estimated it accounts for about 10% of all people with diabetes having so-called non-albuminuric kidney failure. Nobody has a clue. That's the number one question Vivian Fonseca asks me. What's the mechanism? Well, if I knew that, I'd be in science. I don't think anybody knows why. It's postulated that it's interstitial disease, and somehow the glomerulus gets away with it. That makes zero sense. So I don't understand. Sundar maybe has a hypothesis for this. I really don't know, and to my knowledge, I've asked. Nobody else seems to know.
Yeah. My hypothesis is, and just for the record, I had the privilege of debating Dr. Bakris at American Heart, if you remember, in 2019. He said SGLT2 inhibitors are hemodynamic, and I said it is the fuel hypothesis. And I was really nervous.
We all learn. I do remember. We all learn.
We learn, we live, and we keep learning over there. But to me, so I always tell people, and this goes back to the person who taught me nephrology in Madras. I'm blanking on his name. I can't believe. He's in Apollo. He was a nephrologist. Doctor?
30 seconds.
Dr. Mani.
MK Mani.
MK Mani. Thank you. Thank you for that. He stimulated this interest in me in the 1980s over there. Everybody says the kidney is a filter. I said there are two organs in one. There is the filter and there is the pump. And I tell people, the filter, the glomerulus, it does not have much of an energy consumption because the energy for it is the heart, which has pumped the blood and it just goes through. The tubule has to do all the thing. 80%, and Dr. Bakris can cut this thing, of the energy consumed is that K-ATPase pump, which it is using. Now, whether it takes it back in the PCT, the loop of Henle, wherever it is, it has to do it. And the other point, so my point is, the glomerulus is okay. I mean, hyperglycemia can damage it, and then the protein leaks through. Protein is toxic to the interstitium and all that. You get the fibrosis, you get a lot of things. And in hypertension also, there's is it increase in intraglomerular pressure, which is forcing its way through. But I believe, these people who are, now it is my speculation, there is tubular hypoxia taking place, because diabetes to me is also tissue hypoxia at the level. And in the inner medulla of the kidney, and Dr. Bakris, correct me if I'm wrong, the PO2, the partial pressure of oxygen is about 10, 15, 20. It cannot support oxidative phosphorylation. So the fuel there has to be purely glucose in the glycolytic thing. You cannot use anything else. And the beauty also is the guy who's doing most of the work, the PCT, the proximal convoluted tubule, glucose is not a preferred fuel there. Ketone is also not a preferred fuel over there. They use fatty acid because it's a big thing over there. And the reason we don't know yet why glucose is not preferred is those cells are the ones which do your gluconeogenesis. They're the ones sitting over there. So nature doesn't want a futile cycle. You make it and you use it. That kind of doesn't make sense. So the fuel thing is different all through it. And my thing is that with SGLT2 inhibitors, ketones become a fuel. I don't know if it is right or wrong.
So wait, so Sundar, I agree with everything you said, and I want to add one thing to you. The kidney is not two things. The kidney is three things. It
Oh,
is
okay.
also an endocrine organ, because
Yes.
let's not forget about renin. Let's not forget. I mean, let's just, you know.
Erythropoietin.
Erythropoietin.
And the
Okay,
fascinating
I mean,
thing is,
that's
in
fine.
fetal life, in fetal life, the liver makes erythropoietin. The moment you're born, within a week or two, the kidney. And this fascinated me. I've gone back and looked at all the original literature about why is the kidney sensing hypoxia. We have all the carotid body, this and that. They're not sensing hypoxia. The paracortical cells. And I'd be interested in your thoughts. I have my own thoughts.
No. I agree 100%. And you brought up something that unfortunately can only be looked at a basic science level. And that's why clinically, you know, one could argue that SGLT2s are protecting the kidney in a mechanism that is not too different than is protecting the heart in terms of metabolic pathways in the hypoxic state. Has not been examined. So
yeah, it's not been examined. Absolutely. Yeah. So what happens, this is my thing. So, you know, we all check, you know, the finger ox, it's 98, 96, 92, we're okay. But from 90 to 98 is a 8% drop. That's, you might say, hey, it's nothing. But in the kidney, if it drops from, in the medulla, if it is dropping from say 20 to 12, that is a huge, that's a 50, almost 50% drop. So it is uniquely poised to pick up small, clinically relevant things. And those, you know, it is at the paracortical junction of those, they are actually neuroendocrine cells which are there, which make the erythropoietin. When they are hypoxic and they don't, they become fibroblasts. They de-differentiate, as it were. And all the SGLT2 studies that's been shown, erythropoietin goes up, hematocrit goes up, they rejuvenate them. The Japanese have done a lot of work on that, looking at the re-differentiation of those cells.
Dr. Bakrish,
just my thoughts.
Regarding, is there any other tubular dysfunction beyond what Sundar described in diabetics? Tubular dysfunction.
Well, yeah, you can develop renal tubular acidosis, which is common. Usually it's longer term. And again, I think Sundar said something, and I'm going to come back to it. The workhorse of the kidney, everybody thinks the workhorse is the glomerulus. The workhorse of the kidney is the proximal tubule. And the amount of energy that is needed, the reabsorption that is occurring, the homeostasis that's responsible for is just out of control. Now, yes, long-term, the distal tubule, you can develop renal tubular acidosis there because so basically hydrogen and potassium are not going to be in sync. But guess what? That can happen at the proximal tubule as well. So there are a number of things that can, it's amazing to me that the focus is on glomerular diseases when in fact the tubule can have all kinds of things go wrong with it. And most of the time it doesn't. So it's kind of a big deal.
Yeah. The second question is what Sanjay had asked you. Isha, just 1 minute, Anjali. The second question to ask you is that Sanjay asked you about the dippers and non-dippers. And we know the non-dippers in diabetic have some sort of a subclinical hypertension, whatever you call it. And they're also prone to kidney damage because of diabetes, almost equal to people who are hypertension. And of course, you have given is there any specific mention about managing them in the new guideline?
There is nothing in the new guidelines about that because that is not well understood. I can tell you, I just finished writing an editorial. It's not published yet. It's going to be published next month in Hypertension on the longitudinal trajectory of blood pressure. And so if we look at this mathematically, and we look at the total area under the curve of blood pressure, not what is it in the office, what is it at home, the total area under the curve. The kidney not only modulates blood pressure, but it's a good buffer of blood pressure to protect itself within a certain range. But if you reset everything at a higher level, that protection erodes with time. So if you have diabetes, and now on top of that, you got a blood pressure, not real high, but let's say 150, all right? The kidney will protect itself to a certain extent, but if you start getting spikes through the day and they become more frequent and the pressure is up at night, the kidney loses this ability to protect itself and you will get faster declines in kidney function. And one of the things that predicts this, believe it or not, is quality of sleep.
Absolutely.
Quality of sleep. I'm not talking about sleep apnea. That's a given. But I'm talking about people that have anxiety. They can't get to sleep, or they get to sleep, but they stay asleep for 2 hours. Then they're up. Then they can't get back to sleep. Those people are disasters in terms of blood pressure, in terms of speed of kidney function decline, in terms of glucose control, across the board. And until you fix that, and you can't fix it with just giving blood pressure medicine or glucose, you got to fix the sleep. Then you're okay.
Fantastic answer. Anjali, you had some question?
Yes, sir. So this is related to Dr. Murlia sir's talk on ancient to current management of diabetes. And I really, it was passionate, spontaneous. I don't have words. But I want you to help me to know whether I have understood correctly, sir. From ancient times to now, what I think, especially when you mentioned that the SGLT2 inhibitors have taught us diabetes like nothing else has taught us. And I think these two separate, because the treatments that were done, especially of the ketogenic treatments that were done with the nutritional and the metabolic parameters, changing herbs and all that. So here aren't there two distinct differences? One where people are born with a carbohydrate metabolism problem, like type 1s, and people with autoimmune disorders, autoimmune defects in the carbohydrate metabolism pathway, insulin, glucagon, and all that. And then we have certain who are born with a tendency but are dealing with a fuel and a fluid overload, isn't it? I mean, that we are only talking about fuel calories, I understand, but I think haven't SGLT taught us that, SGLT2 inhibitors taught us that there is also an overload of fluid that we have to deal with? And because we are removing the fluid and it's giving such an important results in improvement of kidney function, heart function, apart from hyperglycemia management.
I mean, it's a very complex question. Let me do it. But if I may make a point to the renal tubular acidosis, there are very few patients. I've had some patients for a long time. It's type 4 RTA, and these are the patients. People will say they're on Lasix or something, and they're on fludrocortisone for the the hyperkalemia and all that. So I've had a patient. People will say, "What are you doing? You're using fludrocortisone, you're retaining sodium, and then you're giving Lasix." But that's the only thing that kept them going. So, and it is the hyporenin hypoaldo. And for the fellows in endocrinology, I always say, "What is the hyperrenin hyperaldo?" Barter's syndrome. And Dr. this thing. So there are two separate things over there. But coming back to your question, see, this has fascinated me as well. And if you've listened to Dr. DeFronzo, he's a nephrologist and an endocrinologist, and he said, this is what he said in one talk. When the big guy in the sky put the kidney in, he told, you have two jobs, right? You need to keep the salt in, because if you don't keep the salt in, you don't have blood flow, you can't live, you don't have a vascular compartment. But then when you have the flow, you need nutrition. So he said sugar, and the transporter in the gut and in the kidney is the sodium glucose. But the body prefers sodium. That is the active transport. Glucose just sits on its back and gets in over there, because you can use fat for energy, you can use, and then there's a very complex procedure to convert protein into carbohydrate. You cannot convert, in humans, you cannot convert fat back to glucose. Glucose can become fat, but we don't have the machinery to put it in there. So the nature, and actually this goes back to Dr. Bakriska says, when we came out of the ocean, we were living in a water environment. That is why it doesn't make sense that we are, trying to salt when we lived in that environment. And now we have to protect to keep. So sodium, glucose are both there. They are both running together. So I take your point that, it is salt. But I do not believe, type 1 is a different disease that is purely over there. But in type 2s, now you could have the metabolic syndrome, but the genetic component is very small. It is the environmental thing which we do to ourselves. And the body has got, Dr. Bakris can bear your tremendous reserves to adjust. You can eat 10 packets of chips a day. If your kidneys are good, it will get out. You can drink 20 cups of water a day. All you're going to do is pee. The body knows how to. That's the beauty of the inner medulla, where That's why the oxygen is low, because there is no blood flow there. Otherwise, you wash out that gradient to take back all the sodium. So I don't know that I've answered your question, but salt and sugar go together. Salt is more important than the sugar to the body. I don't know, Dr. Bakris can add his thoughts.
No, I was listening, and I'm just thinking that one of the things I tell the patients is the kidney, God knew that we were going to be stupid and we would abuse ourselves. And so think of the kidney as workers on an assembly line. And so the work comes, all the nutrition, the salt, the glucose, it all comes, and they're handling it and all, it's fine, okay? But now you've increased the assembly line, the same number of workers, but now you've got 5 times the work. Most of the time in the factory, those people would quit. Here, the kidney does it. And ultimately, some people are going to die off because they can't take it. But there's endurance built in to our bodies, and that's why we're doing so well. But the one other thing that Sundar knows, didn't say this because he was focused on the kidney. One of the things I also tell the house staff is that the heart and the kidney are a married couple, and they actually talk to each other. They've got hormones, they've got nerves. There's all ways to talk to each other. If one isn't doing well, the other one is going to try to help, but it's not going to do well either. And it's going to try. And ultimately, if one starts failing, the other one's going to fail. And you can do this, what you can to support it, and it will support it. But the thing that people don't appreciate is beyond that. I will tell you, I was at a meeting. This was a large clinical trial meeting. 700 people are from all over the world. And I got up and I said this. I was followed by a cardiologist who echoed it. And then Peter Rossing got up. Now, Peter Rossing's an endocrinologist from the Steno in Denmark. And Peter and I are good friends. We were all good friends. And Peter goes, well, George, if that married couple is there, they're living in my house, the endocrine environment. And it's actually very nicely put, because guess what? The gut in kidney failure, and not dialysis, but reduced kidney function, the gut reduces the amount of branched chain amino acids it puts out, the bacteria. Guess what? The heart needs those branched chain amino acids for energy. So all of a sudden, you've got an energy deficit. So this is integrated physiology at its best, and it's really complex. And I just wanted to put that out there to say that, yeah, we can talk about the tubule, we can talk about the macula densa, but by the way, there's a whole environment. You're talking about a part of one room in your house, but the rest of the house is there. So.
Good.
So Sundar, I have a question for you. You've now seen the benefits from DAPA-CKD and credence and all this, where you've seen they've included patients all the way up to GFR of 25, and there are reports about using metformin even in low GFR patients, and it really doesn't cause too much of problems, and anecdotal lactic acidosis. Do you think, I mean, that's a gray area that I'm treading into, and I don't know what your thoughts would be, but
let me tell you.
Yeah.
Now, wait a minute. All right, ask your question. I'm sorry. Ask your question.
So do you think we need to revise the guidelines to see that we should stop saying that, we should stop using SGLT2 below 45, and we should stop using metformin again below 45 again? Yeah. So what are your thoughts about this? Should our guidelines be revised?
So SGLT2s, so the 2022 guidelines, SGLT2s can be used down to 25. Okay. Now, you may not know this, because I'm not sure it's actually online yet, but it will be imminently. There is a paper out of Canada. It's a small study, 250 patients, something like that, looking at sotagliflozin in stage 4 CKD, stage 4. And what they found was it was perfectly safe to be used down to a GFR of 15. And there is a study going on right now in England in dialysis patients with SGLT2s, specifically looking at the heart, obviously. But the 2022 guidelines will say SGLT2s down to 25. Now, metformin, with all due respect, is freaking poison if you're using it to GFRs down below 30. No way. And it's unappreciated the amount of lactic acidosis that occurs in patients that are not that compliant when you're between GFRs of 30 and 45. It's not that bad, but it's there. So for me, I automatically cut the dose, and this is the recommendation. When you get to 45, you automatically cut the dose to 500 BID. And I got to tell you, for me, when you get to 30, 35, I stop it and I move to other things. And I'm a big fan, since Sundar mentioned Ralph, I'm a big fan of pioglitazone. And I use it at 7.5 milligrams. I may go to 15. I don't go any higher. But I've had amazing results with that. So, and there's a stroke benefit, as you know, from the data. So, you know, that's my 2 cents as a nephrologist.
Thank you. I think Sanjay, it is time, and it's my Sanjay. We
Can I make one point? Sorry.
Yeah. Yes. So,
No. I agree exactly. 45, 30 to 45, and below 30 in the US, of course, you know, like he said, I'll see you in court. So you're running on things. But we didn't touch on one aspect of the kidney. Now, lactate is not the problem, but it is secreted as lactic acid, the H ion, and the kidney does your acid base. You can do a little bit with the respiration, but the kidney has to do the metabolic part of that. You can't deal with that acid load if you have a bad kidney. Lactate is a good fuel. You can do lactic dehydrogenase and take it back to pyruvate and do it. But the H ion is the problem over there.
Dr. Isha, you want to ask something before we close up?
Isha?
Please.
Yeah, that's it, sir. I don't know what else to say. Yeah.
Thank you very much, George. Thank you very much, Sundar. And thank you, Sundar, for stepping in for George
Yes,
at the last
thank
minute.
you. Thank you.
But
The last time I stepped in for Dr. DeFranco, if you remember, in Pune.
That's true. True.
That's becoming a habit with you.
But good, Dr. Bakris came back, Sanjay. And
yes, thank you so much, George.
Thank you. I'm sorry.
We did discuss the diabetes guideline 2022. I mean, that was your subject for the second talk. Thank you, Bakris. And
thank you.
Thank you very much. It was an excellent session. And I would like you to close the session and thank Dr. Das, Dr. Isha, of course, Dr. Sundar and Dr. Bakris need not be thanked. I mean, we should thank more than anything else because they spare time and come and grace this platform to give such excellent lectures. So thank you, both of you. And we look forward to have you physically next year in Pune.
Okay.
Face to face.
Thank you.
Thank you, everyone. From the scientific committee, we close the session today. You want to say something?
And we would like to remind everybody we will start at 10 o'clock in the morning tomorrow.
No, 8:40 in the morning.
Sorry,
tomorrow.
8:40. Thank you so much.
Thank you. Thank you.
Bye-bye, everyone. Join in tomorrow by 8:40.
Thank you very much for giving the opportunity, Sanjay. Thank you very much. Me and Isha, thank you profusely.
Thank you, sir.
Thank you, Anjali. Thank you, Sanjay. Thank you. Bye-bye. Bye-bye. So I'm leaving the meeting. Bye. Isha, bye. Good to meet you.